So I am representing pull-through maneuver in STEMI leading to catastrophe. So case summary, 62-year-old female non-diabetic and hypertensive presented with severe central chest pain for 4 hours. ECG showed anterolateral MI. So primary PCI was planned immediately and shifted to cath lab. So you can clearly see that the left circumflex artery is a non-dominant, non-obstructive vessel, but the LAD is having a critical disease in the proximal part involving the diagonal, and then there is 100% mid-occlusion with very faint antegrade filling. So we say that's a pretty straightforward case, like it usually happens in STEMI. However, we face difficulty in wiring, and we used a workhorse wire, the cyan blue. And so for when facing difficulty, we use better wire support. We use a 215 millimeter balloon, and then after that, wire was crossed successfully. The same balloon was pulled multiple times, like we do in STEMI for daughtering, like bottle brush, and we knew that the nightmare was waiting for us. So cine after daughtering with 215 millimeter balloon shows that there is a grade 3 perforation. It's the type 3 LS perforation, but also you can see that the arrow showing that there is a jet from where the perforation started. So we were lucky that we were having a balloon in the guider, so we immediately took the balloon at the perforated site so that we can have a balloon tamponade defect. And then we inflated the balloon for 15 to 20 minutes, but we were not successful in sealing the perforation. Now what options we are having at that time? We can wait, observe to see that the perforation is expanding or sealing. We can again reinflate the balloon to have a tamponade effect. We can also deliver covered stent. We can prepare for pericardiocentesis. We can do coiling or fat embolization. We can call for surgery, and with reversal of heparin also. So perforation could not seal the balloon inflation cannot seal the perforation. Despite repeated prolonged inflation, we did 2 or 3 times of 15 to 20 minutes of inflation, but we were not successful. And then you can see that that perforation is expanding into the cavity. That type 3 perforation was converted into a type 4 perforation.
Because we have enough time, if we like go through it right up from the straight, because lots of times we'll be wanting to come back and see what happened. So if you see the first slide where you start your first picture, can you show us, and we can have comments of the panelists, because this is a very interesting case, and ऐसे ही लग रहा है,
this branch is not going to the apex,
so
it is going laterally.
We can also appreciate that is a very late antegrade filling of the LAD.
Yes, late antegrade filling.
आगे चलें डॉक्टर. Okay.
I doubt.
Yeah, this looks into the LAD. The wire is into the
but
LAD.
the wire looks, I mean, I think...
But this is a calcific
the wire
vessel.
go all the way through the apex, It seems like it's not in the true lumen, probably.
Yeah.
Probably ये septal की तरफ आई है, और वो देखिए LED के साथ पैरेलल चल रही है, इसके थोड़ा राइट के ऊपर, ऐसे लग रहा है. और लेकिन ये इतनी perf कैसे हुई है यहाँ पे?
I think this was a bit of over manipulation with the wire when they were trying to cross it with the help of balloon, and the wire didn't go into the true lumen.
I'm not sure. It doesn't happen. I mean, I think
and
the wire is not in the true lumen.
Yeah, और देखिए इतनी tight लग नहीं रही थी, so probably it's not went into the वो जो vessel है LED है ना, शायद उसमें नहीं हो. It might be someplace else, but direction तो ठीक लग रही है. There is a shadow next to it ना, side पे एक आ रहा है. Am I right? Just आप नहीं बोलेंगे डॉक्टर, ताकि उनके भी comment आए. क्यों सर?
So did you inflate the balloon as well, or was it the wire only? Did you inflate the balloon?
भाई सर इनको भी आप कमेंट करते जाएं, बाद में करते जाएंगे. आप बताइए ना कि ये अभी आपके ख्याल में LED के अंदर है या नहीं है?
Wire looks into the architecture of the vessel, but it is not in the lumen of the vessel probably.
Okay, sure, ठीक. आगे. और इतनी सिंपल मैनिपुलेशन में वायरिंग के साथ तो इतनी पर्फ शायद नहीं होती ना.
होती नहीं.
है ना. सो जैसे डॉक्टर साहब ने कहा कि बलून सपोर्ट भी आई है, so clearly is like pushing through something, huh?
And also, if we say that if we are in the septal branch, so we cannot expect that that kind of perforation septal perforators can do.
ठीक है, चल आगे.
Sorry, I cannot hear.
On करना.
Mic
You have to confirm the wire, where is your wire is. It's as distal and as possible. Then you have to proceed with the daughtering and every manipulation after that.
Yeah, you are right that we have to go to the apex, then we have to do the daughtering also. Okay, now what options we have, I already told you. So this is the cine after doing the balloon inflation, and you can see that that perforation is expanding into the cavity. Type 3 perforation is converted into type 4. And you can see that the balloon was there to seal the perforation, but we were not successful. Repeated balloon inflation was done, and you can see that the perforation is expanding into the cavity. So we immediately called for echo, and then there was mild to minimal to mild pericardial effusion, but no signs of tamponade.
अभी भी देखिए जब when a dye hangs like this in the myocardium, so it's not probably going into the pericardial space.
Yeah.
It's probably hanging there, so it's not a free-flowing perforation like we expect. It's still hanging in there, huh?
So now I will show you the next step.
So, one question here. Can you go back?
Yeah.
So, were you having difficulty in getting the wire all the way down?
Yeah, we were facing some difficulty. I think that when we were crossing the proximal critical lesion, maybe there was a ruptured plaque that diverted our wire towards, the wire taken an acute angle, and then the wire was shifted towards the mid LED. So I will show you in the next slide that how our wire was taken and when we went to the true lumen.
Where do you think the wire is right now? आपके ख्याल में वायर कहाँ है अभी?
क्या कह रहे हैं sir?
Sir is asking where you are expecting the wire
right
is.
now?
I don't think it's somewhere. It's not in the true artery, I believe,
Yeah.
because
It's not gone far enough. It's just like somewhere in the middle.
Yeah.
And जो direction भी है, it doesn't seem to
Direction भी
conform
ठीक नहीं है.
to any of the vessels we saw earlier.
Yeah.
So even if it's in the lumen, it's not even in the lumen. That's what it looks like.
Yeah,
probably.
it's not. Did you try any other wire, or did you keep the wire this way where it is and put in any other soft wire and try to see if you can go through?
No, we didn't took another wire, and we did daughtering and bottle brush, and we were not having any difficulty in passing the balloon.
Your wire is in the mid.
So how did you confirm that whether is it a true lumen or not?
Yeah, that's the next question, and I was expecting
let's
that.
see the next
so,
step then.
as we can see that the perforation was not sealed by repeated balloon inflation. So next step was we should take the covered stand and deploy the covered stand and seal the perforation. So when we took
इस
the
जगह पे आपने multiple inflation दी है.
yeah, we did multiple inflation, but as we were not successful, so we took the covered stand. We were the ability having the covered stand in our cath lab. So when we took the covered stand, so by surprise, our wire was pulled back in the proximal part. So that, unfortunately, that scene was not saved. So we use a ping pong catheter to seal the perforation and save the time. We use 7F femoral access and with 7F guide. So we use that ping pong technique to seal the perforation, and you can see that in that image, our wire is pulled back into the proximal part of the LED, as it's clearly visible here. And might be that was the reason that we were not in the true lumen, and that covered stand was not able to cross the lesion. So that's why we immediately shifted towards the ping pong technique and used the 7F femoral access to cross the lesion and gain access into the true lumen.
So डॉक्टर साहब आपका वायर पूरा पीछे आ गया
Yes.
तो फिर पिंग पोंग की क्या जरूरत थी कि इसी कैथेटर के साथ आपने जो करना था कर लेते?
Actually, we tried our best, but as I told you earlier that we were not in the true lumen and we have to seal the perforation. The perforation was expanding, patient was hemodynamically collapsing. So we thought that we have to gain another access to seal the perforation.
नहीं वो तो आप बिल्कुल ठीक कह रहे हैं लेकिन अब if you lost your wire, your catheter is back, तो दूसरे कैथेटर ने भी वही करना है जो इस कैथेटर ने करना है, ऐसा ही नहीं?
यस एक्चुअली हम ये सोच रहे थे कि अगर हमारी वायर लॉस हो रही है, जिस तरह हमने देखा है कि इस व्यू के ऊपर वायर हमारी पीछे आना शुरू हो गई थी, तो वी वर नॉट इन द ट्रू लूमन एंड वी वर नॉट एबल टू क्रॉस दैट एरिया अगेन. We kept the balloon in
तो दूसरे
deflated.
कैथेटर से कैसे हो जाती
Yeah,
cross रहती?
I will show you the next slide.
ये अभी पहला कैथेटर, ये भी अच्छा ये पहली अभी वायर, पहली वाली वायर है.
Yeah, you can see that we have the previously placed wire with deflated balloon in the proximal part of the LED.
And you can now see a distal LED filling up.
Yeah.
So after pulling
LED
the
So
wire
you can
back,
see that there is an acute angle the wire is taking.
so अब वायर जब पीछे आई तो अब आपको फिलिंग भी नजर आने लग
Yes.
पड़ी. Okay.
And that view is showing that we are in the true lumen. That acute angle wire was taken, confirmed us that now
इसी में
we
से
are in
अगर
the true
दूसरी
lumen.
इसी में से दूसरी वायर डाल देते तो क्या था? Just curious कि AC कैथेटर में से अगर दूसरी वायर चली जाती तो पिंग पोंग का एडवांटेज क्या था?
Yes, that's the important question.
Just a question. I mean,
They were actually
देखिए आपने बिल्कुल सही किया
extraluminal
ना?
from the
मैं
beginning
just
and
curious myself.
So
afterwards
I
they
will
got-
ask my senior that who was doing the case that he can answer the question. That is the different wire. Cyan blue workhorse wire.
To buy a time
Yeah,
till
it's,
you are having a tamponade at the vessel.
as I mentioned earlier, the covered stand was not going, and so we were keeping the balloon on one side to seal the perforation, and we took the access from the femoral side to gain time. So we were doing not we were not free at that time when we were taking the femoral access. We were keeping the balloon inflated to seal the perforation, and then we took the femoral access.
चलो ठीक. Right, Dr. Wagner. So let's move on. हम आइए. और चलते हैं. It's a very interesting case, Dr. साहब आगे चलते हैं.
So now when we have a wire in the true lumen, so without any further delay, we deployed the covered stand 2.8 into 19 mm, and you can see that there
Covered
is,
stand है Dr. साहब.
that one is the covered stand graft master.
जो स्टेनिंग तो आगे है.
Yes.
तो लेकिन आगे वो जा नहीं रहा था तो जहाँ जा रहा था वहीं हमने डिप्लॉय कर दिया.
No, actually that
जहाँ
one
पे
is the
standing है,
dilemma
वो
that
extra
where
lumen
we
है,
should deploy the covered stand.
then luckily they got
Mostly
back.
will say that we have to deploy the covered stand
second
at
wire है,
where
वो
the
फिर
perforation
center
is
को cross करके true
we
lumen
are
में
seeing.
गया.
But actually the perforation was at the
Actually,
outlet from
जब
where the
ये
jet was
ground
coming
master
out.
लेके जा रहे हैं उससे पहले they should have confirmed whether they are in the true lumen or
Position of
not.
the wire should be confirmed.
Yeah, I
वहाँ पे
asked
बात
this
कर रहे
question.
हैं
He
सर.
didn't
सर वहाँ
confirm.
बात हो रही है.
अच्छा so sorry. I'm so sorry. जी सर फरमाएं.
Sir, I asked a question and I will repeat it. Before taking the graph master, how did you confirm that you are in true lumen or not?
Now or previously? sir?
Before taking the graph master.
So in the previous scenario, you can appreciate that there is a filling of the LED. That one is the important and
Now,
most
even
important slide.
Before that,
Before we were tried to deploy the covered stand, but we were not successful.
because at that time you could have checked with over-the-wire balloon or with microcatheter if that could have
So
gone
patient
through.
was hemodynamically collapsing, so we don't want to take the microcatheter and spend extra time on that.
चलिए,
But
10
then
मिनट रह गए हमारे सो
there
अब
arises
खत्म
a
करने देते
question
हैं
that-
then इनके बाकी लोग भी आ जाएंगे ना so आगे चल लीजिए.
So till the time you are not clear where the vessel, where the wire is, you cannot put in the graft master, isn't it?
जी चले
Okay.
चलते हैं आगे 10 मिनट रह गए ताकि वी कैन फिनिश ना. Okay, अब तो वायर लग रही है
तो
कि
वायर
वेसल
true
में.
lumen में लग रही है.
Now we are.
अब तो वायर ट्रू लुमन में लग रही है.
Yes.
Yeah, now in true lumen ठीक है.
And you can also appreciate that there is a severe diffuse disease, residual disease in the mid to distal LAD. And then we deployed a drug-eluting stent and the residual part of the LAD. And we were having a great TIMI3 flow. And you can see that the perforation was not expanding into the cavity and the perforation was sealed. These are the final views of the left anterior descending artery. There is no any extravasation of the contrast, and that staining was just in the pericardial space. So we confirmed that.
There's some rim of fluid.
Yeah, some rim of fluid in the pericardial space. There was successful sealing of the perforation without further expansion into the cavity. We confirmed that on the echocardiogram after 30 to 40 minutes. And then we took the RCA shot after that, and then right coronary artery showing mild to moderate promiddle disease. So what are the take-home messages? Workhorse valves can occasionally cause vessel injury, so which may result in perforations. Ruptured plaques are thought to be the cause of the STEMI. So workhorse valves should be used cautiously, as wire may cross through ruptured plaque in close proximity to the intima media interface. Although acute collisions are generally considered softer and more navigable, aggressive wire manipulation and dottering can sometimes lead to massive perforation. The operator should always be prepared to manage both rare and common complications, and a prompt response is effective to manage complications such as perforation. Thank you so much.
Yeah, that nicely done. आपके लिए आपके supervisor भी हैं यहाँ पे?
जी, डॉक्टर फराज अहमद।
डॉक्टर साहब, फराज साहब, any comments आपको देते हैं? माइक दें प्लीज। इधर खड़ा रहे माइक वाला।
Thank you very much. A lot of, early morning firing on my registrar.
Yeah, I'm so sorry for that. But it's such an interesting case,
I was just holding on because I really wanted, because our registrar. Yes, they should answer. Actually, the problem where it happened was the wire over the balloon, because the workhorse wire was not crossing the plaque, which led to MI. And that balloon over the wire created the force in the wire, and the force took a pathway. Probably there can be a lot of explanations. Probably wire took a pathway through the ruptured plaque, and it just went on and lacerated the vessel. Initially, the wire was deep into the distal LAD. It was not in the mid LAD. That's why we were kind of assured that we are in the LAD as per the usual anatomy. So that's why the dottering was performed. But probably the mistake was the balloon over the wire, which created a lot of force and tension in the wire. And eventually, because we have forgotten one important point, this was a STEMI case, and the patient was having a lot of ongoing pain as well. And the more we occluded the vessel, obviously the pain increased. In all those heat movements, the wire came back till the mid course and then in the proximal course. But while inflating balloons and while doing dottering, we were kind of assured that we are in the LAD vessel. When we tried to take a cover stent, at that time the wire was in the mid LAD, but the cover stent couldn't cross. And that's why, because there was already a thin rim of pericardial effusion, but still no signs of tamponade. And we really wanted to avoid the tamponade in a STEMI case, because it will be another a challenge to deal with. That's why we thought we should try a covered stent, because if you notice in the initial pictures, the exact thin jet of perforation was in the proximal course. It was not in the mid LAD. It was the laceration in the vessel which was leading to extravasation and other appearances like that. So the main jet of perforation was in the proximal course, where the actually tensed wire took a course and led to vessel injury. So when we failed with the covered stent, So we decided not to, keep the balloon in deflated position. Obviously, we can try a parallel wiring because the vessel was already restorated. I was expecting that the parallel wire, may take some time. And obviously,
डॉक्टर साहब 2 मिनट और रह गए, पैनल्स ने भी बोलना है, तो any special comment?
I think the reason they were using the ping pong was that they wanted to keep the wire in the proximal part and inflate the balloon so that they would reduce the extravasation as much as possible while they were trying at the same time to get another wire, and maybe that will go into the true lumen.
तो वो उसी कैथेटर से क्यों नहीं हो सकती थी पैरेलल वायरिंग?
I think they had inflated the balloon and the wire at that time.
Okay.
So while they were rewiring.
Sure. अब 2 मिनट है जी, 30-second comments from everybody.
So in acute STEMI, one should be really very careful. The wire should cross easily because the lesion is very soft. If you are trying hard to get the wire in, imagine that there is something abnormal, and it should not be, dotted with a balloon or something like that.
Dr. Samra?
Sir, what I have done is always...
करीब बोके बोले please. आवाज करीब बोलिए माइक के.
Sir, mic is not working. To me, always confirm the wire position, then manipulate.
Okay.
I feel the wire. First, the wire has to go all the way through. Try to get it there. If you are unable to get it, use some other wire. Okay, and then I think the wire was not in the true lumen, and you must have pushed hard to. I mean, you cannot just perforate like such a perforation. Just putting the balloon. Either it was inflated in the false lumen, and a lot your wire even in the middle of the case is hanging in the middle, and if you're trying to get the graft master, you cannot get it through. So you salvage the case because you got your wire all the way in the true lumen, all the way down. So that's the key, that your wire has to be in a good position. That's why you salvage the case. If you could not have gotten the wire there, it would be difficult. It would have been a catastrophe. Second thing is that just if you're unable to get through the Dr. Sohail Aziz repeatedly, just put the wire, take a second wire, try to cross it through the same catheter. I don't understand why the ping pong technique that you put in.
Dr. Fawad sir?
I think it's a nice case, especially for the fellows who work on the rotor for primary PCI. Remember one take-home message: if you are dealing with a primary PCI acute lesions, which we presume they are the soft lesions, try to take the wire to the tip of the vessel. If you see the initial few cines, the wire is in the mid-LED. At that very stage, I won't be doing push and pull maneuvers, and I think that exactly happened. The wire is in the mid-LED. We are not sure whether it is the true lumen or somewhere else, and a lot of push and pull had happened, and that injured the wall. Thank you.
Dr. Ibrahim?
In acute MI, because we all know that there is a ruptured plaque.
Doctor, on kar le mic.
एक दफा प्रेस करते हैं.
Yeah.
Bole. In acute MI, as we all know that there is a ruptured plaque or abrasion, and even in our workhorse wires easily go into the plaque, and once you enter into the intima, then the simple workhorse wire also behave like a hard wire, and they can go down even up to the apex in some intimal regions.
So as Dr. Salim rightly explained, that in acute MI, first we have to check the behavior of the wire and the route of the wire as to whether it easily goes to the apex, or at least in the appropriate or the proper way of the vessel, whether that is LED or circ or the RCA. And the other thing is that over manipulation, because in acute setup we can't afford even a minor kind of complications. It's not an elective case. So over manipulation of anything, that is whether it is wire or balloon, that
Sir, 30 seconds, we're behind time.
Sir, very good case and nice save. Probably the wire initially went some small vessel and was pre-dilated, but you were lucky enough that it was not, the perforation was not in the pericardium. So it was, patient was not at any time in cardiac tamponade. And second, always check the wire position. Either the microcatheter or the cheaper version is the over-the-wire balloon. You can have a small injection and can check wire position. Third, there was a complex, bifurcation. There was a diagonal visible in the initial.
Yes.
You could have taken the wire into the diagonal and just dotting, and you could have clarified the anatomy. So, and the last thing is the, better to take the right side injection just before that to have a knowledge of the anatomy before, whether it is a type A LED or type B, or how much the RCA is perfusing. And another thing is to have some knowledge of the LV EDP. Either by some catheter in the LV, you should check the LV EDP.
Great. Thank you, Dr. Saab. Dr. Saab, thank you very much. A great case, lots of learning points here. And great.
Yeah, thank you so much. I appreciate all the valuable comments from the speakers. Thank you so much for giving me the opportunity.
Great. Now, Dr. Ayman Azhar, your case. We're safe at cath lab using IVUS. I think one of the most dangerous things which one of many of us do is when we weaponize a wire. What I mean by that is that if the wire is not crossing and you don't really see it progressing, you push the balloon forward, and then when you push, it will go wherever it can find its way.
Thank you.
Putting it where you need to direct it, it will find its own way. So that is the most dangerous thing you can probably do, especially in acute MI. When your wire doesn't travel, you push the balloon there, and then you make the wire just so stable, just go anywhere it finds. So, a great case, a lot of learning experiences here. While we're waiting, any comments?
So just one brief comment. When we use a balloon over the wire, and we try to manipulate the wire through the lesion, the tip load of the wire becomes unpredictable. So a little bit of push can exit the wire out of the vessel, so one should be very careful.
That's a very good point, because you can use different wires better.
Yeah.
Actually, primary के अंदर तो you sometimes कुछ हो रहा होता है, नजर आता नहीं है, and you're just like feeling your way through. So, okay, Dr. Saab, just take it away.
Assalamu alaikum. I am Dr. Ayman Azhar. I am a resident in internal medicine in 4G Foundation Hospital, Rawalpindi. First of all, a very good morning to you all, and I must say I am very much honored to have the opportunity to be presenting a case in this platform with such prestigious doctors. The primary operators in this case, which I am about to discuss, were the worthy General Sohail Aziz and Dr. Ismail Ahmed Khan. He's in the audience. We had a 61-year-old lady. She was hypertensive and diabetic. She presented to us with 9 months history of exertional dyspnea and chest pain, ceases angina class 3, and she had unstable angina for the last 1 week. We performed an echo which showed 60% ejection fraction. She had normal size LA and LV, normal valves, and good LV systolic function. Her ETD was done 6 months prior, which was positive for ischemia. You can see over here that her labs were fine, her troponins were positive, she was vitally stable. On her general physical examination, there were no significant findings. We performed her systemic examination, which yielded no significant abnormality. Her EKG revealed deep Q waves in lead 3 and non-specific ST segment changes. So this is the gray score of the patient, which estimated actually the 6-month mortality of the patient and basically the risk of death and MI in patients who were admitted with acute coronary syndrome, and it was 104 points in this patient. So we can see over here that these are the videos of the coronary angiograms. These show cranial views, and in these we can see a Jatkin's diagnostic catheter engaging the left main stem. And these cranial views show diffuse critical disease in mid-course of LAD. So these are the caudal views, and these caudal views, these caudal views show critical disease in mid-course of LCX. Okay, so this is the, these are the videos which show right coronary artery. Right coronary artery mid-course had critical disease along with 60 to 70% disease in the distal course of the RCA. And you can see in the last video, the LV sign showed good LV systolic function. We included also the syntax scores of the patients, which decided the revascularization strategy which was to be employed in the patient, which showed 14 points low risk in syntax score 1. Syntax score 2 showed 9.6% PCI 4-year mortality and 2.6% cabbage 4-year mortality. The 2-year all-cause death was 2.4% as far as the logistical clinical syntax score was concerned. So basically, this was a 61-year-old female, diabetic, hypertensive, crescendo angina, CCS3, not responding to 4 anti-anginals. The angiogram revealed the patient had triple vessel coronary artery disease. Her Gray score was 104 points. And now we decided to hold a heart team meeting, and we decided to basically discuss the benefit versus risk ratio of cabbage versus PCI. We took the informed consent from the patient, and the patient was unwilling basically for cabbage. So we took the informed written consent for PCI. And our plan was to proceed with PCI to RCA in stage 1, and we were going to place a 1 drug-eluting stent in the mid-course, and stage PCI to LAD in left circumflex was to be done in the stage 2. The typical basically inventory which is used in any coronary angioplasty, that was our initial plan, but obviously it went a bit wrong, a bit of the complications which occurred, which we'll discuss later. So we were going through the right radial axis, we were going to use GBR French guiding catheter, run through guide wire was going to be placed in distal RCA, lesion was going to be prepared with dilatation with a semi-compliant balloon, then we were going to place a drug-eluting stent, and finally post-dilatation was going to be done with a non-compliant balloon. Okay, so you can see over here in the stills that first what we did was that we placed our run-through guide wire, we parked it in the distal RCA, and we did that via a Jatkin's guiding catheter. The next step was to use a 2 into 15 mm semi-compliant balloon, and we used that to pre-dilate the lesion in the mid-RCA. Now while we were pre-dilating, you can see over here that we noticed there was some staining, and this staining was extending from the RCA ostium to the late mid-course. And while we were deflating, we noticed that it was extending even further. Now, what were the differentials in this case? The differentials were either there was a dissection or there was a perforation, and patient became symptomatic, patient's blood pressure dropped. So our diagnosis or basically assumption in this case was that the guiding catheter had resulted in an iatrogenic coronary dissection. So next step, what we did was that we placed a 3 into 48 mm drug-eluting stent, and we deployed it from ostium to late mid-course. Now, what was our purpose? Our purpose was actually to push the dissected flap against the media and to cover the extending dissection to prevent the further extension of the dissection. But you can see over here in the first and second video that even below the stent, you can see the staining which is extending beyond the distal edge of the stent. And it is extending even more distally in the second video, you can see that as well. Now, what can we do to cater to that? Normally what we would do is that logic dictates that we would take another stent and we would place it further to cover the distal edge. But that is not what we did. What we did was that we went for IVUS technology, and we saw what was happening inside the vessel from inside the lumen. And by doing so, we saved a deployment of an extra stent, and we saved the vessel from becoming a stent jacket. That I'll cover in the last. So after we deployed the 3 into 48 mm DES catheter, stent, we placed a microcatheter. And by placing the microcatheter, our purpose was to see the distal edge of the staining, to basically see the point which was distal to the dissection. Okay. So after that was done, we did post-dilatation with a 3 into Okay, so we did post-dilatation with a 3 into 75 mm non-compressible Trek balloon from distal stent to the osteoproximal stent. And this was done to basically ensure the stent apposition and to ensure that the stent was properly placed. Now in the last stage, what we did was that we employed IVUS and we used IVUS to see the distal vessel, but there was no evidence of any extending hematoma in that case or extending dissection. And the IVUS showed that the stent was well opposed and it was well expanded.
Yeah, I will shall it or not?
Yes, sir. Yeah.
It doesn't matter. Right click करें.
I was working on my laptop.
ये उनका
Yes, sir.
relax.
So what we did was, there's some glitch with the laptop, let me explain it. What we did was that after we employed the IVUS, we reviewed the vessels, they showed that there was TIMI2 flow, and after that we saw that there was some spasm in the distal part of the vessel, and we gave intracoronary nitrates injection at the time to basically relieve the spasm. And because we noticed that the patient's blood pressures had improved, and we noticed that patient was pain-free, and the spasm of the distal vessel had also improved, so what we did was that we decided to take a break. We called it a day. We went back to CCU, we placed the patient on agrostat infusion, and then we decided to restudy and reopen after 24 hours and to see if the vessel spasm, if it had been relieved or not. Okay, so you can see over here that this is basically the slide which is after the intracoronary nitrates injection, and we can see over here that there is TIMI3 distal flow and there's no evidence of the residual dissection, there's no evidence of intramural hematoma, and that is the reason that we decided to call it a day. Okay, so these are basically the restudy images. We decided to reopen and basically evaluate if the flow had been improved or not. And when we re-evaluated the patient, we could see that the flow had been improved. So ultimately, the take-home message from all of this is that instead of employing extra stents, because extra stents, the more the stents increase, the length of the stent increase, the number of stents increase, the adverse outcomes also increase. We have to place the patient on a longer duration of dual antiplatelet therapy. The risk of stent thrombosis and restenosis also increases. So IVUS basically helped us in saving the patient from extra stent deployment. Next thing, which is the take-home message in this case, is the Murphy's Law, that whatever can go wrong will go wrong. So seemingly a simple or a seemingly straightforward procedure like angioplasty had its complications, so we always have to have a bailout plan ready, always have to be on the lookout for these complications and be ready in case these happen. Secondly, always coaxial engagement of the guiding catheter is necessary to prevent the osteal dissections. That is the second take-home message of ours. Always before giving intracoronary injections, we should apply we should basically check for the pressure tracings, intracoronary pressure tracings. Identifying the proximal and the distal edge of the coronary dissection, that is a key to identifying these dissections. And finally, IVUS actually helps us in identifying the extent of the dissection, the extent of the lesion. So it helps us in saving the patient from the adverse outcomes. I'm so grateful for all your patient listening. Now, if there are any questions, I would like to direct them to Sir Sohail.
Do you have any IVUS images with you?
Dr. Sahab, mic mein bol, please.
Do you have any IVUS images with you regarding this procedure?
IVUS.
Dr. Sahab, इनको ना exit करें इसमें से उधर से चल सकते हैं IVUS. Okay, what it doesn't show here is that एक तो पहला view दिखाएं डॉक्टर साहब. Please को play करो. Okay, I think the पहला view था ना, that kind of nobody realized even इसमें भी शायद कि there's an osteal lesion in the RCA, which probably when the guider was engaged or उसके injections थे ना, that is what triggered the whole dissection. डॉक्टर साहब पीछे जाइए. हाँ भाई चले आगे वो right इसके बाद आएगा. अगला प्लाई नेक्स्ट भी नेक्स्ट व्यू हाँ बस ये इसको चल लेने हाँ इसको चल लेने बस इसका राइट के ऑस्टियम पे भी एक लीजन है ना and somewhere around the wiring and all probably that's where the dissection happened. And you cannot see it. और जी बलून के बाद हुई लेकिन अब मेरा जो फीलिंग है कि बिकॉज इट्स सच अ स्नग फिट कि उसके अंदर जब बलून भी इन्फ्लेट किया ना और हल्का सा पफ जो देते हैं ना वहीं पे डिसेक्शन गॉट ट्रिगर्ड एंड डिसेक्शन गोज ऑल द वे डाउन. अब दिस वेरी डेंजरस सिचुएशन के यू नो वेयर डज द डिसेक्शन लीड ऑन टू. अब बताइए कि अभी यहीं से अब यहाँ शुरू कि dissection like this, so what would be a good way of dealing with this? Because any extra injection will increase the dissection, जो कि already halfway down to पहुंची हुई है.
Can I make a quick comment? See, I think guide-induced dissections are almost always iatrogenic, right? So probably didn't pay attention to the waveform in the heat of the case, and you inject it. I think the most important thing there is the fact that it extended is several more images were taken. If you do see a guide-induced dissection, the fundamental principle is to stop taking more pictures. Do not give any more dye. You're going to shut the artery down, or it's going to propagate retrogradely into the aorta. So at this point, really the most important step would be just to take a long stent and go all the way to the ostium. This could spiral further down, and you already see a large intramural hematoma. Thankfully, it's contained because there's an abrupt stop close to maybe 40% in the AV groove. But again, I think taking more pictures is probably not a good idea and would only make things worse.
Yeah, if any further injection will be disaster. Okay, इसमें जो चीज़ें डॉक्टर साहब आगे चले एक और चलाइए यहाँ पर चल don't touch it anymore. इसको राइट क्लिक में चलेगा हटे हटे. Yeah. Okay, these are the IOS images. Doctor, so the IOS images showed that there is a dissection, and after the first dissection, the proximal part was stented, and it was post-drilled. Uske baad there was a lot of disease distally to the stent all the way to the bottom. Usme phir humne IOS ke chal nahi raha. So IOS showed just a thin lumen, and there was a lot of tendency कि उसको भी हम stent कर दें. But अगर आप dissection के ostium पे stent कर दें, the mouth of the ostium is sealed, तो फिर आगे dissection seal नहीं होना, बढ़ेगा नहीं. लेकिन जो when you stent it, तो वो जो hematoma है ना, that gets pushed down distally into the vessel, and lumen कम हो जाएगा, and the hematoma is there. So what we were showing here is that when you do an IOS, you find that there is a hematoma, but there's no dissection. So there's a tendency कि उसमें second stent डालें. But what we did was we just left it alone and restudied. और आखिरी view दिखाएं, डॉक्टर साहब. The next day, इसको चलने दें. Next day, it all kind of the hematoma disappeared within 24 hours. So you don't have to chase the hematoma. The hematoma is going to get resolved. So that is वो IOS नहीं नजर आ रहा और वो जो post वाली नजर नहीं आ रही. डॉक्टर साहब पीछे करके दिखाइए.
Sir, just a comment. When you do IOS in something like this, when you have hematoma and all specifically when it's dye stained, a lot of times your IOS images are very deceptive. They will look like there is atherosclerosis because all that hematoma has a dye stain on it, so it appears shiny like a fibrotic plaque or a fatty plaque. So it's always tricky. You have to sort of combine your angio images with your IVUS images. You know there's barely any disease in the part of the RCA after the stent. So that was probably all hematoma that you were looking at when you did the IVUS, and it wasn't that sort of a disease, because it's totally cleared up now.
Asad bhai, because we knew beforehand that part of the artery was disease-free and nobody touched it, so it had to be the hematoma which was pushed down.
Yeah. And especially the appearance looked like a typical type 2 dissection. It's linear and it's smooth, and probably that's how it cleared up in the next day.
The aim of probably showing this was, beta ona dikhao display chalaoge. Where's the guy gone?
So while he's pulling up the images, again, when you deploy
so
this...
the aim was that if you seal the hematoma, the entry of the dissection, the dissection will stop propagating. Or jitna aap aage usko inflate karte jayenge, the hematoma will keep on traveling distally, and you can't just end up stenting all the vessels, because there is a tendency कि इसको पूरे के पूरे को stent कर दें. So after that initial stent, we left it alone, and the very next day it had healed to the last view, which you will see. Doctor, दिखाइए आखिरी view. And it was propagated because probably the osteal lesion wasn't appreciated to be significant enough, and that injection brought it on. So, जी sir, ये mic दो बेटा.
You know, the real interest is in the picture on which we were convinced enough to shift the patient to the CCU. This is what we really want to look at, if these people can, just correct the problem, because we have got the explanation of the IVUS and other things, but for a take-home message, we really want to see it.
यार इसको चला सकते हो तुम?
Because that is actually the different thing, sir, that you have done, that you shifted
because
the patient confidently.
There was a big debate कि इसको stent करना है कि नहीं.
Yeah, at times some people deploy a smaller size stent just not to let hematoma expand.
इसको play कर
So how you got convinced? So we really want to see it.
आप इसके वो basic पे जाके play कर सकते हो? डॉक्टर साहब अपने flash दें उनको. आपको चाहिए लोड करके देखा करें ना कि सारी वीडियो चल रही है कि नहीं चल रही ना. That is the key जो आप बता रहे हैं ना. So let's have some comments while they can fix that thing.
So dissections.
See, the other important principle has to be, when you deploy the stent, you want to make sure you don't go super high, because you'll keep chasing your tail then. Deploy the stent nominal, don't aim for perfection, and if your plan was already to bring him back in 24 hours, that would be a good time to post-dilate. Otherwise, you'll keep putting stents upon stents to no end. So deploy nominal, don't go crazy, don't post-dilate. Obviously, if the stent is severely underexpanded, you're going to have to do that. But with a hematoma, that is a very important consideration.
Sorry, Hakeem Saab, I missed your comment.
So the comment was, with a hematoma, it's very important to make sure you deploy the stent nominal and don't aggressively deploy it, because what is going to happen is all the blood, most of the blood is contained in the proximal portion where the dissection originally happened. If you were to deploy it, say, at 16, 18 atmospheres, the hematoma is going to go further down and actually cause luminal compromise. It appears that you didn't have luminal compromise, you didn't compromise flow. Sometimes the entire artery can shut down. Then what you end up doing is keep putting more and more stents. There's a lot of blood that's contained behind, and it's really going to shut your lumen down. So, the point being, you just deploy the stent nominal and don't aggressively post-dilate it.
Yeah, this is an issue that if you try and post-dilate it very aggressively, whatever hematoma will further go down. That's a very relevant point. Chalo, Doctor?
So, one question regarding the use of the agrostate. It was necessary to give the agrostate because the post stent there was good flow in the distal vessel. There was no obvious reason to give so much agrostate infusion. So
you can see some very good views here, but it's not displaying on that image. आप ऐसे करना कि जाके ना, because we got 2 minutes, just show के panelists को दिखाइए कि this is the view we left it, which was a real big debate. Because it's very interesting. There are diffuse disease. डॉक्टर साहब इनको भी दिखाना है आपसे. आप लोग देख लेना, फिर इनको भी हकीम साहब सबको दिखाई, यहाँ पे मिगदाद साहब को दिखाई ला. डॉक्टर साहब इनको भी दिखा दे, because 2 minutes more, डॉक्टर साहब.
Can we see the iris?
Just one comment to re-emphasize is that the moment we take the balloon down on the right, so the guide is sucked in. That's very important part where you need to be very careful injecting in through that guide. So I think just what we can do is have a little bit of pullback of the guide so we can prevent that.
I mean, the real question to me is, do you leave this is what we left it, and the next day it grew to a perfectly normal architecture? Is it the Kai Doctor?
So I think so. It's a very nice case and a very nice save, and all the steps were followed in an orderly manner. First of all, I mean, it is an iatrogenic dissection by the catheter. While engaging, or it could have brushed the proximal part. And the important thing was that after the puff, no more injections were given. That was a nice thing. And another, the proximal part was sealed off. And then waited, and then imaging was done to confirm that, and waited again not to put another stent. And ultimately, you got the T3 flow, and the lesion was also covered. It's a nice case.
Thank you, Dr. Yeah, I think that's the real thing. Try not to give injection and seal the ostium as quickly as possible. So I think we're like, any final comments? I'm sorry for the bad imagery.
So just one brief comment. So these things happen when we are doing volumes in the cath lab. So the important thing is to keep your cool. It's not easy when you are doing and the patient is having chest pain and he or she is moving his arms and she is restless or distressed. But the important thing is to keep your cool, and you should keep the guide in, your wire should be there. And if you are having the wire distally, that is the lifeline for the patient. And you can do easy...
Thank you very much for a great session. A big hand to the presenters. Thank you very much. Good luck, Doctor.
Assalamu alaikum and good morning. We are going to start another session which is hot debates in intervention cardiology, STEMI care, which is combined session with Asian Pacific. So first of all, I would request the chairperson to come to the podium. We have some from abroad. They will be joining us virtually. Rizwan Khalid, probably he's virtual. And then we have Habibur Rahman. Then we have Professor Muhammad Ishaq, Professor Khan Shah Zaman, Professor Sayyid Tahir Shah, Professor Mansoor Ahmad, Professor Muhammad Hafizullah, Ghazanfar Ali Shah, Nawaz Lashari, and Tariq Masood. Please come on the podium and take your seat. Our first speaker is Parag Doshi. He's from US. He will be talking to us about non-culprit lesion in STEMI. To do or not to do? Where do we stand? And Dr. Doshi, can you hear us?
Yes, I can.
Okay.
Are you able to hear us? Hear me okay?
Thank you very much. And you can start your presentation.
Okay. Good morning and thank you to all the friends in Pakistan. My talk, non-culprit lesions in STEMI, to do or not, in my opinion, would be that it depends. What's the clinical relevance? So 50% of the patients with STEMI have multivessel coronary artery disease. 40% of them have complex coronary plaques. They are associated with less favorable hospital course. They have poorer ejection fraction, more likely to require bypass or stage PCI, more likely to have recurrent events, and it's an independent predictor of adverse clinical events. So what are the options? Either you do culprit-only revascularization or complete revascularization on the table. And if you do culprit only, what do you do about the next lesion? Either stage PCI as inpatient, stage PCI after discharge, optimal medical therapy, and then stage PCI either with recurrent symptoms or inducible ischemia. So what's the data? What do the studies say? There's so much to talk about. So I'll go through some of the earlier data quickly. What are the guidelines? In 2021 guidelines, which I think are already dated, class 1 indication, the selected patient with hemodynamically stable patient with STEMI and multivessel disease, stage PCI of the non-infarct artery is recommended to reduce the risk of death or MI. Now, recommendation 2B is STEMI with low complexity multivessel disease. PCI of the non-infarct artery may be considered at the time of primary PCI to reduce the cardiac event rate. And I believe that the guidelines are already old. And clearly, based on the data, patient with cardiogenic shock, it is class 3 to perform routine PCI of non-infarct artery because of the adverse data. Why do we only do culprit PCI only? We all know that it is safer. We are worried about procedure complications, time, more contrast, potential of stent thrombosis because prothrombotic state. We really didn't have much data. 2011, actually, one of my colleagues published a meta-analysis and did not reveal any benefit of performing multivessel PCI at the time of STEMI, but clearly more data was needed. So what changed? 2013, the PREMI trial was randomized for preventive angioplasty during myocardial infarction. The patient was assigned to either infarct only or preventive PCI of non-infarct arteries. 465 patients were randomized. Cardiogenic shock was excluded. What is the result? In every single outcome, death, myocardial infarction, refractory angina, and repeat revascularization, preventive PCI of non-culprit vessel was superior. Conclusion, in patient with STEMI and multivessel PCI, preventive PCI of non-infarct vessels significantly reduced the risk of major adverse cardiovascular events. More studies came out. The other important study was Dynamic 3 Primalty. Here, it was after PCI, you did stage PCI guided by FFR before discharge, not on the table. And what was the data? Look at the interpretation. In patients with STEMI and multivessel disease, complete revascularization guided by FFR significantly reduced the risk of future events compared to not performing invasive intervention. And it was mostly driven by repeat revascularization. So PREMI was on-table PCI while DYNAMI was stage. So what about either if you decide to do it doing the same procedure or stage PCI during the same hospital stay? So there was the culprit trial, CVL-PRIT. And effectively, it was measuring the success of complete revascularization for STEMI patients, whether you did it on the table or stage during the hospitalization. And again, 296 patients were randomized. This was done in UK. What are the results? Once again, complete PCI, fixing all the lesions, was much better in terms of mortality, recurrent MI, and the outcomes were better. So now I think we've been convinced that a patient with STEMI, and if there were the lesions, complete revascularization, they're on the table, or during stage procedure is better than doing only infarct-related lesions. What is the new data? So the 4 trials you should know is complete, FIRE, full revasc, and the latest to come out is BioVasc. The complete revascularization trial was again published in New England Journal. It randomly assigned patients with STEMI and multivessel disease who had undergone successful culprit PCI with a strategy of either complete revascularization or leaving the other lesions alone. And then it was a 2-by-2 trial. A complete revascularization was randomized according to the timing of non-culprit, either during the same hospitalization or as a stage. Once again, 3-year follow-up, complete trial showed lower risk of death or MI or ischemia-driven revascularization. What was the conclusion? Among the patients with STEMI and multivessel coronary artery disease, complete revascularization was superior. Very importantly, the benefit was consistently observed regardless of the intended timing of non-culprit lesion PCI, whether you did it on the table or as a stage procedure. FIRE trial was studying the same issue in older patients. And again, here the important point to note was it was guided by FFR or angiography. The results, once again, were in favor of complete revascularization. Conclusion was the patients who underwent physiology-guided complete revascularization had a lower risk of composite major adverse cardiovascular events. The latest one is FFR-guided complete or culprit-only PCI in patients with myocardial infarction. This was also a multi-center trial. We don't have time to go into full detail. However, here it was not shown to be beneficial to perform complete revascularization. Why is that? So there were several criticisms. The event rate was less than predicted. More importantly, only 19% of the patients had complete revascularization achieved. And they also had a higher risk of restenosis, stent thrombosis, and TVR. There may have been selection bias. This probably not representative of other overwhelming evidence that has been seen. Just recently, in December, BioVasc immediate versus stage PCI in ACS trial came out. We have shifted the gears here. Here it is not just STEMI, but these are all patients with acute coronary syndrome as well as STEMI. In the primary outcome, and here every patient got complete revascularization. The difference was, or the study point was immediate versus stage within 6 weeks. It is a 2-year follow-up and ongoing. The results were in favor of immediate complete revascularization. So why do we not always do that? Because severity of the non-culprit lesion may be overestimated. We are again worried about complications and contrast load. So I think we have proven that complete revascularization is good. Should we do it on the table or not? How do I apply the results? What do we do? Number one, do revascularize the patient. Perform it early, if possible during hospital stay or as a stage procedure within the first 4 to 6 weeks. If patient is stable during STEMI, you may do non-culprit, but decide based on the patient and lesion. Your culprit PCI should be simple. You should be dealing with other major lesions. You should not be fixing a 70% diagonal at the time, for example. Renal function should be reasonable. And then cardiogenic patient and dual culprit, if you have 290% lesions and you don't know which one is, then that is reasonable. And other important point is don't leave the CTOs behind. Studies have shown that complete revascularization, including CTO, is superior compared to leaving them behind. I think I concluded in time.
Thank you very much for the nice talk, and it was very comprehensive. And we have time for comments and questions. Please stay with us, Dr. Doshi. Any comments from the panelists or question from the audience?
Yeah, can I just make a comment?
Yes.
Yeah. I think the decision of addressing the non-culprit vessel varies from person to person and from the individual, depending upon the clinical scenario, hemodynamic status, and the amount of the contrast used in a primary PCI for the culprit vessel. And because, as you have clearly said, that there's a vasospasm element is there, so we may overcalculate any lesion in a non-MI producing artery when we take this decision. And moreover, the clotting cascade is so much active, so I suppose that this decision should depend upon the operator, the patient's overall condition, and the severity of the disease.
Very interesting topic and excellent presentation of the, mostly it was a meta-analysis of different trials which we went through. One thing which I got the message is, and that's what we have been doing up till now, please correct me if I'm wrong, that people who are in cardiogenic shock, patients who are in cardiogenic shock, we should only do the culprit vessel and come out. And patients
completely correct.
Sorry. And patients...
I apologize. Complete. The data is suggestive of only doing the patient in cardiogenic shock and culprit vessel.
Yes.
Unless you are not clear that which one is a culprit. You have a global systolic dysfunction, diffuse ST depression, and you have a 99% LAD and RCA. You do both. But outside of that, yes, only culprit vessel in cardiogenic shock.
Sure. And the other thing is when we do the PCIs, especially primaries and in patients who are in cardiogenic shock, if you are suspecting one of the vessels which is a culprit, you do it and you wait. And if the patient doesn't respond, or the patient is on the table and you are there, and then you take some time, and if the patient is not responding, you can do the other vessel if you think that that is also a culprit. This is what I think should be done. Thank you.
Thank you very much for a very informative talk. I think as Professor Shah Zaman has pointed out, every patient is different, and clinical
scenario changes from cath lab to cath lab depending upon availability of infrastructure and hardware and expertise and whatnot. Complete vascularization is ideal if possible, but as we have already mentioned, you have to keep in mind the safety, the renal profile, and the clinical state of the patient is very important. In our setting, I think we have to modify all these rules and guidelines according to our available circumstances and facilities. The culprit vessel, of course, has to be dealt with, and staging is important, but in our setup, once you lose the patient, when the patient is discharged, most of them don't return back for their follow-up or for stage of procedures. So in our setting, if we can do complete revascularization, that makes a lot of sense and also economically very appropriate.
Thank you.
Sorry, I would like to just comment on Professor Saab's wordings. We cannot change the rules of the game by saying that the patient will not return. That is a totally different affair. And that has to be discussed, I think, separately. We have to follow the rules of the game.
Thank you very much for the kind comments, and thank you very much, Dr. Doshi, and you can stay with us. We have next, we will be, the sixth case will be presented from Sindh Institute of Cardiovascular Diseases. Dr. Gayan, you have 5 minutes. You have to present your case, and then there will be discussion by the audience. And
Assalamu alaikum, good morning. I'm Dr. Gyanchand. I'm assistant professor in SICVD.
On the table decision.
So this is the whole diagram of our satellite centers in Sindh. In 2024, we have treated 1.7 million patients in all of our satellite centers. Hyderabad, Sakhat, and Mohammad Khan, Ladkana, Nawab Shah. So we are very busy cardiologists. We have 28 chest pain units across over the Sindh. So in our all chest pain units, we have 376 patients. Out of we have 8,800 patients are ACS, and that's shifted to our satellite centers for the coronary intervention. So one of our satellite centers in NICVD is SICVD Mithi, very far away in Tharparkar. So we are covering whole of our Mirpukhas division. So we have a patient, the 57 years male patient in the emergency department by the passenger on the March with the collapsing status, the ongoing VT fib. Patient with the cardiogenic shock, so CPR done for more than 30 minutes, intubated, ventilated, and ECG was done that shows the extensive ventricular AMI with CLIP 4, and patient was taken to the cath lab. Sorry, this is my backup slides. My EVI is not working, so I'm going through my backup slide. This is the coronary angiogram of the right system and the left system. So this is all. What should I have to? Yeah.
This is the coronary. This is the team, the Sindh Institute of Cardiovascular Disease have shown their case. and they will, the PIC Lahore, they will comment how they will do it. And after that, their comments, the Sindh Institute of Cardiovascular Disease will tell us how they have done.
Doshi, I hope you are with us right now. And the rest of the cardiology team, may I request PIC cardiology team to kindly come up and take their stage over there. With me is I am Professor Viral Mohiuddin, currently the Executive Director. And with me are my 3 colleagues from PIC. So as you could see clearly over here that this person, Dr. Suleiman, Dr. Wali and Dr. Matiullah, they are with us, my 3 assistant professors. The reason why I had them over here was because they have been doing a lot of primaries and a lot of such patients in our labs over there. So could you anyone please pass on the mic to them? They have it? Great. So these are the vessels. As you can see, the patient has got a triple vessel disease and an extension. And on top of it was in a cardiogenic shock. A massive CPR was conducted. Patient was ventilated and then heroically shifted into the cath lab. There's always a challenge to do such things. And though, of course, this gives you something, of course, they did a LED because unfortunately these views are there, but you can see there is a disease in the left anterior descending artery. Now, which to the house is the question is, do you think is the culprit vessel? The first question. Which is the culprit vessel?
As the patient had anterior wall, the patient presented with anterior wall MI. So the culprit vessel seems to be the LAD, which has been addressed. As we can see, the patient presented with the anterior wall MI and cardiogenic shock, and CLIP class was 4, I think. So in this case, LAD was the most likely culprit vessel.
Any lead from the ECG?
Sorry, we don't have the ECGs with us, but the ECGs were basically showing a bizarre pattern. As you remember, he was in VT VFib when he landed in the emergency department, and they conducted a massive rescue operation at that moment. So, first of all, which is the culprit vessel or vessels? Because over here, when you look at the RCA, you can see a tight osteal disease, and we are all very well familiar with the fact that RCA has a... So now, because the first question always is, which is the culprit vessel? So if for you the culprit vessel is LAD, and you say that you will go ahead and do the LAD angioplasty first?
Yes, I would like to go with the LAD angioplasty first. If the patient is hemodynamically stable, we can go for the other vessels, but ideally it should be done as per the recent study that should be done in hospital.
And in terms of the complete revascularization, how would you like to proceed with the complete revascularization?
And during the same hospital stay, we would address the culprit vessel first, and in the same hospital stay we can revascularize
How would you do it?
vessel.
How long would you like to wait? Dr. Mati, would you like to comment on it? How long would you wait to go ahead with the circumflex or the RC at the same setting, or would you like to wait?
As the patient is in cardiogenic shock, and if not response to the LED stenting, then we have to do the other vessels as well, because if we don't do the other vessels, we can see that RC is also is diffusely disease actually in the mid part as well as the distal portion. So we have to do the other vessels in the same hospital stay within 24 to 48 hours if we can see the patient is not responding to the treatment.
Right. So from team PCI, the opinion is that we'll be probably be going immediately for the PCI of the LED, and then within the, if the time over there permits and the patient's strategy is such, then we'll bring the patient back within 48 hours, do the other culprit vessels, if time and his renal profile and everything permits.
Thank you so much, Professor Bilal Muhyiddin and the team from PIC. And now we'll see how the operator actually managed the patient, and he'll take us through the procedure.
So patient with cardiogenic shock, STEMI, anti-oval MI with LED TIMI2 flow. So we have only fixed the culprit vessels, the LED with the direct stenting and post balloon, and this is the final result. So patient back to the CCU, remain intubated and ventilated for 3 days, and patient extubated successfully, and patient got discharged. So again, same patient, after the few days, came with history of the severe chest pain. So again done the angiogram. This is the left system. You can appreciate. So we have fixed on that time only left circumflex, and we are come out. Leave the RCA alone. So we have another case. Also, no, not the RCA.
Question to the House is basically that would the House consider this a proper full job done just after this presentation of Dr. Doshi over there also, that there is plenty of disease in the RCA, which is a dominant vessel. So, and it has its own potential.
RCA seemed to be co-dominated on that time, right? You can appreciate that left circumflex is the larger than the RCA.
So how many of you would consider RCA as co-dominant, or how you would consider this as a dominant? May I request
another one is the RCA is the diffuse, ostium, mid, distal.
It's a very large vessel.
So we can have comments from one or two of our worthy panelists, because we are a bit short of time.
I will start. It's sometimes it's a dilemma to decide about the culprit vessel in a STEMI patient most of the time. And what we see in this case, LAD is having a sluggish flow. So LAD is the culprit vessel. So one should go for LAD fixation first and then consider other vessel. Then another important thing is whether you have to put MCS or without MCS in such cardiogenic shock patient. So in our setup, most of the time we don't have anti-aortic balloon pump, or impeller device is not available in Pakistan. So we have a poor main impeller device or intra-aortic balloon pump, which is dual inotropes, norpine and dopamine. And if you start earlier and give proper diuretics cover, you can be very quickly recover this type of patient of STEMI with LAD lesion.
I think there is no any role of IABP now currently in guideline is data shows is the class 2B IABP. Whatever, in my last 3 years experience, I never used IABP in cardiogenic shock or whatever. So in my practice, I have totally skipped IABP right now. No role of IABP. You have to open the culprit, come out.
I would submit that if you are in doubt and you are not clear about the culprit vessel, and if possible, you should go for complete revascularization. That will be a good option, you see.
Thank you.
So
I
we
think
have about 5 minutes.
If I can give a comment on that,
we have 5 minutes.
Let's remember that stenting does not guarantee that the vessel will remain open for a long time. Remember that there is always restenosis and occlusion rate of 5 to 7% over a year. And if you do not have contralateral vessel going, the patient will collapse any time. So I think it's very important. And RCA was not really non-dominant. It was at least co-dominant. And it was at least a 3O vessel. It's nothing less than that.
So the debate is about whether the RCA and circumflex should have both been attempted at the second, on the second occasion, or at the same time?
I think both should have been done at the same time.
Okay.
Yeah.
What was the EF?
EF.
Patient when discharged, the EF was done, that shows the 30%.
So with that EF, you definitely need a complete revascularization.
Yeah.
Or maybe not in one sitting, but you should definitely consider it.
Yeah. So any other comments, and then we'll move on to the next presentation. Anybody else wants to? Yeah. So, I mean, I don't know.
Yes, I have done. We have done the LV gram on that time. We have not put this slide in LV gram, and that was a high EDB on that time, right? So I think no any role of the high BP, whatever the EDB, you have to open the culprit.
And what was the RCA after you do the angiogram again?
The same disease. Likely that was the spasm and the ostium.
RCA.
We have done the second angiogram. We have done with the nitrates. The ostium is clear out, right? The only mid and the distal disease RCA was appreciated on that time. In the second time.
Thank you, sir.
Okay. Yeah. Yes, Dr. Haroon, you wanted to say something? You have half a minute. If you can complete the RCA angioplasty in that time.
So this patient is a high-risk patient anyway from the start. Number one, it is a 3-vessel disease. Number two, the patient was in cardiogenic shock. And I think it was wisely done, wisely chosen to do LAD first. And when you go into the second session, then you should do complete revascularization, because then you have the time. And if you leave the patient with a 30% ejection fraction, especially in the second session, you are leaving the third artery as well, you may get another catastrophic event. And then you might not be able to do anything. Thank you.
Okay. Okay, so, जी डॉक्टर साहब आप बताइए. Okay. So by index hospitalization you mean within 3 days, 5 days, 7 days? What's your time period?
Within 3 to 5 days, sir, of the initial admission.
Okay. Any fine? Ji Bilal.
After the 15 days of the patient.
That was done for angina. That
Yeah.
was not an elective procedure.
No.
So since the second...
Patient came with history of the chest
Now
pain.
again, we do not have a clear answer saying that whether this... Because of course your LED is now well preserved,
Right.
but now you still don't have an answer saying that was this a circumflex lesion causing the problem or the mid-RCA lesion causing the problem. So the second time, if it was just a planned intervention, it would be a different story. Then you could have decided that, okay, this is what I would like to do. But when a patient is coming back, and as you have said in the second angiogram, there was a right disease also, and there was persistent and at least a co-dominant vessel. Thus, if it is a co-dominant vessel, then all the more important, then both these vessels need to be addressed too. So
The second time we have done the angiogram of the RCA, we have cleared out the ostium of the RCA with nitrates. That's going good. So only mid of RCA seemed to be moderate to severe on that, right?
Right, because
so
the RCA from ostium right up till the point of bifurcation is just
from the
a
mid to
conductive
distal.
vessel.
Yeah.
And that is why it roughly remains the same. On the other hand, the real part of the RCA is afterwards, after the crux, where the real RCA feeding part starts. So that is the whole idea of this discussion is you have done a fantastic work, you got the patient out, you saved the
I
patient.
think should have to done.
But this is a discussion.
But we are waiting for the...
Can I make one comment?
Yeah, Doshi, please do.
So this is Parag Doshi from Chicago. So
Yes.
I think we just discussed the importance of complete revascularization. And the fact that this patient came back with ischemia and you had to do another stent is actually considered a negative outcome, because that is one of the, that's part of the MACE in majority of these studies. So it effectively proves that complete revascularization should be done in STEMI patients, whether during the index procedure or early on as a stage procedure in the first few weeks. So I think that the point that you have to do a second procedure itself actually proves that complete revascularization is important for patients with STEMI and multivessel disease.
Thank you, sir. Thank you very much for your kind comments, and in the sake of time, we'll proceed And the next presentation is by Professor Miqdad Ali Khan. He needs no introduction. He's, an authority on intervention, and we all benefit from his useful postings and his updates. So, without any delay, I'll request Professor Miqdad Ali Khan to do a presentation, and his topic will be "Should late STEMI PCI be done?" It's a topic which is close to everyone's heart, and I think he'll answer a lot of lingering questions. Thank you.
Thank you very much. Good to be here. I have an interesting topic in the way we talk about ethics all the time, so I'll be touching on that as well. So if we look at all the data, there's no question, no ifs and buts. Acute MI, primary PCI, pretty straightforward, very well established data. You look at Korean data on the left, you look at the French data on the right. Morbidity and mortality is totally different between the two groups. So that's a clear thing, no discussions about that anymore. So if primary PCI is that good, why don't we do PCIs for every MI? And SWIFT is a should we intervene following thrombolytic therapy? This is an older study, but it's still pertinent in today's practice. This is 800 patients post-lytic randomized to medical therapy as well as versus PCI, and the 12-month mortality is actually no different. So one may say, hey, this is an old data, 1999, it's not relevant. I'll show you data that shows that, yes, it's relevant even in today's practice. The infarction rate's the same, no difference. Left ventricular ejection fraction, we argue with the patient that, yeah, it'll get better, but that's no different. So late PCI, what we call as miscrowd. And the miscrowd actually, as a cardiologist, how often do we see patients coming to us with different opinions saying that, oh, Dr. So-and-so was saying that get a PCI, it's good for you. And you are saying that it's no good, so what's the rationale? And I'll show you some confusing patients there. Confused patient there. So if you look at 2021 guidelines, pretty straightforward cardiogenic shock, we talked about it, heart failure, class 1 indication, either PCI or CABG, no ifs and buts. Look at the timing when I present, because the ACC guidelines have a newer change in 2025 a little bit. And we'll go through the appropriate use criteria there. So ongoing ischemia, heart failure, VT, VF, PCI, 2A. Symptom onset 12 to 24 hours, PCI 2A, fine. Folks who have MI with totally occluded artery and no symptoms, don't do it, class 3. So then there's a question about, one of the guys would say, okay, let's get the viability study, see how does it go. And how about are we following the guidelines when we see a patient? Is it really based on the updated data on 2025? So let me give you some scenarios, how things have changed from 2021 to 2025 guidelines. Could I have my slides, please? All right. All right. So this is a CABG patient with inferior wall MI and had lytic. It's visible here, but it's not visible. Okay. And he's having 4 hours of chest pain. So after 4 hours, an ECG is done, but look at the wordings. Chest pain is resolved. So this person is asymptomatic, but you get another ECG and the ECG is actually unchanged. So there is still ST elevation. So how would ACC grade it? So this is a RCA graph that's open, balloon stented, good results. what is the ACC guidelines, what appropriate use criteria. So this is more of a salvage rescue PCI. According to ACC guidelines is 2A. And this is 2021, and the 2025, the AUC is 9. So it's very important to open this artery according to 2025 federal guidelines. And it remains 2A from the prior. So not much change there, but AUC is improved. Let's go for. So this is based on REACT trial, which is the rapid artery action trial and rescue trial. 90 minutes, reduced mortality, reduced revascularization, lower MI, and lower MACE. So this is a 45-year-old smoker, infraposterior wall myocardial infarction, 48 hours earlier, received lytic therapy, having somewhat mild chest pain, transferred to another hospital as part of invasive therapy. You can see the ST changes there. This person is brought for angioplasty, circumflex is open. What does the ACC say there? Well, it's a 2B classification. Look at the AUC. And this is how we should address the patient that, yeah, this is going to make so much difference. And the appropriateness is still better, so do it. Mild post-infarct angina. How about this 40 years old young man with anterior myocardial infarction 48 hours earlier? Look at the timings. The whole thing is late STEMI PCI. And earlier who is transferred to your hospital for invasive therapy, he is totally asymptomatic. STs are still high. Coronary angiography is planned for next morning. He is loaded with ticagrelor, and this is what you see. How many of us will say, well, it's a very doable angioplasty. Why don't we try it? We have nothing to lose. Look at the ACC guideline. It's a class 3 indication. You're not doing any good to the patient. In fact, it may be harmful. Look at the appropriate use criteria. 1, you are not making any difference to the patient other than making few extra bucks. Why do we say that? If you look at the occluded artery trial, again one may say, well, these are old trials. What are you talking about? Still duplicated in today's practice. This occlusion criteria, look at heart failure, VTVF, left main 3, these are excluded. So this is not pertinent data to folks with multivessel disease, with a heart failure, with VTVF. So 5-year rate of primary endpoint, no difference. 8 years old data, follow-up, no difference. How about the discussion regarding the, oh yeah, we are improving LV ejection fraction. No LV ejection fraction improvement. This is the TSCA study. This is a Canadian study, TSCA 2. You can see 1-year follow-up, systolic volumes, diastolic volumes, ejection fraction, no difference. So angiographic difference does not portray into clinical difference, and there is no difference in composite death, reinfarction, or heart failure. This is a very interesting Belgium, it's a case report, and this very interesting thing. So this is a 74-year-old diabetic gentleman who had epigastric pain, took a week earlier, took antacid and got better. No symptoms currently. He checks with the primary care physician. He looks at the ECG, there's QV1 to V4 with ST elevation, and he refers it to a cardiologist. So being a good cardiologist, as old-timer, we all thought, well, open artery is the best option. So this guy is a believer in open artery. He goes ahead and he opens the left anterior descending artery. If you look at the angiographic results, see the diabetes improve, see the LADs improve. Well, what happens? On third day, he drops dead. This is the post-autopsy. And when you, third day post-mortality angiography, see, what you have done is you have trashed the microcirculation. So instead of you doing something with good intentions that, yeah, I'm going to open the artery, it's going to open artery, he's going to be doing well. Well, what does ACC 21 say? They say don't do it. Class 3. How about February 2025. With the current data where we say, oh yeah, we use agrastat, we have better stents. We always see people talking about on our forum on cardiology, oh, thin strut stents, so this or that. No. Look at what the ACC is saying. All right, 55-year-old woman having atrial myocardial infarction 3 days earlier. Remember, look at the timings there. Patient's heart rate tachycardic, blood pressure is low, she's on dopamine, and she's transferred to a major hospital. She's in failure. All right, so STs are up, LAD is done. What does ACC say? Well, ACC terms it as class 1. How about appropriate use? Very pertinent. This is cardiogenic shock. Go for it. Culprit only. This 1990, this is a very interesting case. You could talk about that case for 4 hours. So many pertinent things. That interesting case from Sindh, but we didn't get time. Anyway, in patients, look at ACC 2025, irrespective of time of symptoms. So here you don't look at the time. 1 day, 2 day, 5 days, go for it. Another acute MI patient, VTVF, timing, this is done, LAD is done, class 1, ACC, appropriate use criteria as 8, ACC terms it as 2A. I'm going to, this was an interesting case regarding the viability, but since they're short of timing, we are not going to spend time on it, but look at the different opinions we get. All I'm saying is that when we see patients, they're very confused at times because we have given them 50 opinions. Somebody says, yeah, do it. Somebody says, don't do it. Somebody says, go for bypass. Somebody says, no, do just the medical therapy. And especially this more common today, in today's practice, than before. And I would just finish with the stitch data, still pertinent. Robert Bono, who is a really godfather of viability, and we go by that, but viable myocardium, irrespective of what you do, they do much better. I would finish, my time is finished. Thank you very much.
Thank you very much, Professor Miqdad Ali Khan from RMI. He showed us the evidence-based medicine behind late STEMI PCI. And now we are a bit pressed for time, so we'll move on to the next case presentation, how would I treat, and the case is going to be presented by WIC, Wazirabad Institute of Cardiology. Dr. Sahab, aapka naam? Dr. Hamid will present the case. You have 5 minutes to present, and then we'll have the...
Professor Nadi, just a quick question from Professor Miqdad, if possible. Is it possible?
No. Afterwards.
Hello, Assalamu alaikum. I am Dr. Amir here from WIC. Yes. Today case is 49-year male, smoker, hypertensive, presented to our emergency for chest pain for the last 2 hours. ECGs were done. He shows anterior MI, and there with the presenting blood pressure of 90 systolic, and there was bilateral cracks. The patient was candidate for the primary PCI. So after the emergency management, patient was shifted to cath lab for the primary PCI. And her angiography shows, his angiography are done, and it shows right system. There is severe disease in the mid of RCA, and also distal disease in the PD and PLV. The angiogram of blood system shows LMS is normal, but there is critical osteal disease in the circumflex, and also LAD is totally occluded. The primary PCI team decided, sir, case is still there. So the primary PCI team decided to fix the culprit vessel. One wire was placed in the LAD, another was placed into the circumflex. The lesion was pre-dilated to 12 balloon, and after the balloon dilatation, there was 2 options. because there was a critical disease in the ostium of the LAD, circumflex of, and there was a total LAD occlusion, either to lift the patient for the cabbage or to do the bifurcation stenting of the LMS to LAD and circumflex. But as the patient was in impending shock, so our primary PCI team decided to fix the LAD first. So after the pre-dilatation, the mid-LAD lesion was fixed with the Onyx 318 stent, and the proximal was fixed with the 3.522 Onyx stent. After the stenting, the carpet vessel was fixed, patient symptoms was improved, pain was pain-free. So the primary PCI team decided to left the case here and left the circumflex to be addressed later on after patient is further stabilized. So the question is how we should treat this critical circumflex at the follow-up.
So for the debate, I'll invite Dr. Qazi Tufail, well-known interventionist from Sheikh Zayed Hospital. He'll, give you his views about treating the case.
I am Dr. Qazi Tufail from Sheikh Zayed Hospital, and the case is presented 49-year male with acute anterior wall MI, and the angiography of this patient was, this is the RCA, and RCA is a calcified vessel and tight mid-stenosis, and PDA and PLV has tight osteostenosis. And the left system shows the left main was normal, and LAD has total osteal occlusion with fresh thrombus, and circ has tight osteostenosis. And this is the angiogram. No doubt it's a triple vessel disease and clear cut. If it's an elective case, this is no doubt it's a cabbage case. But in case of acute anterior wall MI, it is a very tough call. And I was on call, our institute is on call. Then how we will proceed? There is a debate. Should we multiple option? If I am in a cath lab, the question comes in my mind for decision management decision. There is an option, send the patient for cabbage. Number 2 option is give SK, then send for cabbage. Number 3 option is over to LAD and then send for cabbage. Number 4 option is go for a single stent strategy. Stent from left main to LAD and DEB to circ as a stage PCI. Number 3, stent from left main to LAD and tap stent for circ as a stage PCI. Number 4, go for a 2-stent strategy, either DK crash, mini crash, culotte or V stent. My decision will be, because it's a acute anterior wall MI and primary setting, you have not much time to decide. You have to decide on this straight way, and you cannot, no option to go discuss someone else, and you have not manpower, you cannot delay. Then I will not go for cabbage due to many local logistic issues. All of you know how our cabbage will be done. Number 2, I will not go for a single stent strategy because the literature doesn't support, and there is a risk. It's a fresh thrombus in the LAD ostium. The plaque can be protruded into circumflex. If circumflex occluded, then there will be a disaster. I will not go there. The third option is I will go for the 2-stent strategy, and 2-stent strategy, DK crash, mini crash, culotte, all are the good options. But I will go for the culotte technique because I am comfortable with this technique in the emergency situation. And for my plan for the culotte for this patient, I will take 7 French guide, and I will take wires palette 50 and run through, pre-dilate with 2.5 the both vessel, and I will do first stent from left main to circumflex 3.5 into 22, then part the left main with 4.5 into 8 NC balloon, and then recross the LAD and open the struts with 2.5 balloon, and the second stent I will go from left main to LAD with 3.5 into 22, and I will do kissing both circumflex LAD with 3.5 at 8 ATM and final part with 4.5 into 8 NC balloon in the left main stem. This will be my plan.
Thank you very much, Dr. Qazi Tufail, for your views on how to manage this complex patient in the acute setting. I think we are a bit pressed for time. I mean, obviously, there are more than one ways to skin the cat, and of course, everybody can, chip in with their technique, what they would use, and whether it could be a single stent or, with a dab on the side. So what we'll like to do is to request Dr. Hamid to show us what he actually did, and then maybe we'll have time for one or two questions, and we can ask Dr. Miqdad if Bilal wants to ask something.
As Dr. Qazi Khalid said, that we should go for the upfront to stent technique. But in this case, LAD has been already addressed. Now the patient has come for the critical osteocircumflex. So we have to change and plan according to this patient. Yes. When the LM is fixed, then we have the 2-3 options. Either we should tap for the circumflex and then the pot. But after carefully viewing the scene, we can see that there is only 3 to 4 millimeter of stent placed in the LMS. So as per our NC balloon size available, we have a minimum of 8 millimeter length NC available for the pot. So we have not the option of the tap. So we decided to proceed with the culotte technique. One wire was placed in the circumflex, another was placed into the LAD. The lesion in the circ was pre-dilated with 2 into 12 SC followed by 3 into 12 NC. After the lesion preparation, the stent and circ the lesion in the circ was addressed with a 4 into 26 onyx stent from LMS to the circumflex. Then after that, the LAD was rewired, and then pot was done with 3.25 NC in each LAD and circumflex, and after the pot, LMS was addressed with the pot of 5 into 8 NC. And this is the final results of the lesion. Thank you.
So, the worthy panelists, if anybody would like to...
Yeah, I think a very interesting case and pretty well done, really. But how do you know that your LED stent, was it really hanging in the left main or not? And if not, then do you expect any space left without the stent? What do you think? I mean, you have done a good job, forget it. Now,
sorry,
what do you think about that? Is it possible?
Sorry, sir, can you repeat the question, please?
Was there any LED stent hanging in
Yes,
the left?
yes. LED stent was hanging into the LMS. Database, we decided to proceed for the tap.
So, in effect, do you think you crushed that stent or not?
Sir, I think the stent in the osteomalady patient has come after 2 weeks of the initial stenting to put a wire into circ behind the studs and crush. It was a difficult, challenging then to go for the culotte in this case.
Okay, but a good job done.
Thank you, sir.
Anybody else with any questions regarding the actual case? I mean, obviously, this is left main stenting now, and, we need imaging to optimize the, the stents and to get a good long-term result. So, there are...
Well, since imaging is not there, let's not even talk about it.
Sir, we have the limited IFS. Yes, I want to ask one question for my learning. We have the maximum stent of 4 and maximum NC size of 5. I have picked the maximum size stent and the maximum size NC. So due to our logistic issues, we decided to save the IFS for further cases.
Well, in this case, you see, as far as your maximum size in your own cath lab inventory is concerned, currently you have balloons of 5 and 5.5 and even 6 available. So actually it is to get and the cost difference is nothing, it's the same cost. So what you need to do is that probably over here, before starting off with your second PCI, what you could have considered was that since there was this possibility, as pointed out by Professor Masudo there, that your left main stent may be hanging. So you could have considered doing first a post-dilatation on that point, get a 4.5 or a 5 balloon, post-dilate it, make sure that you are well approximated, and then you start your intervention of the circumflex. Because if you are not actually well hanged, well placed in the left main, there is always a possibility that you may go behind the left main stent, then cross, looks everything okay, and even you may damage the stent, not realize it. And that's where the imaging really helps you out.
I mean, the problem is that, as you said, that you use the maximum size stent and the post-dilatation balloon, but that still doesn't, equate to the fact that, you need imaging for proper sizing and to see the final result. But as, our worthy Qazi Tufail also mentioned, I mean, there could be a debate about why not to do a culotte or a DK crush as a, the index procedure rather than following it up, which probably might have made your life less complicated and maybe given a better long-term result. But then it depends on the logistics, whether you want to, take on a patient in the middle of the night with the complex procedure and end up with a disaster. So, these are things which can be debated in our setup. And I mean, yes, Colonel Mujib Saab, yes. Mike to bhai. Colonel Mujib Saab is, mashallah, one of the most senior operators here. And
yeah, the thing is that whatever you see angiographically, whether you put in a 2.5 stent or 4.0 stent, at the end angiographically picture would be the same. So you will not find any fault. In this day and time, I think if you have a bifurcation, main stem disease, and particularly involving a dominant circumflex system, it is not good idea to do it without an IVUS. That is what I feel at this time. If you are taking too big a risk and you got no idea how you are crowding the stents and what is the status inside, and you are taking a lot of risk, I'm afraid.
Yeah, I totally agree with that, and I think that in this day and age, with especially in a teaching hospital where you have imaging facility, whatever IVUS you have, you don't need, really a very high resolution, but you need to really optimize your result, otherwise you will not get, the results which you want. I mean, one can debate whether culotte is better and whether DK crush is better in this situation, because both branches are of the same size, and, maybe culotte is slightly user-friendly, but then there are problems with the side branch restenosis, which is slightly higher than DK crush. So there can be, options about the technique, but I think almost most of the experienced operators here would agree that it should have been a, one-go procedure where you should have taken on both the vessels in the same go. But
Nadeem, I agree with what Mujib has said. There has to be some minimal criteria of stenting left main that we have done an appropriate job, other than just overexpansion. So I think for left main, we have to adopt a strategy where we should be safe and clear that we have done the right deployment. So IVUS, I think, is important. Yeah, that's right. Exactly. Yes. And the visual impression can be very deceptive.
We shouldn't be satisfied whatever we've been doing 5 years, 10 years behind.
Thank you.
Any comments from any of the worthy panelists regarding this patient, or any questions from Professor Miqdad?
I think nothing succeeds like success, and they had a good procedural result, but it's very, very difficult to imagine that you have a stent in LED and then you put another stent from left main stem to circumflex. Very, very bold to do it. very bold. It takes a lot of courage. And of course, there will be an area between the left main stem and LAD which will not be covered. And that is the area which is the big concern for the operator, and that should sort of steal your sleep for the night as well. But anyway, it was done in good faith and good, but I think one should be more careful in doing a thing like that. Operator.
Yeah, I mean, yes, and of course there is, with the recently implanted stent, you are, liable to even cause disruption to the elution of the drug, and with late side effects as, restenosis. So, I mean, most of us here, we would agree that if the operator was able to manage, then maybe it could have been a single, procedure which should have taken on both vessels.
So I think all the points are very well taken. I'll just add one thing. When patients presented to a place and they know that you have just 3.515 NC, don't do it. Just do plain angioplasty. Send the person to the right place, have it done in a right fashion, rather than, oh, I placed 3.5, but I dilated eye with 3.5 because I had just 3.5 balloon. That's not, that excuse should not be used. Secondly, we always say, yeah, class 1 indication imaging, class 1 indication imaging. That's very good if I'm working in my MSU place, beautiful. But when you're in Pakistan, there are places where the patient can hardly afford one stent. And you are doing a complex case like that, and then you talk about IVUS. Thirdly, I will say, in acute MI, time is crucial. So doing a complex case like a DK crush or some other exotic procedure, make sure you maintain the flow in the culprit vessel initially. So I would not try a DK crush in this case because you just established the flow. This angle is more than 60. If the need comes, go ahead, do a tack, do something, but don't waste time by crushing a stent into circ, which you cannot cross, and you are doing kissing balloons and parts and kissing balloons and parts and wasting your time. So those are a few things that need to be kept in mind. Thank you.
Thank you so much. We ending the session now because the next session is ready. So thank you very much, worthy panelists, for your input.
Thank you.
And Dr. Jabbar for conducting the session.
Just I wanted to say a few points. MashaAllah, everything done very well. And what we have listened to Dr. Miqdad, we endorse it. But one thing where in the situation in which we are doing our PCIs, like without the imaging available, I think 2 points need to be addressed. One is that whenever you have done a bifurcation like this with 2 stent strategy or even with 1 stent provisionally, if you don't have the imaging, as Dr. Suhail says most oftenly, that you should take a big balloon and you dilate it as much as possible in the left main and give an injection of the contrast. If nothing passes through, it means you have post-dilated it very well. That is very important. The other thing is, especially if you have done left main without imaging, then bring back the patient for follow-up for coronary angiography at least 2 to 3 months later or at least 6 monthly.
Thank you very much, sir, for your valuable insight. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum and a very good morning. Ladies and gentlemen, esteemed colleagues and faculty members, warm welcome to everyone and thank you for joining us in this interesting and engaging scientific session, which is the second part of Hot Debates in Interventional Cardiology. I am Dr. Jahanzeb and I have the pleasure of co-moderating this session with Dr. Zubair Akram. And we'll be guiding some exciting and engaging discussion in this session. So we have a very fantastic and excellent lineup of distinguished panelists and esteemed and eminent speakers from local and international faculty who will share their valuable insights and expertise with us. So without wasting any further time, let's get started and make the most of this learning opportunity. I would request our expert panelists to come on the stage and kindly take their seats. Okay. So I would request Dr. Shahriyar Sheikh, Dr. Salman Arai, Dr. Junaid Zafar, Dr. Tariq Farman, Dr. Sher Bahadur Khan, Dr. Hashim Baraich, Dr. Tayyib Mohiuddin, and Dr. Kadriya Atfal from Turkey.
So, Professor Shahriyar, please. Okay. So, we need people on the stage also. So, Bilal, can you join us on the stage? The Caesar, please, can you come on the stage? Professor Servers, please. Okay, take it. Okay, yeah, yeah, right. Yeah. So, over to you.
So, please join me in welcoming our first speaker, Professor Fahim Jafri. He's an interventional cardiologist from Singapore.
And the talk for him is multivessel PCI, is it justified in economically constrained country? So over to Dr. Fahim Jafri from Singapore.
Dr. Fahim Jafri, can you hear us?
Conflict. I have to be in a different meeting overseas than I previously committed to that. And my second apology is because you probably can see it or hear it. I've come up or developed a bit of laryngitis, so my voice is going to sound really weird. That said, let's move on. My name is Fahim Jafri. I'm an interventional cardiologist here in Singapore. And my job over the next 10 minutes is to talk about multivessel PCI and address the question, is it justifiable in economically constrained countries? I don't have any conflicts of interest related to this talk. The question you have to ask is, what makes spending money justifiable in a resource-poor environment? And there's several. At the first level, if there's a mortality benefit, that's clearly justifiable. Of course, there aren't too many things in cardiology nowadays that improve mortality, but things like primary PCI, TAVR, some congenital interventions, ICD for secondary prevention are up there, and these things clearly have a mortality benefit and are justifiable in poor countries as well as rich countries. At a second level, if there is a reduction in morbidity, reduction in MI, urgent revascularization, hospitalization for heart failure, it makes sense to spend the money even in a resource-poor environment, because these are important endpoints. And at a third level, we talk about some interventions that reduce symptoms, and if there's a reduction in symptoms that is substantial, maybe there is a role for these interventions even in a resource-poor environment. I think the important fact to understand is that in cost-constrained countries, patients are often young in the prime of their life and they're single breadwinners, and that's something that we often sort of ignore, the fact that a lot of our patients are quite young, and when they're young, they have a lot at stake, and so reduction in morbidity matters in these patients. Now, when you talk about justified, you also have to ask the question: is it justified compared to what? What are you talking about? Is it cabbage? Is it medical therapy? For most of this talk, we're going to be focusing on medical therapy, but I will say that in general, bypass surgery will always be cheaper than multivessel disease in a resource-poor environment, and therefore, just on cost grounds, bypass surgery will perhaps always be more justifiable And this is different from the US and Europe and even Singapore, where surgery is more expensive. But you also have to consider the fact that the morbidity of bypass surgery is huge in a lot of patients, especially in poor countries where the loss of work of a single breadwinner can have serious implications. So you keep that also in mind. When we talk about the topic, we have to use several lenses. We have to use the STEMI lens, the non-STEMI lens, and the stable ischemic heart disease lens. And just to summarize things in a nutshell, for STEMI, spending the money, even in a resource-poor environment, is justifiable. For non-STEMI, that answer is probably justifiable, and I will show you the data. And for stable ischemic heart disease, I will submit to you that the answer in general, in both a resource-poor as well as a rich country, is no for most patients, but with some caveats that we will address in a second. Now, when you talk about STEMI and multivessel disease, this is a data set that is huge and very, very robust, with a bunch of randomized trials going from 2013 to most recently in 2024, all basically comparing culprit-only intervention in STEMI versus complete revascularization. And the bottom line is that all of them show a benefit. Yes, the benefit is reduction in urgent revascularization in some trials, but is also a reduction in hard endpoints like MI, hospitalization, etc. And only one trial, the full revas, actually didn't show a benefit, but the bulk of the data says complete revascularization is beneficial. Now, why does it make sense? Why should non-culprit PCI reduce events? And it does make a lot of sense, because when you look at culprit lesions where the patient presents with a STEMI, the non-culprit lesions are not benign. They are hot, active, and they are at high propensity for rupture and producing an acute coronary syndrome. So it makes sense to fix these, in addition to fixing the culprit vessel. Now, what do the guidelines say? This is the 2021 guidelines from the American guidelines, which basically gave it a class 1 to do multivessel PCI, but in a staged fashion. And they gave, and if you wanted to do it all in one, which is to some extent more cost effective, it's cheaper, especially for, because the patient doesn't have to pay for a second procedure. If you want to do it in the same procedure, it's a class 2B. You can consider it. Remember, those of you who are older than me or as old as me will remember that doing something like this would be heresy just 10, 15 years ago. The more updated 2025 ACS guidelines from the Americans, they removed the idea, the issue of stage, and they said basically fix the non-culprit, whether it's in a stage or it's in the same setting, that's up to you. But they were leaning more towards doing it in a single procedure. They give it a 2B, and they're sort of saying that it's preferred to do it in the same procedure. And this is after the multi-stars trial results. The European guidelines, on similar fashion, give it a class 1 to fix it either during the index or a stage procedure. The guidelines are pretty consistent. So for STEMI, multivessel PCI is quite justified, even in a resource-poor environment. Many of these patients in Asia are young and they're at the productive age, and so you want to do everything you can to bring them back into their productivity. Timing, I think you can use judgment. You can do it in the same setting. The advantage is it's more cost-effective. The problem, of course, is longer procedure, more dye. Patients often don't tolerate very well. Operator fatigue, especially at 3 in the morning, those kind of things. But if you're going to do it as a stage, do it within 45 days. But the guidelines now support doing it all as a single procedure. Now let's shift gears to non-STEMI and multivessel disease. I think here the data set, unlike the STEMI data set, is less robust and less clear. There are several trials, and I don't have time to go through all of these. Many of these are relatively, robust in terms of numbers. A lot of them is observational data rather than trials. And so the challenge with the non-STEMI data, or the question of multivessel PCI in non-STEMI, is several-fold. The first is, when you talk about culprit only versus non-culprit, a lot of the time in non-STEMI, we don't know what the hell the culprit is, because the EKG is often unclear. It's a poor predictor. Of course, if you see Wellens changes, you know it's the LAD, but often the EKG is not revealing. And then this group of patients has a lot of heterogeneity. heterogeneity in terms of age, comorbidities, other things. And so the majority of the studies in this realm are observational. There is limited prospective or randomized data, and the data itself is mixed at best. Not all studies show a benefit, unlike the STEMI data set, which is pretty consistently shows a benefit. Having said that, the biology still is the same. In other words, when you have a non-STEMI or non-ST ACS, the non-culprit plaques are not benign. They are hot, they are active, and they are at a propensity of rupturing. And so fixing the non-culprit vessels in this setting makes a lot of sense. These are not stable lesions. So what do the guidelines say? Well, the European guidelines in 23 gave it a class 2A to fix multivessel disease in non-STMI. So suggested you do complete revascularization. The American guidelines are a bit strange and interesting. In 2014, the guideline paper gave it a 2B to do multivessel PCI in non-STEMI, saying that it may be reasonable. You forward almost a decade later, and in 2022, or the 21 guidelines, they retired the 2014 guidelines for non-STEMI, and in their entire write-up, there's no mention of what to do with multivessel disease and non-STEMI. They're sort of just, silent on that chapter, probably consistent with the ambiguity that's related to this topic. But in 2025, the most recent set of guidelines, they bring it back in, and it gives it a class 1 indication to do multivessel PCI of non-culprit vessels in non-STEMI. So for non-STEMI, multivessel PCI is probably justified in a resource-poor environment. And now let's, in the last couple of minutes, switch gears to stable CAD and multivessel disease. Everybody knows the ischemia trial. I don't have to go over it. 5,000 patients randomized to an invasive versus conservative strategy with 4-year follow-up. 77% of them had multivessel disease. And the bottom line was that no difference in outcomes at 4 years between the conservatively treated as well as the invasively treated arm. There was even an extended follow-up, no difference in total death. There was a reduction in cardiovascular death, but an increase in non-cardiovascular death. I don't know what that means. And no subgroup really showed a benefit, whether it's extent of ischemia, multivessel disease, or LED involvement or not. Now, it's important to remember that in the ischemia trial, having multivessel disease is bad, okay?
This was a very interesting, excellent, thought-provoking presentation. which was highlighting the need to adopt a cost-driven protocol and a frugal approach towards multi-vessel PCI in a country like Pakistan, which is financially challenged and it's an underdeveloped country. So now we move on to our next speaker.
Assalamu alaikum, Pakistan Live.
Please, go ahead, please. Okay.
The next talk was from Dr. Bilal Murad, and he has just gone to Rawalpindi Institute of Cardiology, and he'll be, relaying a live case from there. So he's on his way to Rawalpindi Institute of Cardiology. So we have got 10 minutes of his talk to discuss. The topic of the discussion was obviously by Dr. Fahim Jafri. He took 3 scenarios. It's STEMI, non-STEMI, and stable ischemic heart disease. Culprit only or multi-vessel. So I would like to have comments from all the panelists, and then the topic will be open for the audience. Bilal, what are your views about STEMI, culprit only or total revascularization, and then non-STEMI as well?
A great question. So the evidence is clear that complete revascularization following ST elevation myocardial infarction, we should be pursuing that. We've known that for a long time, and I did a lot of work personally myself looking at data sets in London and British Columbia. They were all observational analyses which demonstrated the benefit of complete revascularization, and has now been shown in large multi-center randomized controlled trials. The strategy, I still practice culprit only at the index procedure, and I often follow up with a staged revascularization of bystander coronary disease within the next 4 to 6 weeks. Why do I do that? Some may think that's old-fashioned. I don't. I think that you should deal with a culprit, let them recover. Vessels, lesions, they appear much more different when you bring them back. The vessels are less spasmodic. There are many times I actually bring people back for stage PCI, and what was severe lesion is no longer a severe lesion. So I believe that it kind of reduces unnecessary PCI. When you put a stent into someone, you've met them literally for 10-15 minutes. When they've come straight through the door, you know nothing about them. You've taken a bit of a medical history. You don't know how compliant they're going to be to medications. You don't know anything else about them. So treating the culprit, allowing them to recover, bringing them back, you get the opportunity to learn so much more about patients before you pile in more stents. So that's my strategy. I do culprit followed by stage revascularization. However, sometimes if the patient is, there's financial issues, we still get that in the Western world in terms of travel, they live far away, they can't come back in for a staged PCI procedure. If the first intervention has gone smoothly well, there's no concerns, and the second one is relatively straightforward, I would go ahead and just do this. There is evidence that you can go ahead and do it, I will often treat that at the same sitting. With regards to non-ST elevation myocardial infarction, there is limited randomized control trial data. I have been involved in setting up the complete 2 trial within Canada, where they are looking at recruiting non-ST elevation MI patients into the complete 2 trial. So that will be informative. I think where the data currently stands, that if someone comes with a non-ST elevation myocardial infarction, they do benefit from complete revascularization, and I do strive to achieve that. I would treat the culprit. Culprit can be somewhat very difficult to define. Yes, you can use wall motion abnormalities, regional wall motion abnormalities, your maybe ECG localization, or the most critical lesion where you feel you've treated the culprit, and then bring back and pursue stage revascularization. For stable coronary artery disease, I have my own views on that. Right now, everyone looks at the data and they say that, well, actually, stable coronary artery disease it should only be done for symptoms. There's no prognostic benefit. Well, actually, it's not been studied. The ischemia trial, we all talk about it, but remember, 15% of people in the ischemia trial had normal coronary arteries. I'm sorry to say that. So if you're investigating a treatment modality and 15% of your population group don't have coronary disease, it's somewhat quite strange for me to believe 100% the outcomes of that study. I'm sorry to say that. I mean, that will upset a lot of people here, but that is the truth. Okay? But even then, if you look at the data, with the long-term data that's coming out, we are seeing benefit in reduction in spontaneous myocardial infarction. We do see a benefit in reduction in cardiovascular death. Yes, there are nuances in how you define that and how you differentiate that from total mortality. But I do believe that there is benefit of revascularization in stable coronary disease, and time will tell with longer follow-up. We conducted a very large study in British Columbia looking at complete revascularization in stable coronary artery disease. In the real world, our patients who have stable coronary artery disease, they are much more sicker, they're more symptomatic. Okay? And what we found is that if you have a population that is similar to your ischemia trial, low risk, minimal symptoms, then you do get the same outcomes. However, in the real world, patients with stable coronary disease that would not otherwise be recruited into trials, I believe they benefit from complete revascularization, and we've actually shown that. We had a paper published in CCI a few years ago. And stable coronary artery disease is very difficult to study. So if you're going to run a trial for stable coronary artery disease, you are going to include low-risk patients. You're not going to include very symptomatic patients. Why? Because you want to reduce the crossover, and so by inherent design, these trials include low-risk patients. So I'm a strong believer that complete revascularization is important in selected patients in stable multivessel coronary disease.
Thank you, Bilal. So now it's time for local live. Yesterday you saw a live case from Armed Forces Institute of Cardiology. Today, now it's time to get to Rawalpindi Institute of Cardiology, and we have got operators like Bilal Murad, Salman Arai there, and Bilal Iqbal will be joining in the afternoon for live cases from Rawalpindi Institute of Cardiology. So it's time to go to Rawalpindi Institute of Cardiology and see who are the operators and what are the cases they are going to present. I can see Bilal Murad there. So, hello, Rawalpindi Institute of Cardiology, can you hear me?
Dr. Salam, can you hear us?
RIC, are you with us? Okay, so we have got a young interventionist from Rawalpindi Institute of Cardiology who is present with us here, and she is going to present the case, and then Bilal and the company, they'll be... So, Dr. Sana, can you come here and present the case? So, over to Dr. Sana to present the case.
ठीक है अभी लाइव है डॉक्टर की ऑडियो तो भाई
Assalamualaikum. I'm Dr. Sana, cardiologist from Rawalpindi Institute of Cardiology, and I'll be presenting the first live case that will be broadcasted live from Cath Lab C, Rawalpindi Institute of Cardiology. Our operators are Dr. Abdul Salam Azad and Dr. Hasnain Yusuf. So this is an 82-year-old gentleman. He's hypertensive. He was recently admitted at Rawalpindi Institute of Cardiology with anterior wall MI, with a history of chest pain for 3 days. And he was late for lysis and primary PCI. So he was admitted with us and had an angiogram within the first 24 hours. His diagnosis was triple vessel coronary artery disease with left main stem. He was referred for CABG and was discharged in stable condition. He then presented in clinic with history of angina, CCS class 3, but interestingly, he never followed up with cardiac surgeon because he wasn't willing for surgery. His case was then taken up by the heart team for discussion for further options of multivessel PCI. So on the basis of high frailty index and patient's own inclination towards the PCI, he was then advised multivessel PCI. His physical examination was unremarkable. All the baseline labs were normal, except for creatinine that was 1.26. His echo revealed hyperkinetic mid and apical anterior wall and septum with preserved thickness and ejection fraction of 40%. So this is his angiogram. It depicts severe multi-vessel disease with severe LMS disease and osteoproximal LAD, osteoproximal circumflex with calcification, and severe diffuse disease in proximal and mid-course of right coronary artery that is codominant. We did his elective PCI to RCA with 2 drug-eluting stents on 23rd of this month, and he was again discharged in stable condition, readmitted for hydration and repeat creatinine levels, and now we are doing the left system PCI. So House is open for discussion for any PCI options for the left system.
So, before we get back to Rawalpindi Institute of Cardiology, maybe 1 or 2 comments from any of the panelists regarding this case. How would you had approached this case? It looks like a short left main, tight calcific, and obviously a co-dominant large circumflex territory as well. So, any comments from any of the panelists? Dr. Bilal?
Could you just go back a slide and put up the angiogram showing the left main stem? Is there like an AO caudal projection?
Replay. Can we have this slide back, the angiography? Yep, there it is. Can you play it once again? So, the left system, yeah. The next. Okay, so here it is for you, Bilal.
So, this is a codominant circumflex, and you've got severe disease in the left main stem. As you quite rightly pointed out, it's a short left main stem. The severe disease in the proximal circumflex, the severe disease extending into the proximal mid-LAD. So this, and there's a lot of calcium for sure. Okay, so it's got a lot of calcification essentially in the prox LAD. So ultimately, my approach to this, of course, I would have a 7 French guide. This is a left main intervention. You will need to predilate each limb. I suspect you're going to require calcium modification in the LAD. How you do that? You can do that with rotational atherectomy. You can do that with cutting balloons, whatever tools you have available. Intravascular imaging is key. I would do this case with intravascular imaging. And ultimately, how the vessel behaves, I would actually also maybe even rotablate into the circumflex. So I would do the rotational atherectomy of the LAD, a rotational atherectomy of circumflex. Some people may not opt to do that. And ultimately, I'll probably end up using a 2-stent bifurcation strategy. With regards to he's got the ejection fraction is 40%. I'll be interested to know what Bilal Murad thinks. He's obviously an operator. He practices in the US where they have a lot of availability of impeller. I wouldn't want to know what the systemic blood pressure is. I would like to know what the EDP is. But I would do this case personally without impeller.
So, Bilal, my question to you is, what they have done is, it is as a stage procedure. They did RCA 3 days back, and the patient is on hydration. It's 1.4 creatinine. So what would your approach would have been? If you applied a single stage approach, or would you have staged it?
I'm a big believer in staged PCI. I like to, if I'm taking on complex intervention, I always like to grab the low-hanging fruit, as they say. It optimizes the cardiovascular status. Get them the ejection fractions 40%. Get them on guideline-directed medical therapy. Medical therapy works. And this is coming from a hardcore interventional cardiologist, getting them on, ACE inhibitors, beta blockers, dapagliflozin, all the heart failure therapies, improving the LV function, is only going to benefit your complex stage procedure.
Okay, thank you. So, are we ready to go to Rawalpindi Institute of Cardiology to join Dr. Bilal Murad, Dr. Abdul Salam and his marvelous team? And we should go live. Salam, can you hear us? Dr. Bilal Murad, can you hear us?
No, I was able to.
Dr. Salam, can you hear us?
Are you able to hear us? I don't think you're able to hear us.
Dr. Bilal, can you hear us?
I can hear you, but I don't think you're able to hear us.
Check.
There is a bit of distortion in your voice.
उनका आवाज़ नहीं आ रही है हमारी आप मेरी आवाज़ उनको नहीं जा रही ना तो मुझे तो कोई भी नहीं है का बलून सर में करते हैं ओके मैं सर से बात तो ये कौन फिक्स कर रहा है उनसे मेरी आवाज नहीं पहुंच रही एलईडी का बलून दो
Salam, can you hear us?
we can hear you आप दिखाएं मुझे एलईडी का बलून दिखा दे एलईडी करें सर बिलाल जी circumflex को प्री डिलीटेशन करना ले
Now, as they sort out the IT problem, Bilal Iqbal, I have a question for you. That this
Bilal
is a Medina.
Murad, can you hear us?
जल्दी करो.
So this is a Medina 111 lesion, right? And by definition, two criteria. This is a complex bifurcation, and you have already suggested that you will go upfront two-stent strategy in this octogenarian with a mild CKD and EF of 40%. What would be your preferred choice of two-stent strategy in this case?
So, you know, this is a comment, this is a question I was asked yesterday, and I believe that you can use whatever two-stent bifurcation strategy you like, whatever you're comfortable with, as long as you've appropriately sized and opposed the stents, as long as you do the correct steps with the kissing balloon dilatation and pot. I think any bifurcation strategy would work. That's my thought process. Personally, I'm a big fan of DK Nanocrush, and I would very happily do that.
Dr. Abdul Salam, can you hear us?
Yeah, we can hear you. I don't think.
I think they can hear us. We are not hearing them.
I think you can hear us, but we can't hear you. They're trying to fix up the problem.
Save Joe. Jai, to down. ये क्या हो रहा है यहाँ पे? सर को डिलीट किए। इसी नंबर नो। इसके बाद कटिंग यूज करते हैं।
So what we have been seeing, you know, at least till now, is that first of all they have got a pacemaker in, and then obviously 2 wires down the circ and LED, and then we most probably it's a cell French, obviously it should be, and then we saw them doing rotation of left main to LED. So that is at least what.
Zubair, can we discuss the case?
Yep.
So as I think just for discussion sake, as Dr. Bilal Iqbal was just saying that, you know, probably DK crush is his preferred strategy. So just for discussion sake, I would like to ask him what are the limitations, you know, in culotte versus crush. What is the thing, I mean, other than the anatomical considerations and, you know, the angle and everything. So considering, you know, equal sort of 50-50 chance, but why would you prefer a DK crush over a culotte? So your comments.
So I use both strategies. I think you could use either one. I don't mind. The reason why I would not like to use a culotte here is because you're probably, the left main stem is short. You probably end up with a double layer of stent throughout the whole of the left main stem if you did a culotte technique. So to me, the way I look at bifurcation is you can use tap, you can use crush, you can use mini crush, you can use DK nano crush. The list goes on. I believe that any bifurcation strategy do well-sized, well-opposed stents and minimize the number of overlap stent segments and minimize the amount of crushed stent segments. I believe if you can minimize the amount of crushed stent segments and overlap stent segments, you basically really promote the re-endothelialization and reduce the stent-related complications.
So what's the, I mean, there is some data that there is a higher risk of restenosis at the side branch in the culotte as compared to the DK crush. Are you, I mean, is there a consideration as far as...
There is, I mean, there are some, there is some evidence, it's all anecdotal, observational. I know my colleagues in Seattle, they all, when they come to DK nanocrush, you know, the circumflex ostium naturally is prone to instant restenosis. Why? Because it's a very mobile segment of the artery. The media is quite thick. So all of these, so you whatever you do, whether you use cutting balloon angioplasty, you use rotational atherectomy, you always get some degree of constrainment in the circumflex ostium. So to mitigate that, some people they would treat the LAD as a side branch in a DK nanocrush technique and stent from the circumflex back to the left main as with one stent entity. Whether that transforms into better long-term outcomes remains to be defined, but it's an interesting hypothesis.
So, any comments from you, Dr. Jalal, Dr. Nasir Samor, or any other worthy panelists?
I think it's quite a complex case, left main and large left system, a big left system. Considering our local perspective, from my personally, I would go after preparing the lesion well. I'll go with the procedure with the bifurcation strategy, which needs minimal handling. Personally, I would go for mini crush, and the reason for that is a short left main, both DK crush, yes, culotte, yes, both can be done, but I think a strategy where the operator feels comfortable, he is more adept in that. So personally, I would go for mini crush in this case, and the reason it will shorten the procedure, and I personally feel more comfortable with that.
A quick question from the audience. They have placed a
In addition,
TPM
there
wire.
is
This is a co-dominant system, right? So could we have got away with the rota pacing, just like Dr. Tahir Kheli showed us that it can be done outside on the wire during the TAVI procedure? We can do it with the rota wire as well, or with just administration of amnoflin and a standby atropine, or was the implantation of TPM
So I want to make a comment on that. So, you know, the rotor pace technique, which we described and published in JACC Intervention last year, it works very well. We had a cohort of 135 patients, and it works very, very well. Here, the indications for, so that was a comment I was actually wanting to actually make to the operators, but we haven't had the opportunity to hear from them what they were thinking and what they've done. Is
Okay,
so here I would pace, because for left main and right coronary, dominant right coronary, dominant circumflex, left main, I would pace. A rotor pace technique.
Are you able to hear us?
Personally, in DK,
Sir,
I prefer, where possible, nano crush over the whole length DK, because it reduces the metal in the main vessel in a big way.
So I mean, to me, all the mini crushes and DK and nano crushes, so the DK crushes, for me, it's all become nano crush, because I believe that we should minimize the amount of crushed material.
So, Bilal, what's your practice? You prefer nano over DK crush now, or more of a DK crush? And what are the situations where you go for DK crush selectively?
So, I mean, if I'm using any crush technique, I think DK and nano crush works very well in all anatomies. That's what I use.
And a supplementary question: do we have a major trial supporting DK nano crush in left main? Do we have a major trial or a study which supports DK nano crush?
I mean, the way I look at it is this: there's a trial for DK crush, right?
DK
nano crush. I don't believe there's a specific trial for that, but it reduces the amount of. You get the same result, same principle are applied as in the DK crush, with reduced metal and reduced crushed material. So that naturally common sense will show you better outcomes.
RIC, Abdul Salam, can you hear us?
Yes, sir, I can hear you.
Abdul Salam, can you hear us?
Yes, sir, I can hear you.
So, Bilal, can you hear us, Bilal?
Yeah, we can.
Is Dr. Bilal Murad there? Yes, Bilal, can you hear me?
Are you able to hear us? Cranial?
Actually, you can hear us, but your voice is distorted.
Yeah, unfortunately, we can.
Maybe you can exchange your mic with Dr. Salam, Dr. Bilal, because we can hear Dr. Salam well as compared to your voice. It's being distorted. Can you exchange your mic with the Dr. Salam's mic?
Volume बढ़ा दें करो.
जाओ. 20.
Dr. Bilal, can you exchange your mic with Dr. Salam's mic, because he is audible, you are not.
उनको दिखा दो. Okay.
Set है. Down.
मेरा खुला हुआ है पीछे का. मेरा माइक्रोफोन खुला है.
जाए.
मेरा खुला हुआ है यार बत्ती चल रही है इसकी.
Save down.
आप ये देखा.
कहाँ तक है फैसल?
नहीं, ऑन भी क्या नहीं है मेरा, क्योंकि उनका आवाज मेरी.
Salam, can you give us a quick rundown about your case and what you have done till now?
Yes, we can.
22.
Are you able to hear us?
Down.
Can you help us, sir? On है मेरा माइक्रोफोन ऑन है भैया नेट लाइन है तो इनका आवाज नहीं जा रही है ना बेचारों को 3.5 वो जमेश साहब की आवाज नहीं पहुंच रही है नेटो दे नहीं नेटो दे हाँ पिक्चर लें ओके तो फिर उनसे सही देखत अच्छा सर्कमफ्लेक्स का साइज 30 काफी है 38 ले लें 38 ले लो एलईडी में डायसेक्शन बहुत लंबी है हाँ लिख लें वो बात के बाद जल्दी से आप स्कैन कर लें उसको हाँ ये पकड़ें ये थोड़ा एसटीएम तक कर दें उसके बाद सवाल कैसे करेंगे यूनिवर्स की राट करें लंबा नहीं बन जाएगा कम जबरदस्ती शामिल दे जी 3.538 दे दें जी यूनिवर्स की राट करना पड़ेगा यूनिवर्स की राट में क्या करेंगे हम
Dr. Bilal, just a question. Quite calcified, and we know the left main is also quite calcified. Would you start upfront rota in this case?
Hello, Bilal. Have you exchanged the mic with Dr. Salam?
डिसाइड ही करनी थी हेलो इस पे लगाएं वो वाला
देन आप ये स्क्रीन हटा सकते हैं सेटिंग वाला
देखिए लास्ट स्टेप्स इस पे टारगेट लगाएं इस पर ये किसकी है एलईडी कौन सी है हेलो बस दे जी एलएमएस 3.538 देते निकालें जी ये ट्रू
इसको आप कहाँ पार्क करेंगे इसको
सर LMS 12
सर्कमफ्लेक्स को जेल कर देंगे ना दिस हैज टू गो बियॉन्ड द ऑस्टियम और द एलईडी ताकि आपके पास फिर सर्कमफ्लेक्स के ऑप्शंस रहे यू कैन नॉट गो LMS टू एलईडी राइट नाउ
अभी आप हम एलईडी को डिस्टिल करें ना
लेकिन ऑस्टियम
we can see is a dissection extending from the proximal LED towards left main.
Are you able to hear us?
Yep, a bit better. Have you exchanged your mic?
मैं करता हूँ देख लेंगे दोनों मसला नहीं कोई रहना जाए हमारा
Until we get comments from there, any concern about the OM branch because that's quite a fair size OM branch.
तो पकड़ना
इसको आवाज आ रही है सलाम भाई सलाम की आ रही है
मुझे आवाज नहीं आ रही
उनकी आवाज आ रही है ओके तो आप रिप्लेस कर दें
Dr. Bilal,
also having seen this large dissection in left main extending to LED, can we go for a reverse decay
what is
crash?
your take
on
on putting in a temporary lead in this situation?
I would not have done that. I would have used rotor pace technique. I think it works in 92-93% of the time.
Can you hear us now?
I can't remember the last time I put in a temporary pacer with the rotor pace.
Can you hear that? Because they have already done the right coronary artery has been addressed.
Hello?
And the patient is hemodynamically stable. His heart rate is okay.
Sure. I mean, the thing is, we've got an analysis which we're presenting at TCT. We've analysed in contemporary practice about over 250 patients now, and we found a left main stem rotablation, the use of a large burr, 175 burr and above, proximal left dominant circ, proximal dominant RCA. All of these are strong predictors of heart block peri-procedure. So, and the rotor pace technique is such a great technique. You don't have to put in a temporary pacer. You just use crocodile clips. It's such an easy intervention, and it addresses bradycardia. So why not? Cheap, simple, easy.
So what's your take on doing a viability study in such a situation before proceeding for such a complex procedure?
I thought, I don't believe, if there's a question of viability, of course, I would do an MRI scan, but I thought there were no scar segments mentioned, and there was no suggestion that there was scar on the echo or anything like that. But yeah, if there's concern about viability before taking a complex intervention, sure. It's
can you hear us?
Talking about the strategy of this.
Are you able to hear us now?
Case. If we talk about
can you hear us? Assalamualaikum.
If we want to keep
Assalamualaikum, Bilal, can you hear us now? Maybe the mics
are.
Are you able to hear me?
Just stand left main to LED.
That's also very good. Yeah, there's different ways to do the same thing. 100%.
Okay.
Can you hear us, Zubair bhai?
Can you hear me, Bilal? Hello.
418 आ जाएगा? 418 दे दें. Sir, no, we are stenting LMS to circumflex with 418.
Salam.
Salam. Kindly, can you switch your headset with Dr. Bilal Murad? Is it possible? Can you request someone to switch the headset and mic with Dr. Bilal Murad? Because your system is functioning perfectly well. Yeah, that's the way. Good.
Can you hear us now?
Yeah, distortion.
Assalamu alaikum, can you hear us?
Yeah, we can hear you right now. Bilal, welcome to Park
good.
Live, and
Finally,
we can see you. You know, thanks for coming all the way to Pakistan. You know, Dr. Sarah has presented the case. You know, it's a left main case with the RCA disease as well and bifurcation. And obviously, RCA was fixed about 3 days back, and today you are dealing with the left system. You know, so what have you done till now? Can you let us know what have you?
Yeah, let me carry through the case. Your volume is a little bit low right now, but I'm just going to carry through the case. So I think you've reviewed the angiogram. This is an elderly gentleman with an EF of about 40% and has severely calcified LAD lesion. We actually IVUSed it first, and it was a mixed fibrotic and calcified plaque. There were some segments of about 180 to 270 degree arc of calcium, especially involving the ostium. And similarly, the circumflex actually had similar calcification as well. Now, the ostium of the left main being absolutely critical, every time we would touch the catheter with left main, we would have significant pressure dampening. So the plan was that we would then at least create some space in the left main. We did some balloon PTC of the ostium of the left main with a 3 millimeter balloon and then a 3.5 cutting balloon. The left main was actually not that calcified, less than the LAD in the circumflex. So the idea was to create enough space in the left main to make it easier. After that, we proceeded with rotational atherectomy of the LAD. It was done at about 160,000 RPMs using a 1.75 millimeter burr, followed by cutting balloon PTCA using a 3.5 cutting balloon. Following that, the circumflex has also been treated with a 3 millimeter balloon for pre-dilatation. And as you saw, there was a significant dissection in the LAD. So we have put in a 3.5 38 millimeter Medtronic Onyx stent, which has been deployed from the ostium of the LAD, sparing the carina to cover the dissection, because we still have to deal with the left main and the circumflex, and we have to decide about what's the best strategy we want to use. But in order to stabilize the dissection and prevent a hematoma that sometimes that can extend downstream, we felt it would be best to stent the LAD, which is now secure. So we're in a pretty stable condition. We have not had any heart block. And I think I heard some conversation about the different techniques of pacemaker. Personally, I think that the two approaches that I most frequently use are intracoronary aminophylline works beautifully. I have not used a temporary pacemaker in almost 20 years now. And of course now with the wire pacing through the rotor wire as well would be an excellent choice as well. Of course the third option is a temporary pacemaker here. So where we stand right now is that we have to treat the circumflex and the left main stenting. So what was the panel's discussion regarding the best strategy for stenting? What was the consensus there?
So, obviously there were a few concerns about the short length of this left main and then the ostial disease of the left main. Then obviously the circ was co-dominant, it was a large vessel. So, mostly the favored strategy for most of them were either a DK crush or a nano crush, and obviously not a Q-lot stenting. So that was the consensus here. And
yeah, I think one of the challenges of any complex bifurcation stenting here is that this left main is a little bit short. It is a large vessel, and he's an 82-year-old gentleman. We talked about the Q-lot versus DK crush. I think that it's also not unreasonable, given his age and frailty level, is to actually take a look at the spider view and then see if we have a good separation angle, and perhaps even consider a mini crush technique and not make it terribly complicated, because the more manipulation we do in the left main with the lower EF, we run some risk of hemodynamic instability. Fortunately, he's been pretty stable so far.
So, what you have told us that obviously after the rota, there is a big dissection in the proximal LAD, and you have changed your strategy, First of all, you have gone with just stenting of the left LAD till the ostium. What we can see is there is dissection of this short left main as well. Why not a crossover? Because there is a dissection in the left main also, and which is a very short left main. Dr. Bilal, can you hear us?
Yeah, I can hear you, but the volume is very low, so it's hard for me to make out everything that's being said. Koi volume upar ho sakta hai na?
So can you hear us?
I can hear you, but the volume is very low.
So you know, my question is that you have stented this dissected part of LED till ostium, and you have not done nothing with this left main, but there is a dissection in the left main as well. Why not a crossover? And what's your strategy now when you have gone done stenting to the LED ostium? So what's the strategy right now?
So right now I think, as I'm talking to Salam, I think what he's planning on doing is to do a reverse coulade right now. So I think we're going to put in a 4018 stent from the ostial of the left main into the LED and overlap it with the previously deployed 3.5 stent, and then go back and then treat the circumflex.
Okay.
So are you treating, Bilal, are you treating, then are you going to treat the circumflex as a tap technique then? Is that what's the plan?
Yeah, that's correct. I think Salam has wired down the circumflex and he's going to stabilize the left main first.
Yeah.
And then we're going to go back, recross it through the struts and then stent through that.
Yeah, I mean, yeah, so tap would work. You could, if you want to treat the side branch first, you could still do your DK nanocrush and treat the circumflex, crush the stent, and then treat the LAD. You've actually got good luminal gain in the circumflex. Any thoughts on considering drug-coated balloons from the circumflex, then stent across it and see what it does?
Yes, absolutely. I agree with you, Bilal. I think, again, in an effort to try to minimize complexity here, you know, if we have a good result and, you know, like we saw in this case from China yesterday, you know, learning from our Chinese counterparts of treating the circumflex artery with the DCB, I think that would be an entirely reasonable thing to do. So I think what we'll do is we'll treat the circumflex, IVUS it, see how it looks, and if it looks like a stable, good luminal gain, no major dissection, I think it's entirely reasonable to treat with a DCB.
But, you know, but I would have, if you were going to use a DCB strategy, I would have treated that up front. So you would do the DCB, then stent across it, and if after stenting across the circumflex and doing the pot, the circumflex looks great, I wouldn't even bother crossing it. And, you know, you've got a short left main. If you don't need to perform a kissing balloon dilatation, why disrupt the stent architecture? So my strategy would have been for DCP. If you're going to do it up front before your left main stent.
I 100% agree with you, Bilal. I think that was our original strategy. I think considering the fact that we had a dissection in the left main and the LED, I think the feeling in the room was that let's stabilize that first. So we had to, you know, it's one of those things about you go into complex PCI with one particular plan, and depending on how the patient reacts clinically and technically, you have to kind of modify and be nimble about changing your strategy. So we had to modify that strategy a little bit here.
There's many ways to do the same thing, and as long whatever you're comfortable with, and as long as you're doing it well, which you are, is great, fantastic.
So we're going to do an R caudal view right now and see how the circumflex looks, and then we can talk about whether or not we need to do anything more to the circ or not.
Bilal, what sort of which stent have you put in the left main? And I would like to have comments from you, Bilal Iqbal, and the panelist. Which stent type is your preferred stent for left main? Are you putting the thin strut stents also like R0 in left main, or what's the choice of stent if you have to stent left main? Which is your preference?
So to answer that question, everyone has their favorite stents, right? We have Osiro in Canada. My stent, my go-to stent for anything and everything is a Resolute Onyx.
Okay, what about you, Bilal? What about whether you go with Abbott stents or Resolute Onyx or R0? So which is the thin strut? What is your preference for left main stenting?
So, you know, in this particular case, we've used a 3538 Medtronic Onyx stent for the LED, and then I believe we put a 4018 in the left main as well, the Onyx stent. I think that, like Bilal said, you can use any one of those. If there's a big side branch that I need to protect, I think the Onyx stent works beautifully. I think the new Boston Scientific Megatron stent works really well as well. And there's a big size mismatch between the left main and the LED, using a 3.0 or a 3.5, because the Megatron can go up to almost 5.5 as well, and you can have large side struts as well. So I think you can use any one of those stents. When I need positioning, I will say I prefer the Abbott because of the the mid-marker stent positioning allows me to nail the ostium much more easily with the Zion Sierra stent. But as Bilal said, I think any one of those options would be good.
So what's your strategy for this ostial left main stenting? You know, do you put a cusp wire? Because we have seen so many of the cases of longitudinal stent deformation, you know, when you pull the balloon back, the guide sucks in. So would you routinely do a cusp wire, place a cusp wire to prevent that longitudinal stent deformation?
Yeah, I think, that's a great question. I think that is generally a good strategy. I don't do it routinely, and I'll tell you why. So I generally tend to, after deploying my left main stent, I disengage my guide significantly and take the balloon and hang it half in the aorta and go to really high pressures of almost 24 atmospheres. And then if I'm going to engage my guide catheter, I don't move my balloon. I leave it in the left main and the aorta and gently guide my guide catheter over it. Kind of like what we do with the guide extension catheters, the inch-forming technique. If you do that, then you won't have a problem with hitting it. I think the problem occurs when you have a large left main, undersized stent, or deployed at just a low pressure, and your guide is very close to the ostium, and then you suddenly jerk your balloon backwards. Then I think then there's a significant risk of longitudinal stent deformation.
And
but
then you're covering.
I just want to make an important comment there, and this is something I do, and that's my practice. Is when I have a protection wire in the circumflex, and I'm stenting from the LAD back to the ostium, and everyone then tries to re-engage your left main stem. But you have to be very careful to remember that you've got a jailed wire going into the circumflex, and you could de-roof that stent from the left main stem. So that is another cause of longitudinal stent compression from re-engaging your guide. The other thing is that when you remove your circumflex wire, it's much easier to do before the pot. So now, once you've done a pot and you really oppose that stent, sometimes you've got to be, of course, you can remove your wire, but you've got to really back your guide out and just pull carefully to make sure that the guide doesn't dive in. So my practice is, whenever I deliver the pot balloon like they had for the post-dilatation, once I deliver that into the LAD, then I remove my circumflex wire, and then I do the pot. That's provided that you're happy that there's flow in the circ, and
Okay. And when you're covering the left main stem ostium, which margin do you target? Is it the lower margin or the upper margin? And secondly, for every 1 millimeter stent platform expansion, there is 2 millimeter longitudinal stent lengthening. So is it a matter of concern for later on longitudinal stent deformation?
That's always a theoretical risk. And there are times I've done it and I haven't got it, and there are times I've had significant stent shortening. I used to get a lot of that with the Promus platform. I don't use that anymore. But these are very valid questions and thought considerations for sure.
So, Dr. Bilal, what you told us that the strategy now for you is reverse culotte. What about TAP?
Yeah, I think those are all good options. I think what we're going to do next is angiographically we have a pretty decent view of the circumflex. And I think what we're going to do is do an IVUS of the circumflex as well on the LAD, and then see. Let's look at the circumflex luminal gain and dissection, and then try and make a decision how we should proceed with it. I'm not opposed to leaving this without a stent, because I think trying to make it into a complicated stenting sometimes gives you immediate benefit, but in the long term and with more restenosis as well. So let's see how the circumflex does, and definitely actually does not look bad at all.
So I would like to have your comments, and Dr. Bilal, maybe Bilal Iqbal.
How about avoiding a stent at the circ ostium, since the ostium is still holding it there, and we go for a DCB only at the circumflex ostium. Number one. Number two is that how many of us are doing pot with the side branch wire jailed? Is that a safe strategy, quite safe strategy when you are especially doing the procedure with the EBU or XB guide and the target is left main ostium? Is that not a safe strategy to remove the wire and do the pot then?
No, I agree with you. I think
that's what we said just now.
Right, go ahead. See? Okay. Yeah, so generally my to to deploy, if I'm going to jail a wire, I just deploy my standard about 10 atmospheres. If I usually would use a jail balloon technique as well to make sure that I preserve the ostium. Then, before I do the part, I will take the wire out, do the part, and then rewire it. That is generally my my practice. I agree with the concern about safety. I think some of the wires can get seriously stuck, and if they do, then you have to use a microcatheter and take it sort of almost behind and nudge yourself behind the left main stent. Things that you don't want to do, unfortunately, because then you can cause trauma as well. So I agree that in the general practice should be that the side branch should be removed before you do high pressure part.
Bilal, one more question, Not all the labs in Pakistan, they have got access to IVUS. And what we have, been doing, we must have learned from us in the Masters Forum, pot puff. So, what we do is, in left main, obviously, when we do a pot, we give just an injection to see whether the dye goes beyond left main or not. If it goes, then we think that we are suboptimal. And then if it doesn't go, we think whether it's with 4.5 or 5 balloon, it's okay. So any experience from anywhere around the world? I am sure you must be doing IVUS in all cases, but anything you have heard from other parts of the world regarding pot puff? Is it a reliable thing to do?
I certainly have not heard of the strategy at all. I think these days with imaging being available, and later on I'll be talking about the Centers of Excellence and PCI, and I think every single consensus document, both in Europe and the US, would recommend intracoronary imaging in procedures like this. So I'm not personally familiar with it, but of course, certain systems, like over here with the resources, I think tend to become more innovative. I think what should really be done is to do some kind of a comparative study to make sure that how do we validate what we're doing if we're going outside of the norm with limited resources, what's the best way we can prove what we're doing actually works consistently.
Yeah, Professor Nadeem has a question. Yeah. Dr. Bilal, question is that, with the current data supporting IVL rather than rotablation for calcified left main and to avoid this dissection in the LED, what would you have done in US? Would you have done an IVL or would you still have gone with the rota?
I actually don't think better is dead yet. Maybe it will be someday, but not at all. And I will say that the strategy of rotor shock actually is something that we do reasonably often as well. I think I don't think it's accurate that IVL therapy does not cause perforation. I have personally had those. My colleagues have had them as well. I image a lot after every single IVL run. I usually use OCT. The calcium fractures are pretty deep, and one of the things to avoid, for instance, is that when you do IVL, you can't really do very high pressure post-dilatations because those calcium fractures deep in the wall of the adventitia have caused post-stenting perforations as well. So you have to be very careful with that as well. Now in this particular case, I don't think that there was enough calcification. And again, I use OCT to understand, or IVUS to understand the depth of it and the length of it, and how many quadrants are involved. If the calcium is extremely dense, I don't think rotational atherectomy or orbital atherectomy alone will work. So I use maybe that to treat superficial calcium, but the deep wall calcium needs IVL or OPN balloons. So in the US, this particular case, I would have done it with the rotablator also, and not with IVL, simply because on IVUS, I did not see the amount of calcification that would justify IVL therapy for this one. Having said that, if I see something different on IVUS, I completely agree. IVL would have been an excellent point. The other thing is that what also spared this IVL for here is that the left main is short but it's large, and the amount of calcium in the left main was not terrible. So again, if the left main, you see this very densely calcified left main, and making sure that that stem expands properly, IVL it works beautifully in that area. But be careful, I've had 3540 IVL balloons perforated the bifurcation of the left main LED as well. And when that happens, it's pretty nasty because now you have to put a covered stent in and then protect the circumflex. I know it's not very common, but it's not, it doesn't come free of cost.
Can you just update us what you have done? And I think it's is it still a reverse culotte going on, or we just missed the last part? Can you just brief us Dr. Bilal, what you have done?
Yes.
Till now?
Yes, so while I was talking to you, Salam was diligently working away. So we've took the circumflex wire out, rewired it, and now he's in the process of doing a reverse clot technique. As you can see here, he's got one balloon sitting from the left main to the LED. Then you have this stenting of the circumflex.
So why reverse culotte? My question to you was about TAP at left main. So what, the preferred strategies I know are Europeans go for culotte most of the time, and the Chinese go for this DK crush. So, but in this case, why not TAP?
Yeah, I think that, again, I had mentioned earlier, the original strategy, if you were going to stent, would have been a culotte stenting here. The reason for doing the reverse is because of the dissection in the left main and LED. I think, again, you have to respect what the primary operator feels at the time. I think Salam felt that we needed to stabilize the left main ostium, and I have to support that decision here. And so that stenting was done. So now that that is done, the strategy then left is either a DCB and seeing how the left circumflex looks. And I think he felt that there was enough of a plaque burden over there that a reverse culotte strategy would be more effective.
The reason why I'm asking is because from the ostial of the LED to left main, you have got a 4O size stent, and obviously what I expect is for a reverse culotte, you will be going with a 3.5 stent from circ to left main. So with a pot of about 4.5 and to 5 in left main. So maybe it will be a bit undersized stent for left main from if you go with the reverse culotte. But if it's a TAP, you won't be bothered about that.
Yeah.
Moreover, as a cardiologist, we are a big fan of KISS. Keep it simple and safe. I think Dr. Zubair has a point. You can finish off the procedure with a tap, simple tap.
I think Dr. Zubair's point is a very, very important point. But the other point is why I would not be very keen on using culotte here is what I mentioned earlier. This left main stem is short. It's about 5 to 6 millimeters at most. It's just about you'll be able to get a pot balloon in there. And if you're going to do a reverse culotte, remember when you do a culotte, you've got to have at least 5 millimeter of stent proximal to the bifurcation. So you have subjected this patient to 100% left main stem and double stent layer, which is fine. But I mean, it just reduces the risks of stent thrombosis, restenosis, re-endothelialization, etc., etc., etc. So I would have preferred, in this stage here, I would just use TAP. So much more easier.
Those are excellent comments. I think that's the conversation we are having here in the lab as well right now. I think that's the value of getting so many opinions. Salam feels that let's just try the TAP also. I'm in agreement as well. I'm a strong believer in doing complex PCI with the most simple strategies and not making things complicated, because I think it just leads to more issues further downstream.
I just want to raise another technical point here as well. So whenever you have a very, very short left main stem, you want to leave at least 5 to 6 millimeters for a pot. We have 6 millimeter balloons that exist. I don't know whether your cath labs are equipped with it, but those are very good for these short pots to have. So in these scenarios, when you're recrossing from your left main stem LAD stent into the circ, it's best to really achieve the most distal stent strut. In that way, you maximize the length you have proximally to allow you to deliver a healthy proximal optimization with a 6 millimeter or an 8 millimeter balloon.
No, those are excellent points, Bilal. I completely agree. So what's happening right now is that Salam is proceeding to deliver a 3530, a 3.5 by 30 Medtronic Onyx stent into the circumflex through the stent cuts, and then we'll do a tap.
No, as long as yeah, as long as you.
So again, I have curiosity here. I'm sure there must have been some conversation about the use of whether we should use any kind of mechanical circulatory support
And
here or
one more
not.
caveat to the short left main over here, and we are just putting a stent over there, because we've got 3 to 4 cells. The chances of stent distortions are also there.
Shall I get sent?
Bilal, is that not?
लेकिन स्टैंड डिलीवर हुआ है कि नहीं अभी? एक आध मिलीमीटर क्रॉस.
Bilal, we are running short of time, so you have got another 5 minutes to go.
Vacillation.
Hello. Yep, you can. Yep.
Let me tell you, blocking a vessel is not as good as optimizing the stent. They're two different things.
Yep.
So if you think that you have a balloon of 4 NC and you have done enough block optimizing, there is no trickle down the line. How would we prove that if you take a 3O balloon and then try and see if there's a trickle at all? At best, I think it is a poor man's IVAS.
Yep,
and is
yep.
nothing more than a Hakim's
but you know, in my experience, obviously, it did work, and obviously we are following up so many of cases, you know.
I know, but we are not sure that it is.
Obviously, that's why I had put the question. Maybe, you know, we can do a pot puff, and later on with the IVAS facility there, we can just counter check also. So, you know, Bilal, what's the plan right now?
So, we're going to do a tap here, and as expected,
you are going to a tap. I think everybody of the opinion, including Bilal, Iqbal and Nasir Sabur, etc., that tap would have been a better strategy here because of a very short left hand. Nasir Sabur sir, yeah, please. There is a question from General Nasir Sabur.
There is some haziness at the ostium phallidae. How would you take it?
And that's the junction point, I guess.
Sorry, again, I didn't understand.
Haziness in left LED ostium, Bilal. That's the question. Would you like to do IVAS or before you do?
We will be doing an IVAS. We will certainly be doing an IVAS. Right now, what Salam is trying to do is to deliver stent cuts.
So, you know, Bilal, here is a very important technical point, I think, especially for the young interventionist sitting here, you know. So, whenever you are doing a bifurcation stenting, you know, your upfront two-stent strategy, you always start from, if it's such a big vessel, you always start from a side branch first. But here, obviously, because of our left main and LED dissection, you stented the LED and the left main first, and then with the bigger stent, you know, about 28 mm at least stent, then you have to cross it. Then there is a problem of crossing there, and I think you are going ahead with the guide extension now. So, you know, it's for, if there is no bailout situation like this, which you encounter, you know, it's always better to start from the side branch and then go to the left main first. So, Bilal, we will catch you in a while, you know. There is another interesting case going on in Cath Lab B of Rawalpindi Institute of Cardiology, where the chap Salman Arai is doing a CTO, and he'll just give you a brief account of what he has done, just for 5 to 7 minutes, and then we'll get back to you. Over to the Cath Lab B of Rawalpindi Institute of Cardiology.
Sounds good. Thank you.
Dr. Zubair, Zubair Saab, can I make an important comment here? They were using a guide extension here, I presume, to deliver a stent into the circumflex. This is not going to work. All right? If you get your guide extension into the circumflex and you get your stent in, You cannot remove your guide extension and then deliver a balloon. I've tried it many times. It's not going to work. You have to cut the guide extension off or use a 6 French trap liner because it's shorter. If you think through the maths and the length of your balloon shafts, if you get a guide extension and deliver your stent in a side branch, you won't be able to deliver your crushed balloon to do your bifurcation. Just an important point.
Okay. So, welcome, Dr. Salman Rai. We can see you. Welcome to Pakistan Live. Thanks for being here. Can you just briefly tell about the case and what you have done till now?
I always heard that there is a difference between speed of light and speed of sound, but today we are witnessing it. Definitely a lag. Dr. Salman, can you hear us? Okay, he's nodding. At least he can hear us. Dr. Salman, we can't hear you. Can you tell your IT guy to fix the problem? So once the problem is fixed, we'll get back to Rawalpindi Institute of Cardiology for the live transmission. Meanwhile, we'll have another presentation from Dr. Fahim Jafri. He will be navigating us through the uncharted territory of ever-expanding and ever-promising role of drug-coated balloons in interventional cardiology. Dr. Fahim Jafri is an interventional cardiologist from Singapore.
Hello.
And that's basically because there was a scheduling conflict with another meeting that I was committed to attend in Korea. And, you know, the second reason, the second apology is for my voice, where I've come down with a bit of laryngitis and I know I sound really odd. My job over the next 10 minutes is to talk about the role of drug-coated balloon in routine interventional practice, and hopefully I will try to convince you that there is a role for DCB in modern interventional practice. I have no disclosures related to this talk. The question you have to ask is, why should DCB be part of the cath lab? And there are many situations where a stent is not ideal. There's small vessel disease, long diffuse disease, bifurcation disease, in-stent restenosis, high bleeding risk patients. And something that's unique to Asia, we have very young patients often. And so when you put a stent in a 27-year-old, you're basically subjecting that patient to chronic stent disease. Chronic stent disease is a real thing. These patients have a 2% per year event rate, which is either ISR or even worse, very late stent thrombosis. And so there are many reasons for not wanting to have a piece of metal in a coronary artery. What do we need to know about DCB? We need to know where to use it, and we need to know the technique. And so these are some of the DCBs that are on the market at present time. Most of them are paclitaxel, but there are some limus balloons. Most of the evidence is for the paclitaxel balloon, although there is emerging evidence for the limus balloons too. In our lab, we mostly use the paclitaxel balloons, just to give you some insight. Now, these are some of the situations where DCB can be used: in-stent restenosis, de novo disease, small and large vessel, bifurcation lesions, diffuse disease, and then these are some of the patient subsets where there may be a role for DCB. The data on each of these is mixed, and so perhaps the largest data set is for the in-stent restenosis group. And I don't have time to go over all the trials. There are multiple trials, most of them small, looking at ISR in either bare metal or drug-eluting stent population, comparing randomly DCB to DES. And the bottom line is that if you look at collectively all of this data, this is a patient-level meta-analysis of 10 of these randomized trials, the Daedalus study, about 2,000 patients. And if you look at the composite on the right side, the primary efficacy point, which is in this red square, is in favor of a drug-eluting stent, driven largely by lower ischemia-driven revascularization. So DES seems to be better than DCB for ISR as a whole. Now, it's important to look at the data with a little bit more of a deeper dive, and this is a pre-specified analysis of the Daedalus trial, where if you look at BMS ISR versus DES ISR, you look at the efficacy, which is in green, and the safety, which is in red. For BMS ISR, DCB and DES are equally effective with no safety signal. So they're as effective with each other, but no safety signal. For DES ISR, it's a bit different. For in terms of efficacy, DES is more effective than DCB. In other words, if you put another DES in a re-stenosed drug-eluting stent, the efficacy is better. However, what is of concern is if you look at it down here, there is a safety signal. It doesn't reach statistical significance, but there's a very strong trend where there is numerically more longer-term events, death, MI, etc., when you put a DES within a DES. And the explanation for this is that BMS ISR is mostly neodermal hyperplasia, so it makes sense to use an antiproliferative drug. It should work. Whereas DES ISR is more neoatherosclerosis, and there's already been a failure of an antiproliferative drug, so maybe another antiproliferative drug is not enough. You need scaffolding. And so this safety signal is important to keep in mind, especially when you're putting in a second and a third layer of stent. So for BMS ISR, which is now of historical interest, we really don't use bare metal stents anymore, but nonetheless, DCB is as good as DES with no safety signal. But for DES ISR, DES is more effective, but there seems to be a longer-term safety signal which you need to keep in mind. Of course, it's important to remember that DCB is vastly superior to just using a balloon, and this is the Agent IDE trial, which was the basis for the approval of the Boston Agent DCB in the United States, where almost 40% of these patients had multiple layers of stent, and so they compared DCB versus just balloon angioplasty, and huge, big difference in the drug-coated balloon arm versus just POVA. There was no stent arm, which would have been nice to see. So for DES ISR, DCB is vastly superior to balloon angioplasty alone, but keep in mind that if somebody comes with DES ISR and he already has 3 layers, I'm not sure putting in a 4th layer is a good idea in that situation. What do the guidelines say? Well, there are no American guidelines on the subject because they didn't have it until recently, but the European guidelines give it a class 1. So class 1 indication for DCB for any kind of ISR, whether it's bare metal or DES. What about de novo disease, small and large vessel? Well, there's quite a bit of data on small vessel disease, a bunch of trials, small vessel defined as less than 2.75 or less than 3, basket small being the largest of the lot, but still only 750 odd patients. And the bottom line of these trials is that DCB seems to be either non-inferior or slightly better than a DES. So if you have a small vessel, if you use a DCB, it's as good or maybe slightly better than using a DES. And this is sort of data, one of those trials, the Restore as small vessel disease trial, but even over the longer term, the benefits of a DCB are they hold up. And in the Piccolo 2 trial, if you look at it on the right, the blue bar is MACE in the DES arm, much higher MACE with DES compared to DCB. Now, of note that there are no society recommendations for DCB in small vessels, but in our practice, we use a lot of DCB for small vessel disease, and I will show you a case or two. So, for de novo small vessels, DCB is equivalent to DES and may actually be better. What about large vessels? Well, the data set until very recently was actually quite limited. Large vessels defined as more than 3 or more than 2.75 in some studies. Overall, mostly small studies or observational studies. which showed that overall DCB was effective in this group. But the larger trial that very recently a large trial was presented and published, the REC-Cage-Free-1 trial, where they took patients with de novo coronary artery disease of any diameter, and half were small vessel and 50% were large vessel. They did adequate lesion preparation, defined as no dissection that is more than C, so no type D, E, or F dissection, residual less than 30% with good flow, and then randomize them to DES versus DCB. About 2,000 odd patients, 50% were small vessels, 50% were large, heavy use of scoring balloon. The crossover rate was very low, and at a median follow-up of 2 years, it turns out that device-oriented primary endpoint it failed to meet non-inferiority in the DCB arm. In other words, DES was better than DCB, driven largely by clinically driven and physiologically driven target vessel revascularization. Having said that, I will point out to you that the event rate is on the low side even in the DCB arm, although it is higher than DES. Now, if you look at the patients and stratify them by vessel size, it turns out that the larger vessel patients did better with DES, and that's shown over here. On the left is small vessel disease, no difference between DCB and DES. Again, cementing the idea that for small vessel disease, this is pretty robust. But for larger vessels, there's a pretty sharp divide in event rate, again, driven by revascularization, almost a threefold event rate in DCB compared to DES. Now, there are some caveats in this trial, and one of the biggest caveats is that the DCB used, it was a paclitaxel DCB called SWIDE, excuse me, which is not mainstream. It's only available in China. We don't have it. We've never used it. Whether or not that's playing a role in any of this is hard to know. But nonetheless, at this point in time, for de novo large vessels, DES is superior to DES is superior to DCB, not DES, that's a typo, compared to at least one trial with the caveats. Now, in the last couple of minutes, let's look at a couple of cases. This is a 62-year-old man with every risk factor under the sun, diabetes, hypertension, ESRD, presented in 2013, so a long time ago with a non-STEMI. And at that time, the left system was pretty good in the circ and the LAD. But the RCA in the RPL had a critical lesion. You can see that this is just about a 2O vessel, and this was treated with a 2O drug-coated balloon back in 2013. 3 years later, he comes back with chest pain, and this time the left has progressed. But I want to show you the RPL. It looks better. It looks widely patent, and if anything looks bigger, this is the positive remodeling that you often see with paclitaxel drug-coated balloon angioplasty. And the patient then had another angiogram 3 years later, so 6 years after the index event, and this remained open. Here's another case, young man, 37, unstable angina, and the culprit was this large diagonal with a very critical lesion. You can see a severe diagonal lesion up there. And I'll show you another view. Separate ostia for the LAD and the circumflex. Critical ostial diagonal lesion. These are difficult to treat because you don't really know what to do. If you put a stent, it protrudes into the LAD. And so what did I do? I used a cutting balloon, 2.5, opened it up, and then treated it with a 2.5/15 paclitaxel coated balloon, 8 atmospheres for 90 seconds, and this is the final result. You know, not perfect, but not too bad. Certainly better than before. He comes back 19 months later with chest pain, unstable angina, and this time there was new disease on the other vessel, which I'm not going to show you. But look at the diagonal. The diagonal looks beautiful, looks pristine. It's bigger. It is remodeled positively, and let me just show you. That's before. This is after DCB angioplasty, and then 19 months later, it is positively remodeled. One final quick case. This is a man with an inferior lateral STEMI, where the culprit was stented, and then he had an LAD lesion, which basically was a CTO. We referred him for bypass surgery. He was turned down. And I just want to show you what we did. Opened up the CTO with to go with a Gaia wire, and it was very tough to dilate 2O NC balloon with a big waist. Ended up needing to use an IVL, and this is what it looked like after IVL. So it looked reasonably okay. My plan was to stent proximally and DCB distally, like a hybrid approach, because on IVUS this whole LAD was very diffusely diseased and quite small. So we used 3 DCBs, 2 in the LAD, and then 1 also in the diagonal. And then after that, we get this dissection. Okay. Now this is the non-flowing section at type B because no holding up of dye. The dye dissipates, but nonetheless, it's an ugly dissection. What did I do? I decided to continue with my plan. I stented the LED, the good result on IVUS. And then 1.5 hours into the procedure, this dissection remains unchanged. And so what did I do? I decided to leave it. So we left it. 4 months later, he came back for an elective angiogram and look at before on the left and look at the after on the right. That dissection has completely healed up. Looks very good, looks very normal. And I'll show you another view of it. Bad dissection on the left, and on the right side, completely healed up. You can see it playing in slow motion. So the point I'm trying to make is dissection heals, so don't worry about dissections as long as it's not more than type C. This is how it looked like 4 months. So the technique, I don't have time to go over much of this. Lesion preparation, you want to get a good lumen gain with good flow. You want to know which dissections can be left behind, and look at the 1 ratio. Use rotablation or lithoplasty if you need to, like we did in this case. And you want to leave behind non-flow limiting lesions, non-flow limiting dissections, not no dissections. So leaving a dissection is okay as long as the flow is good and the residual is not bad. Otherwise we need to stent, and this is what the Asian guidelines say, the same thing. So to conclude, ladies and gentlemen, DCB angioplasty has an important role in modern practice. ISR is an obvious target, it has a class 1 indication, but de novo disease with a lean patients all could benefit from DCB. The technique, of course, is very, very important. Ladies and gentlemen, thank you. I'm happy to answer any questions.
Thank you. Thank you, Dr. Fahim Jaffrey. Now we move to next segment, and that is how would I treat session. And now the institutions which are participating are Lady Reading Hospital, Peshawar, and Faisalabad Institute of Cardiology. So first of all, I'll request Dr. Mohib from Lady Reading Hospital, Peshawar to present his case, and then obviously Dr. Hassan from Faisalabad Institute of Cardiology will respond. Over to Dr.
Case presenter. Presentation. Bismillahirrahmanirrahim. I am Dr. Mohib, working as a fellow intervention in cardiology at Lady Reading Hospital, Peshawar. I would like to thank the forum for giving me opportunity for this presentation. So, this is a story of a 91-year-old female with history of class 3 angina despite optimal medical therapy, previous history of hypertension, pertinent history of coronary artery disease. She has undergone coronary angiography twice previously at another institutes in 2020 and 2022. She was advised CABG but turned down by the cardiac surgeons. Vitally, she was stable. Her ECG had normal sinus rhythm. Estimated GFR was 74 mils. Troponins were normal. She had preserved LV systolic functions and no regional wash motion abnormalities. So let's look at the diagnostic coronary angiogram done through the radial approach. In the caudal views, we can see there is severe disease in the distal left main stem, osteoproximal LAD, and some calcification. Circ has severe lesion after the origin of OM1. The OM1 is also severely diseased at its osteoproximal part. In the cranial views, we can see the mid and distal LAD is normal. The RCA is non-dominant, a severe lesion in the proximal part. So, what should be the strategy in this 91-year-old female with class 3 angina despite optimal medical therapy?
So a very interesting case by Lady Reading Hospital. First of all, it's a 91-year-old lady and obviously mid-shaft left main disease. And over to the experts from Faisalabad Institute of Cardiology, Dr. Hassan, to say how would he treat, and then Lady Reading will respond.
कौन सी वाली आपकी?
What would I do?
ऊपर
जी, recent most.
पहली वाली है ना? ये पैसी है, यही है?
जी ओपन.
Assalamu alaikum. I am Dr. Hassan Randhava, working as Senior Registrar at Faisalabad Institute of Cardiology. You have seen the angiogram, and now we'll just go for case summary for this. As you can look over the angiogram, the severe distal LMS and calcium chunk in distal LMS. This is a left dominant system with moderate osteal disease of LCX and angulated LAD with 40 to 50% osteal disease. Narrow angle between LAD and LCX and 70 to 80% distal LCX disease. This is a calcified LMS, and as you can see, as you have heard, about 91-year-old this lady, and it is a surgical turn-down case, then it would be managed percutaneously. This is how I would manage this case. I would take at standby for intra-aortic balloon for circulatory collapse if happened during procedure. Challenging wire during LAD, I would take up the San French guider and place a TPM lead in RV, workhorse wire in LCX, and while doing the wiring in LAD, I would take a polymer-coated wire, either angulated microcatheter or double lumen microcatheter or reverse loop I would take to cross the LAD. Pre-dilated LMS and with 3 NC and with LCX with 2.5. If LMS holds well, I would just go for an IVS run. Review LMS for calcium and needed for atherectomy, and lead review LAD and LCX with significant disease. IVS for distal LCX, and as I did the NC balloon 2.5 in distal LCX, either I would manage it by DEB or through stent. Now strategy for LMS. After doing IVS, I would just decide go for debulking technique. It would be rotational atherectomy. I've taken up the San French guider for 1.75 bar per rotor pro. And after doing atherectomy, I would just review again by IVS, and either for calcium fracturing and needing for the cutting balloon, that is a rotor cut. My first strategy for going for this PCI would be DK culotte, that is angle is quite narrow and is a sizable LCX vessel. I would just go for LMS to LAD 3.5 and port with 5. Rewire the LCX and do KBI, and later on just stent the LCX by 4. Port again with 5 and rewire LAD and KBI again, and final port with 5 balloon. My second hand strategy for this procedure would be DK crush, in which I would just place a 4 stent in LCX and crush it by 5 balloon, rewire LCX and KBI, and later on stent LMS to LAD with 3.5 or 4 stent. Port with 5 and rewire LCX, go for a KBI, and final port with 5. The strategy can be modified as by taking side branch LAD as a side branch and recrossing to angulated LAD. With crest stent may be a difficult thing because chunking up the metal inside the left main would be a difficult thing to recross for LAD. My last and third option would be LMS to LAD with DEB to LCX if evident minimal disease in ostium of LCX while doing IVS run. And these are my 3 basic, top of the line is DK with culotte, and second one DK crush, and third one, if there is evident minimal disease at the ostium of the LCX, I would go for LMS to LAD. Thank you.
Can I request the enthusiastic audience at the back, please maintain the quorum of this session. Thank you.
ठीक है, क्लोज कर रहे हैं। नीचे वाला था ना? हाँ। किधर से हम लोग? यहाँ? नीचे, नीचे, नीचे, ये।
Panelists, you have seen the case before. Dr. Maheb presents. How did he treat? Any comments from the panelists? Jalal, Nasir Samor Saab, or Bilal? Any comments?
I think it's a complex case, left main distally involved, quite calcified lesion. I think lesion preparation, bed preparation would be very much desirable, good bed preparation, and then choosing the right bifurcation strategy over here. So DK crush, I think, is the strategy of choice because it's a stable case, 90 years plus patient, and we have to go with optimal bifurcation strategy from here.
I think I agree with Professor Jalal. IVS would be really very helpful in deciding the sizes of the stents and also to have a look on the osteal circumflex to quantify its severity and then to decide about the strategy of the left main to LAD and circumflex stenting. Thank you.
Yeah, I would agree with whatever's been said. Lesion modification, I would certainly pursue rotational atherectomy. It's a calcified nodule. Using a large burr, 175 burr is reasonable. Once you do that, intravascular imaging. I'd have to look back at the angiogram. I can't remember what the circ ostium looked like. It didn't look so diseased. Maybe I got it wrong. But, you know, keeping it as simple as possible. I mean, a provisional left main to LAD would be great. The patient's 91 years old.
So we took 7 French EBU 3.5 guiding catheter through the right radial approach using balloon assisted tracking. So circ was wired with the workhorse guide wire. Navigating the wire from LMS to LAD was challenging. It was wired with samurai guide wire. Lesion in the circ was initially pre-dilated with 2.5 SC balloon, then was further dilated with 2.75 NC balloon along with the LMS. 3x20 drug-eluting stent was deployed in the circ. Post-dilation with 3.5 NC. Pre-dilation with 2.5 SC balloon in the LAD and then 2.75. The lesion was further dilated with NC 3.5 at high pressures. Three into 24 drug-eluting stent was deployed in the proximal LAD. Stent positioning in the caudal and cranial views. 4 into 20 drug-eluting stent deployed from ostial proximal LMS to LAD, overlapping the distal stent. As you can see, there is no spillage of the dye into the vessel while the stent is being deployed. Port done with 5 NC balloon at high pressures. Ostial flaring. Stent in the LAD post dilated with 3.5 NC. Report again with 5 NC balloon at high pressures. We can see there is no negative port puff sign. And the final shots. So post-procedure, the patient was stable. He was discharged home on optimal medical therapy. She performed even Umrah after 3 months. She is doing well on follow-up. I think in our setup, PCI is a viable option in patients like these who are turned down by the cardiac surgeons. Thank you.
So the floor is open for questions, but we are running short of time, so we can take a couple of quick questions.
I guess the first video was balloon tracking through the radial artery. So in that balloon tracking, balloon was not inflated. I don't understand that because the balloon tracking was initially done in the center where I work by Professor Mamas. He did, initially we thought it was a crazy idea, but I noticed that balloon was there, which is correctly positioned half out, half in, but was not inflated. So that's only just providing support. That's not really balloon tracking. So balloon tracking, smaller balloon, need to be low pressure, need to be inflated half in front of a guider, and that's how reveal the spasm will be less. So small artery, you can get your bigger guider. But that's not proper. To me, it's not a balloon tracking. What I don't know what panel thinks.
Can I come in? Hello, can I come in? Actually, balloon was inflated, but the contrast was less, so that is why it was not visible.
What he's saying is that because of less contrast, the balloon was, though it was inflated, but it was not obvious on angiographic views. So
just one thing I want to ask about, no IVUS pre or post procedure, because distal left main and proximal artery wasn't looking that much prepared for the stent. So any post procedure IVUS to see the status of stent expansion and subintimal.
Yeah, that is a very valid comments. We should have done the IVUS, but at that time the IVUS was not available. So otherwise we have prepared the bed sequentially, initially with the 2.5, 275 and 3.5 NC balloon.
I think one thing here in this case, there was a very clear situation, age versus disease. At 91, I would be very careful doing minimum possible to help his symptoms.
That's a very fair comment, sir.
Yeah, and that is exactly what is done. It was kept simple, and even 40-50% osteal changes in circumflex is very acceptable. I'm happy to look at the result, and that should be.
Thank you for bringing this in perspective. At the conclusion of this very interesting session, I would like to thank everyone for their engagement and active participation. Thank you.
So the next session, we're going to get started with that on coronary imaging and physiology. I have Professor Bilal Mohyuddin and Suhail Salimi moderating this session with me. I would request the chairpersons, Dr. Farooq Jalisi, Dr. Najib Azim, Dr. Shahid Abbas, Dr. Tariq Abbas, Mohammad Bilal Siddiq, Salman Waheed from Shifa, and Masood Ahmed, Umar Mufti, Naveedullah, all those who are here as chairpersons to come onto the stage. Now, Fahim Jaffrey was a very eloquent speaker. I really enjoy his talk, and so he's going to be giving us a talk on clinical decision making based on coronary physiology. Where do we stand in 2025? So if we have his talk, is he ready to go? Please get him on the screen.
My name is Fahim Jaffrey. I'm an interventional cardiologist here in Singapore. I must apologize on two counts. First, for not being there in person, and that's basically because there was a scheduling conflict with another meeting that I was committed to attend in Korea. And the second reason,
Can we have the other talk on clinical decision? Yes, come on. No, fine. नहीं वो चेंज करने लगे हैं दूसरी ऐड कर Dr. Qazi Zapoor, can you join us on the stage as a panelist? Is it going to be a while before we... And are we connected with China already? They're ready to go there? Okay. अच्छा क्या हुआ वो दिखा देंगे अच्छा अच्छा अच्छा तो बीच में दिखाने के लिए अच्छा तो वो मैंने वो केस में मैं नहीं देख रहा बट वो क्या बीच में आता था सीट अच्छा अच्छा तो वो क्या उन्होंने कर लिया केस तो ब्रीफ कर लिया अच्छा बट इतना टाइम होगा तो बीच में वो भी दिखाने चाइना भी कर लेंगे तो फिर मेरे ख्याल से चाइना ही करते हैं और फिर उसके बाद देख लेंगे लाइफ स्टेज
चेक कर ऑडियो तो लगी हुई है
बहुत देर लगा रहे हो कितनी होगा रेडी हो तो शुरू कर देना कितनी देर लगनी है चाइना को भी आना रेडी हो You know, this is an important session, very much neglected in Pakistan with the, it's a class 1 indication now, ESC, ACC, all of them have given a class 1 indication to use imaging and physiology with coronary interventions. I guess there's a delay in the talk being set up, so we're going to go live to China. And Professor Bilal, I believe you have to leave, so you want to do the China session there.
Nanjing First Hospital is very close to us because... Good morning, Nanjing. How are you? Good morning, Nanjing.
Yeah, good morning. Yes. Can you hear me?
I understand it's more like good afternoon over there.
Yes, afternoon. Yes, great.
This is Professor Bilal Mohyuddin from Pakistan. We're good friends with Cheng over here, and a lot of his friends are over here. And First Nanjing is extremely important to us. I understand Yifi is going to is leading the case. Yifi, would like to introduce your team and tell us about your case, please.
Yeah. Thank you. This is Nanjing First Hospital, and thank you invitation to Knife Case for this conference. And first of all, I introduce my procedure team. On my side is Dr. Go and Dr. Tao. And my imaging and technician is Dr. Pan and Anderson Yan and Anderson Yuhang. And first of all, I asked my colleague, Dr. Go, to introduce this case and clinical information. Please, Dr. Go.
Okay, thank you.
This is case level 6 from Nanjing Forest Hospital, and it's my honor to introduce this case. This is a 57-year-old gentleman who was admitted into our hospital presenting with recurrent chest pain for 20 days. He suffered from essential hypertension for several years. After admission, the lab test found his eGFR and the BNP was normal. ECG found elevated T values in these 2, 3, and IVF. His echo found left ventricular ejection fraction slightly reduced, 51%. He was diagnosed as unstable angina and essential hypertension. Next. 1 week ago, this patient, after admission, this patient on the way to coronary angiography. The baseline angio find very severe stenosis at middle right coronary artery. According to the ECG, this might be the palpable lesion. Yeah, next. From the epicardial view, we could find from the ostium LAD and to the distal LAD, there is very severe stenosis, and there is also have a high diagonal. It's not big, it's small. And the left main is very short, but it's very large. And from the ostium or left circumflex might seems normal. Yeah, at the distal left circumflex is intermediate lesion. Next. From spiral view and LA cranial view, we can find a very big second diagonal, and it's very large. And the ostium of the second diagonal is very severe stenosis, and the length of the second diagonal is more than 10 millimeter. Next. So 1 week ago, we tried a drug-eluting stent at the right coronary artery. So the chest pain, the patient did not have any chest pain. Next. So today, the target lesion is LAD and second diagonal bifurcation. The syntax score for this lesion is 18, and we also calculate the syntax 2 score. 4-year mortality for PCI was 5.2%. 4-year mortality for cabbage was 9.6%. According to definition criteria proposed by Professor Chen, LAD second diagonal is definitely a complex bifurcation lesion, and LAD first diagonal is a simple lesion. Next. Yeah, this is very familiar with the definition criteria. Next. After Professor Chen report the results of Ultimate trial and IVAS trial, both 2024 ESC guideline and 2025 ACC guideline recommend intravascular imaging should be used for complex PCI. Next, the recommendation is class 1 CVA. So today our strategy, I've guided PCI and the Digger brush for complex LAD second diagonal bifurcation, and the provisional standing for simple LAD first diagonal bifurcation. That's all. Thank you.
Okay, thank you, Dr. Gao, and introduce this patient clinical information. Okay, I summarize this case. This is stage A PCI for the left coronary artery, and LAD is diffuse lesion, and the LAD diagonal 2 is the 2 bifurcation, and it's diagonal lesion. And I think this is clinical information, and I think now we can discuss this lesion, this case, and to how to treat this case. Thank you.
Well, the case, of course, is rather complex and interesting and challenging. So what is your take on it? You intend to do first the imaging studies and then move forward, or how would you like to go forward with it? And where do we stand with it right now?
Okay, as for this true publication, and definitely it's true publication. Okay, according to Professor Chang, his definition criteria is complex bifurcation. So I will show you what I've done. Okay, so next. First of all, is uses the radial approach, and the 7 French EBU 3.5, and 2 wire runs through and CM blue into the LD and diagonal, and we use proper. From this, all auto AP view, we can see this diagonal osteomus severe disease. So we used the 15 compressed balloon to pre-dilate and check iris for the LD and diagonal. Okay? Dr. Pan, can you show the iris imaging for our experts?
Okay, let me show the iris imaging. Can you see the iris imaging? The first round, we check iris from distal LAD to left main after pre-dilation. And here, this is the distal landing zone, and here the vessel diameter is about 2.5. Then go and pull back, we can see eccentric plaque. And here, this is the LAD and the third diagonal bifurcation. And here, the lumen area is just 1.4 millimeter square, and the plaque burden is more than 79. Then go and pull back. The vessel is in middle LAD, and the middle LAD vessel diameter is about 3.1 millimeter. Then go and pull back. We can see calcified plaque. And the calcification angle is about 180 degrees. Then go and pull back. Here, this is the LAD and the second diagonal bifurcation. Near here, we can see the vessel diameter is more than 3.6 millimeter. Then go and pull back. This location is the LAD and the second diagonal bifurcation. And here, the area is just 2.5 millimeter square, and the plaque burden is more than 80. Then go and pull back. This is a proximal LAD. The proximal LAD vessel diameter is more than 4.1 millimeter. Then go and pull back. This location is near the ostium LAD. And here, this is the diagonal 1 bifurcation. And here we can see the diagonal 1 vessel is very small. Then go and pull back. This is the LAD and the circumflex bifurcation. And here, area is just 77 millimeter square. And then go and pull back. This is the POC, and this is the distal left main. We can see the distal left main. The plaque burden not very large. It's just 29 millimeter. Then go and pull back. This is the middle left main. The body left main also vessel is normal, and the EM more than 6 millimeter. We measure the whole readiness from the distal landing zone to LAD, and the second bifurcation is about 68 millimeter. And the nettiness from the distal landing zone to ostium LAD, the nettiness is about 87 millimeter. Okay, this is a baseline iris imaging.
Okay, thank you, Dr. Pan. We introduce the iris imaging. Here we can see from the iris parameter, it's a very long lesion from the distal LAD to the ostium LAD. So first of all, this is a pre-dilated diagonal, and then we pre-dilate to the LAD middle and the distal. And based on iris imaging, we use the 2.5 to 3 millimeter drug-eluting stent input in the distal LAD. Here is the stent deployed. And then we use the 3029 millimeters drug-eluting stent putting in the middle LAD. Here so we have done. And then we will deal with the bifurcation lesion. Okay? So, and based on the iris imaging, its diagonal 2 is 2.6 millimeter. I will use the 2.5 diagonal stent into the Tiger 2. Okay. Here.
The second stent appears to be slightly under-deployed. Did you post-dilate it?
Yeah, already the post-dilated.
Okay. So let me take opinion from our worthy panelists. Would you like to add something as far as the IVUS images are concerned? Or Tariq Abbas, the Qazi?
It's a very complex and diffuse disease throughout the LAD, I think, and there's a patchy areas of calcifications. Somewhere is more and somewhere less. The approach would be either you do the stenting of whole LAD, but the problem is with the diagonal branch is a small vessel, and I would like to do the instead of having a lot of metal, just to do balloon to keep it open. If there is some one or two type of dissection, I will accept that. And the second thing is I can think about using the drug-eluting balloon also in the side branch, and the rest of the procedure is the same like standard procedures.
Anyone else? Qazi?
I think in the proximal part of the vessel, I think there's a significant amount of calcium. So I'm just wondering if they were thinking of prepping that lesion with IVL. That might help, because in some sections it was like almost 180-degree arc or more.
So, Dr. Fahim, I understand you are with us live. Dr. Fahim? Any one of our panelists also want to add on to the opinion?
Opinion is the same, should go for the pre-dilatation of the LAD and PCI to LAD and drug-loading balloon to the side branch, which is not very much significant.
Right, so from here basically the panel is of the opinion that these are diffusely diseased vessels which require aggressive intervention, and of course the diagonal does appear to be very small, so like to cut down on metal part. What is your take currently on such diffusely diseased vessels? Rather than doing all by metal, you first try a DEB and see if that holds, or you just simply go with a metal, looking at all that calcification that we have?
Yeah, because this is diagonal 2 is only one largest sand branch for this LAD, so I think it's important vessel. So I don't want to do the provisional standing for this case. So I want to do the post-stand technique for this bifurcation. So it's the decay crash is commonly used in our case lab. So here is what to do the decay crash for this bifurcation, and we deliver the 2.5 stent into the diagonal, and before the side branch is then deployed, I pre-posting the non-compliant balloon 3.0 into the LAD.
So in terms of the proximal, hi Bilal, can you hear me? This is Shaoliang Chen from South Korea.
Hi Xuan, good to hear from you.
Hi. Yeah, to say hi to all my friends there.
Yeah, they're all saying hello to you from here too.
Yeah, I'm so sorry. I apologize for being able to participate live this year. In terms of the case, so for the proximal severe calcified lesion, based on the IVUS finding, I don't think the calcification is very severe, because the calcification thickness is pretty small, and also the calcified arc is less than 120. So I don't think we need to use IVL. That's my comment. Thank you.
So when you talk about the thickness of the calcium, what is your cutoff?
Yeah, actually, based on the guideline recommendation so far, I think the calcification arc greater than 180 degree. That's one-off cutoff. Then if the calcification thickness greater than 200 micrometer, I think these are very important cutoffs.
Right, so 180 degrees calcification and then 200 micrometers. So Fahim, since I can see you are back online, so what is your take on the images that if you saw?
Yeah, great case. I agree with Dr. Chen. I think I would just do ballooning for the proximal calcium. I didn't think it was that bad. I think for the diagonal, I would have probably just done DCB and and gotten the diagonal sorted out, and then do a DK crush more proximally for the main application.
Yeah, I fully agree. For the bifurcation, I think first diagonal is not severely diseased. Second diagonal is pretty severely diseased. I'd like to use DK crush for AD and the second diagonal.
So when you have these arcs of calcium, at what stage would you really say that this time it is extremely essential that we should either go for the newer arthrectomy techniques or the old one where you want to just do a rub it down? So which is the one that you're going to opt for?
I think if you have concentric rings of calcium and long lengths of concentric rings of calcium, that's where you worry that it may not open with the balloon. I think it's still reasonable to try a balloon-based strategy first. Go with a high-pressure NC balloon. If you're able to open it up, fine. If not, then you can either go with IVL.
Bilal, can I ask was this I know in the risk factor they didn't mention, but it's 57-year-old, very heavily calcified, diffuse disease. Was the patient diabetic? That sort of disease we see in diabetics, because if there is a diabetes, it will affect your mode of revascularization.
Right. Added more over here or any, but if you have that size, or if you have a calcific nodule, and if the calcium length is more than 5 millimeters or thickness is more than 0.5 millimeters, those are the other criteria which help you decide whether to address the lesion with IVL or rotational arthrectomy first. The nodules have always been an issue in terms of intervening. The earlier they were doing to shave it off, and probably rotational arthrectomy is better, but now I think Dr. Chen and Fahim and others can comment as well, but now they're saying IVL is probably better because you can hit it deep, because some of these eruptive nodules reappear. You just don't shave them off. So there's a whole debate about eruptive nodules versus calcific fibrotic nodules on the surface. So I'd like, while we're waiting for the case being done, thoughts from Dr. Chen or Fahim there on that.
I think
the problem always comes in when you have those small nodules over there, which are like about 70 or 80, and you really don't know whether you'll be able to focus on them properly or not. Panelists.
So nodular calcium is a difficult animal.
IVUS, right? Because here IVUS was done in the beginning, and I think based on this IVUS, I probably will not do arthrectomy in this case. I think you can get away without arthrectomy. But when you're not doing imaging, then it gets tricky. Fortunately, with IVL, it has become a little easier. Because you don't have to deal with rotaregret. If your balloon is not expanding, you can, for most part in the US, you can get away by doing IVL, and you will be able to expand. Here, calcium distribution is more. I think it's not only the arc, it's also the thickness and the length of calcification. Here, it is more patchy. And I think you can get away without arthrectomy in this case if your non-compliant balloon does not work, angiosculp or cutting balloon, you will be able to deal with it most likely. Second thing about provisional versus upfront dedicated, I probably would have gone with provisional. Long diffuse lesion in LED, I agree that diagonal is probably a reasonable size. It's not a very small diagonal. But 51-year-old, 90 millimeter long lesion. We have DCBs now. And then you can always change to bifurcation later. I would have gone with provisional and maybe DCB in this case if needed.
So, Cheng, what would you consider as in such patients as a form of modifying the lesion before you start going in? Would you just simply go in and balloon and start stenting, or would you prefer always to have a vascular preparation? And if you do prefer a vascular preparation, then which technique? The same question was also for Fahim.
Oh, thank you once again. Yeah, because I want show very severe calcification. So I think using non-compliant balloon or even cutting balloon is good enough. And after ballooning, I think we need to say if the balloon could be expanded very well. For this case, the balloon was expanded very well, and vessel lumen increased too much. Second point is that actually, for diffuse calcified lesion, particularly involving mid-segment or distal segment, absolutely we will use rota. But for proximal, very severe calcification with a calcified thickness greater than 200, absolutely we will use IVL. Another choice is orbital, but orbital is associated with a relative high rate of perforation. So in general, the cutting balloon, scoring balloon could be good enough for mild to moderate calcification. So I think now is the time. Oh, another point there about DCB for side branching. This year we just published our DCB BIF clinical trial. We only include a simple coronary bifurcation lesion. But this case has a very complex bifurcation lesion. So I think Gajen and my team has done something.
Yeah.
I didn't think diagonal. I think now it's time to introduce all steps you have done so far.
Okay. Because we use the non-compliant balloon 3O to pre-dilate the LAD, and even from the IFS imaging, we can see the calcium arc is less than 118 degrees. So also use the non-compliant balloon expansion very well, 2.3. And non-compliant balloon to crush, and also use the 3.5 hot balloon to crush. And
Yeah,
this
actually-
pot.
Actually, after first balloon crush, so angiographically there is type A dissection, I think. Go ahead.
Yeah, from the IVS imaging is the proximal the main vessel is diameter is 3.5. Also, we use the 3.5 pot balloon to crush the side branch stem. And here we can see the pot balloon the crush. The pot balloon is invented by Professor Shaoliang Chen. It's dedicated pot for the bifurcation balloon, and we can see the balloon is different from the convented balloon. Here we can see the balloon is short, very short. We can position the cornea and to do the proximus crush.
I'm not sure if a pop balloon available in Pakistan. The pop balloon has a very short shoot at the proximal and distal edge. So I think it's very, very suitable for post-dilation.
We've just started using it in Singapore. It's really, really good.
So
congratulations
Fahim, what
to
is
you,
your
Dr.
take on the
Thank you,
need for
Fahim.
vessel preparation? Which technique in such vessels should be, and how should we go ahead?
So, if you have a lot of nodular calcium, we will tend to ablate, but I think here I agree, just a high pressure balloon dilation was adequate. We also have a low threshold for using IVL. I probably would not have used IVL over here. I think you could probably get away with a good high pressure NC balloon dilation. I think in Pakistan, probably your threshold for ablation needs to be lower if IVL is not available or too expensive. So you have to kind of modulate what you do based on what's available. But, I agree with what's being done so far.
So any experience with either of you with high pressure ballooning? So, we always have this debate that should you be just on a standard pressures or high pressures. So what is your take?
So I tend to go with slightly smaller balloon, but
uber high pressure. So, I'll take if it's a 3O vessel, I'll take a 2.5 and go up to 28 atmospheres, go up slowly, watch the balloon, make sure it doesn't rupture. And usually you can get away with very good, dilation. OPN is another option, but OPN is, and adds to the cost and other things. And so I think just a regular NC balloon, smaller balloon, much higher pressure works very well.
The smaller balloons always have a problem that, they tend to slip very easily. So your ability to focus on a standard point at times becomes tricky.
Sorry. You take a slightly longer balloon, but then after that you need to make sure you go 1:1 with an NC balloon at moderate pressure and make sure you see full expansion in orthogonal views. And if you have full expansion in orthogonal views, then you've dilated the vessel and you're good.
Okay.
Bilal, can I ask, it's been mentioned for the side branch use of DCB, which is obviously a lot of us do use. I want to know what's the people experience with this sizing for that. Is it that you 1:1 or go smaller? Because recommendations, I understand what are, but our experience is we go slightly smaller because we don't want to dissect this small vessel. But I don't know what's the other people experiences. Sizing of DCB in a side branch. Did they go 1:1 or they go?
For sizing, of course, over here you have had the advantage of doing a prior imaging. And that imaging has already given you a sizing, but the sizes have been quite, let's say, kind to you because it says...
No, I understand. I'm saying what ratio do you go with the size? Do you go balloon size is the same as the side branch, or do you go slightly under? Because obviously recommendations at least same size, but our experiences we're trying to go like slightly under.
I think
because they dissect quite a lot otherwise.
Tariq Abbas wants to take on the question.
Yeah. I think if you go undersized balloon, you will not be delivering the drug to the lesion also. So the two sides of the thing, definitely you are preventing the potential of dissecting the side branch, but at the same time, if you are using undersized balloon, you are not delivering the drug to the lesion also.
You see, usually it's a vessel preparation with the 2 balloon, and then whether you put in a 3 or a 3.5 or a 4 or 2.5. We started doing a 1:1 dilatation prep when we were especially using the bioabsorbable stents. Now, since the bioabsorbable stents are gone, so usually as far as balloon preparations are concerned, we don't cross 0.8. But at times, we do go, especially when you're doing a left main, you do a pre-ep with a 3 or a 3.5, and then you go forward if you're especially planning to put a 4 or 4.5 stent over there.
Yes, I think it's a recommendation. It should be 1:1, but it should not be more than the size of the vessel. But
no, I don't think so. I disagree with your statement. So
I think Cheng has a point over here. Yes, Cheng.
Yeah, DCB ratio should be no more than 0.8. So for the, if the side branch vessel diameter is 3, so we prefer to use 2.5 millimeter DCB. That's a requirement. Yeah, right now I think Dr. Ge has rewired second diagonal, right? So
yeah. Yes.
Could you tell us the key point for the rewiring?
Yeah, this is already used the LED non-compliant balloon to crush the side branch stent and rewire the side branch. And here is some of the typical tricks and how to easily to rewire. So first, I think to crush the side branch stent very well is a great step. So first of all, rewire is difficult, so I use the 2.5 the non-compliant to crush again, and then use runs rewire and into the side branch. Okay, and for decay crush technique is first rewire, and from the proximal stent strut is very important, because if we use the distal stent strut, probably when we do the first Kishin balloon deformation, then probably distal is side branch wall, maybe those stent struts are covered. So here, after that, rewire and use the IVs to check this wire is from the proximal stent cell or the distal, and here use the IVs to check it. Okay?
One simple quick question. You see, there's always this desire to go from the distal most strut as far as doing a crossing into the side branch is concerned. But as we saw over here, it was becoming a challenge to go in. So at times then you're just sort of left with the fact that you just need to get into it. So how important is it to really take on to the most distal one, or just cross when you just can't cross? For him, would you like to take on
the... I think it's a great question. You know, we just finished our DK Crush A trial. In that trial, we only included complex verification, randomized to IVOS or angiography guided. So in the IVOS guided group, in the IVOS guided group, almost 30% of rewiring from the distal cell. So it means without the IVOS guidance, so probably almost 30% of the first case in balloon infection will be done in a wrong way. This will be not good for decay quash. So Pantau can show us how to define the revive from the proximal cell.
Yeah, let me show the IVOS.
Right. Nanjing first, probably we'll be leaving you in about a minute or two, because we have another live case also coming in, and then what we'll request you is that once you have completed your patient, just stay with us and we'll take you on in between again, and then you can just show us all the things that have been done.
This part of looking at the wiring with IVOS is very important. I would suggest you let them show it.
Sure.
So you are wiring with IVOS now?
I think they were showing how they look at the cell in which the rewire is crossed using IVOS.
So Pantau, can you hear us?
Yeah.
Yeah, show us how to define the rewire from the proximal cell. Go ahead.
Yeah, here we can see the guide wire at 9 o'clock, and here we can see.
No, we cannot see. We cannot see.
Okay.
Central IVOS image.
You see?
看不见，你们那边好像信号已经断掉，已经僵硬了。
他们是不是那边是转到那边个？
不是，我们的信号好像。
你们的信号不是很稳定。
打点名。
So Bilal, can you?
现在可以看见吗？
不用，一模。
So Bilal, can you hear the voice from Nanjing?
Yeah, we can see you.
Bilal, can you hear me?
Yes, sir.
那我觉得他们听不见我们。
Yeah, there was a bit of a voice drop in between, but now we can hear you again.
Oh, how to?
Okay. Pantau, go ahead to show IVOS image.
Okay, let me show the IVOS imaging. In IVOS, I will at 9 o'clock we can see the.
Well, we are not getting your images at the moment.
把 IVOS image 放到这个大屏上。
Here, can see?
Yeah, your image is frozen. We can't get you live over here.
哦，但是好像大屏上的 IVOS 没有传到这个会场的屏幕上去了。Bilal, can you see IVOS image?
Yeah, we're not getting any, not getting fresh images at the moment. They're all frozen images.
对不起，他们现在没看见。So I think Bilal, you can move to another live case.
I think maybe come back and show it then.
Yeah.
So what we'll do is we'll just make all the recordings, also of the side hole entrance with the IVOS, and then we can have it with you as we move on to our next live case, which is coming from Rawalpindi Institute of Cardiology. Sure. And I'll hand over the mic to Professor Numan now.
Thank you, Dr. Bilal. So the next case is a multi-vessel CAD case with the rotational atherectomy, and they'll be using imaging to guide us through the case. And I believe Dr. Asim is doing the case, Dr. Asim Javed. Can we have the... Dr. Gul Zaman and Dr. Asim Javed. Can we connect to RIC, please? Okay. So we'll have a brief presentation regarding the clinical. आपका क्या नाम है, Dr. Asma will give us a brief history of the case.
ये वाली थी ना? RIC2 ये इसके अलावा RIC2 3 के 6 आखिरी मेरे पास पड़ी है नहीं 2 सेकंड का
USB दूं? हाँ है
नहीं 2 सेकंड
So waiting for this presentation, we started because it was an imaging session, and they have the IVIS runs on this presentation for the case. So that's why it's not just the history. I believe they did the imaging before, and they have the runs here, and they're just going directly for a rota over here right now. So unlike the last case where there's just 180-degree arc of calcification, it didn't meet criteria for any, apart from non-compliant balloons is what they went for. We got a good response. We'll see what we find in this case, which prompted them to go for rotational arthrectomy on imaging.
Assalamu alaikum. So let's first discuss the history of this patient. It's a 66-year-old male. He's diabetic, hypertensive, and smoker. He had a PCI-2 LED done about 6 years ago, and now he's presented with angina CCS class 3. So the ECG did not have any acute change. The echo showed an ejection fraction of 50%. So this is the first view, the apicaudal view. You can appreciate a lot of calcium in both the LED and the circ territory. In the epicranial view, you can appreciate a stent in the mid-LED, which appears patent. Now, in the iliocranial view, if you focus on the ostium of the left circumflex, it appears significantly tight, whereas in previous views, you could see that it was a moderate lesion. The iliocaudal view, if you look at the ostium of the LED, it appears as a hazy critical lesion. The RCA was non-dominant. So for this purpose, the patient underwent an IVIS of the left circumflex first, and as the operator was passing the catheter into the left circumflex, he did face a bit of resistance. So this is the IVIS run. I'm sorry. Well, now this is the catheter being pulled back from the left circumflex into the left main. You can see a lot of calcium, at least a 270-degree arc of calcium, which is causing a lot of dropout. Now this is the circ ostium, and there is a calcific nodule at the ostium of the left circ. And when the catheter is pulled back into the left main, this nodule is extending into the left main stem. These are the still images of the left circumflex. Here in the first image, at the ostium of the left circumflex, you can see this nodule, which is basically extending into the left main. And that was the reason why in the iliocranial view, it appeared quite tight. It's approximately a 270-degree arc of calcium in the mid-LED where the operator was facing a bit of resistance. Now, the reference vessel dia was taken for stent sizing and it appeared to be 3.8 mm. So a stent size of 3.5 mm was decided for left circumflex. Now this is the IVIS run from left main stem to LED. Now this is a catheter being passed from the left main stem into the LED, and you can see a calcific nodule at the 6 and 7 o'clock position. And once the catheter entered into the LED ostium, there was a significant calcific arc of approximately 180 degrees and a huge plaque burden, which was causing the significant narrowing and the critical hazy lesion, which you could see in the caudal view. So now this is the same plaque burden which is into the mid LED and it's quite calcific. These are the still images of the LED, and at the ostium you can see a 180 degree arc of calcium with an MLA of 3.1 mm, and the reference vessel dia sizing was taken, which was 3.8 mm, so a stent size of 3.5 was decided. The IVIS image of the left main stem, where a calcific nodule is seen at the 6 o'clock position, and the reference vessel and the dia of the left main stem was 5.3 into 3.8 mm. So the patient has triple vessel coronary artery disease with high Syntax score, and he was advised CABG as a first option, but he declined it owing to his domestic reasons. So now let's go over to the team and decide what they decide further. Thank you.
Thank you. So nice presentation. The IVIS, can we go live to Dr. Asim?
Yes, hi Noman.
Hello, Anji. So can you tell us what you've done so far and where you're with the case?
So welcome to Rawalpindi Cardiology. With me, I'm assisted by Dr. Gulzman, and is our expert.
We still can't see, yeah. So,
Shahid and Faisal. So you've seen the diagram. I'll show you the first diagram view as well. So you also have the screen on.
Yeah, we can see your angio images.
Yeah. So it's say wide.
Sort of smoothen out and shave off some of the proximal edge of the old mid-LED stent, because the new stent will be going and overlapping with the old one.
So, Noman, I want to remove...
What RPMs did you start with, and about your experience of using aminophylline, would you routinely give it in LED or non-right cases, or thoughts from the panelists regarding that in terms of...
Noman, if you could just give me 1 second to show how the signal operator removes the rotabur, and then we will answer all of your questions. So just going to show, I've come back to the Dynaglide mode, and
you can even just pull it out, huh?
So I'm just pushing my wire in, and the burr is automatically coming out. If you see my O-ring, the sheath is coming out, the whole system is coming out. I'm just pushing on the wire.
Okay.
I'm not removing anything, I'm actually pushing the wire.
Up.
All out? Okay, that's it.
Nicely done.
There's a click system. Yep, I'll take care of it. Thank you.
Noman, can I ask a question?
Noman, you
yes,
can
please.
ask your questions.
Sure. So what 1.75 is compatible with 6 French system, which is fine. So 2 questions actually. Are they using 6 French system or 7 French system?
No, this is
And the second is this, that because it's a very prox LED, and some people usually take their wire out of the left circumflex. Is there any thought process of putting a microcatheter or a guideline or something to protect the left circumflex while you're doing the rota of the left main into the LED?
So 2 questions. What sheath size did you use for the 1.75 burr? And second, thoughts on keeping a microcatheter in the circ for protection of the circ?
Yeah, so this is 7 French system that we are using because it facilitates our bifurcation strategy as well. If we need to do anything, it makes our life easy. But otherwise, yes, 6 French was also possible, doable. So people do protect the circumflex wire if you want to do rotablation simultaneously by keeping your microcatheter on top of it. Practically, I haven't done that before. I know Dr. Bilal has done it, and we could have shown you that as well. But I preferred to do what we do in routine, that we did the rota of the circ, then removed that wire, and then we did the rota of the LED, and now we will wire both, and we'll do an IVUS for you, and you can tell us how you want us to do the deal with the left main and the LED and the circumflex.
All right.
Yeah.
And the experience of using aminophylline before these routinely, do you give it in non-right cases routinely or not, or what your thoughts are on that?
Yeah, so my approach with aminophylline has generally been to use intracoronary, not intravenous. It's actually been extremely effective and it's simple to use. If you take aminophylline, the US comes in a vial of 100 milligrams per ml. I apologize, 25 milligrams per ml. So if you take 4 cc's of that and dilute that in 96 ml, you make a 1 milligram per ml concentration. And if you take a 20 cc syringe and inject it through the guide catheter directly into the coronary artery just before you do atherectomy, that really helped with the bradycardia as well. Generally, I don't routinely use it. It's only if I can demonstrate that there's bradycardia, then I will stop. Of course, there are multiple ways. There's IV aminophylline, which needs to be started about 15-20 minutes ahead of the infusion procedure itself. There's also the option of doing wire pacing. There's intracoronary aminophylline. And of course, sometimes physicians will just opt to do short runs just so that we don't generate too much debris and don't have much bradycardia. So really, different scenarios, different strategies can work. But I've personally had extremely good luck with aminophylline for the last 20 years and have not had to put a temporary pacemaker in any thrombectomy or rotor cases.
The measurements you had for the stent that you'd chosen, that you'll go for a 3.5 for the LED insert, both those measurements, I'm assuming, first from the distal vessel. There was from the distal vessel. They didn't mention where those measurements were taken from, the EM measurements that you had in the initial IVUS presentation. I guess we'll do the measurements again over here.
Yeah, we will do the IVUS for you now. So what I'm doing is I've pulled my microcatheter back. I've exchanged the wire on it. So this is a trapping balloon 2.5 that's gone in. So I'm going to trap this and remove the microcatheter.
What balloon are you using for trapping in the 7 French guide?
This is a 2.5 millimeter balloon.
I'm sorry, 2.5 non-go?
Yeah, 2.5 millimeter balloon. Spider. Line flush. Epicaudal piece. हल्का सा टेस्ट दीजिए. अच्छा ठहर जा, चलें, ठीक है. ये वायर उधर रखें. I was late.
Any thoughts from the panelists while they're wiring and working on getting the IVUS down for the images? Would you have approached this case differently, or?
I mean, I think it's being very well done. I don't think I can add anything more. I think it's a good strategy, very thoughtful, and I have nothing more to add, to be honest.
Anyone else? Tariq bhai?
we wanted to make sure that this gentleman has.
I think as far as the LED is
Asim, if it's
concerned,
going to be a little bit time before you show the IVIS images, should we go to see the results of the CTO case that was being done in the other lab, or are you ready to go with the? Oh, so you're bringing it down now, okay.
Yeah, we can do
IVIS
the
images देख लेते हैं फिर उसके बाद चले जाते हैं.
free time if you want. We can record the.
अब करने लगे.
Okay. यहाँ से करते हैं. Okay, start recording. इसको बंद करें.
Can you zoom in the IVIS image?
Yeah. So you still with us, or what we wrote up in the main?
Actually, have it on the bigger screen right now instead of the SN image or Flora image.
So, do you have IVIS on?
We can't see it. It's so put the IVIS screen on the main screen where you're showing the Flora image right now.
Okay, bring the IVIS, please.
Yeah, this is better, but put this on the Flora image screen, on the main screen, if you can. चलें सही है फिर इसी.
No, we'll get it on the.
Sir, IVIS was
we are trying to get the main screen and for this.
For now, we can't see anything. Can we?
You've got it now?
Yeah.
Noman, you have the IVIS?
And then we have the, not on the main screen yet. Yeah. Just hold on a second. They lost connection here. They're reconnecting.
होने वाले स्कीम.
But इधर नहीं नजर आ रहा उसको देखे.
So from our side, the IVIS is right of the whole screen.
Oh yeah, we can see it on the side screen. I guess we'll work with that. So you're doing a pullback from the distal circ right now?
Okay, so I'm going to do the pullback now. Start recording, please.
So obviously, this is a scattered fiber lesion. There are some segments not calcified. There you can see an area with calcium and disruption of luminal area is quite loud. The diameter is 375.
Proximal.
Okay.
That's the ostium. A big calcific nodule there coming into the main stem. And
doesn't seem to be as prominent as the nodule.
It's the nodule extends into the left. Stop here, please.
And don't see the obvious cracks in the calcium that you wanted to see, but sometimes you have these micro dissections, micro cracks in the calcium, and you can still stretch with the balloon. So before doing anything else, would hit with a non-compliant balloon and then.
Yeah, that was the PTCA and the LAD thing.
We'll give you an IVIS.
Now, where are you right now?
Are we going to do the for you?
Can you get the main screen on?
Go into the epicranial. Do the ring down, please. Okay, that's fine.
So now you're going into the LED and.
Yeah, that's the LED. The stand that there, not beyond the stand. Okay, start recording, please.
This is the manual pullback, and now proximal to see the calcification or large luminal area.
Stop recording.
The next step is going, now non-compliant below circumflex.
So what strategy would the do here? We are going to pre-dilatation, and you guys tell us if you want us to deal with it.
I think there is some cracks in some of the areas in the calcification, but would go for non-compliant balloon dilatation. No more need for any burring or anything else, and then just for distal, so stent sizing, you can do distal vessel measurements distal to the lesion now. I guess.
Yeah. So how do you want?
My question is, do they have an IVL available?
I'm sorry?
Do they have an IVL available if we can't dilate this?
They don't. I don't think so. Do you have IVL available? Yeah, they don't. In Pakistan, nobody has. There is a company who is trying to bring it in, but yeah, no IVL.
I think as far as the route of the circle is concerned, has not make any difference, because already the lumen of the circ was around 2, and using a 1.7 burr in the 2O vessel doesn't make any difference. So another thing is the nodule. And you can get some polishing effect on the nodule, otherwise there is no crack in the circumflex vessel.
Yeah.
But LED definitely couldn't see the obvious crack, but they have done something with the rota. Then the next move should be in LED with a cutting balloon either and to prepare the vessels, and IVL is available, is not available in Pakistan for the nodule in the circumflex which is extending into the left main.
Plus, that old stent in the mid-LED looks like it's underexpanded as well. So when they're going to go back in, they're going to need to treat that as well.
It does look underexpanded, yes. So while you're working on it, we'll try to get the results from the CTO case they were doing. There was a case by Dr. Salman Arai. Can we go to the lab so they can just show us what they ended up doing? So Asim, we'll leave you for a few minutes and then be back while you're making the decisions, and then you can share with us what you ended up doing.
Okay. Cutting balloon is.
I mean, how many of you will go directly with a cutting balloon? It's very costly in Pakistan. I personally would just go with a non-compliant balloon. If it doesn't show optimal expansion, then consider cutting balloon option. And as far as the nodule is concerned, I guess yes, the vessel diameter was pretty decent over there, but the nodule present there, but with the wire bias, sometimes you can still hit it. And there's a whole discussion regarding when the IVL comes, if it's available. I guess for nodules, IVL will be the best option. Initially with this rota, now going back to IVL for the nodules as well. Any thoughts on that from the people who have experience in using IVL in US? I believe Dr. Farkad Alamgir, can you please join us on the stage?
Just a quick comment on fracture. Sometimes it is very difficult to see on IVUS, especially with this phased array, volcano IVUS.
Dr. Farkad Alamgir, please join us on the stage.
Boston or OCT, you will be able to see fractures very well. But likely there are microfracture. It was 1.75 burr, and I don't think there will be any problem except for the nodular calcium. But the problem is that there is nothing good for nodular calcium except CSI.
I'm sorry, you said CSI for the...
No, I was saying that when there is nodular calcium, whether it is IVL or rotational arthrectomy, nothing works as perfect. CSI may have some role there because it is more orbital arthrectomy.
I think we're also being careful about
not,
the moment you start injuring
fracture on
nodule that is sort of non-obstructive in the distal
speak closer to the mic? We can't hear you that well.
The left main, and you may
I was saying that hard to see fractures sometime on phased array. IVUS, volcano IVUS, if it was OCT or Boston IVUS, you will be able to see fracture. But given that 1.75 burr was used, there will likely be then should not be a problem.
So we have some wait to switch to the other lab in the RIC. We're going to go back to China and see what they ended up doing. Some change of plans. While they're trying to make the switch over, Asim, can you tell what's your plan now? What measurements did you get from the distal vessel for stent sizing, and what are you planning to do?
Well, once you have an IVL, just be prepared, because the IVL console need to be charged. Unfortunately, you cannot charge same time and use same time with the same port. So that's what I'm saying. If you're going to use an IVL.
And here we can see this diagonal angle is widening. So we can use the non-compliant balloon is not easy to cross.
Okay.
So I use the
smaller balloon to make some room.
Semi-compliant balloon, 1.5 to pre-dilate this stent strut.
Okay.
And then use a 2-point semi-compliant balloon, pre-dilate, and then 2.5 non-compliant balloon and cross this here. It's very easy. So, and do the final kissing information here. You can see it's a final kissing. After the final kissing, and use the port technique for the proximal LD. This is a 3.5 non-compliant balloon.
A very nice result in the end. Yeah.
Yes, and it's the 2.75 non-compliant balloon to dilate the middle of distal LD. And we check IVs. Okay, in Dr. Pan.
Show the secondary IVL.
So this is post-stenting IVUS run?
Yes. Yeah. We can, from the IVUS image, we can see the ostium, LDSTM.
Yeah, initially images that you showed, the ostium of the LED looked a little concerning. I was wondering how, we'll see on the IVUS if there's distal left main plaque or not, and did you kind of nail it, or you keep it away from the ostium a little bit?
You can show, Dr. Pan, you can show the ostium, the LD.
Yeah.
Ostium LD.
Wait a moment. Here,
yeah, we can see.
Ostium LD.
Okay. Some disease there, but pretty good lumen area. So if you pull back, it's like this strut or so in the. This is at the ostium of the LED.
Yes. Yes.
So you have like a little bit of strut hanging in the just across the circ when you pull it. Yeah. Okay. So it's kind of nailed it at the ostium.
Just right. Across the cranial.
Pretty good lumen area there. What are you getting there in the ostium area? Now we're going to switch over. If you can. So
okay, she's another imaging.
Nice MSA throughout. So we're going to switch over now. Thank you. Great case. Great job.
Okay. Thank you.
Excellent case. So a lot of learning points. Thank you. We're now going to switch back to RSC. Can you show us the CTO case, and they can give us a follow-up from by Salman Arai? So I wasn't here when you started the CTO case. If you can just give us a brief run through as to. Salman, can you hear us? Salman, can you hear us? Can we get connected to the lab?
Unmute kare. Can you hear me now?
Yes, we can.
Not working. No, can you hear me, Naman?
Yes, we can. We can hear you.
Acha, so first of all, it's an honor to be here. I'm joined by Dr. Chien, Dr. Adir, and the wonderful team at RIC. So your audience has not seen any of this case because पिछला हमारा audio चला ही ना था सिरे से. So we're going to now start from the beginning. So this patient is a 64-year-old physician who came to us from Lahore. He had a history of hypertension, CAD. He actually had long-standing history of disease. His first stent was in the RCA 2008. Then he had a stent in the circumflex. आगे ना बढ़ाएं, just यहाँ पे रोकते please. Let me go. नहीं. आगे ना बढ़ाएं. I'll tell you when to go forward. So CI in RCA, then LCX, and then last year he had bypass. And you can see here got vein grafts to OM diagonal or lima to the LAD.
Within 2 months, he started having symptoms again. And they did an angiogram and they saw that all of his grafts were occluded. So they treated the proximal circumflex, but then again he had symptoms in August. He had another procedure. And then in November, he came in and he was found to have this occlusion of the sort of mid-circumflex going to a large sort of open branch. He also had occlusion of his RCA and also occlusion of the mid-LED. So the lemma is attached distally. It does not supply any of the proximal circulation. So at that time, the idea was to put the proximal supply by the lemma. So he went into flash edema. They had to do emergent balloon pump. And at that time, they did POBA of the left main and POBA of the prox LED circumflex. This is in November of last year. At that time, I think he had some relief of symptoms, but since then he has had progressive return of his angina. And interestingly, his angina is positional, and it's not reliable with activity. And in talking to him before the procedure, it seems that maybe related to salt and water content. Because Ramzan, when he was fasting, he felt his angina was less. After Ramadan, his angina has been more. So one of the first things we did was we did an echocardiogram. And on the echo, we found that his ejection fraction is about 40%, and he has moderate mitral regurgitation.
We just have 5 minutes. If you can just quickly go over what was done with the case. And
yeah,
I know
so this,
it's a very complex case to go over, but
this is a 2-hour case. Okay, so this is a 2-hour case. Let me show you what we did. So the moment we took his pressure started to drop. So you can see that he has got severe extent restenosis of the left main, and as you know, his artery is occluded next. So his pressure dropped into the 60s with a map of about mid-50s, actually pressure of 80s. You can see he's got a high-grade stenosis next. And you can see this is RCA supply, the large OM next. So at that time he started to become unstable. He started to cough. We felt that was a sign of pulmonary edema, so we gave him 40 of Lasix next. We decided that the safest thing to do would be to do a left main intervention to get at least some flow going next. So we wired without any contrast. You can see we wired next. You've got a high-grade stenosis LED. We fixed the angioplasty next. We then went ahead and addressed circumflex next. And then we used a cutting glue to cut the osteocircumflex and the left main next. Next. And because the guide was keep getting seated, we put a third wire in, like a simple to keep the guide from getting in. But despite that, his pressure was very low at that time. You can see he also has a cutting balloon-induced dissection, which actually is a good sign next. So this is a cutting balloon going in. That was just a balloon angioplasty-induced dissection next. Next. So we then did JSBT next, and we treated his LED, and we treated his left main into circumflex next. और ये यहाँ पे आप देखें कि we put a stent from the left main to the circumflex. Next, you've got the balloon in the. This is a balloon in the LED next. 4 atmospheres. This is the high pressure of the stent deployment next. We then take the balloon back. We worry about trapping balloon next. Then we rewind it next. After we rewind it, we balloon back. Then we did the flaring next. So we'll pull this wire back from the cusp, we put in the LED, we take the LED, but we're trying to avoid the LST next. And now then, this is what we were left with. At that time, his pressure came up to a healthy 110, 115. And at this point, we were actually going to stop and get the opinion from the panel, but unfortunately, the feed wasn't working. So we felt that we should do HDR because this is our only opportunity to do this next. So then what we did is then we felt more comfortable doing deep injection angiography next. And now you can see that this is this highly calcified mid-circumflex. Now this mid-circumflex had been attempted before at one of the institutions in Karachi, I forget which one next. So there's always the idea of dealing with a failed C2 attempt next. So the first thing we did was we put a stabilization, we left the stabilization wire in the LED, we got this sort of knuckle wire to get down and get the microcatheter next. We then engaged the cap with the pilot 200 and we advanced the turnpike LP into the cap next. And here we advanced the turnpike LP next. And then we confirmed our position to show that we were across the cap approximately. And next we did HDR. And this is your HDR. And as you can see, there's really not a whole lot happening there. Maybe you see some atrial branches coming off. At that point, we took a new Feeler XT without a tip next. And this is the Feeler XT. And just see what happens. And the Feeler XT crosses. Next. At that point, we did a picture from the right to confirm maybe we were. Next. We tried to get the microcatheter down, it wouldn't go. I said, hey, there we go. So now we're across.
Yeah.
So this highly calcific lesion, HDR, helped us to get across. Next. We then got wire support. Next. And we tried to get the microcatheter across. We couldn't do that. Next. And we tried multiple attempts with the next. We tried to do, we anchored it ourselves. We tried to get a 1.5 balloon in there. Next. We tried the 1.25 balloon. It wouldn't go. Next. We anchored and we tried the turnpike again. Next. Next. We tried the turnpike LP. Then we said maybe we should rota this. Next. So we, again, you can see, look at the turnpike, tip of the turnpike is getting sort of caught up on that calcium, and it's actually looked a little frazzled there. Next. We then went ahead and tried to get it. Next. We tried to get, this is just the balloons. Next. So then we said we should probably take a rota wire. Now you can see that in comparison to the first HDR, now you can see the channel that connects it to the distal RCA. Next. So we tried to get a rota to airmail this. Next. But you'll see that the rota just prolapses the catheter. Did not work. We tried to trap it and get it down. Next. We did a multiple HDR again. Next. At that point we felt that we couldn't use rota, so we decided to do an external cap crush. So we got into this atrial branch. Next. We then took a 3O non-compliant. Next. And then we gave a 3O non-compliant, and then we crushed the cap. Next. We went to a pressure as high as 18, 20 atmospheres. Next. Next. Next. Next. Once we did crush, we then attempted a 1.5 balloon. It did not go. Next. Then we did a kissing crush. So we did a 1.5 balloon and we crushed that. Next. And we did it again. Next. And here, go back one please. So after we did the kiss crush, we did a high pressure inflation on the 1.5, and you'll see this is granuloplasty, the balloon ruptures. Next. So at that time, the microcatheter was too frayed at the tip, so we took a caravel, and initially the caravel didn't go, but slowly, with persistence and a lot of prayers, you can see the caravel gets across. Next. At that time, we had wanted to use a rota, but unfortunately it was unavailable because it was being used in the other case. So we said, in the meantime, we put a wire there. Next. And because the caravel acted as a channel dilator, we could then get the 1.5 balloon. Next. So we angioplasty this. Next, next, next. And there we go. So we were able to get antegrade flow. The problem is we're in a branch that we don't like. So we tried to wire into the ongoing OM. Next. But the wire kept going to a dissection plane. Next. Now remember, we've done a lot of work at the cap now. We've done the crap crush. We've done what you call granuloplasty. So those are dissection planes. Next. So then we tried to find the most optimal angle to show us what's going on, and this is actually retroflexed. Next. Next. So once we found the optimal angle, next. You'll see it. Next. Next. And here's that optimal angle. Next. So what we try to do is we try to use a workhorse wire, but you can see it's going to a dissection flap. We don't like that. Next. We then tried to take a SUO wire and try to make a SUO knuckle to prolapse. Next. We used a blocking balloon there. That didn't work. Next. This is a blocking balloon, and that's a SUO wire in there. Next. But that, again, you can see is not working that well. Next. We then took a Feeler XT, and that didn't work. Next. So finally, we ended up taking a Gladius Mongo, and we made a shape on it. And there you can see the Mongo is able to get into the true channel. Next. We then advanced the microcatheter, and with that support, we were able to get across. And there we have it. Next. At that point, we decided to take out the balloon from the sinus branch and try and dilate this channel, but unfortunately the wires were braided, so we took out the, atrial, not sinus, the atrial branch, we took it out. Next. We did some initially gentle angioplasty with 2.0, then a more aggressive angioplasty with 2.0, and then 2.5. And at some point the balloon ruptured. Actually, so another discussion point is when you see a stain like this is a 1.5 balloon, and I think that you see it ruptures. And once it ruptures, it starts...
I'm sorry, I know we're all focused on the case. His pressures are 70, 45. I don't know if somebody is addressing that or
yeah. Inka pressure, inka pressure.
But very challenging case, so a lot of hard work. Made a lot of progress there. So,
अपना zero भी check करें and pulsatility भी हाँ दोबारा pressure check करें देखें is it awake?
Okay. So.
No, he's not getting perfusion to okay. Guide से disengage हुई भी. Next, थोड़ा मुझे actually test bleed back. तो test से मुझे test.
So this is.
Let's just do a picture then. Let's just do a picture. Gentle.
ठीक है.
LED में बंद हो गई flow. So fairly flow है. Versatility आप देखिए ना कि थोड़ा सा अगर न्यू है तो न्यू का एक मैप ठीक है.
ठीक. So we're going to switch to, while you're working, this is where you are now at this point. A lot of hard work, very challenging case.
So what we've done is we tried a 2.0 balloon, but every balloon ruptures at that nodule across the stent. And the challenge now is that while we have the rotor available now, we feel we shouldn't do rotor ablation in a dissected plane. We feel this would be a good place to stop and do an investment. I'm not confident that the DCB will pass. We can certainly try it, but I feel, and Dr. Chien is here with me, I don't know if he has any comments, but I feel that we've restored antegrade flow, we've fixed his left main, we should perhaps stabilize his hemodynamics and stop right here. I don't know what the panel thinks.
Yeah, I think probably good idea too if he's got flow right now, if he stabilizes and bring him back, consider for a planned rota. Any thoughts? Would you, after so much dissection, consider taking a rota down? That's the only option we have for calcium plaque modification now at this point.
So, in the US, you'd probably do IVL, but I think here,
would IVL cross? I don't think if the 2 is not crossing, the IVL would cross.
With extender, it may cross. With the 2.5 crossed, so it may cross. Let me just do a pot here just to make sure.
So while you're working here, we're going to go to Dr. Asim because we are short of time. If he can show us what he ended up with. Can we go to Dr. Asim in the next lab?
यार इनकी आवाज जरा ऊंची करा दें मुझे आवाज
मुझे दोबारा वो दिखाएं जो
जी डॉक्टर जी चलिए माइक्रोफोन देखते चलो
Noman, are you back with us?
We can hear you and we are with you. Just can you update us? So after the rota, you're going to start get the measurements and start stenting. So where we are with that?
आगे जाते जाएं एनजीओ की तरफ जाएं आगे जाएं. Keep going forward. Okay, so Noman, what we've done is we did the ballooning of the circumflex with a 3 non-compliant balloon, and then right at the ostium, we know because you get maximum ISR there. So we've used a cutting balloon at the ostium of the circumflex. So this was a 3 by 10 millimeter Wolverine from Boston.
Okay.
So after the cutting, then we went on. We've done a different strategy here. We did the IVUS of the circumflex, and there was no dissection anywhere. It was good flow. So we know that there is a chunk of calcium, a calcific nodule sitting there, and I thought we had achieved good circumference there. We've done a drug coating balloon. So this is a 3 by 30 restored drug coated balloon. We've used that for the circumflex. Keep going forward, please.
Okay.
And then this you can see the inflation. This is the 3.0 drug coating balloon restored. So then we went on to.
And what size cutting balloon did you use for the circ?
The cutting balloon was 3 by 10 Wolverine.
What, 2.5 or 3.0?
3.0.
3.0. Okay. And then you're going the 3.0. Okay.
And we fixed it with a 3 millimeter 330 restored drug coating balloon.
Okay.
Okay. So then we went on to the LED. We've opened the previously deployed stent with a 3 millimeter non-compliant balloon, and then after dilating, and then within the LED also used the 3O cutting balloon Wolverine. And after that, we've fixed the previous LED stent with a coating balloon from Medtronic, that's Prevail, 3 millimeter coating balloon, and we've used Zions Alpine 3.5 33 millimeter from the ostium. You can see the ostial place. Can you see the angio now?
Yes.
So
yes.
this is Zions. So the good thing about Zions is that the stent starts right from the middle of the marker. So these are good stents for precise ostial placements. So our intention never was to go into the left main stem because the MLA there is pretty good. So we aimed for the ostial nailing. So you can see the positioning here. And then when the stent was deployed, we also took a puff to see, there you can see where we exactly landed. So we've used this Zions Alpine for this. And now we are ready to take a Cine. This is where exactly we are. And then we are going to use a 3.5 non-compliant balloon for the LED to fix that at high pressures. So we'll do a Cine with you now. Okay, ready for Cine? Cine, please. Okay, so that looks pretty good.
Looking nice over here.
Go to spider, please. And we will show you the circumflex also. And we can also do an IVUS for you for the circumflex if you want.
I think while you're doing the IVUS run and post
So
LED,
let's
we'll
do
go
a
to Fahim Jaffrey's talk,
Okay.
and then we'll see
So-
the final images
you
once you're
go.
done with that.
Yeah. So there is haziness in the
That's very
circ
nice.
ostium, but we know that there is a calcific nodule sitting
So
there.
I guess IVUS
We
over
do
will help us
IVUS.
decide whether it's the nodule which is making look like that, or is it starting to close down.
Yeah,
So,
yeah. So
that'll be
that's
helpful.
exactly what we will do now. We'll do an IVUS for you.
Yeah. So meanwhile, can we show the talk from Dr. Fahim Jaffrey?
Can I just interrupt and talk about the last? You
Please.
see, from my experience, whatever it is that if the patient, the time to invest is when you've got good hemodynamics. In such a case where you've spent so much time and you've opened up and there's a perforation and there's the hemodynamically the patient's, this is not the time to, in my view, to leave it as an investment. You have to fix it, whatever it is. So you can do inotropic support. You can do, I think, Rota with 1.25 is fine because the problem is calcium. So if they leave it like that with a 70 systolic, he's not going to survive.
I guess not a bad idea to just do an echo right away. I don't know if they're doing it or not because the wire was all the way forward. So if there is a small perf doing it, we don't know if it was because he was
just for
his
the
soft
juniors
pressures
के
begin with.
investment procedure जो है ना वो हेमोड इतना लंबा investment तो already हो गया अब इस stage
So
पे
a
छोड़ना
lot of factors come into play, operator, patient fatigue and all that. But yeah, if his pressures are not coming up, then you may not have a choice. You have to do something before you leave. But I'm not sure if that circ alone is the reason for the, I don't know how much Lima was filling the LED and we don't have all the information there, but yeah. Yes. Can you speak in the microphone, Gun?
In addition to looking at all the coronary causes and getting an echo, they should also be looking at the groin. It was the femoral
Yeah,
abscess. You need to make sure that that's not one of the causes. This hypotension is quite dramatic, and I
Yeah.
agree with Nadeem that we need to be looking for why.
Yeah, absolutely.
Before we
shouldn't, yeah, the case should not stop until we sort out the hypertension is resolved. Yeah, absolutely.
In just the RCM's case, when you're deploying the stent in a proximal LED, ostial LED, when the balloon is up, I take the contrast at that time. Because then that gives me a very good relationship with the circumflex and the left main.
I always do that as well. If you're doing ostial, then you take a picture of the left main.
When the
While the
balloon
balloon
is
is
up.
inflated, that gives an idea, a pretty good idea of the
Where the
segment.
balloon
So we're going to go for, can you show the talk? So play karna.
Circumflex पे डालने आया बस ये तो हो गया LED पे नहीं NC कर देते हैं NC5 हाँ NC तो करते हैं
I must apologize as
उससे कोई बात नहीं आसिम का केस दिखा रहा था हमारा केस दिखा रहे थे वो उस वक्त that's why
वॉइस कैथलैब की वॉइस को भी डाउन कर देना जिसकी चलने में
Assalamu alaikum, Pakistan Live. Bashir and colleagues, thank you so much for the invitation to give this talk today. My name is Fahim Jaffrey. I'm an interventional cardiologist here in Singapore. I must apologize, as I've done on other talks, for two things. First, for not being there in person. There was a scheduling conflict with another meeting that I had to attend in Korea. And I also must apologize for my voice. I've got a bit of laryngitis, so I'm pretty sure I'm sounding pretty weird. That said, over the next 10 minutes, my job is to talk about clinical decision making using imaging, and hopefully I will convince you that imaging is the way to go for most PCIs, and certainly in our lab, we image almost 90% of our cases. I have no conflicts of interest. If you asked me 10 years ago, I would be saying that I have IVUS eyes and I can see the artery. I don't need imaging. But the answer is no. Data is data, and the data is pretty overwhelming. What is the issue here? The issue really is that PCIs these days and the patients are getting more and more complicated. And so we want to do it right the first time. We don't want to see in-stent restenosis, and we sure as hell don't want to see stent thrombosis. Imaging will help in deciding the strategy, optimizing the treatment, and optimizing your stent sizing. So there are a lot of advantages to doing the imaging before as well as after you put in your stent. Now, what are the basic key questions that you need answers to which imaging helps? Well, these are some of them. The plaque extent, so where do I land my stent? The plaque morphology, can I get away with just a balloon and stent, or do I need to do more? And usually more is calcium modification of some sort. And then if I've done calcium modification, what is the effect of that modification? And then if I have side branches, for example, in a left main LED circ case, is that side branch going to behave, or is it going to go down once I put a stent across it? And then after I've put in my stent, did I do a good job? So these are some of the questions we need to answer. So let's go through a process of doing an intervention from beginning to end and looking at how we incorporate all these questions in our imaging sort of schedule. So step one, finding the landing zone. We know that angiographically a lot of segments may look normal but actually are not normal when you image them. And in general, we want to land a stent in as clean as possible a landing zone. When I say clean, we sort of arbitrarily define it as an area where the plaque is low or less than 50%, but understandably,
while
there
the
will
talk
be
is
some
going on,
cases
session is
where
going to please
you
keep
will
quiet.
not
There's a
have
lot of
any
background
normal
noise. So
zone
if you want to
because
have your own
there's some
conversations,
diffuse
if
disease,
you can step
but you
out
want
to
to
do
find
that.
the
Thank
most
you.
normal zone that's possible. And the reason for that is sort of illustrated here.
Request to people in the back to stay quiet.
Through the artery and see the vessel wall. Clearly, my ideal landing zone for the stent is there, as you can see, where the vessel is normal. Now, if you look closely somewhere up here, you can see that the vessel is outwardly remodeled positively. And if you look at the lumen, the actual lumen is unchanged. And so when you do a luminogram, which is the angiogram that you do in the cath lab, you get something that looks like this, where, yes, this was your ideal landing zone, but actually you might be able to land a stent up here just based on the angiographic markers, because that part looks actually quite normal. But the fact is that you would be landing your stent in plaque, and when you land your stent in a lot of plaque, you increase the risk of stent underexpansion, restenosis, and stent thrombosis, which is not a good thing. Now let's look at a case here. On the left side, you see an artery where you can see the skeleton of the artery. So this is heavily calcified. You can see that. And on the right side, you can see that same artery has severe disease in the mid-LAD, which seems to be diffuse and goes all the way back to the left main. Now, what do my eyes say? My eyes say that my landing zone is just after this septum, because this looks pretty normal. What does the IVUS say? The IVUS actually says that no, the landing zone is not where that septal is. It's further down where the other septal is. And you can see that down where the second septal is, the vessel is nice and normal. But where my eyes were telling me that my landing zone is, there's actually a lot of plaque. You would land a stent in about 50 or 60% plaque burden. Again, emphasizing the point that the vessel looks the same on both sides, but on IVUS, there's a lot more disease near this first septal compared to the second septal. What about the morphology? What is the morphology of the... My eyes say that there's calcium on both sides, and so my strategy based on my eyes is just upfront road ablation. That's what I would do. There's calcium on both sides of the vessel. We should do it. But let's see if IVUS changes that. We do IVUS, and we can see distal good landing zone, and then some calcium. But then we come to 360 arcs of calcium. This is not a surprise. We expected to see a lot of calcium, 360 arcs of calcium. Again, even proximally, there's a 360 arc of calcium. So quite a bit of calcium. But what the IVUS is telling me is that there is concentric superficial calcium, but the lumen is pretty big. It's 2 millimeters or so. So if my strategy was rod ablation, I would need to use a bigger burr like 2.0, or I would need to use orbital at high speed. But in this particular case, IVL might actually be a better option because there's concentric calcium, which responds well to IVL, and it is a larger lumen. So rod ablation like a 1.5 burr may not even touch that calcium and may be just a waste. What about vessel sizing? So what do my eyes tell me? Well, that's a 6 French guide. So I would say here is 3.0. Up here, I would say 3.5. And up here in the left main, 4.0. That's what most of the time we would say. We do IVUS, however, we find that actually the vessel is 3.5 distally and 4.0 up here and 5.5 in the left main. So much, much bigger. So IVUS is telling me that my sizing needs to be different. So what do we do in this patient? Well, we started off with marking the areas where there was concentric calcium with the IVUS, and you can see I've taken cines wherever the concentric calcium was, and I'm using that as a guideline. I gave 80 pulses of IVL, a 3-5-12 IVL, focusing the pulses on the areas where the concentric calcium was, so targeted use of pulsing. And after doing so, you can see that angiographically doesn't look too bad. And then I do another IVUS to see the effect of my calcium modification. I can see fractures. I can see more fractures. And if you go look further back, I see a lot of fractures, even in the areas where the vessel lumen was big, like, for example, up here. So I have fractured the calcium in areas where the lumen was big, which a 1.5 burr, even a 2.0 burr may not have touched. So I've got adequate calcium modification and I'm ready to stent. And so what did we do? We took a 3.5-48 distally, a 4.0-32 proximally, post-dilated with a 4.0 NC balloon, and in the left main post-dilated with a 5.0 NC balloon. And that's what it looked, pretty good. And on IVUS, the areas were great. I'm not going to bore you with those details, but the IVUS areas were as high as 20 millimeters squared in the left main. Now, question 4, when you talk about side branches, often the question is, what is the likelihood that the circumflex or a big side branch will go down? And if it looks good angiographically, can I go provisional? Here's another case, a different case, where there's clear LED and left main disease, but we were wondering what we need to do about the circumflex. Angiographically, the circumflex looks okay. Here's another view. Angiographically, it sort of looks okay. Of course, the LED is diffusely diseased and severe, and so is the left main. So what do my eyes say? My eyes say that the circumflex ostium looks good, and we can stent provisionally. But what does IVUS say? Well, IVUS shows that the circumflex actually in the mid is quite good, quite normal. But wait till we come to the proximal circumflex. Here's the LED wire, and you can see there's a lot of atheroma at the ostial circ. Plaque burden here was like 70%, here like close to 80% at the polygon. So what the IVUS is telling me is that the ostial circumflex has a lot more disease than what the angiogram showed. And maybe in this case, a 2-stent strategy might be better because otherwise you're very likely to compromise that circumflex. And so that's what we did here. We did a DK crush and got a good final result. So imaging modified the strategy. The next question you always have to ask is, did I do a good enough job? And there are multiple criteria to define optimal stenting. That includes if you use OCT, minimal stent area of 4.5, but with IVUS 5 to 5.5 millimeters square in a non-left main. In the left main, at least 8 millimeters square, but ideally you want to see 10 based on the Excel trial data. You also want to look at the relationship between the minimal stent area and the distal reference, and the minimal stent area should be 90% of the distal reference. Also, you want to look at malapposition and not have much malapposition, whether you're looking at it on IVUS or OCT. And you also want to see no dissection or no substantial dissection defined as an angle more than 60, a length, more than 3, and, penetrating the media. So a deep dissection, you don't want to see that. So here's a case. Left main LED circ, clearly severe disease. And we did basically a DK crush to the left main LED and circ. And that's what it looks like on the right side. So when you look at this, what do my eyes tell me? My eyes tell me that I have a good result in the left main LED, I have a good result in the circumflex, and all I need to do is put one more stent down here and we should be ready to go home. Now, what does IVUS tell me? Well, we did IVUS, and you can see that the stent, the circumflex stent is really good so far. In the mid, looks really good. But wait till you come to the ostial circ. That's where you get most of the restenosis. And at the ostial circ, as you will see in a second, the actual stent is very small. It's only 4 millimeters square. So what is IVUS telling me? IVUS is telling me that the ostial circumflex is suboptimal, needs more work. So what did we do? Well, we stented the mid-circ as we had planned, and then we did DK crush. Sorry, we did kissing balloon inflation with much higher pressures with a bigger balloon, and then we did final result looks pretty good. But I must say that if we look at the final result on the left and compare it to the other result, looks pretty much the same actually. So the angiogram is lying to you. But when you look at IVUS, you can clearly see that the stent area at the ostium is now 5.8. It is much bigger than 4 and much more optimal. So, does it matter if you're experienced or non-experienced? It does. If you're less experienced, imaging has a much greater boost on your outcomes. But even experienced operators, they still get better results if they do imaging, and this is a study that was published from Korea very recently. I don't have time to go through all the data. There's tons and tons of data, IVUS versus angiography, OCT versus angiography, imaging versus angiography, all showing that imaging improves outcomes. And so the guidelines, whether you're looking at the European guidelines for chronic CAD or the most recent 2025 American guidelines for ACS, class 1 indication for imaging. So in conclusion, ladies and gentlemen, imaging is crucial in most PCI, especially complex interventions at all stages of the procedure, and don't rely on IVUS eyes. I know we all like to think we do have them, but that's not true. The outcomes data strongly suggests a morbidity as well as mortality benefit of imaging in PCI, especially when it's complex, like long lesions, calcified lesions, left main, bifurcation, those kind of things. And it's important for most operators to become comfortable with imaging, whether it's OCT or IVUS, that's up to you. Costs in Asia are always a concern. The added cost of a catheter is not trivial, but think of the big picture. If it prevents restenosis and repeat events, it's probably worth it. Ladies and gentlemen, thank you very much, and I'm happy to answer any questions.
Excellent talk. Precision PCI is now class 1 recommendation by both ESC guidelines and now ACC guidelines also for acute coronary syndromes. They made it a class 1 indication. And we should all consider it, at least for our left main complex bifurcation lesions, offer it to the patients who can afford it, or if they're covered for it, do it with imaging. It does make a difference, as was nicely shown in his practical case-based talk, covered all aspects.
Just Noman, can I just make one comment? People who want to do intracoronary imaging and physiology, make sure they develop a good team who are available 24/7, 365 days. Otherwise, it will be very difficult to provide a good service. That's very important. Team is important.
Demo runs with the machine of the staff are important, so that when you ask them to open up the machine, they're not struggling to hook up, how to switch it on. There should be a quick drill that you should be ready to go for IVUS whenever you want it. So we have Boston Scientific over here who are platinum sponsors for the conference. And we're going to have curtain raising for the Avigo machine, and then we'll go to the case presentations. So the Boston Scientific lead team is over there. We have Ms. Zainab, Regional Manager for Boston Scientific, Mr. Ayuku, who's come from abroad, and Dr. Sadmat Makbul, and Dr. Khavar Bhatt, and Mr. Talat and Faraz are there. And I would request the President of PSIC to do curtain raising for this new Avigo Plus machine, which is the highest frequency and best imaging that they have in IVUS options currently. So that's available in Pakistan, and it has option of being hooked up with intracardiac echo, and they have also DFR option physiology with the same console over here. So so it's nice that we have this option of machine available over here. With that, I think we'll do the curtain raising for the Avigo machine here. I loved it. We got it for our center, and it's so we can have a round of clap for our platinum sponsors here. So if we are ready in the, with Dr. Asim, is he ready to go? Otherwise, we'll start with case-based sessions. Dr. Suhail Salimi, I would request you to come over and take over as the moderator.
So now it's the time for how would I treat the case. So in this session, first the PIMS team would present their case, and then the AKU team would tell us how would they have been treated this case. So first, Dr. Shoaib from PIMS, he will present his case.
Assalamu alaikum. I am Dr. Muhammad Shoaib. I am working as a senior registrar in PIMS, and I am presenting a case which was performed by Dr. Akhtali Mandesha. I was the assistant in that case. It is a case of a 52 years old gentleman who is diabetic and hypertensive. He has good functional capacity. He is a public office holder, new onset angina of class CCS 2 to 3 of duration 2 weeks. And his cardiovascular examination was normal. ECG showed T-wave inversions in anterior leads, and EF was 40 to 50% with preserved LV thickness and normal dimensions. Wall motion abnormality was seen in LV apex. His troponins were positive. So the left vein was normal. There was a critical lesion in the ostial LAD, followed by a critical lesion in proximal to mid LAD, and followed by diffuse disease in distal LAD. There is a critical lesion in proximal circ, and then there is faint flow in the distal circ, and the OM branches are retrogradely filled by the collaterals from LAD. The other view. So there is mild disease in ostium of RCA. The RCA is dominant, but there is a diffuse critical disease in distal RCA and as well as in PLV. So once we calculated the syntax score, both showed that cabbage is favored in this case. So treated plan in this patient is based on that he is having a triple vessel coronary disease with diabetes and moderate LV dysfunction. His syntax is high. He's not willing for cabbage, can't give up his active lifestyle, but he's enthusiastic for aggressive risk factor modification. So
thank you, Dr. Shoaib. Now the AKU team will come and they will told us how they would have been proceeded in this case and what they have done for that.
कौन सा वाला ये? 9. नंबर 2 ना? नहीं. नीचे वाला? 9. हाँ ये. कहाँ से आप बोल? 1 मिनट बस.
Thank you very much, Nasir Rahman from Aga Khan University Hospital. How would I treat this patient? Before we jump on this, let's review some facts about this patient. This patient has got non-ST elevation or angina of recent onset. He has got multivessel coronary artery disease. There are tandem lesions in the LAD with an apical diffuse disease, and the tandem lesions in distal RCA and RPLV, and the inferior takeoff RCA. Again, the heart team approach should be the first thing, but as my colleague told that the patient was reluctant for cabbage, so based on this algorithm, we can offer on patient preference the multivessel PCI. Other considerations will be LV function, which was 40 to 45%. I just got to know his renal function tests. any allergies or any bleeding tendencies. Regarding pharmacology, during the procedure, I shall load this patient with aspirin and preferably with ticagrelor or prasugrel. The ACT for this patient during the procedure should be more than 250. My approach will be for LED and RCA in the first setting and maybe the circumflex in the second setting because this might be a CTO vessel. Regarding the access, the radial approach for left system, an extra backup guide for the left system, and maybe a multipurpose or AL1 guide for the right system. Workhorse wire to cross the LED and RCA lesions, and for the circumflex, might need a microcatheter, a hydrophilic wire, and later we can escalate it to Gaia series if required. As Dr. Fahim Jafri just mentioned about the role of imaging, I think the imaging will be must in this patient because of the multi-vessel PCI. The IVUS role will be to decide about the vessel size, both in the proximal and mid-LED, about the severity of the lesion in the proximal LED, extent of the proximal LED disease into the left main, the circumflex vessel size, and post-PCI stent optimization in both vessels. Again, for the same reason, the IVUS is must for the RCA. The lesion preparation will be of paramount importance in this patient. The balloon size should be 1:1, and if there is evidence of calcification on the IVUS, then I shall use a scoring or a cutting balloon. For proximal LED, distal RCA, and circumflex, my choice will be to stent these segments. But for MSA for the target vessel will be 5 to 5.5. But for the distal RCA, like RP LVB and the mid to distal LED, my preference will be to use a DCB based on the vessel size. If the vessel size is less than 2.5 millimeter, I shall use the DCB, and if required, I can go out for a bailout stenting. Thank you.
So,
this sort of disease, or IVUS is more fancy and more sexy, or whatever.
Most of the labs we have been using the intracoronary nitrates.
I didn't see the short post-nitrate injection of the LED.
Yes, but most of the time we have done that before the procedure. Yes. Yeah. So,
there's a few points to highlight that when the patient has got autonomy, we as a consultant and a cardiologist should have autonomy also. We should refuse these cases also and convince them to go for the surgery. And the second thought is that why not we combine our surgical colleague with us and go for the hybrid approach here. Definitely the difference between the cabbage and the multivessel stenting is, one is a complete revascularization, and long-term result is better due to lima only, because the vein graft has an inferiority as compared to drug-eluting stents on 10-year patency rate. So I think there must be some hybrid approach here too. The surgeon fixed the LED with the lima with minimum short, and we fixed the rest of the lesions with drug-eluting stents, and that will do for the patients better as compared to putting a lot of metal inside the vessels. Anyway, doing a one stage, one go or a stage procedure here, whatever the things available is good for that.
Yeah, very reasonable approach. But before going, what the PIMS team have done, we'll join the RIC team, and what they have done, Dr. Asim, we'll see that. Can we connect with RIC team? So, Dr. Asim, can you hear us? I am Dr. Sohail. So just briefly tell us what you have done and the final image. We can't hear you. So can we join audio with Dr. Asim?
Yeah, very audio on karaye. Sohail, can you listen to me now?
Yeah, Dr. Asim, we are hearing you.
Okay, wonderful. So what we've done is we've done a coated balloon in the LED bit stent. We've stented the LED. We've done the ostial nailing thread with Rhines alpine stent. We came back to the circumflex, which we planned to do a drug coating balloon, but when we did the IVUS, we saw a little bit of recoil in the mid segment of the circumflex. So we decided to cover it with stent. We've already invested so much into this patient. So we've done another Rhines alpine 3.5 by 33 millimeters and post-dilated it with a a non-compliant balloon, and then show them the cranial view, please. It then ended up by doing simultaneous balloon inflation at the ostium like a kissing, but these are both precise ostial placements. And then go next, please. Go next, please. Next, please. So this is your final LED result. Look, next, and that's the final ostial placements. And then we've done an IVUS, we've seen the MSAs, and these are both ostial placements, and the left vein is fine. So we are happy with the result.
Okay, great. Do you have taken the final IVUS run of circumflex?
We can show you the IVUS. Yes, we can show you the IVUS. Can we go live on the IVUS screen, please? Put the IVUS on the big.
Asim, do you have a stent boost? I think that will be quite helpful here.
We don't have the stent boost, unfortunately. We won't be able to show you that. But we can show you the IVUS. We've got the last IVUS run. We'll show you this IVUS quickly. We are very satisfied with it. And then I also need to show you the final result of the last case that we did, that 80-year-old gentleman. We want to show you that final result as well. So can you see this IVUS now? This is the pullback from the circumflex stent, and Dr. Bilal will go through it.
Yes, as you can see here, the stent is very nicely expanded. There's no malposition of any struts. We measured the diameter. It's about 3.6 to 3.7 in the distal segment. The luminal area is about between 8 to 9 millimeters squared. And you can see it's very nicely expanded everywhere. I think the key question is going to be about the ostium. And because of the calcific nodule, you will always see a little bit of under expansion there. But I think, first of all, we nailed the ostium. We did dissect the left main. This is the left main over here. So if I go back just frame by frame, you can see here the stent struts are lined up quite nicely at the ostium. Let me go back here. Sorry about that. And we measured the luminal area there at 7.8 millimeters squared, and the diameter was 3.2 to 3.8. We've taken a 4.0 NC here at the ostium. So we're very happy with the result. We didn't traumatize the left main. Everything is well expanded, and luminal areas meet our goals.
A great case, Dr. Asim, Dr. Bilal. Thank you very much, and thanks a lot.
So before you go off, let me just show you the final result of the last case that was done in the cath lab. Are you still with us?
Yeah, sure. We are with you.
We'll just show you the ethnographic last image. I'll hand over the mic to Dr. And we'll show you the last.
Show us the final result. Hello. Can you hear me? Hello. Can you hear me?
Yeah. Dr. Sir, we are seeing the fluoro image.
We will show you the final result. So I could not communicate finally with circumflex, and we did the plot of the left main
I think this is the
LMS.
other lab.
Okay. Can you show us, Faisal? Okay. These are the result.
Actually, we are not visualizing your images.
After pre-dilatation, there was significant dissection, the LMS and the LED ostium. So we extended the LMS to LED. After that, we fixed the tap strategy. Because the last two results, Faisal. Final. This one. Final results. Next.
Dr. Salam, we are not visualizing your screen actually.
Faisal.
Yes, now we are visualizing that.
Okay, can you see us? Okay.
Okay.
This is where we left you, because I know that Bilal had made a very interesting comment about making sure that we don't take the guideliner through the stent struts of the left main. So Salam was able to successfully deliver the stent without doing so.
It was an issue because the stent left main or ostium, so we have to take a guideliner because I have an issue that stent can got embolized without guideliners. So with the help of guideliner, we place a stent in the LMS to circumflex with a slight protrusion, so we get the circumflex. And this is the final results. See, and we did the final part of the left brainstem ostium. Show us the cranial view, Faisal.
Yes.
The cranial view.
Yes, agreed.
Okay. Finally, we did the IVUS of the RK. The IVUS showed a well-opposed stents, and the MS is quite satisfactory. We can also show you which we want to see.
So we have seen the final result. It's very great. Fine. Thank you very much, Dr. Salam. Actually, we are having this short of time. So thanks a lot, RIC team. Well done. So now it's the final, how the PIMS team would have been treated his case. So
Great.
the PIMS
Okay.
team.
Good job. Fantastic. Well,
Thank you, sir. So this is a young patient who is not willing for cabbage. So we have to perform PCI in multiple sessions. And the plan remained the same. We skipped the IVUS, but the other plan, which Dr. Nasir told, we almost followed the exact same plan. We first perform PCI to LAD. We plan to use DES for osteoproximal LAD, use DEB for mid LAD. If results are optimal, then we proceed to PCI to RCA with DEB, and then we address the CIRC lesion. If the flow is there, then we perform DEB as well, in CIRC as well. So first we address the LAD. We took 6-French catheter through radial approach, and we passed a 3.35 stent, 3.5 into 33 mm stent in ostial to mid LAD. The lesion was post-dilated with 3.5 into 15 NC balloon. This is the post-dilatation result. Then we prepared the mid-LAD lesion. First we use semi-compliant 2.0 into 15 mm balloon, followed by NC 2.75 into 15 mm. This is the result after lesion preparation. Then we used a paclitaxel eluting stent, paclitaxel eluting balloon 3.0 into 30 at 60 ATM for 2 minutes. This is the result after paclitaxel eluting balloon. This is the post-DEB angioplastic angiographic result. The patient was discharged on the next day on goal-directed medical treatment and dual antiplatelets. We plan to perform PCI to RCA plus minus PCI to CIRC after check angio of the LAD. The patient remained symptom-free during these 7 days. Then we took a check angio of the LAD. And then proceeded to RCA. We prepared the RCA lesions with the 2.5 into 15 mm NC balloon, followed by 2.75 into 15 mm NC balloon, and the distal RCA was post-dilated with 3.0 into 15 mm NC balloon. And then we performed a DEB on distal RCA and PLV with 3.0 into 15 at 10 ATM for 2 minutes, followed by 2.5 into 15 mm at 8 ATM for 2 minutes in the PLV. This is the result after DEB. In the same session, we then moved towards the circumflex. We passed a pilot 50 wire with support of 1.5 into 15 mm semi-compliant balloon. And then we prepared the lesion with 2.75 into 15 mm NC. This is the result after lesion preparation. Then we performed a DEB with 2.75 to 10 mm at 10 ATM for 2 minutes. This is the result after DEB. So we kept the patient on regular follow-ups. The patient was compliant with the medical treatment, remained symptom-free and functionally active. His glycemic control was good, and we performed a check angio after 4 months. This is the result after 4 months. There is no late luminal loss. For comparison, you can see when we perform the DEB, and after 4 months, this is the result. So this is the situation of RCA. Thank you.
Thank you very much. Very good results. The lunch is ready, but just a final take from the panelists. And the one thing about the big OM branch, I think they would have been also treated that one.
Just quick question. Why do you do angiogram after 4 months? The check angiogram when the patient has no symptoms. Each angiogram, invasive angiogram, does cause 1 to 2 per thousand risk of stroke and a death, and then slightly higher for the vascular complication. So what was the rationale to do a 4 months later an angiogram if the patient was asymptomatic?
So actually we planned it with patient that we were offering him cabbage, but obviously he was not complying to the cabbage treatment. So we planned that if after all this extensive ballooning and after all this extensive DEB, we want to perform a check angio. That was pre-planned.
I understand, but what was the rationale?
We want to see the positive remodeling. We want to see the.
But what patient advantage? You are still doing an invasive procedure to a patient because just I want to see my result. That, to be honest, I'm sorry. It will be.
You have to have the patient has to have symptoms to go back in to do a check angio. I understand the second one where you went back in because you planned on a staged PCI of the RCA. But what I also want to ask is, why did we not consider using drug-eluting stents?
The questions. I will start from the comments of Professor Tarek. Actually, he was concerned that this patient either would have gone for the cabbage or because he may land with a lot of metal. And actually, we can all say, if we put stents, it is 5 stents or 6 stents or something like that, and how the and recently the DEB has shown promising results worldwide, not only in our part of the world but rest of the world as well, and we are moving in the same fashion. And the results in the last 1.5 years we are performing these procedures, they are quite good. Regarding the particular question, why did we perform after 4 months, we have a plan because we are running a study actually on the plan is to do angiography, check angiography after 6 months. But in this particular case, he is a gentleman who is young. He is ex-federal minister and is an MNA, and his lifestyle is very hectic. He used to move a lot of areas, and he used to have symptoms which were non-specific. So we were concerned whether this is balloon failure, is he having any residual ischemia or something like that. So we wanted to be sure that his symptoms, they are not coming from the coronary artery disease. So that was the reason to perform this. And after that, he is absolutely fine. He does not have any symptoms. He's performing actually regular exercise for more than 1 hour and doing his routine activities. So this is how it is. So, yes, CT angio, again, it's fine, but looking at the angiogram, it's always better to see 100%. Thank you very much.
Thank you very much, Dr. Akhtar. Thanks a lot. Now it's the time for the lunch.
I will be moderating this session along with my friend and colleague, Professor Tahir Sagir. And we have got, in this session, we will cover two live cases, one from Uzbekistan and the other local from Armed Forces Institute of Cardiology, National Institute of Heart Disease. And we also have one dedicated lecture from US by Dr. Tanveer Ram. So I would like to invite the chairpersons, that includes Salman Arain from US, who are present on site, and Dr. Khabar Kazmi, Azhar Ali, Dr. Rajesh Kumar, Dr. Rafiullah Jan, and Dr. Muazzam Naqvi, Dr. Abu Bakr Ali Saad, and Mahesh Batra, sorry. These, we have the expert list, and also on virtually we have two experts, one from Singapore, Dr. Fahim Dafri. Fahim, are you here?
I am. Assalamu alaikum, I am here.
All right, okay. And also Professor Javed Ahmed from Newcastle. Right, so I think we should probably start the live case, and now we take you to Uzbekistan. We have live, could you please check if Uzbekistan is ready to be connected?
Hello, can you hear us? Hello?
Yes.
Yeah, we can hear you, Dr. Raza.
Oh, yes, is this Najmuddin?
Yeah, my name is Najmuddin. It's great to see you. Welcome again to Uzbekistan, and it's my great honor to attend it. Pakistan Live. Hello to everyone. Hello to chairman, panelists.
All right, thank you so much for joining us. And we have already introduced our panel of experts who are from national and internationally. And would you like to introduce your team and also the introduction of the case, please? Over to you.
Yes. Yeah. Today, I'm working with my colleague, Dr. Jawahir Anvarov. You can see him. And our nurse, please come here, is Ms. Shahnaza. And this case was supported by Microport. Thank you for all sponsors, supporters. So the case, the patient is with unstable angina. This session is for the life, acute coronary syndrome. This is the patient with unstable angina. In 2024, patient had kidney nephrectomy from the left side. Yeah, the patient has also diabetes mellitus, second type, and hypertension. And that's all. So, and also, can you just 1 second? We will show you our screen.
Sorry, your screen is off. Yes, now.
Yeah, just 1 second.
Yeah, now we
it's
can
okay?
see. Yes, we can see you clearly and we can hear you clearly. Thank you.
Great, thank you so much. So we have the XBU 3.5 nowadays, the guiding catheter, 6 French, and the radial artery 6 French. So the patient, as I told you, with unstable angina. So this is the right coronary. There is no any
We can't see the coronary images. We just see you.
Oh, really?
Would you like to show us the angiogram pictures, or some interruption in the screen? I will let you know when we are ready to request you to project. Yes, now we can see you. Can you show us the angiogram of this patient? Or
1 second. I'm so sorry.
No, it's okay. Take your time. There is no hurry. We can just wait and.
That's better. We see the radial images now.
Yeah. So this is the diagnostic angio of the right coronary. Maybe you can see it.
Right. Yes, we can.
Good.
Yeah. There is no any disease, but I mean that there is no need to do any PTI in the right. So everything is okay. We checked in the 3 positions. So, and this is the left system. And as you can see, there is a very severe stenosis in the middle part and a little bit in the distal part of the CX. And with the LAD, as you can see, there is a still little bit diseased in the middle part. It's just a simple case, I understand, but the patient is unstable angina, so it's the case that for the real session.
Sure. Can you please stop here so that we just need to ask our panels.
And so I would, once I dilate, get some room, I would then, IVUS, get a sense of what the plaque morphology is like, and then go from there. It's one option would be to try to treat this with a DCB. We do a lot of that in our practice, but I mean, a straightforward long stent from distal to proximal might also be a reasonable strategy.
Right, thank you. And Javed, you have any comments on this or any suggestion? How would you treat this case?
Thank you, Afsa. This is a case of acute coronary syndrome, and the lesion in the proximal circumflex is quite severe, and there is another less severe lesion in the mid to distal segment. I think my approach would be that obviously to wire the lesion, and after that pre-dilatation with the balloon. I mean, I would pre-dilate both the lesions, and after that I will do OCT imaging here, because it would be easy to pick up any plaque erosion or rupture. I think that is the phenomena which is behind the acute coronary syndrome. Just inflate the balloon and get at least less than 50% residual stenosis, and then just leave it and let the vessel remodel. And I think this is a typical example which Fahim has already alluded very correctly, that this would require imaging as either with IVUS, but I would prefer to do OCT here to know that what is the exact cause of this acute coronary syndrome, whether it's a plaque erosion or a plaque rupture. Although it wouldn't change the management in terms of, because obviously you have to do the same thing, but you will know the pathology.
Thank you, Javed. We have the local moderators, the chairpersons. Can I ask one of the experts from locally, any idea or any suggestion, or any change in strategy, or what do you? Sorry, we can't hear you.
May I ask one question from the panelists and the chairmen? So the size of balloon you recommend in such patients with acute coronary syndrome? 0.5 for the first, or
before going for any balloon
as unstable angina, so we'll go ahead and fix this, the wiring in a UUL patient, then pre-dilating, and if I can do image, that will be best to see the morphology of the plaque here, and then to fix it accordingly. And I think that's the usual care as we do in our setup.
Okay, thank you.
What I do usually in acute coronary syndrome settings, that these are the kind of plaques where some plaque rupture, maybe some thrombosis also, and the likelihood of no reflow is there also once you balloon or put a stent in. So I most of the time end up pre-treating with adenosine or vasodilator like nitroprusside or something to make sure that the no reflow is reduced, and start with a smaller balloon, just to make the larger the balloon, the higher.
I just slightly dilate the distal part with the 2.5 down. It's 10 a.m.
And
the nominal pressure is 12.
And which wire did you use?
The wire is the horse wire, the cyan blue.
Okay, thank you.
So we give the 16 ATM. So once just a little bit check, safety check. Yeah, you ready? Yeah, go. I think it's okay. So, honestly speaking, the visualization, it's possible, but not for the
What are you going to, Dr. Najmuddin, what are you going to do with the distal lesions? Are you going to touch it later, or it is, which one, what will be your strategy to tackle both of these lesions? There is some disease distally as well after mid-course.
I would love to do the DCB. What do you think? And for the proximal, that stent.
Before you consider, if you are thinking about DCB, you have to really prep the lesion very well. 1:1 size. So you have to do like 3-0 balloon and then see what the results is, and then you can consider DCB.
I'm sorry. We just ballooned the distal part. How to see how it will be the reaction from the vessel.
Less than 30% residual with a dissection that is not more than type C. And if you get that, then go ahead and DCB and you're done. I'm not sure imaging adds incrementally to it, but then if you decide that, okay, I'm going to do bailout stenting, then definitely image to get accurate sizing, as Javed said, and then see what you want to do.
For him,
so sort of doing things a little bit backwards, but if you're planning to stent, then I would image up.
For him, do you think visually, angiographically, does it look quite tight, or you would like to do some FF or any subjective test of ischemia on this? Or should we leave it alone? So this is also another question.
Yep.
Anyone on
But
this?
I think it's acute coronary syndrome. FFR may not be that much helpful, and lesions look significant.
I wouldn't use physiology. I would just...
I think we need to address this distal lesion before we embark on the proximal stenting. That will be great.
But I think you can cover both lesions with one stent. I think a long stent, this will cover both the lesions. You can take a smaller one, and proximal part you can dilate with a bigger balloon.
Yeah, we have an experience of proximal stenting and distal with a drug-coated balloon. But I think that will be before we embark on the proximal stenting.
So honestly speaking,
very critical.
I think.
Can you see my mouse?
Yes, we can do that. I think there is a very large segment between the two.
Can you see my mouse?
Hardly. No, not yet.
Okay, great. So anyway, we are doing we opened the IVUS. Now we want to do the IVUS to show you the morphology of the structure, atherosclerosis. So, and then my opinion is first to do the distal part, not to take one long stent, just distal part before bifurcation, distal bifurcation, and the short stent around 15 to 16 to the proximal side.
But Dr. Najam, I think at this point doing IVUS is not going to tell you the physiology, because what happened, because you already have dilated with balloon. So it's there will be some dissection in that area, so you won't really know if there was a plaque rupture or this is from the balloon, there is some dissection there. At this time, the only point of doing it is to assess for the size. And I personally feel that you can just put a one stent to both the lesions and maybe just do the 2.5, 38. It's 2.5, 38 or 40 should be okay to cover this.
It's a quite
so just look, I will little bit take out the wire.
Okay, let's see the...
And show you...
Can raise your hand who will do the distal lesion as well, from audience, distal lesion. And those who will not do distal lesions. No. So the majority says that distal lesion should be covered. And
now
should be covered with one stent. How many will go for one stent? Only one. How many will say two stents? So there are two stents separately, so that is the consensus here.
They want to be cost effective.
It depends on the, like we have 48 stent as well, so that can also help.
I think that if
anyway, you are the treating cardiologist, so you know the best to the patient, and you know whatever you make the strategy, will accept that. Thank you.
So.
Please feel free and tell us what you want to do. That will be fine.
So as you can see, I little bit pulled back my wire, and I don't think that a 40 millimeter stent will be enough for this part of lesion. And I don't want to just put one long stent, because there is a healthy segment in the middle part between the two stenosis,
Yes, I think so.
So I will just, yeah,
The healthy
I don't
part is very
like
small. You are going to end up leaving just few millimeters in between two stents if you decide to put two stents. You know, healthy segment is very, very small. There is some moderate disease in the middle, severe disease proximal and distal.
Okay.
So after you put the stent, that area is going to look worse, or you're going to end up having a dissection and putting in a third stent.
Yes, but
I think we need a long stents to cover all from the proximal to the distal healthy area. That's like leaving
So,
in between will be
if we want to
not
put the
appropriate.
distal part one stent, what do you think? The length of the stent, 18 or 20?
For one stent, if you want to cover both the lesions, you need 48, obviously. But if you want to do two stents, then
What is the longest stent available in your lab?
In anatomy, you want to put a smaller stent across the OM so that you don't get carina shift, and then obviously post-dilate, and a larger stent proximally above the OM, don't have carina shift.
So I choose the shorter stent, as one of the panelists suggested, 22, but we just took the 2.75 to 21 millimeter. So we want to, you can see there is some calcification.
I think before this
we
thing,
need to the angio.
we need to prepare the
we need
lesion
to
distal
Yep,
before we
yep,
embark on a stent.
Yep. I'm just taking out the stent and then just be careful to lose the wire.
But just out of interest and for
I
the
would-
audience, if you're planning to stent, then why are you not doing IVUS first?
I would
So,
just
you know,
recommend
as
that we prepare the distal vessel very well before we take the stents.
Dr. Najmuddin, have you got the imaging facility? There is a demand of if we can see the IVUS, the imaging. Have you got that facility in your lab, or we just do?
Yes, we have the volcano.
So would you like to do that, or you just want to skip it and then see the final results?
Okay, I will do the angioplasty.
All right, okay.
First, and then prepare vessel to pass with the IVUS system, and I will show you the lesion morphology.
That's fine. I think there
Just
is
to
no.
give me 1 second.
With such circumstances, there is no hard and fast rule. I mean, different operators
Yep,
do
yep.
differently. Some do maybe two small stents, two stents, or some might do just the proximal and do FFR or something. So there are many ways to, I think, do depending on the operator's experience, their teaching and training. Thank you.
Any thoughts on this, that proximal DES and distal to the DES DCB, and a very good preparation as we have from the consensus document, one-to-one preparation of the distal lesion and then depth and then a proximal stents. Any thoughts from the panelists about from the online chairpersons?
I think we do a lot of.
Sorry, the problem with DCB is that imaging is becoming more and more important, because obviously we have to distinguish between plaque rupture and plaque erosion. Plaque rupture is obviously much more serious than the plaque erosion. So if there is only a plaque erosion, DCBs work much better than in the plaque rupture situation. And so I think imaging perhaps is obviously important in this case, but if they don't want to do it, then perhaps stenting is the answer, and both proximal and the mid to distal lesion.
Yes, I agree with Javed that if we are committed to do a drug-eluting balloon, then we have to do the imaging to exclude any significant dissection, and so then we decide whether it is suitable for a drug-eluting balloon or stent. So I think in that case, if we are committed, then imaging becomes almost imminent.
Actually, Afsar, for the DCB and imaging, it's a bit of a controversial thing in the sense that if you do balloon dilation due to doing DCB and you image, you will always see ugly-looking dissections. If you do OCT, you're going to see horrendous dissections. But the data shows that if you look at angiographic dissections, if you have anything that's a type C, and they all heal up as long as you have, number one, residual stenosis less than 30%. You have good flow, residual less than 30%, and you have a dissection that.
Flags you can see here, and I'm going back to the critical part.
Are you at the proximal now, proximal lesion, or?
Yep. Now I'm in the proximal lesion. Here is a dissected part of the plaque.
Yes, mostly fibrous plaque. It's
Osteum. This is all the way diseased.
yeah.
So that
So you see,
means
as I said, the whole vessel is diffusely diseased. It looks angiographically like you have an island of good vessel, but actually the whole vessel is diffusely diseased.
True. It
So,
is.
Najmuddin, there does appear that a filling defect in one of the parts of the plaque that may be possibly a thrombus formation inside the plaque.
Yes, true. I
Yeah.
think according to Dr. Javed is good in, IVUS, and as he mentioned that there is plaque rupture in both of these lesions. So I think probably it is now it's reasonable to have a one stent, you see, long one covering both. But I think it is up to you whether you want to do two stents or just single stent.
the longest they have is 38, so it's not going to cover one
Just
stent.
a word about imaging in acute coronary syndrome. OCT is a better image modality which show us in a better way the plaque ulcer or rupture. So as compared to
unfortunately, we don't have
IVUS,
now
OCT
data
is
the OCT.
preferable to document the plaque rupture.
There used to be Valcano who
And
you
thrombus
see
as
used to give histological details, but there are no good studies to support that.
So now you can see that the cross, our stent is crossed. I think the position is nice.
Can you show us the
angel?
I
Yep.
only see
1 second. Sure. 1 second yeterdi değil mi? Sen şunca bakır. Sure. Sure. Yok. Netçi verdin? 10. Nominalin? 10. Okay.
It might help if you put the angio screen on the big screen in the middle.
Boy, 3 boss var, hein?
So
Nice.
what
Just
are-
1 second. We are putting another screen for you. It will be much easier.
So what are you doing? Are you doing this balloon or stent?
They have stents.
This is already stent, 2.75 to 21.
The vessel looked a lot smaller distally. You're taking a 275? I thought the vessel looked like a 225 vessel.
225.
I mean, if you look at the IVUS, the distal landing zone was not 275, if I'm not mistaken.
And which stent have you used? What is this stent make?
We just use Fairhawk 2.75 21 from the microport.
Okay.
I think for the audience, you size your stent to the distal
You can see
landing
the
zone.
visibility of the stent in the stent booth is also nice. 50 check up. So we can see it's okay. But I think that in the angulation part, we didn't open yet good. So I would like to, honestly speaking, post-dilate this part with the 2.75 NC. What do you think?
Yeah.
I think the
Can you
results look
suggest
quite
anything
good.
else?
Although there is some compaction in the middle, just to
Yep. In the critical part of the stenosis,
that
as you
is-
mentioned,
yeah.
you're
Oh,
very
yeah.
correct.
Yes, we could see in the IVUS. Correct. This is something-
Yes, we can take 275 NC and we can post dilate the stent.
What was the distal vessel size on IVUS? The size of
So, and I was, just 1 second, we will show you. I was the ultra. 5'ке koyup durayım, okey, iltimas. Okay, okay.
I think when we image, so we have a distal reference segment and we size the stent according to that. So.
Yep. Proximal, you mean?
Yeah.
No, the distal, go all the way distal and go all the way distal and then measure the vessel. Yeah, measure that vessel, please, from EEM to EM. It looks looks smaller than 275, but I could be wrong. Again, for the audience, you size your stent to the distal vessel. If you measure EEM to EM, you then go a little bit smaller. So I think you're overestimating it a little bit. It's just, at 7 o'clock that it needs to come in a little bit. So the vessel is barely 2.6, I think. And up there, that needs to come in up there, bring that in. And again, this is just an important exercise to get the accurate size. So you're 2.6, 2.9. So probably a 2.5 would have been the appropriate size. You downsize a little bit just so that you don't get a dissection distally. But it looks like your stent is good. So
Yeah, I think that 2.75 was very nice for this lesion because
in fact, there aren't any big, large randomized trial. I think what my understanding is that if there is very proximal lesion in large vessels, drug coating balloon or drug eluting balloons are not the answer. I think those lesions should still be stented. It's where the mid to distal vessel where the drug coated balloon could be more useful, and also in the side branch or ISR. I think more usage of drug-eluting balloon without even classifying it, which lesion is suitable for that, I think that
correct.
may not be the most suitable strategy.
Because the concern is that if you use 1-to-1 size ratio, balloon, and it can cause, the plaque which is unstable or is not.
Absolutely.
You can convert this into disrupted plaque and lead to MI. So that is probably a bit. I don't know. Is there any study that needs to be studied?
Basket small is the largest small vessel study, and it shows that DES and DEB is quite equivalent small vessels. The REC cage-free study was just published. And that showed that in larger vessels, 1 DCB that's only available in China was inferior to DES. So the jury is still larger vessels, but our own experience done a ton of young patients STEMI with DCB, and they've all done very well. So a lot of it depends on what kind of DCB you use and what kind of vessel prep you get. But the jury is still out in terms of randomized trials. But look up REC cage-free 1. That was published just a few months ago.
Fahim, I agree with you, but since we have now known that the two separate mechanisms, plaque erosion and plaque rupture is not the most responsive underlying thing to DCB, but plaque erosion is, obviously, because there is no breakage of fibrous cap in plaque erosion.
You're right, but if you look at the original primary angioplasty data, if you look at PAMI, and then you look at stent PAMI, the only difference between and stent for STEMI was repeat revascularization, and you can mitigate some of that by just the drug-coated balloon. So actually, the data doesn't show that stent is any more beneficial, even for plaque rupture STEMI, with the exception of repeat TLR. So I think that we still don't know for sure whether we actually have to stent on patients. Now we have modern DAPT, modern therapy, statins, stuff like that. We did not have it at the time of PAMI, which was 1990 or 1980 actually.
So for him, a conclusion to our discussion. My question would be, would you recommend the cooperators to use 1-to-1 balloon, drug-eluting balloon, just to treat the ACS lesion? Yes or no?
Yeah, well, yes, because DCB is meant to just deliver the drug. You're only deploying it at 6 atmospheres, so it should be 1:1 to touch the intima, but you're going in at only 6 atmospheres, 8 atmospheres if you're using the Prevail Medtronic DCB. So that's quite okay. You just have to look at the image before you put the DCB in. Do you have less than 30% residual, no type C or more dissection, and TIMI-3 flow? If you have all those 3 things, then if you look at the DCB consensus document.
Right. So in the interest of time, I would interrupt. I'm sorry about that. We have only, Dr. Najmuddin, we have only 3 minutes. 3 minutes for you to.
Just 1 second. Can you hear us?
Yes, we can hear.
I'm sorry, there are some problems. There was some problem with connection. So we have implanted a 3.5 12 millimeter to the middle part, in the proximal part, I mean. So we are doing the control angio.
You show us an image. We don't see the image at all.
Oh, really? Can you see us? Can you see us?
Yes, we can see your pictures, but not the angiogram pictures.
No angio. Oh, okay. Just 1 second. Now you can see, yep.
Yeah, we can see now.
So this is the, after the stenting, 3.512. As you can see, there is a huge gap between two stents.
Correct.
And Bishop, sorry. I will show you the, just 1 minute, the IVUS.
Did you take
just 1 second.
Did you take the post-stent IVUS pictures?
Here is the IVUS, just 1 second.
Right.
Can you see the IVUS?
Image quality is very poor.
Now?
Can that be focused further?
Focused, this is the, it's, I don't think that it can be focused because it's directly going with the, so this is the end of the first stand, the proximal part. Now we can see the disease part of the middle, between two stands. It's not severe.
Sorry, can you just rewind? Is the opposition of is the stent well opposed or there is malopposition here?
There is no malopposition.
Okay,
it's
good.
well opposed.
Thank you.
It's already, you can see in the distal part stand, it's also well opposed.
I think stent is a little bit underexpanded, so it may require more work with the NC balloon. It is underexpanded.
Yes.
You could see the clear distance
Yeah,
between
it's not
the
fully.
stent.
Yes, if I'm not wrong, Javed, it is not probably fully expanded.
There may be a dissection between the stents, so I think we should look at that area a bit more closely.
At 12 o'clock, 12 to
The
1
stent
o'clock, there is a
is-
dissection.
Between two stents?
I don't see any dissection between the two stents, to be honest with you.
Let's take
I
another
don't see any dissection.
Just take a look between the.
Here is the proximal part of the stand, the proximal stand. It's well opposed because
What do you think, Javed? Is it well opposed or what do you think?
Here, it needs more work to be done with the post-dilatation balloon. We need a larger balloon to post-dilate and will oppose.
The stent is underexpanded, no doubt about it.
Yeah, I think.
You mean the distal part first stent?
I think the proximal. Yes, this
Whatever on
one.
the IVUS you showed, because there has been interruption in the IVUS imaging pullback, and I mean the stent is underexposed in some areas, and that would require further expansion.
So would you recommend 3 or 3.25 or 3.5 NC balloon?
I will go with a 3.5.
All right, 3.25 or 3 I think is reasonable to post-dilate.
I think better would be to take it from the IVUS imaging, the post-dilatation balloon. It will be better to see from media to media. I think that will be better, the balloon, because they took a 3 fast stents. And if we can measure from media to media, I think it will be better to take the post-dilatation balloon from the IVUS.
Yeah, I think it's a 3.5 balloon here would be quite good. At least I will go up to about 18-20 atmospheric pressure.
So, if you remember, you told us that the distal part of it looked like a 2.5, but we implanted 2.75. So in the middle part, it's yes. We are totally agree that it's underexpanded. We will.
Distal stent edge, is it? So go all the way to the distal stent.
Okay, this is the distal stent.
Yes, here. If you stop here, I think it's probably underexpanded here.
Yep. It looks like 2 or 2.5 at least.
I think the good thing about this IVUS is it is a concentric underexpansion. So it means that the balloon will work here. It's not an eccentric underexpansion where there is one side of the stent is opposing against the wall. But here, all the sides of the stents are not opposing against the wall. So a bigger balloon will do a good job here for further expansion.
So we will gonna take the 3O balloon for this part. 3O balloon.
Is this a 2.75 stent?
And you choose.
Yes.
You use
The 3O balloon
2.75.
would be fine. Yeah.
Sorry, what was the size you used? 2.75.
Yes,
So
2.75.
you can safely go to 3.25 or 3.5 maybe. What do you think, Javed?
Even we can do with that
I
275
think,
larger pressure inflation with that. I think high pressure,
If
like
they-
say 2024 with 275.
If the operator feels that 3.0 is obviously 3.30, 3.25, I think at the initial stage, I will just go with the 3.0 and then obviously I will upsize it to 3.5 if required.
Yes, I'm totally agree. I'm going with the 3.0 balloon, 3.0 215, and I will go with the little bit high pressure, around 18 to 20, and we
Yeah,
will
I think
see.
beyond 20, if you look at the pressure curve, unless until it is a severely calcified lesion, going up to 24, 28 with the non-compliant balloon and a non-calcified lesion only leads to rupture and does not expand the stance, you see. So I think up to 20 is pretty reasonable.
Okay, we will go with the 14 first, and then we'll see what's going on. It's still a little bit dangerous life. Üç koy var ya. Watch. So we are going with the 3.0 on top. 16. Yeter demem şey. 17, 18. Bakın. 8 bakın. Basasın bitti. Yeah, 8 bakın bu. So we gave the 18 ATM. It's fully opened, expanded. I don't want to do anything in the distal part. I know. We will do again angio, IVUS, and we will see. Are you here with us?
Yes, you have 2 minutes, you have 3 minutes only. And
Okay,
please
just
show
the
us
one
what
IVUS I will show you. Yeah, after the balloon dilatation. Use 18 ATM, 0 balloon. Just want to show you, is it still under expanded or it's already expanded?
I think the two key factor of ISR are really good independent predictors. One is MSA, final MSA, and center under expansion. I think nowadays also on OCT or on IVUS, you can calculate the index of standard expansion. I mean, the machines generally calculate it itself.
Fish.
So that looks much better.
Live.
Yeah, it's much better now.
So yeah, it looks like much better. This is the middle part that we post-dilated. It also looks much better. Still a little bit under expansion, but it's much better.
Okay.
I think here in this segment, you can easily go with the now 3.5 actually.
Yeah.
Right.
In the middle part, yeah?
Dr. Najmuddin, we have to show other case now. Thank you so much for
Yeah,
showing
I'm
this
sorry,
wonderful case.
thank you so much. Yeah.
And thank you for
thank
all
you. Thank you.
the panelists and the audience. Okay, so we go to the
thank you very much.
AFIC, and I hand over the mic to my colleague, Professor Tahir Sagir, to moderate the second.
Thank you, Raza Saab.
So
So the next case from Uzbekistan to RIC Pakistan. Dr. Adil will present the history. Yes, we will be connecting with the FIC and then Dr. Adil will present the history.
उसने तो
नहीं एक मिनट वो कनेक्शन हो जाए अच्छा ठीक है आया ना
Endi bet proximalniy. Lux 3 ta turibdi, 2 ga o'tishimiz kerak. Shunda turibdi deganingiz ham ham. Yo, 1
आपका केस
bo'ldi.
good afternoon. So we have a live case up and ready at the cath lab of AFIC. I'm Dr. Adil Yusufzai from Armed Forces Institute of Cardiology. Before joining them, I would present a brief clinical context to know what we are actually dealing with. So we have a 60-year-old gentleman who is chronic smoker, pre-diabetic, who has history of coronary artery disease since 2021, with his RCA being totally occluded, and he was on optimized medical treatment. He was doing fairly well until he presented to us with class 3 symptoms, class 3 angina. His ECG and cardiac troponins were normal, and so were the rest of his lab investigations. His echo revealed a moderate LV functions. His MPI scan was done at the onset of his symptoms in January 2024, which revealed viable RCA with severe ischemia in RCA territory. The fresh coronary angiogram was performed in April 2025. So this is the caudal view showing a normal left main and left circumflex, clearly showing crossfill to the right system. The caudal view showing the same with normal proximal LAD. In cranial view, there is some disease at the mid-course of LAD, about 50 to 60%.
Please.
Flow stop, please. Again showing mid-LAD 50-60% disease with crossfill from the left system to the dominant RCA. RCA is totally occluded from the ostium being crossfilled from the left system. So in summary, we have a 60-year-old male who has class 3 angina despite maximal anti-anginal therapy with moderate LV of 45% in MPI showing viable RCA with severe ischemia in its territory. So I hand over to the moderator of this course.
Thank you, Dr. Adil. Can we take the lab? Okay.
Yeah, so we need to come out.
Dr. Bilal Iqbal, Dr. Ali Nawaz, welcome.
Yes.
We welcome you at Conference Center.
Thank you, Prof. Good afternoon, everyone. From AFIC Cath Lab, we are all set for our second live case from AFIC Cath Lab under the primary operatorship of Dr. Bilal Iqbal. He's joined by Dr. Ali Nawaz, consultant cardiologist, and myself. And in the team, we have got Tehzeeb Shah and Mudassir on the machine. And on the trolley, we have got Kamar and Faizan. And we are accompanied by our nursing officers, Yasmin and Adila. And without further delays, I'll request Dr. Bilal Iqbal to take over the case and further elaboration, please.
Good afternoon, everybody. Assalamu alaikum. Have you had a case summary so far of the background and the history?
Yes.
Okay, so what we have is, we'll stop and we'll go through the frames one by one from the beginning. So we have a right coronary CTO. So we start from the beginning, please. Yeah. Right coronary CTO. Initially, from the diagnostic angiograms before, we felt it may be a blunt stump, but actually there is a slight bit of a lead, but it is blunt into the right coronary.
Bilal, can I just, sorry, this is Professor Javed Ahmed from United Kingdom. Can I just ask you, it's, to me, it appears to be acute on chronic occlusion. And I'm not sure, perhaps, whether this lesion is more than 6 months old.
It's very difficult for me to say. I've been presented the case in anatomy here, and to me, this looks like quite a chronic occlusion. To me, it's behaving like a very solid chronic occlusion. So,
yeah, Dr. Javed, this gentleman had acute coronary syndrome in 2021, and it is around 4 years, and then having anginal symptoms since then. He didn't have any acute presentation in the last couple of months.
Can I ask, his symptoms have been getting worse since when?
Yeah, getting worse, but these are the anginal symptoms, no ACS presentation.
But they've gotten worse, or they've been the same for 4 years?
They were there, but they have gone worse over the last 6 months round. And in the couple of months, they were getting again worse and worse. but no ACS presentation or admission during these last 6 months.
So what's the plan, Dr. Bilal? You are having
So
a
should we start from the beginning again?
injection.
Sorry, I'm just, I've got a naked microcatheter and distal epicardial here, so I'm just going to push that in forward a bit more. Okay, so what we have is, start from the beginning. So the dual angiography that we've got today, our setup is a 7 French biradial system. We've got an EBU 3.5, 100 centimeters, not short. A short guide would have been desirable. We've got a blunt stump in the proximal right. We've got backfilling from collaterals from the left coronary circulation. The occlusion length from that looks quite short and is very, very favorable for an antegrade wire escalation approach. And when you look at the proximal cap, you think there's a lead into it, there's a bit of a channel. So it all looks very promising for an antegrade wire escalation, I must say. So anyway, let's keep going.
Bilal, another important thing, it doesn't look like that much calcification either. So probably antegrade wire acceleration would be the next strategy.
In this, I'm not sure whether it transmits across your screen, but the mid RCA is quite calcified. We've got a lot of calcium.
No,
there is a lot of calcium.
Right.
It is. And so we were actually thinking about once we cross through, depending upon how the balloons behave, that we might have to use some form of calcium modification. So the distal right coronary artery fills principally from possibly some septal channels, but primarily from epicardial collaterals. There's a whole bunch of medial and lateral epicardial channels that come off the AV circumflex that enter into the PLV branch. And so, looking at this, our first and foremost approach is always work your way up the safety algorithm. So doing an antegrade wire escalation strategy. So we were able to initially, can you go forward, please? So these are all the different pathways. So there may be some septal connections from the first and second septal, maybe from the third septals. It's very difficult to say. We did map them out, and we were convinced that maybe there may be some septal connections. And so our strategy was to try antegrade wire escalation strategy, which we were quite hopeful that would work. If that was to fail, if that was to fail, then we would explore some retrograde approaches via the septal collaterals. And if that was to fail, the last bailout option would have been to do go epicardial via the AV groove circ. So that was the approach. I don't know, now that you've seen dual angiography, maybe the panelists would like to have a discussion amongst themselves on what strategies they would do and how they would do that. But for the purpose of time, I'm very happy to plow on and tell you what we did and where we are.
Fahim Jaffrey here from Singapore. Just out of interest, did you do a physiology of that LAD? I mean, there's something that's odd about this case, that he had an ACS 4 years ago, so presumably the right went down at that time, and now he's worse for 6 months. That CTO is very well collateralized. So the question is it the LAD that's actually causing these symptoms versus the chronically occluded right? So I'm wondering if you thought you'd do physiology on that.
I mean, doing the physiology of the right of the LAD is quite challenging, particularly if it gives off potential retrograde collaterals to the right coronary artery. Is basically you're increasing your myocardial perfusion territory, and so if it does come back positive, how do you interpret that?
Well, one approach, which is a bit of an alternative approach, is that you fix the LAD, which is the new thing, and then since we're doing this just for symptoms and not prognosis, he actually might just get better and may do fine. So that's just another way of thinking about this.
But then you're subjecting an LAD that's not functionally significant to a stent, which he may not need. That's the other argument against it.
Bilal, can I ask you a question here, if you don't mind? And basically, did you consider when you were doing antegrade wire escalation that you could do some form of modification of the compliance of the plaque? You know what I mean? That
100%. So we can certainly go on and tell you what we did and how the antegrade approach didn't work. Yeah, sure.
If there was no way forward with the antegrade wire acceleration, whether you would consider a Carlino here or that's not suitable?
It's very short, and absolutely, once we engage the microcatheter, doing a Carlino is something on the cards. But the problem here is you have to, the cap is so blunt, you really have to have a central puncture. And there is a little channel into it, which could you can see something sticking out the proximal cap, which I think might represent a jump collateral, and I believe that was. So we actually, the guide engagement was challenging here. So, sometimes just that in itself, poor guide support is itself as an indication to go retrograde. And so we kind of persevered with an antegrade approach. If you go forward, I'll show you what we did.
So, Bilal, to start with, you will be taking the antegrade approach?
Yeah. So we took a Turnpike LP, 135. I initially had used a field XTR. Field XTR is good, and it did engage something, but then it came back. But the problem with field XTR is it can easily engage tiny jump collaterals. And if you go down a jump collateral and do a Carlino through that, or even a balloon through that, it's not a pretty sight, okay? So we took a Pilot 200. It's got less tendency to go into jump collaterals. Next, please. And, we made, and then there was some tension in the guide system and everything fell out. You can already see there's a little bit of a hematoma starting already. So, and so we actually advanced the microcatheter forward. We used a Gaia, and the passage of the Gaia was kind of leaving the vessel. And I thought, if I persist with this anymore, you're going to get perforation on your hands. And, it's a blunt, ambiguous proximal cap. There's very little guide support. So rather than, could I persist with the antegrade approach? Sure. I could balloon that little stump, see if I can dissect, knuckle into the architecture of the vessel, or just go retrograde, and the occlusion length is short, and I would hopefully get some form of true-to-true crossing. It would be easy to enter in the guide catheter. And so that's where we are. So
I think I agree that after you have shown this picture, perhaps is not the suitable one for Carlino.
Yes, yes. And this is just what engagement with a wire, So if it was a tapered cap, 100% I agree. I would try a Carlino. And, not all CTOs are made for Carlinos. And so if you go forward. So then the septals are challenging as well. There were some connections in the second and third septals. We probed them. We probed them. I used some control wire tracking and septal surfing. There was no real connection there. There was some suggestion that there may be some connection from the S1. It's quite a big septal, but it's a very complex kind of septal origin, kind of retroflex. It's got an aneurysmal segment beyond it, and accessing that was challenging. Could we access it if we really, really had to? Sure, but I think the only way to do that would be to do reverse wiring and use dual lumen microcatheters.
So which wire is this one?
We tried a whole selection. We tried workhorse wire Pilot 50, Pilot 200 with bigger bends, Field FC with primary and secondary bends. There was some prolapse. We even used a Miracle 6, We used a Miracle 6, which doesn't prolapse. So, we gave it a good go. But, the dual lumen microcatheter of choice will be a Sasuke. They've got a Crusade here, which is a bit bulkier. But anyway, I explored some more distal septals, and I thought that just to get on with it, I'm just going to go down the epicardial collaterals from the circ. So that's where we are. So that's just wiring, just going into cavity, not really making any connections. So we aborted that. So then we are now accessing the AV groove epicardial. I've got myself a dual lumen microcatheter. It keeps going down the other route, isn't it? Test there, please. So we've got, it's a very, very challenging epicardial collateral test there, Tora-san.
Yep. It is quite tortuous as well.
Yeah, I know. So that's what I'm doing now. So I've got into the body of the epicardial. I actually had made some progress with the Sion Black just now. Okay, see on black, please. Yeah.
See on black.
So, test there.
Yes.
See, this bit here is very tortuous here, so I'm just working through this here. Lots of branches. So there are two collateral pathways here. One is medial, one is lateral. So the medial pathway is often the shorter pathway, which I was in. I'm just giving it a go in the lateral. I've tried the lateral, it's quite tortuous, but this is a different SUO3Y, which I've got here. So it's just patience, and if you watch my fingers, I don't use torquers that much, but I'm not spinning this wire. It's a matter of just keeping the wire mobile. Yeah, it keeps going up the branch there. Okay, see on black, please. So see on black, when you're in the distal epicardial AV groove circ, see on black is quite a good wire to use. The AV groove epicardial is quite well supported in its distal section. And that's where see on black has got the push to actually get this to go.
Bilal, what sort of percentage you are using epicardial nowadays? I know that they are the most difficult and fragile sort of collaterals.
I do a fair amount. Just this year, I think I've done about 47. So in the last 12 months.
All right.
Yeah. You know, there are, for sure, everyone's frightened to use epicardials. I think once you've got your experience with them and you learn to respect them and don't try too hard and know the limitations. I mean, you can look at the pistoning effect. Look how challenging this is.
And what is your experience of a bit of a mild staining after the epicardial?
A bit of a mild stain of epicardial? I don't see one.
Oh yeah, okay.
Yeah. If there's a mild stain of an epicardial, I'll deal with that, I guess. But you know, I'm looking out for that. The problem here is, in this particular epicardial, it's quite challenging because you've got a tortuous pathway. Test करेंगे?
Yes.
ये यहाँ पे ऐसे जा रहा है ना? So we need to just go in the opposite direction. So just a sewer wire here. Test, please.
Yep.
So do you alternate Sion black for the epicardial?
Tip of the catheter. We need to turn. Yes.
Sorry, I missed a comment there.
Suo 03 versus Sion black for epicardial.
Oh no, I've used a Suo.
Okay.
I've used a Suo, and I'm just trying to navigate through much more tortuous bends where I need the support, and where the Suo is just not giving me that.
I think the problem here is the tortuosity rather than anything else.
Oh no, but sure, but I mean, this is an AV groove epicardial. If it's not tortuous, then it's not an AV groove epicardial. Sure. I agree, and you know, you just work through it basically. So the problem here is that we're also limited with our tools because the Suo 3 wires that they have here are the 300 centimeter ones, and you can't. They're not very good to instrument.
No.
So I've fortunately brought myself some Suo 3 wires, and the problem is I only bought 3, and I'm on my second one. So sometimes you need. So I'm a bit. It's yeah. So I'm working under a lot of constraint and that kind of pressure as well. And this is a very challenging epicardial. So if I fail this, the other option is, do I take a dual lumen microcatheter and get on and to wire the more proximal septal?
I think the first septal looked pretty reasonable.
It is. I agree with you. It's just the access into it is so challenging.
It is. Yeah.
Very. Yeah. That's what it is.
I think I thought you will go for the first septal.
Tester.
Yep.
So this is a Suo now?
Yeah. So the way to address the tortuosity now is see, it keeps going down that other one. Test there?
Yep.
So it keeps, so the other one, it keeps wanting to go down this one here now. But there's so much tortuosity in branches here, this is challenging. So the lateral pathway is not very good. So what I'm going to do now is I'm going to try something called, just going to bring this around here. I'm going to try a little technique.
Center, please.
So basically the technique we're using suo knuckles, I'll show you. When you've got branching ambiguity in distal epicardials. See if I can navigate through that. And with the suo knuckles, it's like, I know a lot of you probably are thinking, oh my God, suo knuckles, yep, it works. And you just basically make an umbrella shape on your suo wire. Like that, see that? It's like an umbrella. Okay, and I'm not going to knuckle this, but you use that shape to actually navigate through the body of the epicardial without going into tiny little branches. So I'll try that now. This should work. You know, I know the transmission time is only 50 minutes. It'd be nice if I could show you a crossing. Once I cross this, I should be all right. Do you see what I mean here?
Bilal, it's not very well projected. Have you got a microcatheter with the wire, this one?
Yeah. There is. Are you not seeing that?
No. That's why. I think.
So then I'm sorry. I didn't realize that. I was wondering why some of the questions I was getting, like maybe it wasn't so. Oh, sorry about that.
No,
I don't know. I don't know. Test. That's a terrible. Should we just take a picture?
Yep. Yeah, ready.
Is this your second suo 3?
Yeah. I've made it that far. Just need to.
I think you may need another one.
So, you know, the one in the medial one is one to go, I guess. I just see on black फिर देंगे.
Sim.
Okay. So I'm going to go back to that medial pathway. It keeps going in that little branch. So what are the panel's thoughts if I can't get through this epicardial? Because you know some epicardials you can't get through, right? To go back with the dual lumen and see your reverse wiring for the first septal?
Yeah, I think that's what I was going to suggest. I will try the first septal.
Go back in the first septal again.
Yeah. I think that would be a good chance to getting through with the dual lumen.
Yeah, that looks better.
Test there.
Yep.
There you go.
Yeah.
Do your fluoro say that?
You're through, excellent.
So that's basically using a Sion black and in a distal. So everyone talks about Sion blacks. Use Sion black only in the AV groove epicardial around the base of the heart where there is safety. The epicardial is better. So now what I'm going to do is I'm going to देखो इसको सेंटर में रखें और पैनिंग कोई ना करें जी. So I can see थोड़ा सा और गाय भी नजर आए और लूप भी नजर आए, ठीक है? नहीं थोड़ा सा और यहाँ पे I often moving myself. हाँ जी बस इतना काफी है, ठीक है?
Bilal, this is Dr. Rizvi. What kind of microcatheter are you using here for the?
I have a Corsair Pro XS 150.
So is there any specific characteristic that you would not use in epicardial versus septal?
So epicardials, epicardial collaterals. Hold on, I'm just trying to instrument through this.
Bilal, what precautions you will be taking in surfing during the epicardial approach?
Acha, can you come to an iliocranial, please? So I'm basically through the epicardial now. I just need to work on iliocranial. So Dr. Rizvi, yes. So Corsair Pro XS 150, Turnpike LP 150 are the main microcatheters. If you need something lower profile, you use Caravel 150 or Fine Cross 150. So here I'm going to have to get around the bend there. You see that? No, I need to move the table. Okay. So I'm going to take an acquisition. Can you see what I have to work through now?
I think you have shown an excellent wiring technique by exchanging it to Cyan Black. I mean, would you have used RG3 at all?
No, an RG3 is an externalization wire, so you don't use that for.
Yeah.
You don't use that for your primary retro wiring.
Oh, I mean, would you do that just for externalization at this stage?
Can you see that? Can you see that? Can you see that? Beautiful. Lovely.
Yeah.
Come on, Bilal. You can do it. Good. Take it. All right.
Save.
Can you repeat that question again, please?
So, Bilal, what is your movement of your fingers? Do you rotate and push, or you just, when you're going through that?
With my fingers? No. So, yeah. So, people that you don't use talkers, they've given.
How do you push the back?
For the microcatheter, this is a Corsair Pro XS. So, I often turn 8 times in one direction. I leave it. If I'm doing continuous, I'll do 8 in one direction, 8 back in the other direction. And so that's what I'm doing. So I'm just, and the thing is, sometimes just leaving the microcatheter alone and then coming back to it works wonders. Sometimes when you have microcatheter fatigue and your microcatheter does not go, sometimes I've just sat down because my fingers are tired, and I come back after 2 minutes, and all of a sudden it's going. So it allows all the torsional forces and all the things that have accumulated inside the body of the MC to actually kind of neutralize. So I just want to take a picture so that you can see what the situation is with the guide. I've got the guide in, so you'll get more support.
We have 5 minutes for you. Then we'll be switching over to
take a picture.
Dr. Rav, and meanwhile you carry on with your case.
So this is a very good situation, yes? Yeah. Sorry, we missed ACT for all retrograde procedures, 350 and above. So here I'm just slowly pushing. Now, that loop, you see that loop on the epicardial? I'm going to monitor that the whole time, all right? If it changes shape, there could be an avulsion, right? But usually that kind of loop in the that is not a loop. It's actually you're looking head on from anterior to posterior, and it spirals like this. So when you look head on, it looks like a loop, but it isn't a loop. A true loop like that is an avulsion risk. Yes. Okay? So now, essentially, this is the Cyan Black, so once I get in the distal cap, we have a good situation. So also note that when the microcatheter does not go, you're focusing on your microcatheter. Remember your guide. Yeah, the guide is backing out. So to make the microcatheter go, just make sure the guide is in, okay? And that gives you a little break with the microcatheter and allows you to instrument. The other thing is when you've got tortuous epicardials or any collateral like this, yeah, can we take a Gladius MG? When you do this, you want to make sure that the wire is free. If the wire is not free, you've got impending you have impending microcatheter fatigue. So it's best to exchange it out. So the wire is nice and free. Also note that between any catheter exchanges or wire exchanges, if you focus on the camera, what I do is always fill your hub with the saline. So when you remove, you don't introduce air into the system. Okay? Now some people at this stage here will do a tip injection. Yeah? And a tip injection is useful to do. We can do one if you like, just to highlight the cap. Just a bit more detail. Please. So we'll get a 3 syringe and
contrast.
I was actually going to take a Gladius MG up because and just show because they don't have much transmission time. If I can get to the proximal cap and you can see that, just give me a Gladius MG. Yeah, and Gladius MG 14 and 190 centimeter G. Take it.
This is contrast. Okay, keep it here.
So you can see when I was wiring the epicardial, you know, my fingers, they were keeping the wire tip mobile. I was not surfing. You do not surf epicardials, all right? And and you just keep the tip mobile and allow it to pass through. And you never force a wire through an epicardial. You let it go. And you can also see there was a lot of little tiny knuckles that I was using to my benefit, you know. That scares people, but you know, once you get a bit of experience with the epicardials, and you learn to know where you can use knuckles to your advantage. You know, tiny knuckles are very, very good to work in. So here. The problem here is there's so much disease, so much friction that I'm having challenges to. There's so much tortuosity that actually transmitting, you know, the wire is so. Yeah. Actually, this may be a good time to see whether we can do a retrograde HDR. What do you think, guys? I don't know if Salman's there or he's still stuck in RIC.
So, Bilal, we are now switching over to Professor Tanveer for latest guidelines in ACS. You carry on with your tough case with the retrograde.
So, sorry, we can't hear you.
And we will we'll come back and see the results. Okay?
Okay, thank you. We'll keep working. Thank you.
Okay, thank you.
Thank you.
So, about the latest guidelines of ACS, it's Professor Tanveer from Emory, America.
Assalamu alaikum, everybody. It's really early in the morning here in Atlanta. So I'm going to start slide sharing now with the topic of discussion, which is the, can you see my slides there, Deborah and others? Look. Can you see my slides, guys, over there at your end? Hello?
Yes.
Can you see my slides?
Yeah, we can see your.
And can you hear me?
Yeah, we can hear you clear.
Okay. So it looks like Tahir is on the podium, and I see other colleagues and friends in the audience. So I'm going to talk to you about the 2025 ACCHA guidelines, for which I was a guideline writer and a committee member. This just released in February this year. So we wanted to produce one document for both STEMI and non-STEMI. And let's see, let me go back a second. This was done because, except for emergent primary PCI, pre-procedure, interventional, and post-procedure management, pharmacotherapy and longitudinal care with guideline-directed medical therapy are similar in ACS patients. And there's adaptation and rewording of recommendations from the 2021 ACCHA SCI guideline for coronary artery revascularization. And through the document, you see insertion of ACS, STEMI, or NSTEMI interchangeably as deemed appropriate. And this was inclusive of trials till and literature review till April 2024. So just to remind the audience, class 1 or green is a strong recommendation. It's a preferred strategy. There's significant benefits to the patient versus risk, and it should be done. On the other hand, class 3, going back to class 1, this is really based on clinical trials. Class 3 is also based on clinical trials where the recommendation is harm. They should not do it. It should not be done. There will be bad consequences to the patient, and we not recommend it. In between, there are class 2A and class 2B based on the volume of work in registries and other observational studies where the evidence is strong that there's probably more benefit than risk. Our class 2B, the evidence is equivocal. We don't know if the benefit or risk is greater. And it may be useful or may not be useful. We don't know that. But it is a recommendation where we like to use the word may be reasonable. So to start off this, as you know, the first thing is non-STEMI is a non-occlusive thrombus. The ST segment depression TV inversion. It is biomarker negative is unstable angina. Biomarker positive is non-STEMI. Occlusive thrombus leads to STEMI. Is generally biomarker positive, but recognize that the first blood draw may be negative and be too early from symptom onset. So what is the initial therapy during hospitalization? The patient arrives in the hospital or in the hospital with an ACS. Aspirin for everybody. It's a class 1. In patients with ACS, initial oral loading dose of aspirin, followed by daily low dose aspirin recommended to reduce death and MACE. And also, we suggest a class 1 addition of P2Y12 inhibitor and oral P2Y12 inhibitor should be administered in addition to aspirin to reduce MACE. And the harm in patient with history of stroke or TIA, practical should not be given because of worse net clinical outcomes. Now, the important thing to understand is that timing of P2Y12 inhibitors we have not stated over here. We will come down to the recommendations in more detail down the line. So here we go. Oral P2Y12 inhibitors in STEMI. In patients with STEMI, managed primary PCI, potent P2Y12 inhibitors such as prasugrel or ticagrelor should be administered to reduce MACE and stent thrombosis. Again, in class 1 recommendations, patients STEMI managed with primary PCI. Clopidogrel is recommended to reduce MACE and stent thrombosis when prasugrel or ticagrelor are not available, cannot be tolerated, or are contraindicated. And in third, again, a lot of patients get fibrinolytic therapy because they don't have access to primary PCI. Class 1 indication, patients with STEMI managed with fibrinolytic therapy, clopidogrel should be administered concurrently to reduce death and MACE. We don't recommend prasugrel or ticagrelor because they're more potent. There are not a lot of studies in this area, but they do cause increased bleeding risk with fibrinolytic therapy in these patients. What about non-STEMI ACS? Again, in patients with non-STEMI ACS undergoing PCI, prasugrel or ticagrelor is recommended to reduce MACE and stent thrombosis. Potent agents, class 1. In patients non-STEMI ACS who are managed without planned invasive evaluation, such as the elderly patient, such as some female patients, such as patients with established and known coronary disease, not amenable to revascularization, and the many of those out there who come back with a non-STEMI, should still try to use ticagrelor to reduce MACE. That's a class 1. Again, in class 1, in patient non-STEMI ACS, clopidogrel is recommended to reduce MACE when prasugrel or ticagrelor are not available, cannot be tolerated, or are contraindicated. And in those patients, say somebody's sitting over a weekend for a procedure or not hospitalized under care but will not undergo angiography till a few days later, this is a class 2B. It may be reasonable. So in patient non-STEMI ACS, plan for invasive strategy with timing of angiography greater than 24 hours, upstream treatment with clopidogrel or ticagrelor may be considered to reduce MACE. It may be reasonable, okay? Generally, what we like to do is to know the anatomy in the cath lab and give them a bolus dose or loading dose of the drug before proceeding on, because you know the anticoagulation in the cath lab might take care of it 4 hours or so before these drugs are active. All right, what about intravenous P2Y12 inhibitors? I don't know if this drug is available in Pakistan or not, but among patients with ACS and PCI who have not received a P2Y12 inhibitor, such as those with cardiac arrest or shock or who are vomiting, intravenous cangrelor may be reasonable to reduce periprocedural ischemic events. This is a class 2B. What about intravenous glycoprotein 2B3A inhibitors such as tirofiban? This is class 2A. In patients with ACS undergoing PCI with a large thrombus burden, no reflow or slow flow, adjunctive use of intravenous, and this now we also added intracoronary based on 3 small trials, intravenous or intracoronary glycoprotein 2B3 inhibitor is reasonable to improve procedural success and reduce infarct size. Class 3 harm, in patients with ACS, glycoprotein 2B3 inhibitors should not be administered routinely due to lack of ischemic benefit and increased risk of bleeding. Now this came about because we have more potent OP2Y12 inhibitors, and therefore we don't routinely give glycoprotein 2B3 inhibitor anymore, except in a cath lab situation. All right, what about anticoagulants? If PCI is not planned, say somebody's come to the hospital, inpatient non-STEMI ACS, intravenous and fractional heparin is the drug of choice to reduce ischemic events. Class 1. Class 1 is also given in non-STEMI ACS in early invasive approach not anticipated to receive either enoxaparin or fondaparinux as recommended alternatives to fractional heparin. What about coronary revascularization? So class 1 again, patients with ACS undergoing coronary revascularization with CABG or PCI in the same admission, parenteral anticoagulation to be continued until revascularization is completed, say by CABG or PCI, reduce ischemic events. What about cath lab procedures? PCI planned. Class 1, in patients with ACS undergoing PCI, intravenous and fractional heparin is useful to reduce ischemic events. This is the agent of choice. However, if the patient has a heparin allergy or HIT or cannot take heparin, class 1, in patients with STEMI undergoing PCI, bivalirudin is useful as an alternative to fractional heparin to reduce mortality and bleeding. And this is from the large BRIGHT study, particularly the BRIGHT 4 study. Class 2B, now we don't give the same recommendation in non-STEMI ACS to bivalirudin. When patients in non-STEMI ACS undergoing PCI, bivalirudin may be useful as an alternative to fractional heparin to reduce bleeding. And this is a scenario where you cannot use heparin for the reasons I stated. Class 2B, patients with ACS, intravenous enoxaparin may be considered as an alternative to fractional heparin at the time of PCI to reduce ischemic events. And this is because many patients get sub-Q heparin, particularly in the emergency room, and if you want to convert them, there's more bleeding risk with heparin plus enoxaparin versus giving intravenous enoxaparin based on dosing regimens. And class 3 harm, in patients with ACS, fondaparinux should not be used because of the risk of catheter thrombosis. What about primary PCI and STEMI? Okay. Does the patient have cardiogenic shock or hemodynamic instability? If it's yes, emergency revascularization of culprit vessel or PCI CABG is indicated to improve survival. Do it as soon as you can. If the patient is not hemodynamically unstable, look at time from symptom onset. Less than 12 hours. If the hospital transfer is not required, the patient presents to a center which does primary PCI. Perform primary PCI with goal of first medical contact to device activation less than 90 minutes. This is a class 1. We don't say balloon because many times we put a wire down to establish flow. Okay. What about if hospital transfer is required? Primary PCI with goal of first medical contact, device activation less than 120 minutes. This is a class 1. What about 12-24 hours? Primary PCI is reasonable to improve clinical outcomes. Class 2A. What about more than 24 hours? Presence of ongoing ischemia, severe heart failure, or life-threatening arrhythmias? Yes, go proceed with primary PCI to improve clinical outcomes at class 2A. But if the patient has no symptoms, the vessel is occluded, primary PCI should not be performed due to lack of benefit. This is a class 3 or harm. What about for those patients receiving in a center where you give fibrinolysis, you don't have primary PCI, STEMI is present? If there is the STEMI is not present, okay, you do not give fibrinolysis for routine ACS. So fibrinolytic therapy should not be administered due to risk of hemorrhagic stroke or major non-steroidal bleeding in non-STEMI ACS population, for example. If there is a contraindication of fibrinolytic therapy, transfer to a PCI-capable hospital for private PCI to reduce MACE as a class 1. We don't give any timing to this. If the patient does not have contraindication and you anticipate a delay greater than 120 minutes for time from first medical contact to primary PCI, you should transfer. If there's no delay, then you transfer to PCI-capable hospital. If there's a delay of more than 120 minutes, administer fibrinolytics to reduce MACE. And if the symptom onset is more than 12 to 24 hours, the time of benefit from fibrinolytic therapy is gone now, it's generally within the first 6 hours or so, then you should transfer to a PCI-capable hospital, private PCI, to reduce infarct size and MACE, and don't give fibrinolytic therapy at that time. What about STEMI treated with fibrinolytic therapy? You transfer them to PCI-capable center immediately after fibrinolytic therapy is done. Infusion is complete. It's a class 1, ship them to the nearest hospital. If they suspected or failed reperfusion, that means ongoing ischemic symptoms, persistent ST segment elevation less than 50% of resolution in the anterior leads or less than 7% inferior leads, or hemodynamic and electrical instability, you'd go for immediate rescue angiography to reduce the risk of death or recurrent MI. If the reperfusion is successful, recommend early angiography between 2 to 24 hours with intent to perform PCI to reduce rates of death or MI. So patients receive fibrinolytic therapy, arrives, you should be transferred to your hospital with just prior PCI. He's going to sit and wait through the night and get done the next day. That's why we gave this the timing interval. The time you can do it is as soon as 2 hours. What about invasive, non-STEMI ACS, okay? So there are two words that you should know. Immediate invasive strategy means that during the same hospitalization, patient is undergoing to go some form of revascularization, either PCR cabbage. And selective invasive means that the patient will undergo some kind of non-invasive testing before angiography is recommended. So anyway, so if patient is unstable, very high risk non-STEMI ACS patient with cardiogenic shock, signs and symptoms of heart failure include new and worsening mitral regurgitation, acute pulmonary edema, refractory angioedema, hemodynamic or electrical instability, immediate invasive strategy, less than 2 hours is class 1. If the patient has high risk non-STEMI ACS with a grace risk score greater than 140, rising troponin values, and ongoing dynamic ST segment changes, routine invasive, we should do an angiography. Timing of angiography should be sooner than better, but less than 24 hours. That's a class 2A. If the patient has intermediate risk non-STEMI ACS with grace risk score of 109 to 140, absence of ongoing ischemic symptoms, and downtrending troponins, again, angiography should be done in the same hospitalization, sooner than later, but generally before hospital discharge or less than 72 hours, class 2A. If the patient is low risk non-STEMI ACS with grace risk score less than 109, ischemic risk score less than 2, absence of ongoing ischemic symptoms, flat or low troponins, and no dynamic ST segment changes, you can still do routine invasive, but generally we say do it before the hospital discharge. However, this class of patients could go on non-invasive risk stratification, and if they're positive, then go to coronary angiography. What about catheterization lab recommendations? First of all, radial approach is strongly recommended again. This is preferred to femoral approach, reduce bleeding, vascular complication, mortality. That's class 1. New, for coronary stent implantation, left main or complex lesion, intracoronary imaging with intravascular imaging, IVUS or optical coherence tomography or OCT is recommended for procedural guidance to reduce ischemic events. It's a strong class 1 recommendation. This follows the chronic coronary disease guidelines from Europe, which suggests a class 1 for chronic coronary heart disease. But this is for ACS, also for class 1. So imaging is class 1 in all areas now, okay? And again, the other thing I want to tell you that among patients STEMI undergoing primary PCI, manual aspiration thrombectomy should not be performed routinely. There's no benefit. Well, now, the document also suggests that you should aim for complete revascularization. So STEMI with multivessel CAD, and then cardiogenic shock. Routine PCI of non-infarcted artery at the time of primary PCI should not be performed with a higher risk of death or renal failure. Only do the culprit vessel only. If patient is hemodynamically stable, after you've done your primary PCI, you can evaluate the patient with cabbage. After successful PCI with infarcted artery, elective cabbage for significantly stenosed non-infarcted arteries involving the LED or left main is reasonable. And if the patient has low complexity multivessel disease, first recommendation is after successful PCI with infarcted artery, PCI of non-infarcted artery is recommended. Reduced rates of death or MI is a class 1. But we are in the document you will see, we suggest very strongly that should be staged procedure in the same hospitalization. Now, if the patient has multivessel PCR of significantly stenosed non-infarcted arteries of low complexity at the time of prior PCI, the PCI of these vessels may be preferred over a staged approach, but we say it may be reasonable as a class 2B. We don't recommend it as a class 1, but we really feel it should be a staged procedure. What about non-STEMI and multivessel CAD? Again, cardiogenic shock. Do the culprit vessel only. Do not do routine PCI of non-infarcted artery because there are risk of complications. If you have patients who are hemodynamically stable, mode of revascularization such as cabbage or multivessel PCI should be evaluated based on disease complexity and patient comorbidities. This is class 1. Multivessel PCI, if you decide to do that, PCI of significantly stenosed non-infarcted arteries is recommended to reduce risk of death or MI and improve angina-related quality of life. That's the class 1. Again, both for STEMI, non-STEMI, with multivessel disease, we aim for complete revascularization. Now, this is the only segment we put physiology in. We didn't put it in the STEMI guidelines. For STEMI, for physiologic assessment, non-culprit stenosis in patients with non-STEMI ACS, you may consider physiologic evaluation with a pressure wire to guide revascularization. We didn't give any recommendation of cabbage. We just said cabbage may be preferred over multivessel PCI in patients with significant left main disease, complex left main disease, severe left ventricular dysfunction, complex or diffuse CAD, diabetes, and involvement of the LED, particularly proximal LED. What about patients with cardiac arrest? So patient has had a cardiac arrest and has return of spontaneous circulation. We want people to look at poor prognostic features, include unwitnessed arrest, no bystander CPR, non-shockable rhythm, CPR greater than 30 minutes, time to ROS greater than 30 minutes, pH less than 7.2, lactate greater than 7, age greater than 85, and stage renal disease or dialysis. Now, if the patient is awake and there's STEMI, and this should be like a routine STEMI treated as a primary PCR class 1. If the patient is comatose but has STEMI and does not have all these factors, or very few unfavorable features, means the patient had a brief period of rest, which was stated in 5 to 10 minutes, but still comatose, but he has less of these poor prognostic features, we can proceed with primary PCR class 1. However, patient comatose with a lot of unfavorable features, we say prior PCI may be reasonable after individualized assessment, assess the patient, then make a decision to class 2B. We could have given class 3 recommendation because there could be some patient, like a young person, with some of these poor prognostic features where you wanted to give the patient a chance to survive. Yes, you could think about it, okay? But again, we want to look at poor prognostic features. And patient who's comatose, who doesn't have STEMI on the ECG, it's a non-STEMI, do not do angiography. Immediate coronary angiography is not recommended. It's a class 3. It's a no-no to do angiography patients with comatose cardiac arrest, but has no ST elevation. What about shock?
Dr. Tanveer, Dr.
जी,
Tanveer,
बोले.
you are left with 5 minutes more.
हाँ, हो जाएगा 5 minutes. But the revascularization and options and shock in patients with shock, they see it with cardiac shock in hemodynamic instability. Emergency revascularization of cardiac vessel PCR cavities is indicated to improve survival, irrespective of the time of symptom onset. Patient shock, do it as soon as possible, but it should be done. Class 3 harm, only do culprit vessel, do not do the non-culprit vessel. And new for this year, mechanical circulatory support, class 2A, we selected patients STEMI and severe or refractory cardiac shock. Insertion of microaxial intravascular flow pump or Impella device is reasonable to reduce death. This is a class 2A based on the danger shock trial. And class 3, we said, again reiterated, patient MI cardiac shock, routine use of intra-aortic balloon pump, and now we put in VA ECMO because 3 trials, and recently the analysis of these trials published in Lancet showed that VA ECMO is not of benefit in acute MI cardiogenic shock. What about DAP? This is the final slide. The default strategy is DAP for 12 months with aspirin and potent P2Y 12 inhibitors such as ticagrelor, prasugrel as class 1. Now for bleeding reduction strategies, you can start with DAP, the aspirin, ticagrelor, stop aspirin 1 to 3 months post PCI, and stay on single therapy with ticagrelor for the rest of the year. If the patient has triple therapy with DAP and oral anticoagulants, such as if the patient is on warfarin or Eliquis, you can discontinue aspirin 1 to 4 weeks post PCI and stay on a single agent with the oral anticoagulant, generally clopidogrel, because the other 2 drugs will cause increased bleeding. What about DAPT? When a patient is aspirin with ticagrelor with prasugrel, you could continue this for 1 month and de-escalate to DAPT with aspirin and clopidogrel as a class 2B. And what about high bleeding risk patients post PCI? DAPT with aspirin and P2Y12 inhibitor. After 1 month, you can switch to either aspirin alone or a P2Y12 inhibitor alone, such as clopidogrel. And this is the end of my presentation. Thank you.
Thank you, Dr. Tanveer.
Thank you,
any question, we are left with almost 3 minutes. So if there is any question.
Tahir, I cannot see you, hear you clearly. They would need to increase the volume at the other end.
Thank you very much. May I ask one question, sir?
Yes.
What about timing of DAPT, especially in the aspirin when the patient is planned for primary PCI post ST elevation MI? And whether we are
I'm not hearing your question, I'm sorry.
Are you able to hear me?
No, I cannot hear you at all.
Okay.
What about timing of DAPT if the patient of ST elevation MI is planned for primary PCI? We are going to give aspirin at FMC. And what about P2Y12 timing? Are we going to give at FMC or are we going to give on table?
So for the P2Y12 inhibitor, we do not suggest go to the emergency room and get it right then. Generally, we'll do an angiography. And at the time we're going to proceed with PCI, we'll give the prior P2Y12 inhibitor at that time. Because nowadays, the door-to-balloon dynamics are so quick, the effect of the drug will not be there by the time you complete your primary PCI. So the anticoagulant in the lab is adequate enough to hold you to 3 or 4 hours to ticagrelor or prasugrel kick in.
Thank you.
I have a quick question, if I may ask.
Yes, it's fine.
So the 2021 US guidelines for multivessel disease and STEMI, the 2021 guidelines gave a class 1 for staged PCI of the non-culprits. But in the 25, they sort of removed the word staged and then kind of gave it a 2B kind of emphasizing to do it in one go. I was wondering what your comments on that, because it's a big undertaking to fix everything at 3 in the morning.
Correct. In the document, you'll see that we say we prefer staged in the same hospitalization, and of course the trials from the complete trial and all suggested up to 40 days. But generally, we say the patient in the hospital do it the next day or the day after for the other vessels. That's what, but there was some. That's what we gave a class 2B to doing in the same setting. We didn't quite want to encourage doing everything at the same time, but if they look at the document, really, we suggested we do it during the same hospitalization.
Okay, thank you, Dr. Tanveer. It's very nice to hear from you the latest guideline of the ACS. Now we move to our next session. That is the collaboration of SKY and Pakistan Society of Intervention Cardiology regarding the mannerism in the cath lab. I invite Sajid Hakam Saab to moderate the next session.
Okay, thank you. So this is the session with SCI, which is called SKY. So let me ask Dr. Bashiri, who is the co-moderator, and the chairperson, Abdul Hakim, if he is here to come on the stage. Bilal Mustafa and Dr. Mujibul Haq, Dr. Nadeem Kamar, Dr. Akhtar Bandesha, Dr. Nabil Akbar, Shahzad Tawab, and then Dr. Shahzeb and Dr. Bilal Moyuddin. We have a first talk with Dr. Babar Hassan, patient safety and error in the cath lab. Babar.
Pointer उधर पड़ा.
So I was trying to get the pointer, but anyhow, first of all, I want to thank the organizers, and especially Dr. Bashir, for giving me the opportunity, a pediatric cardiologist speaking in an interventional adult talk. तो हम बेचारे गरीब गुरबे यहाँ पे आ जाते हैं तो पर और वो भी patient safety पे बात करेंगे तो let's see. So what are the objectives that I'm going to cover? Type of errors in the cath lab, data from a low resource setting. So do we have data to show why patient safety is important? And then risk mitigation versus failure to rescue. These are two important terms to understand. Once the complication happens, and then the failure to rescue, what does the data show from low to middle income countries? Learning from a congenital cardiac catheterization project outcome, risk mitigation QI, and I'll show you some of that. And then the future of risk mitigation that involves AI now. So what are the different types of errors? I'm not going to go through this list. I think majority of the interventional cardiologists knows about this. But the crux of this is that these are all preventable errors. So if we were to plan properly and risk mitigate properly, these are preventable errors. So what does the data show in low to middle income countries? So this is a paper that we kind of wrote recently in which we compared two different registries. One is the US-based registry, which is C3PO, which is Congenital Cardiac Cath Project Outcome Registry, and the other one is what is known as the International Quality Improvement Collaborative, which is the registry from low to middle income countries. And what does that registry show? So what it shows is that when you look at the adverse events in low to middle income countries, and this is risk adjusted adverse events, the adverse events are actually lower in low to middle income countries compared to the US based registry. But the mortality is higher, and that is interesting because what you see is that the failure to rescue, once you have a complication, the ability to rescue from that complication is higher in low to middle income countries. So it's important to understand why risk mitigative processes and QI processes are important. So this is an interesting work that two of our colleagues were actually involved in from SIUT, in which this is a quality improvement collaborative initiative that is done
towards risk mitigation. And what it uses a quality improvement key driver diagram. And why am I showing this? This is, yes, it is from a congenital cardiac cath registry. It is applicable to congenital cardiac. But if you look at all of these different things, these are very much applicable to even adult intervention labs, especially if you are doing procedures that are not routine. For example, TAVI, for example, if you are doing end-to-end mitral valve repair in the cath lab, these are not routine procedures. So it's important to really go through some of these risk mitigative processes. And look at this procedural length. At times we do not understand the importance of procedural length, and this is an interesting paper that Mary and Boston groups shows that every 10-minute increase in the procedure in the congenital cardiac cath was actually increased the risk of high severity adverse events. So there is a lot of stress in this quality improvement kind of key driver to bring the procedural duration down. So how does it work? So it basically starts off with a week prior, date prior, morning off, pre-case, and a scheduled case pause. And through these different things, it goes down the whole list of what is important to risk mitigate in the cath lab. So equipment inventory, personnel review, patient risk, procedural type risk, case length. And then it starts from the week prior. You start reviewing all your cases week prior, and you start really making sure that every step of that patient journey during that procedure is taken care of. And then you kind of repeat some of that during the day prior, and you can see that, confirmation of ICU beds. You don't want to be in the cath lab with a patient that was high risk, that you knew that there is a high risk of having an adverse event, and then standing there waiting for an ICU bed to open up whilst the patient is kind of unstable in the cath lab. So, and then adjust procedural schedule based on anticipated procedure length. This is another interesting thing, that sometimes when we are scheduling, the scheduler is absolutely blinded to what the risk of the procedure is. And at times, just a simple thing like color coding your cases can help the scheduler even notify you that there is a high risk day that you may call it. So this is a risk calculator that we use, which is known as the C3PO risk calculator, and it uses the procedure type. It also uses some echo findings before you go into the case that will tell you what the possible hemodynamics are going to be in the cath lab. And then based on that, and using the big registry, it gives you what the median procedural duration is going to be, what is going to be your 100% of that median duration, what is the risk profile, and then that can help you really schedule your day properly. This is, for example, from the Boston Cath Lab, that they use different color codes to kind of make sure that their week is properly planned out. For example, a transcatheter pulmonic valve is given a red code because it is a high-risk procedure. And so we have adopted a similar kind of a thing in our setting, in which we have not only color code the cath cases, but we also color code our surgery cases because of our anesthesia availability. So you can actually plan out, for example, this is a day that you really need to have everybody on board, and not on that day, but a week before that. So it's important to have a proper timeout, and I'm just going to show a small quick video to just show you that the timeout means timeout. That when everybody is listening, they are paying attention, anesthesia is paying attention, people are not talking, they are not like moving around, and that proper timeout, there was a good audio on this, really goes through what is going to be the possible complications that can happen in the case, and then plan your day accordingly. This is the future of risk mitigation. So this is an interesting project that now we are becoming a part of. It's known as the GRACE project, in which the hemodynamics within the procedure will be actively input into an AI model to give you risk prediction and the case projection during the case. And through different lighting mechanism within your cath lab, it is going to notify you that your case is not going right and you have to change your strategy. So because one of the thought processes is that initially you will make your patient worse, and then they start getting better, and that trajectory of betterness can be predicted. So conclusion, prevention is the best strategy. One is never over-prepared. Meticulousness is not inefficiency. I want to say that again. If somebody is being meticulous, they are not inefficient. It is because they're going to prevent some kind of a adverse event. and then AI will further refine the risk mitigation. Thank you very much. So just to keep it really boring for you guys, Dr. Bashir has told me to give my second talk also. So मैं अपनी दूसरी talk भी दे देता हूँ. अच्छा यहाँ timing नहीं आ रही थी सामने, तो I didn't know it was in the back. Okay. Ready? Did I save my time on that one? Yeah, I did. Okay, perfect. So I can go a little bit slower on this one because this is a little of more of a complex topic that. Achha, so this is my next topic that I was given. So revolutionizing healthcare research, the transformative power of AI. So I'm not going to talk about all the other aspects of AI, but actually how can AI be helpful in our daily research that we are doing. So I don't have any disclosures, no financial associations, and I'm not a computer or a data scientist. I am just a clinician who's interested in AI, and I've been doing this for a little while. So in the next 10 minutes, I'm going to talk about a brief overview of AI and its use in research. Can AI be a planned activity or just a buzz? AI in cardiovascular sciences, and where do we stand in the low to middle income countries? And then some contextual work. And just when I was sitting and listening to the launching of the pregnancy registry, it gave me an idea that I need to put 2 of my slides in to show some of the AI work that we have been doing around that. So a brief overview of AI. The basic difference between normal statistical things and AI is that in statistics you give them an input data, you set the rules, and then based on that model it gives you an output. In machine learning, what basically the rules are learned. So you give them the input, you give them the output, and the machine learns those rules in the training set, and then in the testing set, what it does is that uses its rules to start giving you prediction. So it can, what statistics does is that it can bound the way you analyze your data. And AI can really unfold a lot of linear and collinear correlations. So these are all the different types of artificial intelligences. AI is the bigger term, machine learning is the lower one, but a little, because there's so much of DeepSeek, ChatGPT going on, this all came because of what we call now the Transformers AI, and Transformers AI has the ability of analyzing data all at once, multiple inputs at once, and then giving an analogy based on that. So, and this has really truly transformed the way we start using AI now. The other big term that one has to keep in mind is supervised and unsupervised learning. Supervised learning is when you give the AI tool a labeled data, and unsupervised learning is when you give them unlabeled data. And typically, unsupervised learning is done on large data set. Unstructured data set. Unstructured se murad kya hai? Imaging data set is unstructured data set. Structured data set is what you find in Excel sheets or SPSS are structured data set, yes or no's, 1 and 2's. So if you want to really unfold the power of AI by looking at different correlations, unlabeled data set, and really making the machine cluster those are the most powerful ways of doing that. But this is a better way, a hybrid approach in which you have supervised and unsupervised, because you can really unfold how the AI really got to the analysis or the conclusion that it is giving you. So what is the role of AI in research? It can help explore and analyze large and variable data sets, structured and unstructured data sets. It can look at linear and non-linear correlations and patterns and can combine all of that. It can help identify unrecognized patterns like phenomapping, topography, and then it can act like a co-pilot in statistical analysis of data set. And I'll show you a very interesting example of this, of somebody who used ChatGPT who didn't have a clue about what stats is and how ChatGPT taught that person to really analyze their data. So again, big data. So you have, we all know as clinicians, there's a lot of data that comes to us through our clinical notes, through our echo images and all of this, through our demographic lab values, imaging, and then really collating all of this data which has structured, a lot of unstructured data, collating all of that in different modalities to start then coming up with a lot of predictions, a lot of different drug delivery discoveries and stuff. So this is the power of kind of AI as we start seeing it happening. So can AI be a planned activity versus a buzzword? And what do I mean by that? So when one plans their AI, the bottom line is that make it patient-centric. If whatever you are doing, that AI is not helping the patient journey, and journey in your context, it is not adding any value to the patient journey, it is just a buzz. It's not really truly a research, it's not really truly adding any value. And that patient journey is all the way from the community, all the way to from the community, the transport system, the basic health system, again transport to a tertiary care setting, and then eventually when the patient gets better and goes back into the community. So this whole journey has to be kept in mind, the care continuum, as you start developing your AI tools and AI research, and then start really seeing where do you add value to the patient's journey. So AI in cardiovascular sciences, I'm going to just give you a couple of examples. So this is an interesting work by Partho's group, Parthos and Gupta, which basically looked at used clustered analysis, and you can see that better prediction than standard methods, even in non-severe concurrent and discongruent aortic stenosis. So by using data and AI and really complex way of looking at it, one can unfold a lot of stuff that you cannot unfold with using normal statistics. This is an interesting paper again that shows basically use of AI and phenotyping of the heart, how the heart looks, what's the shape of the heart, and then saying and clustering it. And then this is cluster 1 and 2 did better after TAVR implantation. Cluster 3 and 4 did worse than after a TAVI implantation. So where do we stand in low to middle income countries? Like any other thing, if you look at this is an interesting, on the x-axis, this is the whole century from 1990s all the way to 2020s, and on the y-axis you see all the different pediatric topics that are gone through. This is high-income country, middle-income countries, and low-income countries. And you can see there has been absolutely no data coming out of low to middle-income countries. And that's an opportunity for us, but also a bit of a scare, because all these algorithms are being trained on data that does not, and Dr. Bashir's Pak Sehat is going to actually show you that this is not applicable. These algorithms are not going to be applicable. This is another opportunity. Look at this. Despite all the work in AI, different publications, look at how much have made it to clinical practice. And this is from radiology, which was the very first to adopt AI. So some contextual work. This is not playing that well, but this was a study that we did on using pulse oximeter to predict at-risk neonate, and now we have gone into analyzing the pulse waves using what we call multi-kernel learning technique to really start deciphering different waveforms. This is, again, alluding to the pregnancy registry that has just been launched. This is the work that we did in using fetal Dopplers to predict which fetus is at risk after birth of death or being small for gestational age. And in fact, small for gestational age is one of the risk factors for adult coronary artery disease. So it's an interesting model that we have created. We have used this model also to start predicting which baby will have congenital heart disease. So these babies did not have their fetal echoes done, they just had Dopplers done that basically gave us the indication that this patient probably has some kind of a congenital heart disease. So the large language models, these are a couple of last slides that I'm going to show. So this is, for example, if it shows 1 second. Okay, so this is a data set that my nutritionist, who did not know much about statistics, put into the ChatGPT through proper prompting, through understanding her data well. She basically made ChatGPT really go through the whole statistics. It creates graphs for you. There's something wrong. So this is, yeah. So it creates graphs for you. It gives you a good analysis of your data. So if you are scared of statistics, you can use large language models to start really doing some of the research. So conclusion is catch up. AI is here to stay. It is rapidly improving. It gives newer dimension to one's understanding. Avoid the buzz. Make it contextual, meaningful, and patient-centric. And data is the key. Thank you very much.
Any questions from the panelists? Over.
Hello. Dr. Babar, I have a question. Working in a real world environment, I work in a very high volume center and we are under pressure of getting a minimum number of procedures done during the day. And because if given the dynamic and the high pressure environment in a high volume cath lab, where many decisions are interoperative, we are not planned for it, we are basically doing high risk procedures coming into the ER. How can we realistically embed a culture of procedure safety and structured case review without slowing our system down?
Yeah, thank you very much for that question. And I routinely get this. The data shows that failure to rescue is high in our countries. Once you have a complication, the possibility of reverting from it is very high. We had lesser adverse events than the developed world, but had higher mortality. I think it's a mindset. So if as an institution, as a cath lab, patient safety becomes as much of a prime as I'm going to use a drug-coated balloon versus post-dilate the stent or not, it will come. So it will come in a way in which you will then start using innovative ways of not making your lab inefficient, but at the same time safe. For example, what do I mean by that? Some of the AI tools, for example, that I said, you can use that to look at a pattern. It can give you patterns of the days in which your lab becomes a bit inefficient and unsafe. And you can use some of that pattern to really study and make your lab more safe and efficient. It all depends on how you're going to look at your data set. But in fact, in a high volume setting, there is actually interesting work that we have shown that people say that if there is high volume centers, they will have less complications. Yes, that is true if the health system is a learning health system. If you are a non-learning health system, and this has been shown, we are going to publish this work, the complications are higher in a higher volume center. So you have to be a learning health system. The learning health system only comes when you put patient safety as a priority.
Babar, how have you incorporated AI in your clinical practice right now? And as a society, with the Pediatric Cardiac Society, what steps are you taking to incorporate AI for the pediatric cardiologists in Pakistan?
So Sajid, that's an excellent question, and I have failed. Just like the radiology paper that I showed you, 4.4%. So a couple of things that I've done. One is from a clinical standpoint, we have a tool in our ICU known as ethiometry that we use to predict patient getting sicker in the ICU. So we have used that with an implementation framework to improve our patient care, because in the night it's a bedside nurse who is taking care of these complex post-op patients. So that's one of the clinical use. The second clinical use that I'm doing is AI around data entry. So there's difficulty in me capturing data so that I can use it into an actionable thing. So I've created if I may call it a product, which captures data smartly and it shows it in actionable items so that you can start taking actions on that. From a Pediatric Cardiac Society, I have failed. No, we have not been able to really take it. I've not been able to even take the patient safety. The IQIC, International Quality Improvement Collaborative, now has launched an IQIC Pakistan work in which all the congenital heart disease centers are going to start putting data on it. At surgical first and then cath. So hopefully through that we can start pushing some of the QI work and then with that the AI work.
So Dr. Babar, can you add a little more? Excuse me. Yeah. Dr. Babar, so you are trying to say that to mitigate the risk actually, to develop the models which are very smart models, you have to use AI. And that will help you in developing all those things. So the real problem is an attitude, or it's the resource actually which is having problem?
Dekhen ji, I'm very bold and that's what I'm notorious for, so it is an attitude. AI नहीं चाहिए होता patient safety quality को incorporate करने के लिए, mindset चाहिए होता है. और वो mindset उसी वक्त आता है when we start, at least in my field, when I start thinking it can be my child on the table. अब जब ये सोच आ जाती है, जैसे डॉक्टर अदीब रिजवी कहते हैं ना, कि don't sympathize, empathize with that person, really put it inside your soul and figure out what they do, and that's when you start creating places like SIUT and NICVD. So I think it's important to have that mindset. We can't say, okay, I'm a very busy lab, or I can't do this. No, you can absolutely do it if you put that as a priority, and then you will actually innovate, because आपकी जितनी busy lab अगर patient quality safety कर गई, कोई और नहीं किया होगा, and that's innovation.
अगर मैं आपको बताऊं, the same problem I'm facing with the registry, CAT PCR registry. Now we have like 140 plus centers, and we have to literally beg everyone for the data. And out of, we just recently did an audit, which I'm going to actually show you later. It's only, we audited 15%, and out of those 15%, only 5% were giving us the full data, rest were not. So unfortunately, we have to own it and take the responsibility. Until unless we don't do that, we just take it as a formality to basically get the health commission license or whatever you call it, but nobody does it. But the importance of data is like immense. Without our own data, as you showed, there's nothing coming from the low to middle income countries. So, and the numbers, initial numbers from Pak Sehat, I was just telling in the other room also, that the cholesterol and the obesity and the diabetes and hypertension is nothing close to the Western countries we see. It's just like triple the numbers over here. So we are basically practicing and doing everything based on their data. We don't know what is happening with our data. Until unless we have our own data, we will not be able to really make a policy or do anything.
Sir, एक और चीज़ बड़ी interesting skin in the game बता दूं कि these algorithms, so at the WHO and World Heart Federation level, the algorithms are now going to also define your health budget reimbursement. So अब आप imagine करें कि whites के ऊपर, Caucasians के ऊपर बना हुआ algorithm will determine your reimbursement in your population, which is completely different. So the skin in the game has to happen.
Lots of AI application in your non-invasive and image interpretation. Has it improved patient care?
So bilkul, excellent question by Dr. Sajid. He said that a lot of AI applications in the imaging world, has it improved patient care? No, because kya tha? It was all used as a buzz. It was a buzz to publish a paper. And then, so we showed this. We put a very fancy tool, FDA approved, in our cardiac ICU, not in this in my current institution, but in my previous one, and the mortality went up. So it was not being used. It was a predictive tool. And that what we realized, until you don't have an implementation framework, a standard operating procedure, a quality improvement lens on it, an AI will not do anything. And once you have that, it can really exponentially improve your outcomes. So until that implementation framework doesn't come, it ain't going to happen.
Sajid, hello, can I?
Yeah, sure. Babar, there's one more question.
Yeah.
You are popular.
Actually, I am going to be talking very uncomplicated without putting in AI in it. I have been in cath lab for almost 46 years, and what I have learned during this period is very simple things. If you manage that is knowing your patient before you bring them into the cath lab, whether there is a history of allergy to contrast in the previously, and they are adequately hydrated. And then you brief your staff as well about the procedure and what you expect. What are the complications that you expect? And during the procedure, if something goes wrong, always look winning. Never show yourself that there is something disaster around. Try to remain calm and winning. Never hesitate asking second opinion of your colleague if he's around. These are in cath lab, and after doing a successful procedure, whatever, I have come across many patients who stupidly or bravely say, "Oh no sir, I can walk to my room." And I said, "No, you will take the wheelchair." He said, "I feel nothing." So don't change your protocol for them. Insist what you have to do for the safety. These are the basic, simple things and which help in a big way.
नहीं सर, बिल्कुल सही है, पर उसके साथ साथ डेटा भी कलेक्ट कर लें, क्योंकि हम लोग एनेक्डोटल मेमोरी पे बहुत जाते हैं कि कुछ भी नहीं हुआ मेरे लैब में, जबकि पिछले हफ्ते ही डिजास्टर हुआ होगा. So I think it's important to have that.
Oh, I agree. That's true.
Okay, thank you. Next presenter is Dr. Wasif Qureshi. Wasif, can you? फिर किस करें? Honey, right? Easy. Achha. Okay. It's recorded or slide? It's recorded. Who's going to play? Okay, the next presentation, I think Wasif is not ready, so Hanif Ragi, case of stable angina, to cath or not to cath? That would be interesting.
Hello, from Cairo, Egypt. This is a hand. Hello, from Cairo, Egypt. This is Hani Ragi. I'm consultant cardiologist in Egypt National Heart Institute, and very honored today to be part of Pakistan Live Sky session. And I thank the organizers and Dr. Bashir Hani for inviting me. My presentation is about a case of stable angina, to cath or not to cath. As we know very well from major trials, some of them pretty old, like the Courage trial, that stable angina patients survive very well on good medical treatment without revascularization. And indeed, in the ischemia trial, this was proven on a much larger scale. But does that mean that of course, this is actually a very, very new slide, which was just put yesterday in TCT Asia Pacific, which shows that in the ischemia extent in 7 years, there is actually a slight cardiac survival benefit in the invasive arm. So this question came after the ischemia trial, to cath or not to cath? Of course, we have to know the anatomy because in the ischemia trial, every patient got a blinded CTA, CT angio, and the patients who had severe left main stenosis or severe three vessel disease were actually excluded. So without cathing, and coronary CT is a form of cathing, without imaging, we wouldn't be able to stratify those patients. And indeed, we know very well that in the guidelines, the latest guidelines tell us that the patients with stable ischemic heart disease and multivessel coronary artery disease with severe left ventricular dysfunction, bypass is recommended to improve survival, not just symptoms. And the same for left main stenosis patient. And some of the left main stenosis patients can be asymptomatic. So you have to cath or at least to CT. So this is the role of CT angio in stable ischemic heart disease. We can use it as an alternative to cardiac catheterization to define the anatomy, especially it is mentioned in the guidelines. And it might actually pose less chance of contrast-induced nephropathy. It also might protect some patients against overzealous cardiologists who might go for ad hoc PCI when it's not really indicated. It gives more chance for harm. And indeed, there has been very good papers on the new role of cardiac imaging following the ischemia trial, in which CT angiography was presented as a favorite tool. Of course, in many places, probably in Pakistan and in Egypt, there are more cath labs than good CT angio place, and in which case I think you can easily substitute and do an invasive coronary angiography instead of a CT. So who are the patients that you should not really cath or even CT? Some examples, not inclusive, patients who are not eligible for revascularization. So stable patients with a terminal malignancy, like terminal bronchogenic carcinoma. Stable patients who might be harmed by angiography as stage 3 or 4 CKD. Patients who prefer not to have an angiography and who are clinically stable and asymptomatic. Patients who refuse to give an informed consent. Or those who known mild ischemia or non-invasive testing, or who have had a previous CTA or angio a couple of years ago, and some very elderly patients. This was an example on Twitter just a few days ago, on the 23rd of April, where Dr. Savage asked about the cardiac cath for a liver transplant evaluation in a patient with 30,000 platelets on INR 1.25. And he gave a lot of examples on different answers. He polled people. But my reply to this was, why not CT angio the patient? Unless they have prohibitive calcium, it's so much safer. So again, this is a patient that you shouldn't cath. One of the ways you can find out if you should cath patients or not is by risk stratifying them. Use the SCAI provided tool to risk stratify your patients. So if your patients have low risk on findings on non-invasive testing, if your patient is doing very well on minimal amount of drugs, you have here the green, which is the patients that you should PCI. The yellow is the patients who are undetermined, and the red are the patients who you shouldn't touch. So, for instance, if you have low risk findings on non-invasive testing, you put your patient here somewhere, and you might need to cath them or not to cath them. You can just CT them. So you give the patients a score. Score your patients and learn how to do it. Germany is famous for cathing everybody. I mean, the Germans don't really go by the guidelines, even in TAVI. They perform more TAVI than other people, and they have the ability to afford that. But they have this health economic consequence of optimal versus guideline adherence in coronary angio in patients with suspected obstructive stable coronary artery disease. They did a microsimulation model, and amazingly, it showed that if you actually assess the patients properly, assume a complete guideline adherent use of coronary angiographies, you actually save money and save lives compared to the real world use of coronary angiography in Germany, which is based on their observational studies in which most patients who suspect coronary artery disease just get a coronary angio. And that turned out to be costing both in complications and in money. We are also approaching an era of bifronged era. One is conservative, where you can even have a bypass, which is guided by CT angio in a low-risk population without even having to go to the cath lab at all. And the other one in which you will cath patients who are very stable, looking for vulnerable plaques, as per the PREVENT trial, which showed that in very select patients, PCI might actually improve the events. And so we have both sides of the coin. Primary composite outcome of target vessel failure was much better in the preventive arm, where patients with a vulnerable plaque underwent PCI. So it's not the end of the story for taking the patients to the cath lab. And some patients who are stable might be taken to the cath lab, but not for just diagnostic coronary angiography, but for imaging using tools which are going to show us vulnerable plaques. So it is the landscape is really changing. This is a very interesting tweet which was just put a few days ago by Dr. Singh, Mandeep Mayo from the Mayo Clinic on not cathing patients, but who are the patients whom you shouldn't PCI. And, he put 15 indications, including patients with spasms, tiny arteries, and indeed here was stable ischemic heart disease patients, mild ischemia and less than 2 antianginals, patients with just a plaque erosion, patients with spontaneous coronary artery dissections. But of course, all of these actually need to be cathed first. And then you have to, again, prevent the overzealous colleagues from going in and hurting some of those patients like SCAD patients. My conclusion is that the majority of stable ischemic heart disease patients should have their anatomy defined by either an invasive angio or a CT angio. And we should use the appropriateness use criteria then on case-per-case basis. There are a few scenarios in which this may not be needed or may actually be dangerous or may not be necessary. And that cath has been wrongly used to perform ad hoc PCI worldwide in many subsets of patients, including very stable and asymptomatic patients. I stand guilty of putting stents in very severe lesions in asymptomatic patients in the era before the courage and the ischemia trial, but we don't do this anymore. It's not recommended by the guidelines. theoretically, we need to protect such patients from eager operators or those who might be in good faith thinking that this is useful for the patients when it's not. And this may be achieved by doing a CT angio or not having the man with the hammer inside the cath lab thinking that everything is a nail that he needs to hammer, and by heart teams. And new published data have shown these policies to reduce both MACE and both costs for not performing invasive angiography in low-risk patients. Thank you very much, and the story is not over. We're waiting for more guidelines, and I'm very happy to take any questions. Thank you, and thank you, Pakistan Live.
Any questions from the panelists or the audience regarding cath or not?
Thank you for an excellent presentation. I have just one question, that nowadays the renal transplants is quite high in our country. A lot of patients we receive, from the nephrologist that they just ask for the coronary angiography, although most of them have the hypertensive, diabetic and hyperlipidemic, but they have no ECG changes like that, and most of them are just sent for the coronary angiography. So what will be your say on this?
Well, sorry, I didn't get your question, but...
Okay, so most of the patients we receive from the nephrologist before renal transplant to get the patient for coronary angiography.
Oh,
yeah.
Before transplant?
Yeah, before transplant.
Right.
So, most of the patients have asymptomatic, but they have risk factor of diabetes, hypertension, hyperlipidemic. So what will be your say on this?
Well, presentation किसी और की थी, जवाब मैं दे. So, renal transplant, the guidelines remain the same. Or for any transplant, for the coronary angiography or to rule out coronary disease. It's the same. There's no need to do a pre-renal transplant or pre-liver transplant angio. The guidelines for the transplant surgery is the same for any surgery. If the patient is symptomatic or if they have signs of ischemia, you do the angiography. But the only screening, if you define that they have to have functional testing like a thallium scan, if that's negative, they can go through transplant. That's the current recommendation. There was no extra angio needed. However, what I have seen since CT angio, if this person was online, I would have asked the questions. The CT angio hasn't replaced angiography. Yeah. In fact, since the CT angio has been introduced in Pakistan, probably the procedure numbers of coronary angiographies have gone higher than before. Because we are detecting coronary disease, people are doing more coronary disease. So what he wanted to say is the totally contradictory of what's happening or what we are doing in Pakistan. Anyway, I won't get into that. Let's move on to we have 5 minutes to get the feedback on the live case.
I just want to ask one more question, if you please allow me. Here.
Oh, okay.
Just related to this talk. It's an excellent talk. My name is Dr. Shoaib Sarwar Hashmi. I want to ask, you just elaborated for the stable angina, we need to go for imaging, maybe the CT or invasive angiogram. So what do you say about the guidelines? What they suggest? Should we go immediately for the stabilization or optimization of the medical therapy first, or should opt directly, even with the class 1, Canadian class 1 classification for the angina, should go directly towards the imaging modality, or should go for the stability first, with the class 1 even?
Well, I don't want to get into that debate, but I think for the stable angina, the answer should be, let's stick to the guidelines. And the majority of trials that have shown, like the Courage and the ischemia trial and all of those things, if your patient falls into that category specifically, I think you can't apply ischemia or Courage to everyone. You can apply to the patients who were there in the trial, who were included, not excluded. Then you can apply all that medical therapy versus revascularization. But that's a different debate, and I won't go into it.
I think the data so far shows that only time you improve the patient's mortality or survival or prognosis is when there is a left main disease. And the reason for CCTA, one of the new recommendations is because you want to rule out left main disease. If patient does not have a left main disease, LAD, circumflex or right coronary artery disease, if you are able to control with medications, it's not going to change prognosis. It's only going to change the patient's quality of life and the symptoms. So now, if you look at the appropriate use criteria, if you send anyone stable angina for cath without optimum medical management, and optimum medical management is at least 3 anti-anginals, so that will be labeled as inappropriate. So only time it will be appropriate if you have patient on 3 anti-anginals and still he is having symptoms impacting his quality of life, then it will be considered as appropriate, or if he has a left main disease on CCTA.
Can I have a comment actually?
Yeah,
What we have learned from this talk is that the speaker was emphasizing overzealous operators not to perform a lot of coronary angiographs without any clinical evidence. But so far, we adhere to the guidelines, American Heart Association or European guidelines for the angiography procedures and all. What was a new thing for me was that a coronary CT angiography, which needs around 100 ml of contrast, and it's given by the IV intravenous line, is less hazardous than a 15 ml of intra-arterial contrast which we give for the coronary angiogram. We can perform an angiogram with 15-20 ml, not 100 ml like that. So I think we should follow the guideline still, but we should not be performing normal coronary angiographies without an evidence of that, as you have mentioned, that either with non-invasive testing or like.
So if renal functions are normal, then it doesn't really matter if you use 100 chronic kidney disease patients, and if your patient is on triple anti-anginal still having symptoms and you're concerned, you can go ahead and go directly straight to the angiography.
Or you can do non-functional.
Bashir Saab, can I have a word on
Sure, please.
Stable angina? Pehli baat to, when somebody has angina on effort, I mean, it's an experience which he goes through. We have different criteria, what's appropriate, what's not. But if you look at just the COURAGE trial, 30%, it was an intention to treat trial. So 30% in the first year went on to have a PCI. Now, this happened in an environment where an ambulance will get you to a hospital within half an hour or 20 minutes. Here, somebody gets an acute syndrome, he's going to travel from maybe 4 hours, 8 hours, 10 hours. The roads are blocked or whatever, 10 people will come with him, there's no retrieval system. So my feeling is that guidelines need to be made on local scenarios and the local fund providers. And even if you get to the right hospital, the treatment may not be uniform. Busy lag raha hai. Yeah, Nadeem Sahab, aap meri baat suno. The treatment will not be uniform throughout the week also. It will be different based on who's on call, what time of day. So I think ye cheez dekh ke you got to be a little more adaptive to the local environment before you just start applying it uniformly.
No, that's absolutely right, and obviously that's why we need the data to have studies and data, and guidelines are guidelines. You always have to use your own judgment also with the patients. But one thing is important to know, that fixing a coronary artery with angioplasty or even for that matter bypass surgery, it's not going to reduce the risk of acute coronary syndrome. Acute coronary syndrome can still occur in these patients whom you have performed the angioplasty. So even with a normal coronary artery, we know plaque rupture can happen and can have acute coronary syndrome.
There are a lot of people who would refuse treatment, who don't want treatment, who live far away. They have other issues also. They've got comorbids. So if they have stable angina, and the way I see it, and they've got this disease process, you say, look, despite this, you will stay well on treatment, even if you can't have an angioplasty or stenting. Okay. So
Yes, I think there's a cost of medical treatment also, and all of those morbidities and not able to work. So you're absolutely right. So I think that has to be individualized in the end. So
can we go to the AFIC, please, to just get the results of the case quickly? Okay, Bilal, we are with you again. If you could just give us your final quick run through in 5 minutes. We can't hear you yet.
We'll just quickly go through what we've done. We're making progress. Hopefully, inshallah, we'll be finished soon. But we don't have a final picture to give you because this is a very, very tough CTO. So we left you here. We wired a very crazy epicardial, very tortuous. So got into the distal right. The problem is there are two CTOs. The distal cap is like a rock. So here I tried to do HDR with the minimum amount of contrast, and you can see how the contrast is just basically going in extra plaque space. The cap is just very resistant and tough. So, and I couldn't advance any wires or anything in there. When I tried to use penetrative wires, I have kept some wires for you just to show you how tough the cap is and how tortuous the epicardial is. Every time a wire goes in and comes out, I don't know whether you can see on the white here. Can you see? Zoom in. They basically comes out like a safari wire in TAVI. Yeah. It's completely super coiled like a pigtail. So it just shows you the challenges we're working with.
Yeah.
So in this situation, we wanted to resolve the proximal cap again go forward. So we went the guide and the guide catheter engagement is also very challenging for the stump right coronary. So let's go forward, please. We're trying to engage the guide, very, very challenging. Next, you can see a small subintimal aortic hematoma. It's of little clinical worry to me. We kind of tried a JR4, that didn't work. We basically did some knuckling, knuckling with it. So we got a Turnpike LP150 and very, very aggressive knuckles and bends. You can see George's course. We're certainly in the architecture of the vessel. So now we are in a good position to kind of make both antegrade and retrograde spaces meet. So then we ballooned along the tract.
So is there a dissection at the ostium extending into the cusp? Is there a dissection at the ostium extending into the cusp?
There is a guide catheter hematoma in the aortic in sinus.
Okay.
Yeah, I've worked with those all the time. As long as you don't inject into them, that was due to a difficult guide re-engagement, and unfortunately, just caused dissection.
Okay.
So we've just got a guide extension down there. Keep going, keep going, keep going, keep going. So now you can see we've interwoved a guide liner, and and then now we've got a very small distance to link the spaces. It's like literally 8 millimeters. But that's easier said than done, because this distal cap is so tough that no wires are penetrating it. The Carlinos don't work. And I'm not even able to instrument a CP12, a Gaia 3, a Gaia 3 Next, Gaia 2, you name it. The only wire I haven't tried, which I have, is an Astato 20. I bought some with me. So I could certainly try that, but my concern is that it's such a stiff wire, it's just, I'm not going to get the instrumentation in the distal cap. So I'm trying to create a connection between the spaces by going up in balloon sizes. I've used a 2.5 balloon. I'm now using a 3.0 balloon. And I'm just trying to connect the spaces. And all I need is the retrograde wire, move 8 millimeters forward into the guide extension, and then I'll externalize, hopefully, and then we can complete the CTO procedure. So that's where we are now. Any questions, any comments from the panel?
No, I think we have to move on to the session. So why don't you continue, and maybe later on we can try coming back and see where you have reached and what have you done.
Sure.
Thank you.
Sounds great. Thank you.
Thank you so much.
Thank you.
Okay, so we're going to move on to the next talk. I think Dr. Wasif Qureshi's talk is ready. He's a good friend and very skilled interventional and structural cardiologist from US. So he's going to talk about initiating a transcatheter program.
Thank you, Bashir. Assalamu alaikum and good afternoon, everyone. So, as structural heart procedures grow, we need to make sure that we have our programs that are set, and as we proceed with new programs coming on, we want to make sure we have the right teams that are together to make sure that these programs become successful. So, objectives of my talk today are the essential requirements for our transcatheter valve program, and I'm going to use TAVR as an example because that's something that everyone here is really accustomed to being part of. Collaborative decision-making, role of the structural heart coordinator and how important that is, imaging and different modalities of imaging that we need to make these programs successful, requirements of physicians, hospitals, these are extremely important as well, and in the end, we'll just discuss the conclusions. So as TAVR was approved in the United States, this was in November 2011, all the societies got together and sent out recommendations, and this is very verbose, and this basically told us all what we need before we start moving on with a good and a successful TAVR program. And as you can tell, that there's a lot of requirements that are there that we need to be aware of. So one is you have to have structural interventionalists or interventional cardiologists who are interested in structural programs. You have to have a good collaborative decision-making amongst yourselves, your surgeons, and your other members of the team, which include EP, include your imagers. And the institutions have to be vested in these procedures as well. So here is a list of things that you really need in your programs. Physicians, like I said, IC, EP, cardiovascular surgeons, imagers who are dedicated to the success of the program, not people who just want to do it as a side job. Hospitals dedicated to the success of the program, they need to make sure that they invest in people as well as invest in the technologies that are coming in, because these are expensive technologies and not everything is always reimbursed. The structural heart valve clinic, where you can see these patients so that they don't have to keep traveling. As Dr. Aziz was just saying, that patients are traveling from 4 hours away with chest pain. So when they're coming in, you want to make sure they get all the information is gathered and they also get the information from you. The structural heart coordinators, now this is a very, very, very important person of your program, and I'll talk about this in a second. Dedicated time and team for procedures. So a lot of times, people are just doing these procedures in cath labs and saying, okay, we'll do one here, and the other. You want to make sure you have dedicated days, you have a dedicated time available in the cath lab for this, and you don't have other procedures scheduled that are going to bump you off. Again, when you have time, you want to make sure you have imaging modalities in your cath lab that are appropriate. So you want to have your imaging in the cath lab, which has been used in structural heart programs as well, and big IIs who can image these patients. Trained staff, of course, if your staff doesn't know what they're doing, they won't be able to prep things for you. You have to have cardiac anesthesiologists who will help you with these procedures. Of course, as we said, if you know your patient well, when you start the procedure, you will probably end the procedure well. So pre-procedure evaluation in a lot of these patients is the key to success, because we can now do a TAVR valve implant in less than 30 minutes, but that doesn't mean that it took us less time to plan this. The planning and the whole implementation is the key to success. Of course, post-procedure wise, where is this patient going to go? Are they going to go to the ICU? Are they going to go step down or anywhere else? And you have to train those people in those units as well when they receive these patients coming out from these procedures. And again, after you've done all this, you have to be able to do research. Like we talked about, if you're not going to do research and not going to produce your own data, you're not going to go anywhere. And the ability to add new technologies, because this is a fast-growing space, you want to make sure that you have enough things to add more technologies. Participate in NCDR. For us in the US, we have to participate in these NCDR registries, because if you don't, then you cannot be part of it. And let's just, as Dr. Bashir Hanif was just saying, that you have 150 or what the number of centers, maybe more than that, and only a few of them are participating in the registries, which is something which is sad to know, because then how are you going to improve yourself and your own quality of work that you're doing? And then, of course, continuing medical education in these different procedures is most important as well. Again, just another diagrammatic way of saying how we make these decisions. Patients with severe aortic stenosis, like I said, I'm going to use TAVR as an example for it, or TAVI. So they're referred to us, they come to the valve clinic, they undergo a certain amount of testing, be it CT scans, echoes, or you review whatever's been done. If they need a cardiac cath, like we talked about the other day, we do not cath everyone who needs to undergo a TAVR procedure anymore. We look at the CT scan. If there are only certain things on it, only then will we cath them. I've done TAVR on patients with severe left main disease. They're 90 years old, and they do perfectly fine. We can get these procedures done. We are talking about, yesterday we were talking about Impella. We were doing a case, an 89-year-old person, putting a 14 French sheath. Guys, we put 14 French sheaths in 89, 90-year-old patients all the time for TAVR procedures. We're doing 14, 16, so I don't understand what the big deal is about putting a 14 French sheath for an Impella. We do this all the time. As long as you've studied the groin properly and you've got good closure devices in, you can do this very safely. And then again, after we have got all the data, we sit together with our surgeons, with everyone together, and we decide when we're going to do it, how we're going to do it, which valve we're going to use, and all the nuances that can come. And also you prepare for all the complications that can occur in these procedures. And then the patient gets scheduled for a procedure. So this is, if you're initiating a program, there are certain guidelines. Previously, we used to have 2 surgeons used to sign off every TAVI or TAVR patient, but now the guidelines have changed and only 1 surgeon is required to sign off and saying that this patient will benefit from TAVR for Medicare, for us, over there, for insurance companies to pay for these procedures. And of course, these are independent evaluations, so it's not that the surgeon and the interventional cardiologist in the room together. They're done independently. Sorry, this thing is, okay. So when I was talking about the TAVR coordinator, this is important because when we started our program, so I did my first TAVR valve implant in 2012 when TAVR became commercially available. We had 1 structural heart coordinator, who we called them, but now we have 3 structural heart coordinators in my program, and we've got 2 other people who work with them. We are doing TAVR, we are doing a mitral clip, and we're doing both devices. We're doing a bunch of left atrial appendage closure devices with Amulet as well as with Watchman, and now we are on the brink of starting our tricuspid valve program as well shortly. So the TAVR program coordinator keeps us all in line, as we call them. They get all the patients. At any given point in time, the TAVR coordinator is looking at probably 60 or 80 patients for TAVR. They're looking at about 100 patients for left atrial appendage. They're looking at about 30, 40 patients for mitral, and then now tricuspid coming in. So, and then we're looking at ASDs, PFOs, leaks, other things that are happening. So these people will maintain a list, and like as Babar Hassan was saying, that they're color coordinated. We color coordinate our procedures as well. So we're going to say TAVR is going to be this color, mitral clip is this, tricuspid is this. So we make sure that when we are reviewing them or when they're doing it, they're color coordinating these patients so we can make sure that those patients are put under those color codes. Now, a lot of times these patients may have dual valve disease. They can have aortic stenosis and mitral. So we'll treat the easier one first, aortic, and then we'll go to mitral afterwards. So you can see that the TAVR coordinator has to do a whole lot of work in the background to make these procedures successful for us. And of course, and then, turning in this data. So we have people who will review our charts and then turn in the data for the NCDR as well. Again, imaging, pre-procedure, inter-procedure imaging, what are you going to use? TE, ICE, transthoracic echo, DSA if you have any complications, and then post-procedure, how we evaluate these patients. Complications, we're going to have heart block, perforations, pericardicentesis, LA perforations, do you have CVOR available, impellas, cover stents, vascular surgery, snares. So we have to make sure that, and with TAVR procedures, if you have strokes or large vessel occlusions, do you have neurointerventionists who are going to go help and these patients as well. And now credentialing. So this is credentialing for a hospital who wants to have experience for TAVR. You have to do 50 TAVRs a year, 20 in the year prior, and 300 PCIs. And if it's a new hospital that's coming on, then their requirements are different. So in conclusion, like I said, these procedures are getting more and more common in most places. We need to make sure we have good teams that are available for these procedures, and the staff and everyone is trained appropriately for them. Thank you. If anyone has any questions, I'm willing to answer.
Questions from the panelists, audience? Bashir. Thank you, boss. Okay, next is a case presentation. A PCI case goes wrong despite doing everything right. Family counseling, documentation, legal and ethical implications. Dr. Umair Abrar.
Can I have the slide change?
Assalamu alaikum, good afternoon everyone. I hope you all are having a good time. I'm Dr. Umair Abrar from OMI Hospital. So a PCI case go wrong without, despite doing everything right, and in which we will focus on the family counseling, documentation, legal and ethical issues. So my patient was a 53-year-old gentleman. He was hypertensive and a smoker. He had an inferior wall MI 2 months back, and PCI to circumflex to OM was done, and patient had a totally occluded RCA and severely diseased LAD at that time. With the EF of 55%, we admitted the patient for the PCI of RCA and LAD. This was the first shot of RCA that shows total to subtotal RCA, and we crossed with the Whisper MS wire. We put a stent pre-dilated, we stented with 3023 stent and upsized with the 3515 NC balloon, and this was the final result. So you can see here in this shot, the stent of the circumflex is quite patent with the severe disease in the LAD, which start from mid-LAD to, and you can appreciate here there is a mid to distal LAD junction, there is a phasic flow also. So this was LED in different shots. So we started with the pre-dilation using 215 SC balloon. We pre-dilate the mid-LED, and after the shot we found that the flow was down in mid to distal junction. So we took the same balloon down there and we inflated at that point, and you can clearly appreciate that there is a tight stenosis at the mid junction of the balloon, and at high pressure that balloon constriction disappear. What actually we noticed, there is a perforation at the mid to distal LAD junction. So we balloon tamponade there with the 215 same balloon, and meanwhile we took the shots and we found the perforation not sealed. So we took a graft master, tried to get there, but unfortunately we failed. Graft master failed to reach there. In this meantime, our system got disengaged, and we need to again engage the guider, and we distally park the wire. So at that point of time, we decided to stent the whole LAD from mid to distal, and then we tried to take the graft master distal there. So we took a stent at mid to distal junction, which was 2.2523, and in the mid with the Onyx 2.7538. And again, we use another stent. So you can clearly see that the perforation is in the RV. So we put another stent in the mid LED. So after the placement of a stent, and we post dilate with the NC balloon 3.25 and 30. At that point of time, we try to locate the perforation site with the balloon tamponade. And we took a graft master of 3019, and successfully we take the graft master down there, and we inflated it at around 10 to 12 nominal pressure. So after the placement of graft master, you can clearly appreciate the perforation didn't seal. We try to locate the perforation site, and we unfortunately use NC balloon that was 3015, and we post dilated it. After the post dilation, the perforation didn't seal. So do we consider another covered stent? At that point of time, patient was quite stable hemodynamically, and we decided not to use another covered stent. So this was the LV gram, which was pretty normal. So post-procedure, patient remained stable, no hemodynamic instability noted, and echogram shows normal LV with RV function, and patient was discharged after 24 hours. This was a case which was published in Scientific Direct, in which they had a coronary artery perforation into the RV at the time of dealing with the STEMI. So, and they covered the perforation.
That's fine. We can leave it here. Mainly the discussion point is the purpose was different. My only concern is, to me, it doesn't really look like perforation. To me, it is like, you see, if you go back, multiple septals are basically kind of a fistula going into the LV or RV. Because perforation, you can't see any particular one place where you are seeing that. And despite all, if you go back onto the angio, we have played these ones.
Okay.
Even before the stent, you can see that it's really a fistula from multiple septals going into that. You don't see anything going from the artery as such. Yep.
This is a perforation, but the leakage is in the cavity. It's a closed circuit. Yeah, वो सारा फुवारा
Actually, it's a perforation and it was extending down when we.
Yeah. नहीं देखिए जब
Just show us the picture, please. Go back.
Perforation तो हुई है, but it's leaking into a cavity.
Go back. No, it's how can it be like coming from 10 places? Go back.
Okay. This was a.
नहीं ये जो इनिशियल था एक मिनट ओरिजिनल दिखाओ एक मिनट भाई ओरिजिनल जाओ हाँ यहाँ तस्वीर लो नहीं फर्स्ट इससे पहले look at the original thing there are septals.
Go to the next one.
नहीं ये तो परफोरेशन के बाद है पीछे जाओ ना go back. No so basically what happened was that we opened up a perforation distally, all right. And then when this whole LED is intramyocardial and this whole LED ये cases report हुआ है ये LED जो थी ये अंदर थी तो what we did was we just kept on rupturing the LED with the stent.
Yeah, but if this was a grade 4 perforation as you are saying, this patient should have collapsed on the table.
It was going into the cavity.
But as you said in the end, he was hemodynamically stable.
Yeah.
So that's very contradictory of this perforation.
But ये देखें ना
इसका पहला shot देखा है जब अपने flow when you stented and ballooned your flow got better so you see the septal the septals filling the LV cavity. That's not the perforation. Yeah. Now इसके आगे because पहले तो it was 99% occluded.
अब ये देखो
Now you see start.
ये perforation शुरू हुई है ना.
So this is a chamber perforation basically.
ये basically पीछे जाओ एक नंबर पीछे जाओ अच्छा पीछे जाओ देखो ऊपर तो क्या बलूनिंग ठीक है ये बलून नहीं खुला चलो जाओ. Now suddenly this opens up and you rupture that.
This was in the myocardial bridge segment.
All right, next. Now look at that. Now this is a closed cavity going into the RV. Rupture हो गई ना उसकी नीचे वाली end उड़ गई.
Look, if the septals perforate, they perforate into the septum.
नहीं. This is a cavity. No, this is not septal. These are not septals. That is the trabecula in the right ventricle.
That's fine. The purpose of this case presentation was basically now what are you going to tell the family? Basically, you have to put in so many stents, and what are you going to document and how? Because obviously the cost limitations become a factor. If you put one covered stent, the cost is significantly high.
Yes, we did the echo and there was no temporal infusion factor.
So you are seeing is the right ventricle and
yes, exactly. This was in the right ventricle. It was a chamber perforation basically.
So if anyone want to say from the panelists, like how would they basically explain?
Yes, sir, this was an interesting case.
And like cost in a private hospital, how is that cost going to be covered because patient may not be willing to pay for it?
Okay, but this is typical case of rupture LED as Dr. Nazim Rizvi Saab mentioned, because after stenting the blood to the RV cavity just keep on increasing. Yeah. So ideal way, I think so after the stenting, especially the graft master, it should not be just deployed and post dilated. Ideally, it should be under deployed. And that time you may not cause the most perforation.
Shahzeeb, I'm sorry, we are not discussing the technical aspects right now. We are only, the purpose of this case discussion was how to deal with the family and the consequences of that. So please forget about what was technically done. So how will you, when you go out after finishing this case, you go to the family, what are you going to tell them? And if patient's family says, I cannot pay, this is what I had, and फिर आप hospital को क्या जवाब देंगे या document क्या करेंगे या legal implications की क्या है? Technical चीजों को आप छोड़ दें please.
I think such bole. Tell them the truth.
Yeah, you have
Sometimes
to tell the truth. Yeah, you have told the truth, but ideally, if especially any private setup, the cost should be bear on the hospital because this is some sort of complication. And every hospital should have the margin, especially when doing these type of cases. There should be some mechanism that it should not be charged to the hospital because certain complication may be just needed 20 lakh rupees.
But how many hospitals, unless you know the CEO or the owner, will be willing to pay the cost of like 200, like 2 lakh उसकी covered stand की multiple other stands डले हैं और भी बहुत तो कम से कम it's going to be 6 to 8 lakhs extra money. So how many hospitals will be willing to pay for that?
Whenever you are doing some job in a hospital, especially we are just doing in the Peshawar setup, we have some clear-cut understanding.
You are in Peshawar Institute of Cardiology. There is no problem with the money.
No, there is also
Bashir साहब ये situation हर जगह होती है कभी-कभी where you have to go beyond their means. And trust me, industry helps a lot. And we request them to reduce charges. Or even they sometimes forgo it completely. So I thank them for that. They saved the situation.
So in terms of
every system has its own sort of backups. ना कई बार तो operator को खुद देते हैं. Like अगर किसी civil hospital में कई हैं वो अगर make a complication and उसको IT से जाना पड़ जाए तो वो operator से कटते हैं. तो वो तो हर ने अपने system बना होता है which is varies from one to the other. Sometimes industry backs up. कई बार आप जेब से देते हैं, कई बार reserve रखते हैं. But the point is कि आप मरीज को कहेंगे माशाल्लाह शरियान खुल गई
पेशेंट बच गया शरियान खुल गई
आसपास भी काफी ब्लड खुला जा रहा है ठीक है ना हाँ तो और पेशेंट ठीक है तो अल्लाह से दुआ करते हैं अल्लाह खैर रखे तो
सर लीगली तो आप कवर्ड होंगे ना इफ यू हैव टेकन अ गुड कंसेंट बिफोर द प्रोसीजर इट्स अ स्टेमी केस आप हाई रिस्क ऑलरेडी जा रहे हैं यू नो इट्स ऑलरेडी अ सीटीओ टाइप ऑफ थिंग
हाउ मेनी पीपल रियली रीड द कंसेंट आई हैव मल्टीपल टाइम्स इश्यूज लाइक व्हेन वी से ओके यू साइन द कंसेंट व्हाट कंसेंट दे डोंट एंड आई नो लीगली यू कैन से दैट बट आजकल हेल्थ केयर कमीशंस भी बहुत एक्टिव हैं दे एंड अप गोइंग देयर एंड देन यू हैव टू गो थ्रू द होल
एग्जैक्टली सो लीगली तो आप अपने पेपर वर्क से कवर्ड अप होंगे और morally या financially तो it's the hospital backing that can cover you with the because it's not a malpractice it's a complication of the
if you allow me one thing we were in Turkey में जो था ना Central City वहाँ पे सारे बैठ के ना खाने पे बात करते and the some US guys said कि यार primary में तो हम इतने relaxed होते हैं हमारा resident भी करता है and their deaths also तो उस वक्त आप high risk position में होते हैं patient expects such an outcome लेकिन जो इस क्लास 2 इंजाइना को जब उसको लेके आते हैं कॉम्प्लिकेशन होती है दैट्स अ डिफरेंट बॉल गेम
most of the time things go okay it's those rare situations when the families are really very hyper I remember one of the families in our hospital actually broke our glasses of the hospital उसे में आके उन्होंने ये तोड़ दी
उसमें फिर आपकी स्किल्स और आपकी सिक्योरिटी काम आती
exactly
you need to have a background
there are two kinds of hospitals ठीक है ना एक जैसे आपका है एक हमारे शिफा आगा खान OMI these are corporate run organizations तो यहाँ health commission everything is sort of on the books तो there are as far as others are concerned जो बाहर होता है हमारे तो उसमें everything is legal आप उसका सब signed होता है otherwise वो होता ही नहीं patient already pay पहले से करता है yes then it's operator dependent in Pakistan it is all to do with the operator how much the person जिसका वो कर रहा है वो उसको trust करता है बिकॉज अगर वो आपका 1-2 दिन पहले देखा है एक्यूट पेशेंट में प्रॉब्लम होती है लेकिन अगर पूरी फैमिली जानती है तो पाकिस्तान में इट्स अ पर्सनली बेस्ड सिस्टम ब्रांडेड वो होते हैं लोग उनके साथ उनके सालों से फैमिलीज चल रही होती तो इतना प्रॉब्लम तो इट इज़ पर्सनैलिटी बेस्ड प्लस हॉस्पिटल की अगर सेठों का हॉस्पिटल है जहाँ आपके इसी तरह लैब्स में वो सामान लेके आते हैं और फिर इस तरह उधर प्रॉब्लम होती है उधर फिर जिस तरह ये मुजीब साहब कह रहे हैं कि वो फिर पर्सनली कंसल्टेंट रिक्वेस्ट करता है हमारे यहाँ ऐसा है ही नहीं इन फॉर एग्जांपल ये जहाँ ये केस हुआ वहाँ कभी भी हार्डली कभी पैसों की प्रॉब्लम हुई है वी टेल द पेशेंट एंड वो दोनों बैलेंस हो जाता है
एक्चुअली नदीम कराची में पेइंग कैपेसिटी इज अ लॉट बेटर देन द अदर प्लेसेस
So I think let's Dr. Babar quickly and then we have to move on. It's on. ठीक है वो हो गया
Sorry.
So हाँ डॉक्टर बशीर आप तबाई में हमने बड़ा इंटरेस्टिंग AI का काम किया है इसके ऊपर IBA के साथ मिलके जिसमें कि 20% deviation of billing आपने हम predict कर जाते थे from admission. So admission के ऊपर आप 20% deviation billing की. So it's the uncertainty between what you quote at admission and at discharge that makes the patient unsatisfied. So you can predict some of this using
as I said,
data.
most of the time it's fine. I would say 80% nothing will happen. The patient will say okay, and they will be willing to even pay for that. But so there are few times when things really go wrong, and then you have to. But I think the key thing is really you have to be truthful, as Mujib Saab said, and you have to document it right. And then if something happens, goes to the healthcare commission or whatever legal issues, you can still defend it because these are the complications which can happen and do happen. Last comment.
So in my observation, I think the understanding of the basic medical ethics of 4 principles, which includes the first one is autonomy. If the patient has provided a mental capacity, it's the patient who decides. We only focus on the family, which is, I think legally is not correct. Is autonomy is with the patient with the capacity. And then I think understanding of medical ethics also, my feeling is poor. Consent process is not appropriate either. So obviously logistic of who is going to pay it, that's later on. First is the ethically and legally we need to be correct.
Yeah. I think the most important thing is a lot of us are kind of a little bit scared when we are taking the consent to really tell them about the complications. I always tell them 1% patient can have a heart attack, stroke or death during the procedure, and very clearly in front of the family, because these things do happen. And people think that if you tell them, they may not agree to proceed with the procedure, but I never had that problem. So it is very important to take the consent properly. Sir, a quick last comment. We are getting late.
मेरी एक suggestion है कि इसमें बड़ा rare होता है ऐसे, तो ऑपरेटर्स को और हॉस्पिटल्स को मिलके एक फंड जनरेट करना चाहिए जो रेयरली यूज हो जाए ऐसे केसेस में.
हॉस्पिटल्स को इकट्ठे होना बहुत मुश्किल है.
डॉक्टर्स भी दे सकते हैं.
You're right. Sir, देर हो गई काफी.
I think with all respects, the proximal lesion was critical. It was a good distal vessel. When this distal inflation was right at the close to the apex and very thin caliber, inflating there was probably chancy. We should just focus on the proximal portion. Yes.
So how we deal this complication in our cath lab? Once the complication occurred, family was informed about the complication, and we tell them how we are going to deal with this complication, and we documented this. And at the end of procedure, family was again counseled regarding the outcome of the procedure and documented it. And we maintain all the clinical records of the patient during the hospital stay, and we discuss this case in the mortality and morbidity meeting for the documentation purpose.
Thank you. Thank you so much. Nice case. Okay, so let's call the next Dr. Wajahat Lodi. He's here to present the next case. Please.
Bismillah ar-Rahman ar-Rahim. My name is Dr. Wajahat. I'm going to be fairly quick and crisp about this newly added section of in Park Life, that is counseling and when things go wrong despite doing everything right. We're going to focus less on the case and more on the medical, legal and litigation purposes. Our basic procedure, and the reason why we're talking about this, is that in Pakistan now we're doing more and more complex cases, as this conference is quite evident of that. So now we need to know more about the rules and laws and counseling and consent more than ever. So informed consent is something that we need to know about. We should not just be a piece of paper that the doctor and the patient signs. It should be something that we need to explain to the patient that what's going to happen, what are the pros and cons of the procedure, is there an alternative, and if do we have any other options. This is unfortunately something that we usually skip upon or hand over to the junior most person in the department. Secondly, the concept is not just only of consent. It is a legally binding document. It is something that is going to help you or bail you out if things inevitably do go wrong. Unfortunately or fortunately, we are in a profession where we are dealing with human lives and things will not always go to plan. And sometimes you need this safety check, this safety netting to bail you out in these times of needs. So just a scenario that you can get a 76-year-old lady with pulmonary edema, comes to you with ongoing chest pain, and you need to intervene. her troponins are raised, she's got a heart rate of 120, and you decide after taking a consent with the family and you take her to the cath lab. So this is where the first things start to happen. You know, you've taken a consent, oh gee, haath se jayenge, we take a right radial, and you can't go through the right radial, you have to switch to the left radial. You go to the left radial, it's very spasmodic vessel, and you somehow get to the left system, you take a few pictures, you clarify the anatomy. It's a diffused triple vessel disease. The right angiogram I'll show you in a bit. But, you know, there's a lot going on there. Since she's got symptoms, she's elderly, she's in pulmonary edema, you think that PCI is one of the options. So a colleague of yours, a designated team member, goes to the family and tells them what they're going to do. But during that counseling session, the patient has a generalized tonic-clonic seizures, goes into ventricular tachy followed by arrest. You then, you know, have to save a life. You go in from the left femoral, you take a venous access, you take an arterial access, you put in a TPM, you're thinking of fluids, you're thinking of resuscitation, and you do all what is necessary at that time to save a life. So the family is again recounseled that what are we doing? After that is just a procedure. The patient has a brief period of asystole for which you do compressions. You try to complete the procedure as safely and as effectively as possible. No fancy stuff. Everything stays provisional. Everything stays simple. You want to decrease the dye burden. You want to be done out of the cath lab as soon as possible. So this is just a left main LED followed by a PCI to the circ. You take a last final check. Minimal dye, you take a femoral shot, you don't want her to, you know, have a retro in the ward and find out that you did everything right, so you do your precautions right. So once you've completed, we did the same, we shifted our patient post-procedurally to the ICU. 8 hours post-PCI, everything was fine until she had another ventricular tachycardia that was unstable. She was cardioverted 3 times, we could not achieve ROSC. And now what do you tell the family? And, you know, how should one break bad news? In our setup, we primarily give this information in chunks, in palatable forms. We sit them down, we tell them what we have done, and we try to explain to them that whatever could have been done has been done. You don't want to lie to the patients, always be very honest, always tell them the truth. At times it might not go very well with the patients, but nowadays everybody has the power of internet. They can Google what you've said, done, and can fact check you. So be honest upfront. You don't want to be caught out lying. So that's the principle that must be followed, that do not lie. So medical documentation is something that we all lack, because in the end, my teacher would always tell me that the only thing that is going to defend you, the patient is gone, the family is gone. The only thing that's going to defend you is your documentation. What have you documented? If it's not documented, it's not done. So your documentations are very important. Your prerequisites, your checklists, any documentation that you've done, previous procedures, allergies. Every time the patient had chest pain, you document it. So you have to document each and every step of the process that you've done. This is just a sample checklist. One thing, this is the timeout time that we all probably skip upon, is everybody essential in the cath lab should come together, should discuss the patient, should identify the patient. What are we going to do for this patient? Why are we here? You don't want to be having a left system engaged and ask, karna kya hai iska, na? So you want to know beforehand. You have to have a plan. And that's how you proceed. So this is a sample checklist. So this is what a counseling routine day looks for us. It's a 3-tiered system. You'll have the senior most primary operator come in, counsel the family member, what we are planning to do, and always ask the patient to repeat what you've just told them. You need to know what do they understand by all that medical jargon that you've told him. The second phase is after you've successfully completed a procedure, you talk to the family, what went wrong, what we did, how good it was, what did we expect to do, and then a third member of the team tells them what's next for the patient. Are there anything that we need to stage? Are we looking for any side effects of the procedure? And what's the plan? So just a normal basic ethics and counseling lecture that I've given. I hope we had more time, but in the interest of time, I'll stop here. Thank you for your patient listening. The panel is now open for discussion. Thank you.
Can I have one quick question? Agar main kar lun, sorry. So yeah, excellent talk, first of all. So I think, just to give you an idea, क्योंकि वो AI वाला मुझे connect करना था डॉक्टर साजिद को और तंग करने के लिए. So you can use large language models and your own data set to create contextual, your own institutional informed consents. क्योंकि अगर आप कहते हैं ना कि हमारी इतनी मोर्टेलिटी, वो तो आप यूएस बेस्ड डेटा पे कह रहे हैं, अपना डेटा है नहीं, तो अगर आपकी मोर्टेलिटी फॉर एग्जांपल हायर है या लोअर है, या कॉम्प्लिकेशन रेट हायर है लोअर है, तो वो फिर एक ज़्यादा ऑथेंटिक और ट्रूथफुल इन्फॉर्म कंसेंट होता है. सो यू कैन ट्यून योर लार्ज लैंग्वेज मॉडल ऑन अ क्वार्टरली बेसिस, और वो हर क्वार्टरली पे आपका जो इन्फॉर्म कंसेंट है उसको बेस्ड ऑन योर डेटा अपडेट कर देगा.
Right.
And then you can use it for more contextual.
Thank you for that.
So, yeah, excellent presentation. Yeah, excellent talk. But what I mean, you covered almost all the bases. Recently, we had a problem with a patient who was very specific. Jigi, aapne patient ko intubate kyun kiya when he had a cardiac? So now we had come. This was a patient who came with a cardiogenic shock, and the patient made it the next day, extubated, and everything went fine. So now we have made an extensive consent form, which includes every single thing. So the TPM and the whole 9 yards. So I think what's more important is to communicate with the patient before, during, as you come out, and as you showed in the movie, after the procedure, explain to the family whether it's a complication or not. So,
right. Thank
excellent.
You.
Yeah, I do the same thing. Like sometimes, especially it becomes difficult when the patient comes walking, and during the procedure now patient codes, and then you are. So I personally, if it happens, I get out right then out of the lab. Obviously the code is being done and taken care of, and then I go and talk to the family that this complication has happened and we are working on it. And we keep repeatedly basically informing them what's going on now, what's going on now. So that is important, but the consent is the key. And you have to be very upfront telling the patients and the families what's going to happen, especially the family, because they are the one who are going to come after you.
True stories.
So something you said is important in this talk is documentation.
Yeah.
Because every document in a patient's chart is a legal document, and it can come in the court of law. So in the US, that's what we train and tell our fellows, and we do it, that you have to make sure that what you're documenting is appropriate, it's true, the conversations have happened, because each document, the chart will be sealed. If the patient dies, the charts get sealed. And that will be pulled out. And if you try to make any changes now with EHR, it puts a timestamp on it. So anyone knows that you made a change. So just make sure everything is documented well.
Can I ask what's a legal requirement for consent in Pakistan? I don't know, because UK, I know the patient has to have a mental capacity. Family need to be informed and involved, but they cannot sign the consent unless there is a lack of capacity. And if there's a lack of capacity, what's the alternate? Like you said, the pulmonary edema patients. Alternates are, you can do the two medics, can sign the form in the best interest. Okay, you can do the best interest, or you can find another person. But family has to be involved and informed. I don't know what's the legal requirement in Pakistan. I think it's important to know is this consent has to be signed by the patient unless patient does not have a capacity. This is general medical ethical rule. I don't know about Pakistan rules.
Yeah.
If I can answer that. Before I answer that, you know, आज से कोई 20 साल पहले ना circulation में एक article आया था medical litigations के ऊपर, तो उसमें जो chief editor था ना, he wrote his opening statement was, friends do not sue friends. And he goes on to say that you've got to develop a rapport with your patient, and if they think you did everything in good sincerity, most time they will not go for litigation against you. And वो जो आप पूछ रहे हैं कि इंटरनेशनल सोसाइटी ने तो एक ऑफिशियल कंसेंट फॉर्म बनाया हुआ है जिसके अंदर पेशेंट का, फैमिली का और एक डॉक्टर का साइन आता है. एंड
पाकिस्तान में लीगल वैल्यू है कंसेंट फॉर्म की, एंड दिस डॉक्यूमेंटेशन आल्सो हैज अ वेरी लीगल वैल्यू. Cases have gone from multiple specialities, from multiple hospitals like Khan, and and the documentation has really saved careers of patients and everything. So documentation काम आती चाहे वो किसी भी hospital.
So do you have anyone who is, do patients here have living wills? Do they have medical power of attorneys? Who do you speak to? Because when something happens, the whole family comes. There are 50 people in the room. But then who makes a decision for the patient? Is the patient on the ventilator? Who makes a decision? Not those 50 people. So they have to designate one medical power of attorney who is going to be the person who you're going to communicate with. You can talk to other people too, but you cannot have 50 people giving you their thought process.
No, but that's only valid if patient does not have a capacity. That's called LPA, lasting power of attorney. There are two reasons. One, you can have medical, you can have financial, but lasting power of attorney is only valid if patient does not have a capacity.
देखिए, our general statement is कि जो भी decision makers हैं वो सारे आ जाएं, you know, yeah, because चाचा मामा कहीं और से उठ जाता है.
Multiple आ जाते हैं, जब कुछ होता है तो multiple पहुंच जाते हैं.
The next presentation is Dr. Faisal Latif. He's going to talk about the role of cath PCR registry in quality of role. Dr. Faisal Latif. Oh, it's recorded. Oh, it's live. He has 2 talks.
Can you hear me okay or no?
Yes, Faisal, welcome. We were hearing you before, now we can't hear you. Yes, we can hear you.
My mic is on.
We can hear you now.
I'm trying to share my screen.
We can hear you now.
Can you see me?
Do we have to close this to
Can you see me, or I'm trying to share my screen?
No,
Deborah has my talk.
We are not seeing your screen.
I'm trying if... Can Deborah see my talk?
Because you have to share from your side. Obviously, we can't do that.
That's what I'm trying to do.
Okay, so maybe you want to, I guess, try to fix it or log in again. In the meantime, I can take another talk.
Sure, go ahead.
Okay.
Yes,
so maybe we can have the Dr. Ryan Reeves talk, which is online recorded. And I think this is another important subject about appropriateness criteria, appropriate use criteria for cath and angioplasties.
Hello, my name is Ryan Reeves, and I'm an interventional cardiologist and associate professor of medicine at UC San Diego, and I have the honor of giving a talk regarding appropriateness use criteria in the cath lab. I have no disclosures related to this talk. A brief review of the history of appropriateness is relevant in discussing today's issues. The RAND Corporation is a non-profit think tank that started the development of appropriateness criteria applied to military analysis. Subsequently, this was broadened to look at promoting scientific, educational, and charitable purposes for the public welfare, which naturally this then was A brief review of the history of appropriateness is relevant in discussing today's issues. The RAND Corporation is a nonprofit think tank that started the development of appropriateness criteria applied to military analysis. Subsequently, this was broadened to look at promoting scientific, educational, and charitable purposes for the public welfare, which naturally this then was parlayed further into looking at healthcare specifically. The first application for interventional cardiology in the literature appears in 1991 in looking at audits of hospital data from New York State. 9 experts put these together, looked at outcomes considering symptoms, MI prevention, and survival, and came up with the categories of crucial, appropriate, uncertain, inappropriate. I'll draw your attention to the red boxes here with different forms of angina, acute myocardial infarction, and asymptomatic patients. And the vast majority were mapped to crucial, appropriate, and uncertain. However, in looking at the asymptomatic indication, over 1/3 were mapped to inappropriate PCI. Prompting further investigation into this. In 2009, a multi-society document was published looking at AUC for ACS and stable angina. This was then compared to NCDR data. 70% of the PCIs were for acute coronary syndrome, and the vast majority of those mapped to an appropriate indication. However, for stable angina, only 50% mapped to an appropriate indication, which then created sensational headlines as cardiologists were accused of performing 50% PCIs in inappropriate settings. This isn't really a proper interpretation of the data and warranted further refinement. When we take a look at the bell curve here on the left of the slide, the curve is skewed to the left where most of the hospitals had a low rate of inappropriate PCI, but there were significant outliers. The document was then updated in 2012 and further in 2017 for stable angina and 2016 for ACS. Multiple changes occurred, including nomenclature. They got rid of inappropriate and went with rarely appropriate, and got rid of uncertain and went with maybe appropriate. The criteria development was enhanced with separate committees and rating panels, as well as more players involved in the care of these patients. There were more interventional cardiologists, surgeons, and clinical cardiologists involved. Symptom classification was modified, getting rid of the subjective Canadian cardiovascular classification system. And I just have a random cities from the United States here in terms of block lengths in feet. Some cities such as Portland and Houston are square, where other cities blocks like Manhattan and Chicago are rectangular with vastly different lengths. So now we just use asymptomatic and symptomatic. Medical therapy was changed to mimic real-world practice, but no mention of patient tolerance is included. Markers of disease severity were enhanced, putting less of an emphasis on non-invasive imaging and more of an emphasis on syntax score and intracoronary physiology, and then contemporary scenarios such as solid organ transplantation or structural heart procedures were added. So here's a flow on the right-hand side of the process, and I have been involved with the recently published pacemaker and ICD appropriateness use criteria. I was the SCI representative on the panel, but anyway, is a review panel and writing group who composes an initial document and comes up with scenarios, and then a rating panel rates each on a score of 1 to 9, with 1 to 3 being rarely appropriate, 4 to 6 being maybe, and 7 to 9 being appropriate. And then this document and ratings are pushed back and forth between the panels to arrive at the final document. So AUC scope of indications will focus more on stable ischemic heart disease, but we see the factors taken into consideration: the clinical presentation, medications, prior testing, prior CABG, invasive testing, comorbidities, and coronary anatomy and disease complexity. But briefly, when we take a look at the 2016 AUC for acute coronary syndrome, there's really one major rarely appropriate we see in the red down there, and that's the asymptomatic patient with no further testing who has an intermediate lesion. Those patients probably warrant further testing before proceeding with PCI. And a brief case here on the right, 65-year-old male, 2 hours of chest pain, ST elevations, received lytics, transferred to our hospital for further care, continued to have persistent pain and ST elevations. Angiography was performed, thrombotically occluded RCA, undergoing successful PCI, and this is clearly an appropriate indication. So here are now the tables for stable angina. We see on the left stratified by 1 vessel disease, 2 vessel disease, 3 vessel disease, and left main. Then going across the columns, we see asymptomatic and symptomatic, and then below that, based on anti-anginal therapy, and then further below that, looking at PCI or CABG, and then with the ratings developed for each scenario. On the right, we have post-bypass patients based on a patent Lima to LAD, and then our special scenarios. So that while this is a very busy table and slide, with a little bit of familiarity, this can be applied in real time. Doesn't necessarily need to be used in real time, and can be used in terms of looking at aggregates of patients for quality purposes. So in comparing the application of the 2017 to the 2012 AUC and looking at patients from New York State in 2014, we see that 911 inappropriate PCIs were reclassified or evaluated with 2017 AUC, and only 140 of those were considered rarely appropriate. In total, there were 171 rarely appropriate PCIs using 2017 data. So some cases were stratified in both directions, but there were more that were shifted out of the inappropriate category. So this is hot off the press, 2025, taking a look at 2017 AUC and data from the ischemia trial. So 1,800 patients from the ischemia trial were evaluated, and to note, their severity of disease was defined based on coronary CT, and this was an invasive versus conservative therapy trial, not a PCI trial. However, taking a look over here, anti-anginal use and symptoms were the biggest predictor of AUC application to this data. So the presence of diabetes, number of vessels, and so forth didn't really have as much as of an impact. So we really need to be aware of the medications our patients are on and whether they're symptomatic. So quick cases, 71-year-old male, multiple comorbidities, multi-vessel disease, evaluated by CT surgery, felt to be at high risk. PCI would be a better option. STS score here is elevated. Again, you see the angiograms. So he underwent successful IVUS-guided PCI. We see a nice left main stent here, and this unfortunately maps to, as do all of these left main interventions, to rarely appropriate. But we did our due diligence and had him evaluated by surgery first. Second case, 60-year-old male, known CAD, not on anti-anginal therapy, low symptoms, needs an evaluation to renew his pilot license, and he has an osteal lesion here in this vein graft. He underwent successful PCI, home the same day. And this maps to rarely appropriate as well. We could have tinkered with his meds to boost him up to a higher appropriateness, but again, this is rarely appropriate. We don't do this for every patient, but it was needed to be done here. So the role of AUC is a clinical tool, a research tool, administrative tool. It should not be a reimbursement decision tool, and not which individual cases should necessarily be evaluated, but more valuable for quality. Our UC San Diego experience, we review our AUC cases every 6 to 8 weeks. We keep our rarely appropriates low, and as I said, the vast majority of these are left main PCI, and we even look for patterns in our maybe appropriates. So, sometimes rarely appropriates need PCI, and sometimes appropriates don't need PCI. Thank you, and have a great meeting.
I think the attendance shows that how much importance these things are in the cath lab, unfortunately, but we have seen really. So I think I'm not going to talk about the report as such. We have already distributed the report, and you can look at your numbers, whoever has what has been submitted, and overall जो भी चीजें थी we have mentioned over there. But I think I thought I'll just quickly, very few 4-5 slides. I just wanted to talk about the importance of the registry, cath lab registry, and the data. I think for last couple of hours we have been talking, and especially Dr. Babar also said, and how less data we have from Pakistan or low to middle income countries, and how important our own data is as compared to what we talk about others. Now, the critical question which we need to ask from all of us, and I think we have seen that also shown by Babar also, the power of data. And this is a guy, Edward Deming, a very well-known statistician and a total quality guru, who said a long time ago that in God we trust, all others must bring data. So data is really important. It's not just my experience, my overall whatever I see or do, but you have to have the data to prove that anywhere you go you have to show what you are doing. So when we talk about the registries, I think science really tells us what we can do, guidelines tell us what we should do, but actually what we are doing, that you will know only from the registries. So that's why really registries are real life what's happening. So it's really becomes very important, the data from the registries, and that's what we really need to work on those. Alhamdulillah, we started this a while ago in like 2008, and now it's like almost 18 years we have been working on it. And Alhamdulillah, with the Pakistan Society of Interventional Cardiology and all the efforts, we have almost 140 cath lab who are enrolled in it, but unfortunately the data quality and overall the completeness of data is not there. We audited around 15% of the sites, which were like 28 of them. And some institutions are really doing a commendable job. Complete data, accurate data, without any issues, and we really thank them and really recognize them. But there are many who really need to really step up and do something. There is a significant gap in terms of ownership, intent, and the leadership. So unless you will not own this data, it will not be possible to submit. If you just do it for the sake of getting the certificate or the license from Healthcare Commission, then obviously this is what we are going to get. And unfortunately, garbage in, garbage out. If we don't have accurate and complete data, that information, what we are going to get, is going to be worse than not having any information. So I think it's everyone's responsibility to really own that data and make sure that wherever we are working, all of us are senior working in cath lab as directors, so it is their responsibility to make sure to look it up. Almost every week I spend a couple of hours to look at all the data from our lab and other labs also, to really go over and make sure what's happening, and try to call people also, request them, beg them to please submit the data, but still things are not happening. So that's why I wanted to request here today to all those who are sitting in the top leadership positions to really own this data and please submit the data. Data accuracy, as I said, it's really a problem. Collection and entry is seen as a task and as a formality. But really, it's not a formality. It's the responsibility which all of us have to take it. Without taking that responsibility, it will not be possible to really get the accurate data, which is going to be a problem. And I feel that this is our moral responsibility also, looking that we have so much dearth of data from Pakistan, and these things are really going to help. As I said, we are running this Pakistan Pak Sehat study, and obviously we are monitoring that data very closely, and we are getting really alarming numbers which we are going to present in the near future. But those numbers, what we are seeing over there, they are completely different from whatever data we have from the Western world. We talk about all those Western data, but we need to have our own data to really make a policy and improve our outcomes. In our lab, this database has significantly improved the quality of our cath lab as such. We can monitor our mortalities, morbidities, and all those kind of things, and see where the lacking is, and that helps us to improve our own cath lab. we have to prioritize, measure, and aim to really deliver. That's the only way to improve things. Otherwise, this is not going to happen. We have built an excellent infrastructure. If you go online, those of you who have seen that, we have an excellent online database developed there, and we have also provided quality metrics for your own lab. It can give. You really need to learn those things. Most of you probably don't know. You can call our Rehan, who has done marvelous job in really getting these things done. You can easily get the quality metrics or reports from your own database and outcomes data also, which can help you to improve your own cath labs, even if you're not interested in contributing to the overall data, but it's going to help you to improve your own quality also. And the research output, unfortunately, from Pakistan, recently we had a meeting at AKU about clinical trial unit, and we were discussing how much research has come out of Pakistan, and unfortunately it's so dismal that literally sharam aati hai dekh ke as compared to other countries, even Bangladesh and India has like huge data and numbers and research publications as compared to Pakistan. So we all have to really work hard to do that. We talk about whenever we give a talk and discuss about trials from the West, we discuss studies from the West, but we don't have our own studies. We should be really talking when we come here about our own studies, our own data, and then we can authentically say, okay, that's what the problem is, and that's how we can improve things on, not just based on the Western studies. They have invested in accurate and consistent, meaningful data. We need to invest in that accurate and consistent data as well. And again, we have to commit to ourselves, are we willing to do that? And if we commit to ourselves, invest in the data, then it will be only possible to have that data. So it's really a call for action. Don't just log in to just put in few data, reflect on it, own it, look at your own institution's performance, and ask yourself, are we really proud of this data? Are we doing our best for our patients? And what needs to change? And then it will be only at that time it will be possible to improve on things. And this data is really going to empower you. The PSIC Cath, Crop Cath PCI registry belongs to all of you, and you have to own it and take it as a moral responsibility. That will be only possible. And together we can lead. It gives us the power to speak the truth and do better. We are the leadership and of our institutions, and we have to, this is one of the responsibility of the leadership, to really make sure that we are able to produce accurate data for the whole country and for the sake of our patients. So if we have to work together, it's no individual responsibility. Only, I think, if we can improve ourselves, if we work together. If we really want to go far away and achieve something, we all need to work as a team. Then it's only possible to improve the database coming from Pakistan as well. Thank you very much.
Bashir, I have a question.
Yeah, sure, please go ahead.
So my question is, why are people not vested in being part of this database? Now in the US, we all have to be part of the database. There's no option. You have to be, because your data is put online, patients can select where they want to go, who they want to see, and this is a requirement. So what are the barriers? I mean, you have already established a forum, you've established a place. Why don't people want to be part of it?
There are multiple factors, based on my experience, I can tell you, obviously, people think there could be personal reasons that we are focusing and doing it. And secondly, I think, again, there is overall lack of interest in terms of research or really putting in database. Then obviously, one of the things is that concern that people will know my lab's complications, my lab's issues, and although we have made it sure that it's a password protected, only they can see their own data, we can't see their data, but still that kind of fear we haven't been able to really remove that despite explaining and telling everyone. Still people think that's how it's going to happen. We have a steering committee of few of the selected from those who are submitting the data, and we have said that you can use your own data to do the research. If you want to have everyone's data, then you can write a proposal and send to the steering committee, and they can use that also after approval from obviously everyone. But there are concerns that I might be selling the data, I might be using the data for myself, or someone else might be using my data, which, or they would know the complication and the problems.
Can I answer that? Because I've been telling Bashir for a long time, we've been a little bit contradictory in our thing without any personal thing. You see, the problem is this: Pakistan में वो चीज़ होती है जो आपको mandatory करनी पड़ती है. अब सब operator registration, promotions के लिए in public hospitals you need to have publications in a PMDC recognized journal. So everyone from assistant professors to associate professor वो जाएगा और promote हो. In private sector इस तरह की कोई बात नहीं है. तो private sector में the only इंटरेस्ट तो होएगा नहीं. वो हेल्थ कमीशन ने अब कहा, इनकी तरफ से लेटर आ जाता है तो वो हम भिजवा देते हैं सब लोग. दो चीज़ें हैं. फर्स्ट ऑफ ऑल फंडिंग. द फंडिंग आपके यहाँ द फंडिंग एक तो लॉ है इंटरनेशनल. दूसरा ये है कि उससे आपको पता, इफ़ आई वांट टू पब्लिश माय डेटा फॉर लेफ्ट मेन फॉर एग्जांपल, एंड इफ़ आई नो कि मैं एक फ़ोन कॉल करूँ और वो सारा का सारा वो खुद ही करके और उसमें से निकाल के कर ले, तो ऑफ कोर्स आई विल वांट टू पब्लिश दैट. आफ्टर NIC ये जो इनका डेटा अभी मैंने देखा है उसमें 16,000 इज द हाईएस्ट नंबर ऑफ वो जो अभी आपका डेटा कैट्स नहीं PCI का और समथिंग लाइक दैट. 25,000 तो सिर्फ NICVD अकेला कर रहा है. दैट नहीं सुन, NICVD कराची इज नॉट.
NICVD कराची
मैं वही कह रहा हूं,
अभी तक
वो उन्होंने कोई डेटा नहीं दिया. और वो मैं NICVD में, एंड दिस व्हेन आई वाज देयर दिस थिंग स्टार्टेड. NICVD हैज पब्लिश्ड. उसके बाद से अभी उनका अपना रिसर्च डिपार्टमेंट है, फंडिंग है, वो लोग अपने उसमें दे पब्लिश्ड इन लैंसेट. दे पब्लिश 5-6 आर्टिकल्स अभी इंटरनेशनल उन्होंने कर लिए हैं और इंटरनेशनल स्टडी. तो होता क्या है कि ओनरशिप, अभी वो ये बशीर सही कह रहा है, वो ये समझते हैं लोग कि भाई ये इट्स अ बशीर या इट्स अ फला, उसमें दे आर नॉट डायरेक्टली एसोसिएट. तो आई थिंक द ओनली वे इज कि इसको आप लोग बैठ के एक तो फंडिंग का और दूसरा इसकी ownership जो है that has to be somehow centralized in a way that जो जिसका जितना डेटा होगा उसको उतनी ownership मिलेगी. Because जब तक ये नहीं करेंगे ना आप तो it's अभी वो it seems like it's a टब्बा thing. मैं बता रहा हूँ that's the whole thing. वरना मिट्टी, अब देखें ना, मिट्टी और लड़काना का आपके पास डेटा है वो क्यों? इसलिए कि वो SICVD और वो उसकी वो so it has become a personalized issue. इसको
depersonalized PSIC crop के नाम से है. It's not Bashir's database or someone else's database. And after society, I know, but society से सारी discussions के बाद ही सारा कुछ किया गया. और one of the reason you were there also that NICVD is going to submit the data, and despite that, not a single data has come to NICVD, which is again one of the biggest centers.
Can I add something? Can I add something?
Please go ahead.
Being from Punjab and working in private public hospitals from last 20 years. Culture of hospitals is, जो government hospital, they don't demand such data from us. The government doesn't demand any data from us. तो सरकारी नौकरी का जो एक mindset है, उसमें this is of least importance. तो अगर एक private hospital के जो ये initiative है, अगर ये add on नहीं करता value in my नौकरी, तो I won't be interested in all this. और यही inertia है जो कि basically one of the leading
but it does not add on to my thing. I am in a private hospital. I am not interested in उसमें promotion का भी नहीं है और ना ही मुझे कोई overall benefit मिलता है. And I have spent months and weeks in the beginning, and now still spending every week at least 4-5 hours to go through all these things. मेरा उसमें अपना पर्सनल कोई फ़ायदा नहीं है. बट जो भी है डाटा सबका अपना अपना है, ओनरशिप उनकी अपनी है. जो भी चीज़ होगी, मैं कोई भी आज तक कोई पेपर उसमें से जो है वो पब्लिश करने के लिए तैयार नहीं, हालांकि सबको कहा हुआ है, लेकिन नोबडी हैज़ डन एनीथिंग. वी पब्लिश वन पेपर जो कि उसमें से ज़्यादातर मेरा अपना तब्बा का डेटा था, मे भी कुछ थोड़ा सा दूसरों का था, उस पर भी बहुत से इतराज़ात हो गए कि जी उन्होंने डेटा यूज़ करके जो है वो पब्लिश कर लिया, हालांकि जो बाकी लोग उसमें इन्वॉल्व किए गए थे जिस तरह से भी थे, जिसने लिखा जिसने किया और वो सारा उन लोगों को ही ऑथरशिप में इन्वॉल्व किया गया था। बट बात वही आ जाती है कि नदीम इज़ राइट कि जी दे थिंक कि जी शायद ये बशीर का अपना डेटा है, ही इज़ गेटिंग सम बेनिफिट आउट ऑफ इट, अप टू द एक्सटेंट दैट पीपल हैव सेड that senior people have said that Bashir is going to sell the data and take the money, which is like really sad. I've been working on this for last 18 years. मुझे उसमें से आज तक कोई फायदा नहीं हुआ, मेरी कोई promotion नहीं है, मुझे उससे कोई financial benefit नहीं है, मैं मतलब I don't know.
Thank you so much, Bashir Saab. I just would like to.
ये जो सब चीजें हो रही, इसमें have you identified the factors कि क्यों data नहीं collect? क्योंकि maybe you should ask and review this. What are the factors that the reason that the data is being not collected? Is it the personal insecurity, or maybe the data collection is a difficult process, or maybe that the people have to sit for hours to enter the data? That may be the laziness, or as he said, it's not a requirement. So then you can find the alternatives. Maybe if you make an app, let me answer you. For example,
it's an app. It is an app, online app
on your iPhone, and then people can start putting the data on that. That would be easier thing. So I think you just have to do a little bit of small survey and identify the factors and then.
Sure. Last comment from Babar.
Bashir Saab, can I just add something?
Babar, you go ahead just quickly. I think we have to finish it.
नहीं, I think बहुत ही important points raised हुए हैं, तो जो Dr. Sajid कह रहे हैं, this is true, and that's why we have been working on creating an app, not an app, but something that will use large language models to display your data so that you can use it in actionable items. देखें, जो भी डेटाबेस है, आप यूएस की भी हिस्ट्री देख लें, पहले एक्सट्रिंसिक मोटिवेशन आती है. एक्सट्रिंसिक मोटिवेशन ये है कि आपकी हेल्थ कमीशंस, गवर्नमेंट बोलेगी बेटा आप कर ही नहीं सकोगे जब तक कि आप अपने आउटकम्स ना दिखाओगे. So that is the first thing that will happen. Intrinsic motivation will come later. The second thing which is important is to maybe convert it into a quality improvement collaborative. Third is to have sessions like these जहाँ पे कोई parallel session नहीं हो रहा हो. Everybody is attending and उनकी CME उसके साथ connect करें आप. तो फिर patient safety और quality और data की बात लोगों के absorb होगी rather than putting a stent in and doing yet another tower.
Bashir Saab, can I just request 1 minute, please?
Just quick, last
one.
Yeah,
just one very quick, and I would not just repeat myself, but I would like to add the experience. Alhamdulillah, Peshawar Institute of Cardiology take the pride of the highest number of contributors, and I just would like to add few points that the way in which we did it, and if other institutions want to share the same experiences, because we are the high volume center. Initially, we tried to force the fellows, but it was out of their depth and they were very busy. So we have then went to the medical director and we recruited 6 transcriptionists and trained them. And we are doing a weekly session with them how to enter the data. So that's Alhamdulillah has reflecting as one of the highest number.
Yeah. I don't know, sorry.
Is, I think we are talking about the use of AI in cardiology and in medicine, and here is one of the best example. So those centers who are contributing to NCDR, we do not have any reservation, but at the contribute to the crop, and slowly they move from NCDR to the crop. And one of the way is if we can sit together, use the IT and AI brand, and see how we can auto-populate the same data from NCDR to the crop. So essentially, they are not doing the double job. When I talked individually to Usman Fahim, AKU, and Abdul Hakim, essentially then they need 2 teams to enter that data to NCDR and at the same time.
We are doing the same. Actually, we do the same NCDR and we actually can import from that, and it is possible to do it. And then we have a lot of other things which we have. Anyone willing to basically collaborate, contact Rehan, will be able to help you in that. And I must congratulate your center and Ikram Center. They were the highest volume government centers who have been giving data. So if there is a will and if you own it, it is possible. Obviously, it's not easy.
Absolutely. I wish everyone have a dedication like yourself, Bashir Hanif sir. One point to add about the one which you have mentioned, because I've talked to Rehan and he's, mashallah, very good, very prompt in response, is the way in which you can auto-populate from NCDR is you can take the data a few months back, for the few months from the NCDR, and from the back end that you can then upload it to the crop.
Sure.
So it will not get auto-populated case by case, but few months you can get the data and then you can upload it back into the crop.
Okay, thank you very much. I think we're going to move on. Is AFIC there? Bilal, we are there with you. Quickly, if you could just in a couple of minutes tell us what have you done. We can't hear you.
So we'll tell you where we left off.
Yeah, go ahead. We can hear you now.
Yeah. So can you hear us?
Yes, we can.
Okay. So what happened was we were in a position where we were in the retrograde. We were at the distal cap. The distal cap is very, very solid, and instrumentation of wires is very, very challenging. There is lots of tortuosity, hidden tortuosity. You know where you see that loop on the screen? Actually, just distal to it, there's a double tortuous loop that when wires come out, they look like kind of safari pigtail wires. Anyhow, we actually go forward one, please. We'll tell you what we did. We basically retrogradely we tried everything. We tried propofol to increase the lubricity and instrumentation of wires. We actually did retrograde knuckles to disrupt the distal cap. And then by doing so, we were able to we thought we could actually transform this into some form of a dissection re-entry technique, and we were able to star into the true distal lumen. So that was a good development in the case. So then we recognized that working on this retrograde epicardial collateral with a tough distal cap was challenging. So we would switch to like an antegrade dissection re-entry. So we kind of starred into the mid PLV, which is good. Then we go forward, please. We ballooned along the whole segment. Keep going, keep going. So here we exchanged the wire out. Keep going, keep going. So we've got true distal lumen, which is great. Tip injection. We exchanged the wire out to a workhorse wire. We've ballooned across the whole segment of the vessel. Keep going.
Bizim salon bizi duymuyor galiba çocuklar.
Keep going.
Can you hear us still?
Yes, we can hear you. Just be quick,
so
please.
we ballooned everything. Then we basically were able to redirect an antegrade wire into the true lumen, into the PLV. Keep going. So, and that we were happy with the second wire position. Keep going. Keep going. This is us trying to. So now we've got. Keep going. So now that's the second wire going into the true lumen in the PLV. That's by disrupting the distal cap. Keep going. So we were happy with this position. Now, we had very poor distal visualization, and our retrograde MC was actually very useful in showing us the bifurcation and the distal cap. So then we used ballooning along that, use a dual lumen microcatheter. Keep going forward. Keep going forward. These are just all the nuances of trapping, and keep going forward.
Can you show us the last one where you are now?
Yeah, we will. So we just ballooned, and more tests. Here's a dual lumen, and we're wired. So now we're in a very good position where we have dissected with knuckle down to the distal cap, but then have entered luminally just proximal to the bifurcation in true lumen PLV distally, true lumen PLV in the PDA. We're going to IVUS, and I think the plan will be just to do DCB in the proximal PDA and PLV and to stent the main RCA. So I think it's been a very tough, long-winded procedure, lots of demonstrations of epicardial skills, using a combined hybrid approach, and ultimately I believe we will have a good result.
Thank you. Hats off to your persistence.
Thank you very much.
Thank you.
That's all I do.
Okay, we're going to move on. Dr. Faisal Latif is there. I think we are going to go quickly to him, and then we're going to go to Turkey for the live case.
Can you see my screen now?
Not yet. Just give us a second. They are changing it. Move Turkey. Faisal, can you hear us?
Yes, I can hear you. Can you hear me?
Okay, yeah, we can hear you. And I guess we are going to move the slides from here.
I think I have control.
Okay, good.
Okay, thank you very much for inviting me to Pakistan Live. Sorry I could not be there this year. I am going to briefly talk about the role of cath PCI registry in improving quality in cath lab. I know we have talked a lot about registries. Here are my disclosures. So I'll talk about NCDR at a glance, how NCDR, any registry can help improve the quality. Like I'll demonstrate one project that was done to reduce bleeding, and then how it can help collaboration in post-market surveillance. So in registry programs, the two basic components are that you have to get continuous clinical data. You cannot pick and choose. You have to have continuous clinical data, and you have to have demographic data. What is the age of the patient, male, female, what are the risk factors, and then you get the technical details also, and then you can use that data in assessing the quality, and then once you assess the quality, then you can use it in quality improvement and clinical research, and that's how hundreds and hundreds of papers have come out of the cath PCI registry. So over the years, this process started only 27 years ago. So it's not like a 50-year-old process, but over the years, so many registries have been added to NCDR. And the first one to start was the cath PCI registry, like CROP registry in Pakistan. So this tells you a map of the United States where the sites have to be part of the NCDR. So the penetration is very high, so that more than 95% of PCI performing hospitals have to provide their data to cath PCI registry. So like Dr. Bashir Hassan Saab said, that if you make it a choice, nobody will participate. And that's the case in the US also. I'll give you an example that, you have to participate in the cath PCI registry to get paid. Nobody is going to pay you, the insurance companies or the Medicare, Medicaid, unless you are part of the registry, because then you're part of a quality improvement program. The ACC also had a peripheral vascular registry. Because it is not mandated by payers to be part of that registry, the penetration is only 15%. So the extrinsic factors that it is mandated is the key to get the data that can be beneficial for the entire population. So you have to have the standardized forms. The adverse events are defined robustly. So you have to define what is post-PCI bleeding. You have to define what is post-PCI acute kidney injury. How do you classify death after PCI? All of those have to be clearly defined in the registry. And then, the key component, like, many said that, who is going to enter the data? Are those people even trained? So we have every hospital that participates in cath PCI registry has data abstractors. So, and data abstractors don't have to be on site. They can actually abstract data. Like our data abstractors, they are not even nurses. They are just, people who are probably high school qualified, but they are able to gather data from what has been documented. And if it's not in the report, they will not put that data in. So you can argue and argue that, this is not a complication of PCI, but unless the documentation reflects that, they would not submit to your whims of changing the data. So you have to empower them to be able to get good data that would be beneficial and meaningful in advancing the field for the benefit of the patients. So for NCDR, there have been many iterations of the forms over the years. The cath PCI registry last update was, I think, about 4 years ago. Then all the many other registries have had different form updates over the years, because you have to see what data is not useful and what is useful, and then kind of make it as easier as possible for the abstractors to get that data. This is an example of a quarterly report that, you can see that in this quarter, how many cases were done, cases that were just diagnostic, cases that were scheduled PCIs, cases that were part of a concomitant procedure like a TAVR is being done and at the same time a PCI is done, so on and so forth. And how the report is structured is that You have to, it's in percentiles. So the best percentile is to try to be in the 90th percentile, that 90% of you're performing better than 90% of the hospitals in the registry. If you're in the 10th percentile, then you are performing in the lowest 10th quartile of the 10th decile of the registry participants. So for example, this is an example of guideline medications prescribed at discharge. So post-PCI, a patient should be receiving aspirin, a P2Y12 inhibitor, statin, beta blocker, and in case they're not candidates for any particular medicine, you have to document that they have an intolerance or allergy, and as long as you document, then that's okay. And to be in the 90th percentile, this should be 100%, that all of your patients are well documented if they are on the medicine, and if they are not, an allergy is documented. And then you have to risk standardized also, because some tertiary hospitals may be doing very high risk procedures as compared to a small hospital which may be doing simpler procedures. So you have to risk standardize to see what type of patients they are doing to be in a certain decile. So here, for example, in hospital risk standardized bleeding is 1.96 for this hospital, and they land in about 50th percentile or less than 50th percentile. So in order to improve their outcomes to the 90th percentile, they have to get this standardized bleeding down to 1.22%. So this is how the data is abstracted, that you can see the initial of the data abstracted over here. They document that this is a 58-year-old female who came in with non-ST elevation MI, the creatinine went up, and they were started on dialysis. So this is an adverse event of acute kidney injury. Then this is an adverse event of hemoglobin drop, post-PCI bleeding, and so on. This is how the data is abstracted, and then there is about 5 to 6 pages that have to be documented. Then this hospital's in-hospital risk standardized mortality is 0.96. So they are in the 25th percentile. So in order to improve their risk standardized mortality to 90th percentile, they have to improve this over E ratio to 0.68. So many times, the problem is, like Dr. Bashir Hanif said, that garbage in, garbage out. If your data is not robust, if you are missing documentation that this patient also is on dialysis, this patient has had colon cancer, received chemotherapy 6 months ago, so on. If they have more comorbidities and they are not documented, then your risk standardized mortality is going to be higher. So documentation of all those comorbidities is important. Medicines at discharge, even if you are, for example, P2Y12 inhibitor post-PCI, if you are at 99.8%, you can see that you will land in 25th percentile. So you have to be 100%, in this. There is very little wiggle room to be in a good percentile. So you cannot miss even 1 out of 100 patients. Otherwise, you will end up from 90th percentile to a 50th percentile. How has the registry helped improve quality? So this paper came out a few years ago to look at the appropriateness of PCI. As you know, it has been discussed extensively that for appropriate PCI, the patient should, for stable angina. Of course, if a patient is having an acute coronary syndrome, almost 100% of those PCIs are classified as appropriate. But for stable angina, you have to be on appropriate antianginals. You have to have documentation of ischemia through a stress test or IFR, FFR, something like that to be in the appropriate category. So once this data was published, then you can see that how the hospitals how the hospital data is widespread. That some hospitals are doing most PCIs appropriate, and some hospitals, the rate of inappropriate procedures is higher, and many hospitals it's lower. But when you have data, then you can work on improving the data and improving the outcomes. So by participation, the absolute number of inappropriate PCIs decreased from 21,000 in this particular study down to 8,000, because then you document ischemia, you make sure before your patient, you do a PCI that they are on appropriate antianginals and still remain symptomatic. This was a project to reduce the bleeding risk. So in Cath PCI registry, as I showed some data, that to be in the 50th percentile, if you have if you have an adverse post-PCI bleeding rate of 2.8%, you are in the 50th percentile. If you're in the 90th percentile, you have to be at 1.68%. To be if you have a post-PCI bleeding of 4.8%, you're way low at 10th percentile. So how do you improve bleeding? So there were, it was identified what things can be done to improve the bleeding rates. So there were 173 PCI sites that were enrolled in this particular data, and as we all know, that use of bivalirudin reduces bleeding, use of radial approach reduces bleeding. In the US, the penetration of radial particularly was very low a few years ago. That has improved significantly. And then use of cath PCI risk calculators for bleeding ahead of time for all these sites actually helped. Because if you know that your patient has a chance of 10% chance of a significant bleeding post PCI, then you will employ more measures like use of bivalirudin, use of radial approach to reduce that risk. And if a patient had, if a patient was assessed to have a higher risk, then you use more of those techniques, and that's how you can. That's how a significant improvement was made in the bleeding incidence. And then next, the last thing I'm going to talk about is how this data can be used for post-market surveillance. This is basically the various devices that we use. So we use, the balloons, the stents, the closure devices, for the TAVR, the type of valve you're using. So because you have big data, you have hundreds of thousands of patients in the data, you can see if a certain device is performing better than this standard of care or not, and then you can decide whether to keep that device or not. So in this particular instance, post-PCI hemostasis for femoral access site was manual compression. So the control was manual compression here, 364, and most closure devices performed better than the manual compression. But VasoSeal performed worse than manual compression, and therefore VasoSeal was removed from the market. So that's how you can track if a certain company or a certain device is not doing well, you can take it out of the market to improve patient outcomes.
Dr. Faisal, we are running out of time, so
okay.
If you would like to summarize and end up in a minute or so that would be helpful.
Sure. I'll just go to the conclusion. So basically, NCTR serves as a model on how to capture data. I hope that somehow this gets mandated so it can be translated into the PSIC crop registry. It can be used to improve outcomes across the Pakistani population if we imitate the NCDR into crop. And then this can be used in physician credentialing and hospital privileges at some point also, but there are legal hurdles in that. Thank you very much.
Thank you. I think we just had a hot discussion regarding the data collection and the cath PCR registry in Pakistan. So thank you very much, Dr. Faisal, for your input. And thank you to the panelists for being here in this session. And we move on to the next session. The moderator is Dr. Nadeem. Nadeem Rizvi will take care from here. And okay, good luck.
Right, I think we are, the next session is from Turkey, Dr. Omar Gotkin's team, in conjunction with the Society of Interventional Cardiology Turkey. I think they're going to show us the case, if you can. So can we have some panelists, Salman, Sajid, कुछ यार आ जाओ ऊपर. आप लोग इधर तो एक दो तो उधर आए ना. Bilal, please, you are on the official list, so I have to. I think everyone's deserted here. Right, or Bilal, I hope you don't mind. यार नहीं तो कोई तो आएगा ना ऊपर जब यहाँ लोगों को ज़बरदस्ती बुलाना पड़ रहा है. Thank you. Nawaz, please join us on that. At least there should be some panelists to show the Turkish. Right. So can we Langyal यार आओ ना, join us. अब थोड़ा ज़रा discussion में फिर official हो जाता है. So can you hear us? This is Dr. Nadeem Rizvi from Pakistan Live. I can see, is that Dr. Omar Gotkin? Yes,
Yeah.
Omar, how are you?
Can you hear me?
I'm
Very
sorry
good.
for joining late, but as you know, we are
That's
usually
fine.
a little
That's
bit
fine
late.
for us.
Yes.
Yeah, we are okay here. No worries at all.
So
So
can you
thank you very
explain?
much for
Yes.
thank you very much for this opportunity. Now we are in Izmir, in Chile
Education and Research Hospital.
Education Hospital, and my colleague İlker Gül, he will do the case, and
Hello.
I will help him. And also we have nurse Hijran. She is helping us, and technician Mert, and also circular nurse Mustafa. So before we start, let's see case from Eren. He will show you the case, and after that, Dr. Yusuf Abdullahi from Germany, he will explain and he will comment on CT angiogram. This patient has CT angiogram, and we ask our dear colleague Yusuf to comment. He's very good CT operator, but also he's excellent CT commenter. So we will have his help here. Thanks for him too. So Eren, could you please tell us regarding the case?
Dear colleagues and dear participants, I would like to present you our last but not least the fourth case of today, which is a LAD CTO PCI. Our patient is a 77 years old male. The patient presented to our clinic, outpatient clinic, in February with anginal complaints. His medical history was diabetes mellitus, hyperlipidemia, and hypertension. He is a former smoker. He has a positive family history of coronary artery disease. ACG findings, let's say, it's a sinus rhythm with normal heart rate, T-wave immersion observed with V4 and V6. Following clinical examination, a myocardial perfusion scan test was decided due to a further evaluation. Echocardiographic results reveals us left ventricle ejection fraction is 58%. There are no significant bone motion abnormalities. He has also a concentric left ventricle hypertrophy. Blood results has revealed a slightly increased fasting blood glucose levels, and LDL level was 146. And myocardial perfusion scan has revealed that there are perfusion defects in apical and anteroseptal balls, which is corresponding to the territory supplied by the LAD artery. As we can see here in the RCA, in the states and rams intermedius arteries, there are no critical plaques, but in the LAD segments, we can clearly see ostial CTO segment. And also we can see reinterrupt 2 flows with ipsilateral and contralateral collateral splice. And we can see epicardial collaterals originating from the distal segment of the ramus intermedius. And also, there is a septal collateral from the RCA, which consistent with collateral connection grade 1. And the first attempt of LAD CTO PCI. Proceeding with a CTO PCI during the index procedure was planned due to having ischemic evidence. Despite using Fielder XT, PT2, and Gaia second guide wires, successful wiring into the true lumen was not achieved. And after that, a failure of the integral CTO attempt resulted in a coronary rupture in the middle segment of the LAD artery. We can see more correctly in the second image.
And when was this procedure done? How long ago?
2 months.
All right.
Nearly 2 months. And the decision, a self-limited type 2 coronary rupture was observed. The patient's vital signs and clinical condition remained stable without any deterioration or symptoms, fortunately. An elective well-planned CTO-PCI was scheduled following clinical follow-up and interpretation of coronary CTA. And coronary CTA was performed before this procedure. A Gatson score was 132. And patient's current medication is regarding the guidelines. Patient's current blood results revealed us slightly better fasting blood glucose level, and LDL level has dropped up to 87. And what is our strategy? A retrograde approach considered reasonable with the failure of the initial attempt, which resulted in multiple dissections along with a ruptured vessel segment. Nevertheless, decision depends on the patient's updated coronary angiographic findings, the current political circulation, and operators' clinical judgment and experience. And also, we are planning to deploy a novel bioadapter stent, Dynamics, today. I would like to tell you a bit more about this stent. Bioadapter is a coronary implant that's designed to adapt the vessel physiology to restore vessel function. It has 3 independent helical sinusoidal strands, which are temporarily connected by bioabsorbable polymer coating, eluting antiproliferative agent. And after the 6 months, the helical strands unlocked, separate, and provide dynamic support. And what is the mechanism of it? As I mentioned, in the first 6 months, it would remain locked and restore flow and achieve high acute gain and low residual stent stenosis. But after the 6 months, these connection parts would unlock and restore adaptive remodeling and maintain low diameter stenosis. Of course, dynamic support is also important. As you can see here, it would restore pulsatility, compliance, and adaptive coronary flow. As we know that with the conventional drug-eluting stents, it would make the vessel more firm, more straight, but with the bioadapter, it would adapt the vessel native pathway. And also it would improve pulsatility, compliance, and adaptive coronary flow. And the first randomized evidence on bioadapter is bioadapter RCT trial. Patient number was 445. It has compared head-to-head dynamics bioadapter and Resolute Onyx test. Primary endpoint was TLF at 12 months, and secondary endpoints imaging by coronary angiography, IVUS, or OCT. 12 and 24-month results from bioadapter RCT demonstrated safety and efficacy of dynamics. Target lesion failure primary endpoint at 12 months was met. Reduction and plateauing in TLF and TBF through 2 years. Statistically significant lower diameter stenosis and late lumen loss versus death, and uniquely demonstrated pulsatility in intravascular imaging endpoints. As you can see here, there is a plateau, especially after the 6 months. And another trial, Infinity CV RCT, the follow-up period was 12 months, and it's also compared dynamics bioadapter and Resolute Onyx test as well. And in the endpoints, a significant reduction and plateau in target lesion failure and target vessel failure after 6 months has been observed. As you can see here, there's a plateau in the target lesion failure and target vessel failure, which were statistically significant. And especially in the LAD lesions after the 6 months with bioadapter, there is a 73% risk reduction has been observed with the dynamic GBR adapter. And what about the high-risk lesions? In the small vessels and local lesions, a risk reduction has been shown within the trial, especially with the small vessels, a statistically significant decreased endpoints has been seen here. Thank you for your attention.
Okay, thank you. So that was a nice presentation about bioadapter, but remember that even on the Onyx arm, I was surprised that 6 months to where it's less than single digits.
Buraya mı göstersin hocam? Işık bizi göstersin.
So, Omar, where are you now?
Yes, we didn't do anything. We're just waiting for you. We are ready. But before, I like to see CT angiogram. So, Yusuf, are you there?
Hi, Omar. Yes, I'm here.
Yes, yes.
Hello to everyone from Berlin. I know it was a very short notice, but I'm happy to be with the Omar team to present his case today. I hope everyone can hear me.
Yes, we can hear you very well. So this is the moderator from the Turkish side, Yusuf. Welcome.
Okay.
Yeah.
Thank you. Thank you for having me. So I will, my name is Yusuf Abdulwahid. I am the head of the interventional cardiology in a university, the Charité University in Berlin. So I will just be very short, give the presentation on the CT. So I got the CT from Omar, and as you can see, when we get the CT images, we have different forms how we analyze. So I will use a method called SLABME. It's easier for all interventional cardiologists to understand. So I will just show the coronaries very fast. Here's the RCA. I think everyone can understand. It looks nice. It's fine, and it's open. I think we have the angio. It will also confirm. But now we go to our CTO segment, which is for today.
We can't see the CT.
You cannot see. I started sharing, so I hope you.
We see from Turkey, so. We see it from
Turkey. Okay.
Yeah, now we can see it. Now we can see it. Now we can
okay, so I will start again from the beginning. So usually when we get the images, as I said, you have different forms how you can analyze the images. But today I will try to use a method called SLABME. It's easier for the cardiologists and the interventional cardiologists to understand it. So our focus will be on the coronary CT. This is how you see your coronary CT can display your coronaries. This is the RCA. It looks fine, not so much calcified. Very, very nice image. And then now we change to the LED, which is, or the left system, which is the focus for today and the challenge for Omar and his team. We can see down here how, which projections we're doing, like the coronary imaging, like the angiogram. This is the CTO segment. So it's nice to understand that it comes exactly what we saw from the angio. This is the like the spider view, this RCX, and here comes the uptake of the LED. It's not so much calcified. Also, when we change the view, we can understand there is some layers here.
That's very important to see that there is not that much calcification. Yes, we have a very small calcification. But
there are some potty calcification, but it's not very much heavily calcified. We know from what we know that calcium plays a very important role, especially in CTO. Segment is a bit long, so and it already had a try one time. This is probably this is from the dissection of what happened at that time, the perforation. But anyway, the segment, it should be not so heavily calcified and not so much tough to cross it. So maybe Omar, of course, can try the retrograde or TDADR, IVAS re-entry, or any method he will choose. Both are completely fine. And this is different views, how we can manage to watch the LED. And it's also on its course. It's not so much calcified. And yeah, I wish you...
But it's a long one, yeah?
It's a long one.
Yeah.
So it's actually a long segment here. This is exactly the segment where it starts from the ostium until it joins probably the mid-LED. This segment completely.
Okay, so can I ask some of my panelists who are from US as well, that do you read your own CTs, Bilal, Salman?
So there's a growing movement to involve more CTs in CTO planning. I must confess that unfortunately our hospital does not do that. I mean, which is me, I guess. I don't order those. Some of it has to do with the fact that the radiologists read our CTs. However, if I have a failed CTO, then almost invariably I will get a CT. So if I can't find the cap, or if it's an ambiguous cap, so I'm more likely to do a CT after I've failed the first attempt, but we're trying to get better about doing it before every CTO.
Okay, good. Bilal?
Can I comment on this point? So probably the radiologists, they usually use something called stretched MPR, multiplanar reconstruction, which usually gets the vessels just a straight line. So it actually, you lose as interventional cardiologist the anatomy and to understand. Of course, it gives the information about the plaque and the distribution, but actually you lose your anatomy and everything you need for as an operator. And this is the difference. So in Japan, they actually use this is where I actually learned. So they use this slab meep method because it's very familiar with all what we do in the coronary angio, and it gives you exactly your anatomy and how we will go. So every curve, every move there in the vessel.
Okay, so in the interest of time, Omar, you can carry on and tell us what you've done.
Okay.
Yes, please. Yeah. So I think I learned a lot from CT because I see that proximal cap penetration wouldn't be that much difficult because we don't have that much calcification, but the length is long. We see the same thing in the angiogram. It was long to us as well. So we will try a nice antegrade attempt because we have some epicardial collateral from CX, but it's tiny and epicardial. We will try, if we fail antegrade, we try those epicardial. I will show you the targets for retrograde. From right coronary, we have some collateral to go to proximal, but filling is not that much. So let's review the angiogram we did today. Okay, this is right injection. Okay, so in here from Areo, we have some feeling, and this is, we have another branch. This could be diagonal. What do you think? And LAD a little bit down, I think. Next, please. Maybe diagonal one. Yeah, yeah. If you look here, LAD at the middle, and we have also another feeling that could be, I think, diagonal. But feeling, we have some feeling, but it's not that perfect, right? Next, please. And also, I checked if we have any separate conus, but we couldn't find it. And I didn't see in the angiogram as well. We don't have any separate conus to go proximal part because I thought it's long lesion. If we have long lesion, we could have some collateral from somewhere. So I tried to check it, but CT show us it's really long. Next, please. Yeah. Okay.
Dr. Ömer, do you hear me?
So,
this is Dr. Nizi from
August, you want to say something? The moderators from Turkey.
Yes, we have two moderators from Turkey, Oğuz Yavuzgil and Nezihi Barış.
I have a question. This is Dr. Nezihi Barış speaking. Dr. Yusuf is still there?
Yes, I'm still here.
Yeah,
cannot understand.
My question is for you. There was a type 2 rupture in previous intervention. Do you see any sign of rupture or total healing? What do you comment?
I would be happy to share one more time the CT to show you how we can see it.
Yes, please go ahead, Yusuf. Yeah.
Thank you. So this is can you see it now?
Yeah, we see it.
Okay. So how this will react, it actually looks a bit, if you look in the LED, it's a bit more, the lumen is a bit bigger, which probably because of the dissection. And there is an element, it's not a contrast, but it's some filling here. So it can be from the dissection perhaps and the perforation, but an active something going there, we cannot detect because of course it was a PQ segment. And again, it's completely, I think,
So that
I
is
think we
healed
still
up.
have the hematoma there, right? Because it's bigger than proximal and distal, that part.
Okay, so Dr. Langreal, you've got a question?
Yeah.
One of our panelists.
I have a question because this was a...
Shall we have the angiogram here?
Can you hear me?
No.
Yeah.
Let's see the angiogram.
Can you hear me now?
Yes, yes.
Okay. Because this was a failed PCI with a perforation, so did you consider bypass surgery in this patient? And then what's the chances of another perforation or a serious complication now? And how would you mitigate that?
Did you get that, Omar? One of the panelists is asking, did you consider bypass and what will be the chance of again having a complication like perforation?
We talked to our surgeons for coronary artery bypass grafting, but our patient refused this treatment, and he wanted to us PCI stenting.
Omar?
Yes.
Can I ask a question? Would you please do a double injection?
Yes, we have some double injections, yes. Next, please. Yeah. Okay, next, please. And here, actually, what we did simultaneous injection. Normally, we have to inject first donor artery, and then CTO artery, right? But here, since we have ipsilateral collateral from the occluded artery, occluded system, which is left system here, we just need simultaneous injection to see better whole story, because in that case proximally feels from RCA and distally feels from collateral, comes from I think OM. So that's why we did simultaneous injection. Most of the time we inject first from donor artery. As soon as we see collateral, we inject occluded artery. But mainly, I think feeling comes from ipsilateral collateral.
Yeah.
To me. Next, please, and I'll try to show you where our target could be. Okay, stop.
Dur. Biraz geri al.
Başa gel, baştan. Okay.
Frame by frame.
If you concentrate here, okay, frame by frame, if you look this upper OM, one of the branches. İleri git. Okay. Yeah. Go more. More. Okay, too much. Okay, stay here.
Yes.
Come back. Yeah. Actually, here, I think I can see some collaterals. Do you agree with me?
Yes. So it's coming from the part of the circumflex system, the epicardial
Exactly.
collateral. Yeah.
Exactly. I think we have something here to be used.
So
but
Omar,
of course, our aim to open this antegrately.
This one.
If you could.
So that's Omar. This is Salman here. Good to see you again within 24
Hi,
hours.
Salman. Hi.
Yeah, I was saying that so sometimes when you have a failed attempt, I think the mode of failure also makes a difference. So if your mode of failure was inability to penetrate a long proximal dissection, then you sometimes become hesitant. But here, the CT suggests that the proximal CTO has healed nicely, probably is chronic thrombus. So I would probably try antegrade first. You don't have good retrograde options. And we can talk about which antegrade approach, but I agree with you that antegrade would give you a good shot at this. And when you approach the site of the previous perforation, that's where you'll have to be careful. So that's my suggestion.
Fully agree. We will try antegrade. And we will try nice antegrade with maybe parallel wire. So,
Omar, this is Bilal. I'm sorry I missed you yesterday.
hi. Yeah, sorry, I missed you yesterday, Bilal. Sorry for that. I'd like to talk to you, but we missed each other.
Yes.
Sorry.
What do you think was the mechanism of the perforation? Because it looked like the wire in the last attempt was true lumen distal LED. So what was the cause, do you think? Was it an oversized balloon that resulted in it? But why did the artery perforate?
I think the wire went somewhere, hydrophilic wire somewhere small artery. What do you think? Maybe small branch. That's
Maybe.
why we have perforation. What I think.
But it showed after balloon. 2.0 balloon.
Yeah.
Maybe.
So you think that the wire is in the lumen? I'm not sure. I don't know.
Okay.
Maybe it's a small branch, and then he perforate. Looks like. So let's start. I think we can see the proximal cap spider view. Let's go to spider view, and we have a Corsair Pro. Yes.
Yes.
Corsair
and
Pro.
Gaia second.
Yes, and then as a microcatheter, and we have Gaia second for CTO wire. Yeah. So to reach the LAD osteum, we had secondary curve, right? Small curve. You know, Gaia has small curve, and we give another curve. It became like this now. So like left Jatkin shape, more or less. Can I see it?
Okay.
Okay.
Can I ask you another question?
Yeah.
Ömer,
Yes.
as your presentation, you told us different guide wires. So this is a failed case and second attempt. So because of the possible time loss, you had to pass some previous basal guide, I think. You have to, for example, use first Gaia or something like that. How did you affect the selection of the wires if it's a failed attempt?
I don't know who did it. Who did that case?
Eren? Who did? No, it's
The
not
first
my
attempt.
case.
For example, if you know
in our
the
clinic.
In our clinic, yeah?
Yes.
Okay.
if you know the failed attempts wires before, for example, Sion or Gaia is failed, you choose the which one?
Gaia second.
We have Gaia second. I think. Yes. Yeah, I think Eren did it. Yes.
Eren presented this
No.
case.
Who did the case? First attempt.
Ilhan.
Ilhan.
Yes,
okay.
our
So
friends.
Ilhan did it, and so I think we have chance with the Gaia still because we hoping the penetration of at the center of the plaque. Hopefully, let's see.
Gidiyorum hocam. Başlıyorum.
So we send our wire now.
Can I ask a question?
But I think
Can
the
you hear me?
CT images are very useful, and also the operator of the CT is very familiar with also coronary angiography positions. In Turkey, not every time you have this chance because we can see the calcium and we can see the thrombus in the CT. Looks like it's very familiar with the angio. It was beautiful.
Yes. Yes, because Yusuf did it. That's the difference. He has a specific
So, Umar,
software.
one question comes to mind is, what is your threshold for switching to retrograde here? How many wires, how much time?
I think we can spend, it depends, you know, what we could do, yeah? If everything is finished, no need to try same thing, you know, over and over. So we have some, so first I like to penetrate the cap, yes? If Gaia second failed it, I will have steeper one. After penetration, I like to go more distal. If I am in subintima, I like to do parallel wire here. If parallel wire also fails, in that time I definitely go retrograde.
Okay.
Test me. So, although CT shows a soft cap penetration, maybe we should have Gaia third here.
Oh, or maybe try, so to me the wire is prolapsing into the circumflex. So keep the wire there and
Yeah.
advance the Corsair and then try. So it's a support issue, not a penetration issue right now.
Yeah, you're right. So
try that first before you up.
Just engage the cap and then just push your micro.
Yes, just slowly. Yeah, slowing it up there.
Yeah. Okay, stay there, here, and then push your micro. You have to. Yeah, you have to.
I want to.
And slow.
Dr.
Just,
Umar?
yeah.
I
Oh,
would
see,
like
it's
to
already
ask
gone.
one
It's
thing.
already penetrated. See that?
Yeah, but the direction, I'm not sure if it is good.
Yeah, it's...
Okay, it's not bad. Okay, so yeah, we share. Just do, yeah, okay. So I think we are giving chance now Gaia, right? So let's see. Because, okay, now I'm waiting him to penetrate now, okay? So he has to do a job. If not, I will change it. Just push your macro more.
Yes.
Yeah. Very good. More. All right. All right.
Salman, do you get any comfort if you're told that it's on a CT it's a soft,
right?
it's the proximal cap is not too hard? Do you get any idea?
Yeah,
do you think there's correlation?
So for me, I'll tell you, obviously, I have a bias, but the CT to me favored an HDR approach because you did not a lot of calcium. If you can manage to puncture that cap, then I think most of it is soft. So I would probably consider doing that.
So you think there is correlation?
Spider?
Yes, and I think the CT becomes very good for identifying ambiguous caps.
Let's have Gaia
and the
third,
proximal CT architecture.
Gaia third.
Gaia third'ümüz var mı arkadaşlar?
Nasıl yapıyor?
You were asking me earlier about the use of CT angiographies in our health system. You know, my colleague Manos Berlakis is a big proponent of that as well. And definitely it's being underused, but I know that he uses it consistently for all CDO and PCI planning. And in our system, the cardiologist actually read the CT angiogram and the radiologist read the non-cardiac portion. But it's incredibly helpful in complex PCI planning in cases like this.
Yeah.
Yes, one more thing, that if there was a dissection on the CT, wouldn't it be safer to go in the retrograde direction? Because they have a suspicion of the perforation as well.
Sorry, I didn't get that question. Can you speak up?
Seeing a dissection, they saw a dissection flap on the CT. Won't it be safer to go in the retrograde dissection because they had a suspicion of the perforation as well? The heel perforation in the CT, on the CT, as you mentioned on the CT.
Yeah, that's what came to my mind also, but they think that they should go through the full protocol of trying antegrade.
I mean, switching to retrograde, shouldn't he be having a lower threshold to switch to retrograde?
Yeah, he's going to try antegrade first and then he'll try retrograde, yeah, if he has to.
If there are not very good collaterals retrograde, then the risk is not insignificant.
Omar,
secondly,
would you like to try the right positions, Ömer?
Sorry?
Would you like to try the right RAO positions? In some positions of angiography, we can see the
RAO. We can
maybe RAO.
Yeah, direction not bad. Direction is not bad. So what?
Direction is okay, but the stump cannot be seen very well.
Okay, yeah. Let's do a little bit go down because we like to insert our macro inside, right? So, okay, hey, let's try now.
But my question is, suppose dissection like this long dissection, how long you wait? Then you reattempt this type of procedure, or any CT criterion that you decide.
So I think
now
we had better have a nice.
This
okay,
type of
let's have a Gaia third
artery
or Gaia second.
So generally,
I think you should. Nawaz, can we have, because there's too many people talking. Can we? Yes, Umar, yes. So is there a question, Nawaz? You can ask the Umar.
Gaia 3. So we penetrated, and now since we have some resistance there, we change our wire to Gaia third. And Gaia third has a straight tip because we did a secondary curve, if you remember. So I don't like it when we try to go intra-CTO. No, we have a small curve, original curve of Gaia third, and we will use this one, right? We don't have additional curve here. But we shouldn't lose our macro position. Otherwise, we have to have another curve.
Is this micro catheter is your first choice? For example, if you have other models, what other types of micros do you want to use?
Actually, we could use here something without nose because, as you see, it's prolapsing easily. Yeah. If you use fine cross here or along, those catheter has no nose, so it will be maybe better for penetration because this has a tip and that tip prolapse. As you see, it happens several times.
Umar, from the Pakistani perspective, we have a limited inventory, so we have Miracle Brothers here. What do you think about Miracles compared to the Gaia? for example, miracles, we have miracle 6, miracle 9, and some operators would shift to miracle brothers in order to get more penetratability and direction. What do you think about miracle?
Miracle. Miracle, you say?
Yeah, I mean, look, I love Miracle. You know, Miracle was perfect wire, okay? I opened lots of CTO with Miracle. Miracle 6 especially, perfect wire. You know, because of the fashion, and I think Gaia a little bit better, then we change our practice to Gaia, right? So, but the Miracle 6 is very nice wire. Very nice wire. Yeah. If you could use it, use it. Very nice wire. And of course, it's cheaper than Gaia.
Would you do a retrograde injection? A retro injection here?
Unfortunately, I have to give ipsilateral injection because here is the. Okay. All right. Not bad. Let's see. But I'm afraid that we will in this dissected plane a little bit because my wire is very. Okay, nice. This is nice. Yeah, very nice. I like it. Okay, stay there. Stay. Let's see. Because last 10 millimeter is extremely important to cap, right? Distal cap. So we have to direct our wire sometimes. All right. So you see, you have to come a little bit right side. And also you have to see from other side. Let's look at from eleocranial, eleo. More eleo.
Yeah, I think if you change the view, you might find that this is going parallel.
Wait. Okay. In here you have to be again right side, yeah? Okay. So it's nice to see at least two waves. Try to work three-dimensional. Yeah, okay. Go epicranial, yeah? You want epicranial?
Okay.
That's the beauty of parallel wire. When we use parallel wire, we know now where we should go, right? So.
And no tip injections?
Umar, you do a lot of CTOs. What do you think about using biplane to save the contrast?
Oh yes, very helpful, I think. Definitely helpful. Yeah. But you had to, use it. I mean, you have to be familiar, yeah, right? But it's very useful, of course. So my brand push my macro. I don't know why we don't need to go that far. Let's a little bit pull back because your micro now direct your wire, right? We don't want that.
Yeah. So Omar,
direct our wire with our hand.
Why don't you do this in the LAO view, because that shows the separation, because this didn't show the separation. So
LAO view, yeah?
Yeah, in the LAO view you can see the separation, but otherwise you'll go in the same direction. Because you're trying to stay away from that sort of inner direction going outwards, and here they're overlapped.
Sure. Let's go to LAO. Slowly, please.
That looks good.
Easy,
Let's see. Wait.
No, see, we're too separate.
Okay, go to LAO. We are in 70 now, but we have a good for parallel wire. LAO, more LAO. More LAO. You see? Now? Okay.
So Omar, like you said, the microcatheter is directing you in that direction. If you just pull the microcatheter back 1 millimeter and then go towards the lateral, towards the diag branch.
Sorry, Salman, what did you say?
No. I said you were correct that the microcatheter may be biasing you in this direction. If you pull the micro back just about 1 millimeter and then go towards the diagonal branch that we saw, might be a little better. I'm agreeing with you.
Yeah. So I think it's now for me time for parallel wire. and I like to go differently. I have to keep distance from the proximal if I do parallel wire. You know, I have to separate my second wire like 2-3 millimeter right side.
Dr. Omar, this Dr. Nawaz, how long you wait to dissection heal, then you retry the wire? Because I did 1 or 2 cases, even 4-5 weeks, when I trying wire again, just going to the false lumen anti-gradely. So what's your protocol? How you decide? We tried
most of the time, dissection stays there a long time. Hematome resorb, but dissection stays. So even after 6 months, you may go easily dissected plane. But hematoma resolve.
So you repeatedly do the CT, or you do the CT one time after some specific time? So far the cost is concerned in our setup, so we can't do the repeated CT in our setup. So what your protocol you are doing there?
But I think for the CTO business, you know, I don't think CT is that expensive, because CTO procedure is already very expensive. I think in some patients, failed patients, if we have post-CABG patients, I think it's nice to have a CT.
I think doing CTO like this, it's never a cost-effective procedure. So you only do CTOs for a particular indication. So if the cost is an issue in public sector in Pakistan, I think retrograde and doing a lot of inventory is not really indicated unless it's really, a problem with the patient.
I think the other challenge over here in this case is that it's an ipsilateral collateral, and normally we don't like to do antegrade injections. But here, unless you were to do a tip injection through the donor from where the collateral is coming from, there's obviously the potential for the hematoma to be growing and compromising Omar's ability to actually see the distal target as well.
So now you can find a different path, and he has some resistance, which is good. Okay, go down. Yavaş in aşağı. Bir dakika olmaz. Evet, in aşağı. You have diagonal there, right? You see the diagonal. Biraz yukarı gel.
So, Omar, we've extended your time. There was about 8 minutes left. We extended it by another 10 minutes. So you can...
Okay.
We'd like to really see this, how you manage it.
Sure. Then let me try, and then if we fail, let's go to retrograde, okay? Online. Do you agree with that?
Yeah, I think you do whatever you do routinely, because whatever you feel is appropriate.
Why we not try the parallel wire in this stage? Because this wire is going interiorly and at the distal cap, and keep this wire over there and try the other wire.
Yes, I agree with you. Oraya git abi, orada bırakalım televizyonu. I fully agree with you. Evet, git abi aşağı. Evet.
The pressure of doing it in front of live audience वो भी मेरे ख्याल में कोई factor होना है.
Omar, this is Yusuf. I just want to ask you something. How you think?
Sorry, say again. What did you ask? Anything, Yusuf?
I think the mic is off. I think, or something's wrong with the sound there. Omar, can you hear us?
Yes, I can hear you.
Okay,
yeah?
good. I think your other team in Turkey probably wanted to ask a question.
Sure. So, I want to go down. Now we change the hands, and if I am 70 mile, I'll maybe do small, a short parallel wire and retrograde. But even if we go retrograde, we need disintegrate wiring somehow, right?
Yes.
Omar,
yes, please. I can hear you, Yusuf. If you say something, I can't hear you. Bir tane daha yeni bana bir gaye 3 verebilir misiniz varsa? Test var abi. Bir dakika abi. Ver abi sen testini. I can't hear you. Arkadaşlar duymuyorum ben.
Biz duyuyoruz seni.
Ama Yusuf'u duymuyoruz işte.
Pakistan'ı duymuyorum diyor ama.
Yusuf'u.
Ha.
Öyle mi? Okay. Injection. AP kraliye gel.
Yeah, the tip isn't behaving very well.
Okay, go. Bir dakika abi.
I think so.
İlerle abi. Bekle. Çok değil.
They're off. Well, at least your wire is deep enough that you can do parallel wiring now, huh?
Yeah.
So, yeah, that's wrapping around, I think.
Yeah. That's right. I'm having fresh wire.
Yes.
Which is the same one. Ali. And çok alayım abi.
So I guess because this is not very calcified, would you ever consider using a Mongo, because that also has a one-to-one torque?
Mango?
Yeah, the Gladius.
We have Gladius EX. I like to have Gladius EX.
Yeah, because I think since this is not
but
so
since
calcified.
I have a dissection plane,
yeah.
I really prefer Gaia.
So you can puncture back into the true lumen if you have to.
Okay, this is better.
Yeah.
But still wrapping.
I think this is the same region where you had the perforation, so I think there must be a couple of planes there.
If it is, if I'm in there, my wire could go easily. So I don't think so. I'm a different, somehow different plane. Okay. Let's do injection, and maybe we should do retrograde. It shortens my procedure time. Yeah, I think, you see, LAO, please.
I think you will keep the soft wire in this place, obstruct this false pathway, and retie the other wire in other direction in order to get the true lumen.
Yeah. Let's try to go a little bit.
Because wire is repeatedly going to the same pathway.
Yeah.
Hello, Omar. This is Yusuf. Sorry, I keep, it's very unstable, the connection. I just want to say, so I think your entry and your main part until the diagonal looks very fine. Also, CT confirms this. I think your wire find a nice dissection. That's why he keeps going. Maybe it's true you can switch to parallel, or you can, as you said, you can switch to Gladius EX. It's actually nice because we know it's not very much calcified, and you can try to track this with Gladius.
Yeah, so now I think I can do parallel now because I have some progress with this wire. So I know where should I go, yeah? Okay, epicranial. Let's see how far I am from the lumen. That's important. Not that far. I could do parallel wire. To do that, I like to have, guys, I like to have
Salman, what's your experience about wire fatigue? If you use the same weightage wire and do it for a long time and then you change it, sometimes you feel that different wire of the same brand, same weightage works. Did you get a lot of wire fatigue when doing long cases?
Yeah, I mean, I think, so I'm going to answer the question in a different way, that if the wire, one wire is not working, for parallel wire, I'll take a wire with different properties, either a bigger weight or maybe polymer jacket. So when you do parallel wire, I like to use different wires. Now, more important than wire fatigue is in calcified CTO, sometimes the wire tip gets stuck. Yeah. And if that's the case, then you can, I've broken tips. So I try to make sure the wire keeps moving. But you're right, you can have wire fatigue.
But Gaia is good in that way that even if you mess up the tip, it doesn't usually get, it usually doesn't get much.
No, the one we broke was the Raider actually. We actually just, the wire stretched out and yeah. So Omar, when you do parallel, do you use a dual lumen or just do you go with another microcatheter adjacent to it?
Yeah, I'll use the same macro. Okay, go up here, time.
But I think coming back to your question about the wire fatigue, even in the calcified vessels, I think the wire is more prone to the distortion as compared to a soft plaque like this one or dissection. Or if it is making it is wiggling again and again, then they are, I think you must be more
Can you explain what you are doing now? Are you flipping to wire or changing to micro?
So I will use now double lumen catheter, double lumen catheter for parallel wire, yeah?
The polymer jacketed wire, as you spoke, it can be slippery and it can pass through easily with a parallel wire, more prone to pass.
And also I think the jacket keeps it from fracturing. Sometimes the core fractures, so fatigue comes in different forms. For example, when a sewer fatigues, it's because it's had made too many bends. But when one of these wires fatigues, typically the core breaks close to the tip, and the polymer jacket sometimes keeps it together.
So, Umar, if you don't have a double lumen, in case we don't,
we have double lumen.
So you use you have. For example, if we don't, maybe in some labs. Okay. So would you use 2 micros that would need 7 French or more, or would you use one bare or one on the micro?
Yeah, 2 micro. When the Corsair and fine cross will be fine. You can use both. Yeah. But mostly I use only one. I lift the first wire and I remove micro if I don't have double lumen catheter.
Dr. Umar, Dr. Nawaz, have you checked the entry point in the CT scan? Because if you are going beyond the entry point of dissection, whatever catheter you are using, this further precipitate your dissection. So you have to keep the catheter at the entry point of dissection, then do the parallel wire on this.
So, yeah, so I concentrate here and I couldn't understand your question, Nawaz. Tell me again, please. Come again. Now I'm pushing my double lumen catheter. I am in. And so I ask for Conquest here.
Sorry, which is the second wire?
Conquest 9.
Conquest 9, okay.
So, I could use another Gaia third next. But now I have to be very precise where should I go, yes? So, can you do a tip contrast, please? Yeah. Öncekini göstersene bir. Okay, I have to go right side, yeah?
Yep.
Okay.
Yes.
Yeah. Exactly, in here. Okay, let's see now. Okay. I have to have separation from here.
जब तक वो शुरू होता है चलने
conquest.
So, Bilal, is that your usual algorithm? You start antigrade, then use a couple of wires, then go parallel wire, and then go retrograde in every case?
I think it all depends on the quality of the retrograde interventional collateral. I think as Umar mentioned earlier that it's not the best collateral and not the most robust one. So I think I would exhaust every opportunity to do an antigrade approach here before I would move over to a retrograde approach. So I think, yeah, in this case, this is exactly what I would do at this point. Try a different wire and parallel. And if it doesn't work, then within a couple of minutes, then I would probably switch over to a retrograde approach then.
I think, yeah, I like to go retrograde now because I will do tip injection.
That looks more
Let's
promising.
see, maybe this is a little bit better place. And we can do a seesaw because I have a double lumen. Go.
I think here the previous dissection means that he's got multiple planes over there by now.
I have balloon. I have to remove this balloon. I will remove anchoring balloon, trap balloon inside because I have no place.
I think your guider is a bit out. If you could have a good injection,
true.
then you'll know.
Dual lumen katetere rağmen aynı diseksiyon planına gidiyor muhtemelen subintimal ikinci telde.
Scoopy alsana. Bu şiti dikmemiz gerekiyor arkadaşlar. Bu şitler dikiliyor ya. Bu şitler dikilir. Yok, hemşire diksin, sen değil. Bu şitler mutlaka dikmek gerekiyor. We have to fix radial sheath, otherwise okay. So
Dr. Umar, this Dr. Nawaz. Generally, we know the dissection occurs on the myocardial side of the
spider,
and so I think best used to do in the left oblique view and see the direction of the wire facing to the myocardium, and you can get the true lumen mostly.
So I have to go with the. Nereden çıkıyor?
I think it's good to recognize one thing, that there is no such thing as a straightforward CTO PCI. We sometimes think that we have an unambiguous cap, a non-calcified segment, but the arteries and the wires behave in different planes, and I think what's important for me to recognize in these cases is that the amount of skill sets and the ability to change your strategy and use different different tools, and Omar is demonstrating, the qualities of the different wires that are necessary in these situations. That's what makes this such a challenging and a difficult, and I think it also emphasizes that anybody who really wants to do CTO PCI really needs to commit themselves to understanding, having a deep understanding of not just the coronary anatomy, but how does the adventitia behave, and how do the different tools, wires behave inside the wall of the vessel. It's so different that there's no wonder that this is known as the most difficult sort of a subset in coronary intervention is CTO PCI.
So this guider is EBU4 or EBU 3.5?
This is 3.5. EBU 3.5 değil mi? Yeah. AP cranial.
This might be the going into the diagonal, is it?
Okay, let's see where am I now. Injection. Wait. Okay, so the second, from another view, the second wire shouldn't be that much far from this LAO. Let's see from here, LAO. Biraz daha.
Umar, if you go a little bit more LAO, you will come in the wedge. Then it will be much easier to see. Okay. I can't really...
Okay, not far, right? So yeah. I can close.
A few millimeters you have to pass. Very close.
Not far.
I think it's near the distal cap, but the bend at the tip, if it enters the true lumen, that might help.
And just another learning point, I think, for people who are operators who are just beginning to learn how to do CTO PCI is, as you can see, Dr. Goktingen is not moving his microcatheter at all until he's absolutely sure that he is in a safe place. Because if you do have a wire perf, it's a 0.09 or a 0.014 perf, but advancing the microcatheter through an area that might have perfed can be much more catastrophic. So again, recognizing that he's taking multiple views, taking orthogonal views, ensuring that he is in line with the vessel and in the...
I have a great resistance here, yeah? Although CT doesn't show me that much calcification, I have a great resistance to Concast Pro, right? Concast Pro is stiff wire. So I think I have some yeah, to me, time to go retro, guys. I should find that small branch and I should go for it. And I am a good position for antegrade reverse card. I like it. Or lastly, I have another guy, a third. Bir tane daha guy 3 var mı? Give me another 2-3 minutes and I will go retrograde.
So for the new audience, this was a case. Sohail साहब, आप ही क्या टाइप का केस है? ये केस था जिसमें they tried to do a CTO and perforated the mid LED antegrade, this one. So then they did waited 2 months and then did a CT. And this time again it's been brought in for recurrence. So there it was a soft primary जहाँ वो proximal cap, so they thought they'll puncture it antegrade.
No.
So this is what they are now doing. They've tried there, now they're going, this is for the audience, that they're trying antegrade. If it doesn't work, the septal collaterals are not very good. There's an epicardial collateral from the left ipsilateral, so they are trying to avoid a retrograde.
LED का थोड़ा सा intershadowed नजर आता है.
Yeah, perforation was 2 months back, and so they waited 2 months.
Are you checking the ACT, by the way?
Yeah, we had the ACT, and we give heparin, additional heparin. Ah, how much heparin?
It sealed itself. It was a CTO.
Huh?
So this.
We give 2,500.
So in antegrade cases like this, Bilal and Salman, you keep the ACT above 300 even before the wire crossage, or you keep it 350 plus or 300 and 350, and then once the wire crosses, and then you make sure that it's above 350.
I have just a question that on CT we saw that there is a calcific block, or you can call calcification there. So is it that time, that place where the wire is buckling? So for those who are familiar with most of the wire, which we don't have like Gaia Next, or what will be from the panel of expert, what will be the wire of choice if we have buckling of the CP12 or a Gaia 3rd at this point here?
Well, okay.
We want to cross it, but we are buckling with these two wires. So what will be the next choice of wire?
We're not sure if we're in the architecture. We still may be extra plaque. And as Dr. Gotekin pointed out, that sometimes is the heel dissection plane. So even when the thrombus heals and organizes, the plane sometimes will come frozen in there. So you get stuck on that. And so sometimes the polymer jacketed wire may be an option. So, you know, maybe take a pilot 50 or 150, give it like a small Gaia-like curve and try that in Pakistan.
Do you see how much resistance I have, guys?
Yeah, we see that right there. So, you're answering your question. Generally, with the antegrade approach, we try to keep our ACT just over 300 and retrograde about 350. Just given the amount of gear that is used, you can see here there are 3 wires. So the goal really is between 300 and 350 in antegrade.
One would be a bit conservative, because generally, you know, new operators, they tend to keep the ACT a little bit on the conservative side before they cross, because they're worried about perforations. And once you cross, and if it's a bare wire, then it's not much of a problem. But if you keep MCs and other equipment in there and double cannulation, then you need to keep the ACT.
Like for instance, in this particular case, you have 3 wires and a microcatheter. So I think if the donor vessel were to thrombose, which certainly can happen. I mean, you know, generally in non-CTO PCI or ACT of 250, 260 is generally pretty good. It's not a problem. But people, I mean, we've had thrombosis when your ACT is over 250 even in a CTO PCI case.
Suppose this wire escalation failed, what will be our next strategy? Like we can go with the knuckle and then we can do a dissection and re-entry?
No, so
Umar, you have 5 minutes, then we have to have our, and we'll come back to you to see what's happened. So you have another 4 minutes to show us.
I will have gladius, and I'll try to do small knuckle, and let's see, because now my aim will be retrograde.
Right, so you're planning to shift retrograde.
Thank you.
The question about using knuckle here. So I think the challenge is that because of multiple wires being used in a previous dissection, there's probably a reasonable size space. And so if you were to knuckle it and you're in the extra plaque area, you're going to dissect the entire vessel, and you might end up with a star and re-enter the vessel distally. But what you don't want to do is to essentially compromise on all the small septal branches or diagonals coming out. And then you don't want to put a complete full metal jacket from the apical LED all the way top, right? So he's trying his best to avoid doing that, which is why he's not using a Feeler XT, for instance, because in that space the Feeler XT will knuckle, and then you'll just be forced to dissect it. So what he's trying to do is to basically re-enter inside from an extra plaque to an intraplaque area. And if it doesn't work, then the next step would be to do retrograde, which is what he plans to do next.
And moreover, if they try to do a star in this area, they might be risking the perforation as well before, because this is extra plaque. So I think in the interest of time, if we are all
you are escalating from conquest
we'll
9
come back
to
and if you can show us, if we have time, we'll come back and you can tell us
Sure.
what it is. So
Yeah,
thank
we
you
will
very
show
much. Any final
from my
comments
side,
from
I just have, I have to go, sorry. So I thank everyone.
Thank you, Yusuf. Yeah, thank you very much. And see you soon, Yusuf.
All right, thank you.
And
Thank
if
you,
you stay
panel.
another 2 minutes,
And I
let's
think
see how
the
graduates
next
will do,
agenda
guys.
item is
Just
our-
wait 2 minutes.
Yeah, sure.
Just
We'll
wait
give
2
you
minutes.
2 minutes. Yeah. Okay.
Yeah, because this is new wire and hydrophilic one.
For this chance, and I wish everyone good luck.
Thank you.
What about trying a Carlino over here?
Yeah, but if you do Carlino at this stage, I mean, it's going to dissect all the way down.
No, Carlino is too late now.
It's too much of a...
All right, I don't think we will do something here. Yeah, let's leave it here. This is, to me, a target. I will leave it here and you can go. I will work for retrograde and I will show you later on what we did, yeah?
Okay, thank you very much.
Yes.
All right, thank you, panel. And I think we close our last session and the next is the general body meeting. Yeah. All right, thank you.
Evet, onu ver. Karavel var mı arkadaşlar? Karavel. Suo isteyeceğim bir de. Evet. Şimdi arkadaşlar, bizim arkadaşlar.
Hocam.
Duyuyor musunuz?
Duyuyoruz Ömer hocam. Bizim kendi zoom'umuza geçelim, oradan devam edelim isterseniz hocam.
Pakistan gitti zaten. Evet hocam. Tamam.
Ömer, Pakistan'dan ayrıldık zannedersek.
Ha, şimdi değil. Hayır, şimdi değil abi. Bir dakika. Hayır. Öyle yapalım dedik ya. Ha? 12-14 abi. Bir dakika. Bir saniye abi. Bir saniye abi. Göreyim yukarıyı. Aha.